Sujata ma'am, you can mute yourself and speak.
Madam, first speaker is ready, no, madam? Lakshmi Saujanya.
Yes, ma'am, I'm ready, ma'am.
Yes, then by 8 we'll start, madam.
Okay.
Jasmine, Sandhya, are you ready?
Yes, ma'am.
You will be calling upon the moderators to start the first session, right?
Ma'am, out of the moderators, we don't have 2 moderators yet. They haven't joined yet.
Which one? Padmavati?
Yes,
Who has
ma'am.
joined? Who has joined?
Ma'am,
Just start
Aruna
with
ma'am
them.
joined and... Okay, ma'am.
Aruna, Padmavati, Dr. Vishwamitra. If anyone has joined, we'll continue. Otherwise, we have to start, that's all. Right?
Yes, ma'am.
By 8 sharp, we'll start. I welcome Dr. Anandakumari Madam, observer of our Evecon today. Welcome, Madam. I can see you.
Good morning, everyone. Good morning, everyone.
We just start within 1 minute, Madam. We will, then you can address us. Jasmine, is
Yes,
Dr.
ma'am.
Vishwamitra there with us?
No, ma'am.
Padmavati, Madam?
No, ma'am.
Have you called them?
Ma'am, Aruna ma'am joined, but she left in between.
I'll just call again them and then we'll start, right?
Yes, ma'am.
Sujata ma'am, we are able to see you now. You can unmute and speak, ma'am.
Okay. Now my voice is audible?
Yes, ma'am. Superb. Yes.
Well, let me share my screen once. Okay. Screen share, please. Screen. Hello?
Yes, we are able to see your screen, ma'am.
Okay.
You can stop the screen share, ma'am.
Okay, thank you. Mine is the second presentation.
Yes,
Okay?
yes. We'll do
8:30. Okay.
Sure.
Thank you. Thank you.
Yeah.
Good morning, everybody. This is Dr. Aruna Lavu, Silklotpet.
Good morning, everybody. I am Dr. Sujata, ophthalmologist from Vijayawada.
Good morning, everybody. I am Dr. Lakshmi Saujanya, gynecologist from Nandyal.
Good morning, ma'am.
Good
Madam
morning,
Vishwamitra, madam, join ayyara? Join అయిపోరు 5 minutes కాదు మ్యామ్ స్టార్ట్ అయిపోతుంది రండి రండి మేడం థ్యాంక్ యూ మ్యామ్ ఓకే మ్యామ్ థ్యాంక్ యూ మ్యామ్ థర్డ్ స్పీకర్ మేడం హూ ఇస్ ద థర్డ్ స్పీకర్ is the third speaker madam I think
Dr. Krishna Prashanti ma'am.
మేడం నేను జాయిన్ అయ్యాను
yes
వీడియో మళ్ళీ ఆన్ చేస్తాను బయలుదేరుతున్నాను
మేడం నమస్తే
ఓకే ఓకే నేను లైన్ లో ఆన్లైన్ లో ఉన్నాను చూస్తున్నాను
yes ma'am thank you Jasmine
Yes, ma'am.
We have Madam Aruna with us. Just you announce the names of all the moderators and let Madam Aruna take over and invite Saujanya Madam, right?
Yes,
That will
ma'am.
be the moderators will be inviting the speakers, right?
Yes, ma'am.
Now shall we start? Now we are on the air. Good morning, respected delegates, speakers, and moderators of this wonderful conference, the Evecon, where all the speakers, the moderators are women. This conference is the brainchild of our dear President of IMA State, Dr. G. Ravi Krishna, sir, who has given the opportunity to Academy of Medical Sciences of IMA State, Women Doctors Wing of IMA State, Wing Health of IMA State, headed by women. All the wings are headed by women doctors. He has given us the opportunity to conduct in unison this conference. I welcome all the delegates and I wish them a happy and fulfilling scientific feast throughout the day. This conference is awarded 4 credit hours. It extends from 8 to 5 p.m., 8 a.m. to 5 p.m. And I request all the delegates to be logged in because credit hours will not be given for the doctors who have not logged for amount of time. Now, before we start, let us have a prayer. Even this responsibility is thrust upon me, though I am not a singer. Please bear with me. I will start the meeting with Ganesha Pradhan. Sri Gananadham Bhajare, Sri Gananadham Bhajare, Chitta Parashakti Sri Gananadham Bhajare, Chitta Parashakti Sri Gananadham Bhajare. Nagayagnya Sutradharam Nadalayanandakaram Nagayagnya Sutradharam Nadalayanandakaram Sri Gananadham Bhajare. Agamadi Sannutam Akhila Deva Pujitam Agamadi Sannutam Akhila Deva Pujitam Yogi Salibhavitam Bhogi Sai Sevitam Ragadveshadirahiත Ramaniya Hrudayanuditam Sri Guru Guru Sannuditam Chinnu Kamalasritam Sri Gananadham Bhajare. Thank you all. Now I hand over to Dr. Jasmine and Dr. Sandhya to welcome the moderators for the session. Thank you.
Thank you, ma'am. Now we'll begin with our conference, the Evecon Online CME 2023, which is exclusive women speakers and moderators, the first of its kind. We'll be starting with our first session, who will be moderated by Dr. Lavu Aruna. She's the immediate past chairperson of IMA AP MPH. And our speakers, she'll introduce. The session is going to be from 8 o'clock to 10:30. Handing it over to ma'am. Dr. Aruna, ma'am.
Jasmine, the other chairperson.
Ma'am, they haven't joined.
But still you
Ma'am,
just...
Dr. Yes, ma'am. Okay. Dr. Padmavati, we have invited Dr. Padmavati, who's the immediate past chairperson, IMA AP WDW Guntur, and Dr. Vishwamitra P, who is professor and HOD of ophthalmology, Visakhapatnam.
Over to Aruna, madam.
Aruna, ma'am.
Please
Good
unmute.
morning. Good morning, everybody. It's my pleasure and to introduce Dr. Lakshmi Saujanya, madam, gynecologist from Nanjal, and also pleasure to start the CME program with Dr. Lakshmi Saujanya, madam. Madam is doing the topic of every dip is not an indication for LSAS. Please, madam, continue.
1 minute, madam. Hello.
Yes, good
Yes,
morning, sir.
Yes, yes.
Good morning, sir.
Good morning, all the people, speakers, delegates, organizing team on the board. Speakers, moderators, and the observer and other people and technical team will be in this Zoom session. You are seeing only 15 people here, but actual live streaming is there. Already more than 300 people are watching. That live streaming for delegates is a separate link. We have shared that link to Dr. Durga Rani madam to send to our observer. She can always click that link and know how many people are watching the program. I want to share this information to the speakers and moderators. You can continue.
Dr. Lakshmi, you can start, ma'am. You can click on the slideshow mode, ma'am,
Yes, yes.
on the bottom right side.
So the time for me is up to 8:40, isn't it?
Yes, ma'am. We are going to put a small timer, ma'am, so that
Yes.
everybody is aware of
Okay.
it. Yes.
Good morning, everyone. Good morning, Dr. Ravikrishna, sir, all the seniors and the colleagues and all the delegates. It's a great privilege for me to be starting this session of exclusive women doctors presentations today. Evecon 2023, first of its kind in India. Today, my topic is every dip in CTG is not an indication for cesarean section. So the aim of this presentation is mainly to understand the basics of cardiotocography, that is the fetal monitoring graph, so that the physiological background of the CTG trace will reduce the incidence of C-sections. Unnecessary false positive cesarean section rates, depending on CTG trace interpretation, can be reduced by understanding the clear physiology of the CTG. It's like ECG for the adult. Of the total number of deliveries that we do, the WHO criteria for cesarean section rate is not to go beyond 15%. So we are seeing that these days, because of various reasons, the cesarean section rates are on the rise, and it's very important for us to audit and reduce the C-section rates to the maximum. This is the CTG graph and the CTG machine. The CTG graph has the fetal heart rate pattern. This is the fetal heart rate pattern. The TOCO is the uterine contractions that will be recorded on the bottom line. When we look at the fetal heart rate pattern and CTG, it has 4 features: the baseline heart rate, the variability, the accelerations, and the decelerations. So this is how a graph looks like. This is the baseline. You can see the numbers 60, 80, 120, 150. So for this graph, this is the baseline, that is 120. The normal baseline heart rate being 110 to 160 for the fetus. The beat to beat variability is in a 1 minute graph. So this is a 1 minute graph. In this 1 minute graph, the difference between the lowest point and the highest point is the beat to beat variability. For example, the lowest point here is 100 and the highest point is 150. So the difference in between the highest and lowest point is the beat to beat variability, the normal beat to beat variability being 5 to 25, and it indicates the integrate autonomous nervous system of the fetus. So variability is good means that the baby's autonomic nervous system is good and it is maintaining well. And these are the accelerations. The third feature is the accelerations. Accelerations are from the baseline. When we take this as the baseline, from the baseline, the rise in fetal heart rate by 15 beats per minute. So here it is 120 here, and the raise is up to 160. So that is up to 40 beats. More than 15 beats per minute is the acceleration. Presence of acceleration is a very good sign. It can be present with fetal movements, fetal contractions, or the deceleration. The fourth feature that we see on a graph are the decelerations. A transient episode of slowing of the fetal heart rate rather than acceleration, slowing of the fetal heart rate. That is from the baseline to more than 15 beats per minute is considered to be a deceleration. So decelerations are of three types: early deceleration, late deceleration, and variable deceleration. And this is all the topic is about today. So just a dip is not an indication. We have to consider all the parameters. What is the type of deceleration? Is it early? Is it late? Or is it variable? How long is it? How about the other features on the CTG graph? How is the color of the light curve, progressive labor, gravidas status, associated complications that we have? All these factors will be taken into consideration before a decision for C-section is done based on the decelerations. So early decelerations are the ones which start with the uterine contraction. The dip starts with the uterine contraction. The peak of contraction, you can see here, these are the contractions and these are the decelerations. So the dip, this is the baseline. The dip starts with the deceleration, with the beginning of contraction. The peak of contraction is coinciding with the nadir of the deceleration, and the heart rate recovers back to baseline once the contraction is over. So this says this is early deceleration. This occurs with head compression. Usually early decelerations are benign. When we see such kind of decelerations, when once we monitor and progress of labor is seen, we can always wait. Late decelerations occur. These are the late decelerations. See, these are the contractions. After the contraction has started, the deceleration starts, and the peak of contraction does not coincide with the nadir of the deceleration. And the deceleration persists, the dip persists even after the contraction is over, which is as against that of early deceleration. So these are usually U-shaped. Late decelerations usually indicate placental insufficiency or fetal hypoxia. And if late decelerations are seen, we need to act quickly. When coming to the fetal baseline fetal heart rate, 110 to 160 is normal. Heart rate below 110 is decreased B2B bradycardia. We can see with late fetal hypoxia, but it can also be seen with cord compression or certain sedative, certain drugs. So here, as you can see, the baseline was at 140. Here it has dropped down to 100. That is below 110 is bradycardia. Fetal tachycardia is the heart rate above 160 beats per minute. It can be seen with maternal pyrexia. On the CTG graph, it is always important that it also shows the maternal heart rate. Whenever the maternal heart rate is high, as in stress, anxiety, the fetal heart rate can also be high. And it can also be present with maternal pyrexia, fetal infection, chronic hypoxia, and with certain drugs, and with excessive fetal movements also, fetal tachycardia can be there. So this is the graph showing fetal tachycardia. Up to 160 is normal. Above 160, here it is at 180, which is showing fetal tachycardia. Decreased beat-to-beat variability is 5 to 25 beat-to-beat variability is normal, but when it is less than 5 or absent, it is decreased beat-to-beat variability. It can be there with fetal sleeping pattern also, which usually does not last longer than 90 minutes. With maternal sedation, certain drugs like pethidine, all these can cause decreased beat-to-beat variability, and severe hypoxia can also cause decreased beat-to-beat variability. So decreased beat-to-beat variability for persisting for longer than 90 minutes, and if it is associated with shallow dips, is an ominous sign. But if it recovers after 40 minutes, when the graph is continued, if it recovers after 40 minutes or 60 minutes or within 90 minutes, we need not worry about decreased beat-to-beat variability. Variability indicates the integrity of the autonomic nervous system. This is the graph showing decreased beat to beat variability. From here to here is 10 beats. So here we can see that it is filling only half of the box, that is hardly 5 beats per minute. This is 1 minute. In the 1 minute graph, it is less than 5 beats per minute. In certain kinds of traces, we see sinusoidal pattern, a smooth wave-like baseline with absent beat-to-beat variability. This can be because with severe hypoxia, fetal anemia, and sinusoidal pattern is also an ominous pattern which demands immediate delivery. Sometimes, as we have already discussed, early deceleration occurs with contraction and ends with contraction. Late deceleration may start a little later than the contraction starts and persists even after the contraction ends. Variable decelerations are the decelerations which are not seen with every contraction. They are not typically related with uterine contraction. You can see variable decelerations with cord compression or true knots, or in cases like oligohydramnios where the cord compression is more. See in this graph, these are the contractions that we are seeing. All these are the contractions. So with these contractions, the fetal heart rate is normal, but with few contractions, the decelerations are there, which indicates that the decelerations are not with every contraction. And amongst the variable decelerations, there are two kinds, typical and atypical. Typical decelerations, variable decelerations are benign. We can give time, whereas atypical variable decelerations are we need to act quickly upon atypical variable decelerations. Prolonged deceleration is the one when the fetal heart rate dips by more than 60 beats per minute, 30 beats per minute, lasting for more than 2 minutes. It can occur with cord compression, prolonged cord compression, unrelieved cord compression, uterus hypertonia, and maternal hypotension. Here you can see the fetal heart rate is at 140, and now the fetal heart rate deceleration is seen here. And it is lasting for 1, 2, 3, 4 minutes. So this is a prolonged deceleration. And if you can see here, it is correlating with the contraction. So whenever we see a graph, we have to follow the mnemonic so that it is very easy for us to label the CTG. Dr. C. Bravdo, D for the risk, whether the patient is low risk or high risk or preeclampsia, IUG, or whatever risk factor is there, we have to note down. Contractions, C. DR is defined risk, C is for contraction, VR is baseline rate, V for variability, A for acceleration, D for deceleration, and O is overall comment. Based on these features, we label it as normal, abnormal, or normal, suspicious, or pathological, depending upon the 4 features of CTG that we see. This is a normal reactive CTG. Here we call this as normal when 4 features are normal. Baseline is normal, beat-to-beat variability is normal, accelerations are present, and there are no decelerations. So this is a normal CTG. So this table is very important because it speaks everything about the cardiotopography and the intrapartum fetal monitoring based on cardiotopography. Here we take baseline beat-to-beat variability and decelerations into consideration. And based on these factors, we divide the CTG, the trace as reassuring features. The features have to be labeled as reassuring, non-reassuring, or abnormal. And once we label the 4 features, and when we write in Dr. C. Bravdo, all the 4 features will be labeled. And according from that, we label the CTG as normal, suspicious, or abnormal. Why so? If it is normal, we can wait for normal progress of labor when everything is permissible. And when it is suspicious, that is, normal means all 4 features are normal. That is baseline, beat-to-beat variability, accelerations and decelerations. Suspicious is the one when any of the 4 features are non-reassuring, it is called suspicious. Whenever a CTG is suspicious, we have to go for conservative management like stop Synto or stop the features that are causing a hypertonic uterus, or stop, try to prevent the insulting factor and give time. And if the CTG is called pathological, if the CTG recovers after suspicious CTG, we can give time. We need not do a delivery immediately if it is suspicious, but we can go for conservative management, see if the CTG is recovering. If the CTG is recovering, we can give time. If the CTG is pathological, pathological means there are two non-reassuring factors. Baseline is abnormal, either ready or techie. Beat-to-beat variability is reduced, or if it is more than 25 beats, or if the decelerations are there, any two non-reassuring factors, we call it as pathological. A pathological CTG demands urgent delivery, whichever is the earliest route, either vaginal or C-section. Suppose if this baby's head is at +2, if I can deliver by applying forceps quickly within 2 to 3 minutes, we can do a vaginal delivery. But if it is not the case, we have to do an emergency C-section, and the C-section should be completed within 20 to 30 minutes. So the CTG shows us the stages of fetal distress. The fetal distress can be in various stages. Initially, there can be hypoxemia. The oxygen levels are low in the fetal arterial system only. Then, if it is continued, it may go into hypoxia. The tissue hypoxia may be seen. And if this continues, the anaerobic metabolism sets in and the fetus may go into asphyxia. Now, let us see a few case scenarios. Mrs. KR, she is admitted in labor. At these are the initial CTGs when she was progressing smoothly in her labor. These are all the normal CTGs so far. At this particular point of time, how do you label this CTG? The baseline is good, beat-to-beat variability is good, but there are decelerations. These are type 1 decelerations, and this CTG is suspicious. So now when the CTG is there, we have to look at the complete clinical scenario. She is 50% effaced, 2 fingers. So at this point of time, because it is suspicious, Synto is stopped. And once Synto is stopped, the CTG is continued. We can see that the CTG is recovering. The fetal heart decelerations, which were deep here, are not so deep. The baseline is normal, beat-to-beat variability is good. No significant decelerations, and accelerations are there. So this was at 11:50, 12 o'clock. And after 1 hour, the CTG is repeated. Again, the CTG started showing type 1 decelerations. By this time, we thought we may have to take a decision, but she's effaced 7 centimeters at 0, progressing quite well. So these are type 1 decelerations and not ominous. So we thought we'll closely monitor, anesthetist informed. So this is the continued CTG. And she delivered by 3 with an upgar of 810 with a birth weight of 2.7, delivered vaginally. So the take-home message from this graph is, when the CTG is suspicious here, we have stopped the insulting factor, stopped Synto, left lateral position, then continued CTG if it is reassuring, and if she is progressing, if she is not progressing, we may have to go for C-section. Mrs. SO, 35 weeks, came with PPROM, and she was progressing in labor. She was started on Synto because she was not getting contractions with PPROM at 35 weeks. Synto, these are the CTGs which were normal. And at this particular point of time, at 10:20 a.m., we saw a deceleration which lasted for 5 minutes. At this particular point of time, stopped Synto. A prolonged deceleration is ominous. So we informed the anesthetist, kept everything ready. She was effaced 2 centimeters. This was at 10:20. CTG is continued. So soon after this Synto stopped, we could see that the CTG has recovered completely, which is normal. And the dip that we saw was at 10:30, and she delivered by 11:15. That is within 45 minutes. With a 2 kg baby, upgar 810. Suppose if the CTG is not recovering at this point, even after Synto is stopped, we have to go for C-section. Mrs. RZ, she is a case of fetal growth restriction. She came in labor at 37 weeks. This is her initial CTG. At this particular point of time, the CTG is suspicious. Then soon, this was at 3 o'clock, the continued CTG showed persistent deceleration. This deceleration, the baby's fetal heart rate fell from 140 to, here it is 80, from 140 to 80. It is not 80, it is 60. It is not picking up. So we have called the anesthetist, and emergency C-section has to be done because it is a FGR fetus, fetal growth restricted fetus, and the baby is already exposed to chronic hypoxia, and the baby is not able to cope up with the compensatory mechanisms within the fetal cardiovascular system. So this has to be dealt with a C-section, 2K, 2.2 kg baby with an upper of 6'8". Next case is Mrs. A.N. She came in labor at 39 weeks. These are her initial CTGs, which are normal. This is her CTG at 3 o'clock in the afternoon. At this particular point of time, see the dips are quite scary. The fetal heart rate was going down up to 80, but beat variability was good, and it was picking up, and again it was going down. At this particular point of time, we thought she may require a section, but she was 6 centimeters at 0. But we prepared for C-section because these decelerations were persisting for quite a long. We prepared for C-section, and CTG continued, which showed it was dipping. The fetal heart rate was dipping, but again it was picking up, and she progressed very fast. This was at 310, 6 centimeters, and by 4:15, that is within 1 hour, she delivered vaginally. She was progressing from 6, 8, 10, and at +2, we applied vacuum. Soon after, we could see the baby at +1 and +2 and delivered 2.6 upper 8, 10. But double setup is required in this case of, in this type of cases. Mrs. B, this is a case to show the decreased beat-to-beat variability. She was progressing. Earlier CTGs were normal, but at this particular point of time, the beat-to-beat variability is reduced. You can see here, from this point to this point, it is 10 beats. It is less than 5 beats. So this is from 12:10 to 12:20 to 12:40. So what we have to do, we have to continue the CTG. Here, see, towards the end, you can see an acceleration. In the beginning of the continued CTG, you can see an acceleration. Again, the beat-to-beat variability is decreased. At this particular point of time, Synto was stopped, and the CTG continued. So at this particular point of time, we thought we'll do a section because almost 90 minutes of decreased beat-to-beat variability. But here, the minute we took a decision, the continued CTG was normal, so we waited. But subsequently, there were late decelerations with decreased beat-to-beat variability. Station was at 0.8 centimeters for 2 hours, non-progressive labor. So though the CTG recovered, subsequently the repeat CTGs were suspicious with non-progressive labor. The dilatation of the cervix was at 8 centimeters, not progressing, and descent was not there. So she has to be taken up for section. So the whole clinical scenario has to be taken into consideration, not just the CTG alone. Suppose if she is at +2, we would apply vacuum and deliver her, but she is not progressing. Suppose if it is meconium also with decreased beat-to-beat variability, we would not wait. This is her continued CTG before taking her up for section, but still we did section because she was not progressing. This was her CTG just before C-section. Mrs. M, FGR, 33 weeks +2. This is a case to show an antenatal CTG. In this particular CTG, this patient is an FGR with umbilical artery high resistance. She was being monitored twice weekly serial growth with alternate day Doppler and NST. The baby weight was, estimated weight was at 1 kg. And so as a routine antenatal checkup, when she came, the CTG at this particular point of time is normal, but there was an unprovoked deceleration towards the end. So any antenatal CTG with unprovoked deceleration is an indication for immediate delivery because it indicates that the baby is in chronic hypoxia going into asphyxia. So C-section is done. It's an IUGR fetus, 1 kg, Apgar 810. Baby was in NICU for 20 days and doing well. Mrs. K, It's a case of large for gestational age baby, second gravida, para 1, live 1. She was progressing well. This is the third CTG. The initial 2 CTGs were normal. At this particular point of time, the CTGs are suspicious. So because the CTGs are suspicious, at this particular point of time, Synto is stopped and the CTG continued. So with this suspicious CTG, she was second gravida, 6 centimeters effaced, station 0. And continued CTGs. Because she was progressing fast, we thought we can wait, and she delivered vaginally 3.8 kg after 8 tests. Now, Mrs. R, gravida 2, para 1, live 1. This was 2 hours, 37 weeks with the oligohydramnias. There were variable decelerations here. The continued CTG is like this, which is now, which was showing decreased beat-to-beat variability. So after 20 minutes, we continued, which showed normal beat-to-beat variability with no decelerations and normal baseline, which is considered to be a normal CTG. 2 hours later, the CTG continued, showed is like this with decreased beat-to-beat variability. At this point of time, we thought she may require a C-section, did an ARM to look at the color of the liquor. The liquor is clear. Effaced 5 centimeters, station 0, second gravida. So CTG continued, which is like this, which is normal. And she delivered by within 1 hour vaginally 3.1 kg with an upgar of 810. So this is a case scenario which is showing sinusoidal pattern, which is ominous, as it has to be dealt with an immediate C-section. This is a CTG showing typical late decelerations. So the take-home message is CTG alone cannot be taken into consideration for making a decision on mode of delivery, either vaginal or cesarean. The whole clinical scenario, like the risk factors, preeclampsia, diabetes mellitus, fetal growth restriction, gravida, elderly gravida status, the type of conception, color of liquor, stage of labor, and progress should be considered before making a decision. And every dip is not an indication for a C-section, because CTG is a guide and not the ultimate thing for us. We have to be very careful in making a decision. But when it is mandatory, we cannot sit on the patient and say, I will do normal only. We have to take all the things into consideration and make a wise decision. Thank you.
Thank you, madam. Definitely, CTG is a boon to all the gynecologists. There is a lot of difference when we started practice and after we got the CTGs. Definitely, it's a boon. As you were saying, the weight of the baby is not an indication for CTG, because a 2.2 baby, when there is a abnormal CTG, we may have to go for scissor. And even if the baby is 3.8, if the CTG is normal, we can still wait. So definitely it's a boon. And not only this, another point is, it is a documentary evidence. When there is a problem with the patient party, at least we have a documentary evidence that what we have done is right. And we can at least save our skin. Thank you very much.
Thank you. Thank you very much.
Dr. Vishwamitra. Dr. Vishwamitra, madam, are you there? Sujata? I think Dr. Vishwamitra, who is supposed to chair this session, is not available. In that case, I am presenting the next speaker to you all. She is none other than Dr. Yanamandla Sujata. Welcome, madam, for your talk. Madam is a native of Krishna district, Andhra Pradesh. She has completed MBBS from Guntur Medical College and MD Ophthalmology from AIMS, New Delhi. MS of, we call it MS, madam, here in Andhra Pradesh.
But it is MD from All India Institute.
AIMS, madam.
So,
She was the first fellow in orbit oculoplasty specialty from Aravind Eye Institute, Madurai. She was the winner of many awards and gold medals, presented more than 900 scientific papers, and demonstrated live surgeries at regional, state, and national, international conferences. For the past 32 years, she has been successfully practicing at Vijayawada by running all surgeries. She has been performing more than 30,000 surgeries in the field of orbit oculoplasty. She is a life member of many ophthalmic associations. She is vice president of ACIN Vijayawada Academy of Ophthalmology for installing various awards at various associations and APOS, etc. Welcome, madam. We request you to present the topic of orbit oculoplasty for our delegates of this wonderful Evecon conference. Please carry on, ma'am.
am I audible, ma'am?
Yes, ma'am. You are.
Thank you very much, ma'am, for the nice introduction. I am going to introduce my branch of orbit and oculoplasty, which is a subspecialty of ophthalmology concerned with repair and reconstruction of congenital, acquired, ocular, periocular defects and deformities. And we are dealing with various congenital deformities around eye, eyelid reconstructions, orbital injuries, orbital inflammations and infections, orbital tumors, socket reconstructions, and finally lacrimal surgeries. And we are also dealing with various other branches of medicine, like regularly with orbital radiology, orbital pathology and microbiology, Department of ENT, neurosurgery, and Department of Plastic and Facial Maxillary Surgeries, oncologists, finally anesthesiologists, we are regularly in touch. Also pediatricians and endocrinologists and various other departments we are in regular touch, unlike of other branches of ophthalmology, where the touch with other branches of medicine are very rare. So ours is a rainbow in ophthalmology, dealing with every other branch of medicine. See, this is the orbit, which is a pyramidal structure having so many types of tissues inside: nerves, vessels, lymphoid tissues, tendons, ligaments, and muscles, fat, and eyeball, and all the structures are having so many pathological issues in the orbit, and we deal with all these things. Other than inside the eye, the diseases inside the eye are excluded from our branch. Coming to the congenital, orbital, and periocular defects and deformities, eye can be anophthalmic either unilaterally or bilaterally. The children are born with this severe deformity, or microophthalmic cysts, and anophthalmology bilaterally with microophthalmos, or cryptophthalmos. You can see here in this picture, one side the lids are covered, the eyeball inside, and these can be repaired by doing the lid surgery. Here the bilateral cryptophthalmos, you can see another case of cryptophthalmos where the eyeball is totally covered. Here it is partially covered. These are the cases of eyelid colobomas, congenital eyelid colobomas, where the coloboma is congenital, having this corneal exposure already with corneal scar tissue formed already. But before that, if we can repair the thing, here you can see the case repaired nicely with pedicle graft from the lower lid, and thereby we can save the cornea. Here is another case of bilateral microophthalmos, where repaired with artificial eyes. But when we are placing the artificial eye, normal socket is like this, and with the microophthalmos, the socket is constricted already. So we need to expand the socket by regular expansions with the expanding materials and then place the artificial eye. Coming to the congenital dacrocele, these newborns have a distended lacrimal sac from the collected amniotic fluid. So these can be spontaneously cured so that we can wait, or sometimes we need to tap the thing before it gets infected. So other cases where there is dacrocystocele or congenital dacrocystitis having this lacrimal abscess and periocular infection and cellulitis and periorbital cellulitis results, sometimes leading to the orbital cellulitis, and sometimes intracranial extension also can be seen with this infection. So prompt intervention is needed in such cases, admission and with antibiotic, broad spectrum antibiotic therapy. And here you can see that if there is a child coming with a complaint of watering and discharge, we need to put our finger over this lacrimal sac area, press over this area, we can see the pus oozing. This itself indicates that there is nasolacrimal duct blockage, so that we need to do some probing after 6 months of age. First 6 months, we can wait for spontaneous opening with massage in this area and antibiotic drops. But after 6 months, we need to do the probing under short GA so that 1 or 2 probings can cure the condition if it is membranous obstruction at the nasolacrimal duct level. But if it is bony obstruction, we need to wait up to 2 to 2.5 years age and do the DCR, external DCR, and cure the condition. Here you can see how the probe is passed to the nasolacrimal duct. A simple procedure. Within 2 to 3 minutes, we can finish this procedure under short GA. And here you can see that vertical incision of lacrimal dilator, and then vertical incision of lacrimal probe, and then pass it horizontally to the lacrimal sac area. If we feel hard stop, it means that we already entered the lacrimal sac, and we can proceed with again vertical descent to open the nasolacrimal duct. But if you see this, there is a soft stop, means that there is some obstruction in the canalicula area, so that we need not continue the procedure. We need to do canalicula DCR in such cases. So coming to the other conditions in the children, congenital entropion with trichiasis and dystrichiasis are very common. Congenital ectropion, you can see here, either unilateral or bilateral. And ptosis is another common condition we see in the childhood, either unilateral or bilateral, or sometimes associated with blepharophimosis syndrome with epicanthal folds here. And this is the post-op case of blepharophimosis syndrome. As early as possible, we need to do the ptosis surgery if it is partial or near total ptosis or total ptosis, to avoid the amblyopia or permanent blindness in the eye. So even today, many pediatricians and other general ophthalmologists are advising no need for surgery in the early childhood, but it is wrong. We need to do the surgery as early as possible. If the ptosis is severe like this, the patients go into the amblyopia stage, permanent loss of vision, and the eye becomes lazy. So we did the surgery as early as 4 to 6 months age also, when there is total ptosis. And these are the pre and post-operative pictures of the ptosis surgery done. Another case of pre and post-operative ptosis surgery. Basically, our aim in the pediatric ptosis surgery is to lift the lid above the pupillary level so that the patient can see and develop the eye nerves and preventing the amblyopia. Here you can see the bilateral ptosis with the post-op result. Another case with post-op result. This is the early small child, 5 months age. We did the surgery, and nicely this is 8 years old girl. The post-op result is very good. The earlier, the better the surgery. Frontal sling surgery is required in many of the congenital ptosis cases. And coming to the trauma, ocular and periocular orbital defects and deformities after the trauma. So usually we see this type of injuries, the total lid injuries, or lid lacerations and bilateral upper and lower lid lacerations, immediate suturing being done to prevent the hemorrhagic problems. Here the another case of lower lid completely lacerated out, repaired properly with immediate suturing. If you don't suture properly, and this is the result, there is a cicatricial ectropion is formed here with a lack of thymus and corneal exposure will be there. So we need to repair it properly in 3-layer suturing. 3-layer suturing, first layer is to the tarsal plate, figure of 8 suturing, and then 2 other layers from the lid margin, and all the edges of these sutures should be brought out to prevent the touch to the cornea and damage to the cornea postoperatively. So this is how the lower lid laceration being repaired with 3-layer suturing. This is a late case with a ectropion repaired properly with the 3-layered suturing. This is another case where there is cicatricial ectropion because of the scar here at the lateral canthus, repaired with small skin grafting here. Sometimes the skin grafting is required, a bigger skin grafting is required like this. Usually the skin graft is taken from the retroauricular area and it is placed over the lower lid or upper lid to replace the volume loss. This is a very interesting case, and most of the pediatricians, they may be seeing this case. Baby is brought with lower lid torn out because of a blouse hook injury. While feeding the baby, mother's blouse hook torn the lower lid. But unfortunately, this laceration involving the lower canaliculus also and lower punctum also. So we need to suture meticulously by placing the punctal silicone tubes, so that the repair should be done properly to prevent the post-op epiphora, lifelong epiphora we need to prevent. Coming to the infections and inflammations, usually the commonest inflammation is thyroid orbitopathy, pseudotumors, orbital abscess, mucocele from the PNS, and orbital granulomas like a tuberculous, fungal, foreign body or parasitic granulomas. And here you can see that there is preseptal cellulitis case. Here it is both upper and lower lid is involved. Here it is gone to orbital cellulitis, where the orbital tissues and the optic nerve is involved, and with exposure keratitis and cornea also got involved. And here is a case of mucocele of the ethmoidal area and completely drained. This became normal after drainage. This is a lower lid abscess in this area, normal drainage done. And this is the post-op picture. And this is a case of preseptal cellulitis due to a lacrimal infection, lacrimal sac infection, properly treated with the medical treatment. And this is the post-treatment picture. And coming to the other cyst in this area, here the orbital cyst is formed here. And if the cyst is behind the eyeball, there is proptosis. Extrinsic proptosis shows that the site of the cyst, here another case of a unilateral proptosis. So these cysts should be evaluated properly. This is the orbital ultrasonography, colored Doppler orbital ultrasonography. Here you can very well see the cyst. Inside the cyst there is a scolex. This is the cysticercosis cyst of the orbital area. Here you can see another case with a cystic area with the scolex inside, very typical of the orbital cysticercosis. Sometimes it is associated with muscles also, myositis. So orbital myositis indicates that there is a pseudotumor or maybe a cysticercosis. If you see the CT scan picture, you can see the well-defined cyst in the orbital area with a scolex also seen inside. Another case in the superior rectus area, a cyst is formed. Another case in the medial rectus area, the cystic lesion is involving the medial rectus. Here you can see another case with superior rectus area. There is a cystic with inside the cyst, there is a very clearly seen scolex is there. very typical of orbital cysticercosis. Another case, and this is the neurocysticercosis. Intracranial cysticercosis are there. Always we should exclude this condition when we suspect the orbital cysticercosis. So normal medical management is with albendazole, 15 milligram per kg per day for 21 days, along with the systemic steroids and supportive treatment. Usually they become normal. See, the proptosis here became normal with the treatment. Another, if the cyst is very anterior under the conjunctiva in the lower lid, we need to excise completely without subjecting the case for the medical management only. But post-operatively, the treatment should be continued at least for 31 days. See, these are the other cases with orbital cysticercosis, a very common condition. Surgical management only when medical treatment fails or anteriorly located cysts. And complications of surgery is, if you don't do meticulously, the rupture of cysts and damage to the extraocular muscles causing squint in the post-operative period. So neatly you can remove the cyst if you do meticulous surgery. This is very interesting. It is developed, it is a larva of Taenia solium, intestinal tapeworm, forming the cysticercosis cellulose at various places. Eye is one of the favorite place for them. And this is where we need the pathologist help to diagnose it properly. And this is the life cycle. Usually pig man is the adult worm life cycle, but cysticercosis is man to man. So it is usually contaminated water, contaminated vegetables, etc. So it is more of a vegetarian disease than non-vegetarian disease, unlike the popular belief that it is a pig-borne disease. And these are the other cases where we managed with surgical treatment of cysticercosis. Here also you can see the cases with pre-treatment and post-treatment pictures. Here the cyst is removed nicely without damaging any of the ocular tissues. And coming to the bilateral exophthalmos, the commonest condition is thyroid orbitopathy, hypo, euthyroid. All these conditions can cause thyroid orbitopathy because the orbitopathy is because of the antibodies formed against the thyroid involving the ocular tissues. That is the reason, not because of the hormonal status. Here you can see that CT picture showing that all the muscles are enlarged and causing this proptosis inside. The fat also got enlarged because of the lymphocytic infiltration. These are the cases where we treated them with steroid in proper doses, proper period. So they become normal usually, but regular follow-up is needed. And there are so many signs and symptoms of thyroid orbitopathy. Dry eyes and exposure keratitis is the worst condition. Here you can see the patient lost the eye because of the extreme proptosis and dryness of the eye and exposure of the cornea. So such cases we need to do the lateral torsography. Here bilateral lateral torsography was done, joining the lids, so that at least the eyeball can be protected till that proptosis becomes normal with steroid treatment. So in extreme cases, we need to do the orbital decompression, either unival or bival, that is lateral and inferior walls. Usually we choose because avoiding the medial wall, and very rarely we go to the superior wall. These are the orbital decompression surgery results pre and post-operative. This is a case of HIV infection with a severe infection around the eye. You can see the various lesions of the HIV infection. And now coming to the eyelid malformations, commonest is this entropion, lower lid entropion or upper lid entropion, or both lids entropion with interning of the eyelashes, that is trichiasis, or extra row of eyelashes, abnormal row is distichiasis. These are the post-operative pictures. Senile entropion is very common condition because of the laxity of the lids. See, here you can see again the pre and post-operative case of entropion. Another here down here you can see the ectropion The same surgery can be done for both entropion and ectropion at the lateral canthal canthoplasty, which is called universal surgery. I named the surgery as universal surgery, and I did many cases with successful results. And coming to the lacrimal disorders, lacrimal sac infections and nasolacrimal duct obstructions are very common. It is the second commonest condition in ophthalmology other than cataracts. So we need to exclude the nasolacrimal duct block before cataract surgery. Simple. We need not do the syringing also. This test is called Roplus test, where you need to press the lacrimal sac area with your finger. You can see the pus and lacrimal discharges coming out. This shows that proximal pathway is normal, and that nasolacrimal duct is blocked. So we need not confirm it with syringing test. You can straight away take the patient for DCR surgery. These are the cases where the lacrimal sac is already developed into mucocele. Huge mucoceles are formed, but we need to exclude any malignancy in such cases by taking out the lacrimal sac for histopathological examination. Here is a case of lacrimal sac abscess in a small child. We need to drain completely and then do the probing, and then if requires at later age DCR surgery. Nowadays the DCR surgery, endonasal DCR is getting popularity, saying that there won't be any scar in this area. There's the only advantage there, and the simple surgery they say, but the failure rate is very high. Only 80 to 85% only success rate with the endonasal DCRs. But our external DCR is almost 99 to 100% success rate, and the scar is minimized by meticulous suturing. Here you can see you don't see any scar after 6 months. You have to search for the scar in our external DCRs, and our success rate is very high, nearly 100%. We need not repeat the surgery also. So here you can see the post-op DCR cases. So coming to the eyelid neoplasms, so various mass lesions are affecting the eyelid, starting from the chalazion or viral warts, or if there is any granulomas forming here, either lateral canthus or medial canthus, and whole lid is involved in case of capillary hemangiomas. Here you can see, but capillary hemangioma is a self-resolving condition. Within 6 months to 1 year, it completely resolves. We need not do anything, or intralesional injections can be given, and so that it can reduce in size and to prevent the amblyopia. And here the intralesional injection being given in capillary hemangioma, this is the mass reduced and amblyopia is prevented. Sometimes we require to do surgery. This is another case of capillary cavernous combination hemangioma. I did surgery, and this is a result post-op. And another case where surgery is required in cavernous capillary hemangioma combination in child. So coming to other lesions, this is a lesion kissing nevus. The both upper lid and lower lid is having nevus, and which is touching each other. So this is a condition which can be easily repaired. This is a case of rodent ulcer, where this medial canthus is involved, basal cell carcinoma. This is squamous cell carcinoma here, lateral canthus. It is repaired completely, removed and repaired completely here in the lateral canthus. And this is the meibomian cell carcinoma from the upper lid, hanging from the upper lid. And this is repaired with a cutted weir surgery, that is lid sharing technique. And this is another case of meibomian carcinoma, repaired completely with proper suturing. These are the other cases where the malignant lesions are being repaired properly by selecting the proper surgery. Coming to the orbital neoplasms, the proptosis can be axial, eccentric, unilateral, bilateral, recurrent, progressive, pulsatile, reducible, intermittent, painful, or painless. So exophthalmetry is the common thing we do. Other blood tests and microbiology tests and radiological and ultrasonography, FNAC, all these things help us to diagnose properly. This is the exophthalmetric reading of proptosis. And depending on the mass lesion, vision loss, extraocular mobility, and associations with other CNS and ENT associations, systemic disorders. We have to divide the orbital tumors into congenital, infantile, childhood, adult onset, and inflammatory, infectious, neoplasms, and primary, secondary, benign, malignant. So many classifications are there. Many congenital, developmental are meningoceles, encephaloceles, microphthalmos vicis, dermoid, epidermoid, teratoma, capillary hemangioma, lymphangioma, eosinophil granulomas. This is the dermoid cyst in the lateral canthal area. These are the neurofibromatosis with involving multiple neurofibroma lesions all over the body. And coming to the hemangiomas, lymphangiomas, vascular meningiomas, neurofibromas, gliomas, schwannomas, which are neural, histiocytomas, fibrous osseous tumors, lacrimal gland tumors. All these things can be seen in the orbit. So here is a case of hemangioma of orbit. This is the post-op picture after lateral orbitotomy was done and removed the tumor properly, restoring the vision. You see the hemangioma occupying the retrobulbar area. These are the other CT pictures. See, you can see here that glioma with the axial proptosis, where the vision is lost in such cases, but we can do the surgery for the cosmetic purpose. Coming to the malignancies in the childhood, rhabdomyosarcoma is very common. Hemangiopericytoma, you can see this huge tumor occupying the entire orbit and pushing the eyeball out, and we need to remove the tumor. In such cases, we cannot save the vision and eyeball, but this is the CT picture of the huge tumor, almost size of a small coconut. And coming to the other neoplasms extending from the neighboring area, either maxillary carcinomas or ethmoidal tumors into the orbit. Here is an ethmoidal mucocele extending into the orbit. See how it is occupying entire area. We can drain this, but with the help of ENT surgeons, we can do it properly. This is the post-op condition of the after drainage. Coming to the malignancy in the pediatric age group, Ewing sarcoma and nephroblastoma, neuroblastomas. Here is a case of nephroblastoma with how the orbit is completely destroyed with secondaries in the chest picture. Adult onset tumors are again leukemias and neuroblastoma lymphomas, and all the things can be seen in the adult. Commonest is from the secondary deposits from lung and breast cancers. These are the secondary deposit from breast cancer. Other secondary deposits, and lateral orbitotomy is the answer for all these things. Coming last topic is socket reconstruction. This is the final topic. So where after removing the eyeball, what we do is reconstruction with the artificial eye. See how best we can reconstruct. See, these are the pre and post-operative cases of eyeball removal and reconstruction. Various implants can be used. You can see that dermis fat grafting being done here with the proper implantation. Yeah, we don't do proper surgery. This is the end result. So meticulous surgery is the answer for all these cases. So these are the results. Thank you very much. I think I have given a brief introduction about my favorite topic, orbit and oculoplasty. And if there are any doubts, you can ask me. And regarding this branch, this is only introduction. There is so much to learn from this branch of orbit and oculoplasty. I'm thanking Dr. Phanindra for giving me this opportunity. And also I'm thanking IMA for giving me this opportunity to speak in front of you, share my experiences. Thank you very much.
Thank you, ma'am. Ma'am, Dr. Vishwamitra, ma'am, do we have you here? Dr. P. Vishwamitra, ma'am, have you joined? Please respond.
I think we are not having Dr. Vishwamitra madam here. Thank you so much, Madam Sujata, Madam. That was a wonderful spectrum of cases that you have shown us, from congenital to inflammatory, traumatic, neoplastic, whatnot. All the pictures are self-explanatory, Madam. You are a boon and an angel for this part of Andhra Pradesh. You should have, we didn't even know that the excellent work is being done in Andhra Pradesh itself, Madam. Thank you so much, Madam. We have no words to congratulate you for the plethora of work that you have showed. For the cases that there's some questions are there, but I don't think they need to be answered, because wonderfully you have shown. There is a question asking what is the indication for orbital decompression for thyrotoxicosis.
In case of extreme thyrotoxicosis case, where there is corneal exposure is threatened, and also optic nerve stretching and loss of vision is threatened, which is not resolving with the systemic steroid treatment, we need to do the orbital decompression, so that immediately the orbital area is expanded into the neighboring sinuses, like inferiorly into maxillary sinus, medially into ethmoidal sinus, or laterally. We get more space for the ongoing disease. Thyrotoxicosis is an ongoing disease. We need to make more space for the disease. So that is what we do in the orbital
Before
decompression.
papilloedema sets in, we have to undertake the decompression procedure.
Yes,
Thank you, ma'am. We have another question. What is the compare the success rates of external and endonasal DCR?
Still the endonasal DCR is having maximum success rate is 80 to 85%. Our external DCR, which is more than 120 years old surgery, TOTIS procedure it is called, with so many modifications, which I can do in less than 10 minutes. I have done more than 30,000 cases in record in India, entire India, maybe international also. So 30,000 cases I did with 100% success. And there won't be any failure in such cases, and scar also minimized. That is what the comparison I do.
Thank you, ma'am. I have a doubt, ma'am. I have two of my relations, ptosis, late onset ptosis, madam. One around 7 to 10 year old. The other one is after in the teenage. Is there any chance of oculoplasty for these two?
Yes.
Can we advise? One
yes,
is like now almost 20 years past with the ptosis.
Yes, ma'am.
The other one is just a teenager who has developed a ptosis bilateral.
The indications for ptosis surgery is only two types, madam. If the ptosis is too much, that is partial or more partial or total ptosis, which is obstructing the view of the eye, in the early childhood, it can cause amblyopia, that is lazy eye. That will not develop, that eye will not develop throughout the eye if you do surgery later. So the earlier the best, the surgery should be done if the ptosis is involving that visual pathway. But if it is not involving the visual, minimal ptosis, only cosmetic problem, we can wait up to 18 to 20 years age, and we can do it the surgery under local anesthesia with the cooperation of the patient. We need to ask the patient, look up, look down, and do close the eye, and all the things from exact very good cosmetic results. So it can be done after 20 years if it is very minimal ptosis, not having any vision threatening problem. So that is these are the two problems.
Thank you so much, ma'am. We are privileged to have you on board of this Evecon 23, and I'm profusely thankful to Dr. Fanidhar sir for introducing you to us. Thank you so much, ma'am.
Thank you. Thank you very much. Thank you.
Over to Dr. Padmavati, madam, to moderate the next session. Speaker would be Dr. Prasanthi. Dr. Padmavati, madam, are you there?
Yes, yes. Yes.
Please, you carry on, madam.
A very good morning to all of you. I congratulate our women doctors and all the state IMA leaders for organizing this Evecon, today's Evecon. And it's my pleasure to introduce my friend, Dr. Krishna Prasanthi, a good physician from Tirupati. She is president for the AP chapter of Physicians of India. She is a very active IMA member and served as chairperson, AMS Andhra Pradesh, and also an executive member for the National Women Doctors Wing. She is spiritual and is associated with many social organizations. And she's very well known to many through media because of her very good number of awareness programs on health and other diseases. With this, I welcome Dr. Krishna to give her deliberation on insulin. Thank you.
Good morning, everybody. Thank you very much, Dr. Ravi Krishna sir, Dr. Fanidhar sir, for giving this nice opportunity to speak for a wonderful program of Women Doctors Evecon program. I thank Dr. Ramani Madam for very good structuring this scientific schedule, and I was really impressed by my previous speakers, Dr. Lakshmi Saujanya, Dr. Sujata ma'am. Really, how I think we are more than the ISRO scientists, what we are doing now. And really very much impressed by the pics of Dr. Sujata ma'am. I think my session will be something different now. My topic will be pearls in practice for insulin injections usage, because day in and day out, not only for the patients, many of our doctors may be using for our family members also. So I think it would be more appropriate topic to speak on this. So I have no financial disclosure or conflicts of interest with the presented material in this presentation. My flow of presentation will be a brief note on the physiology of insulin secretion, rationale for using insulins, types of insulins, insulin injection techniques, and barriers for insulinization, and few take-home messages. Everybody knows what is how the insulin is getting secreted from the beta cells of the pancreas in continuous and biphasic manner. And it's a polypeptide hormone consisting of A chain with 21 amino acids and B chain 30 amino acids linked together by 2 disulfide bonds. It binds to the insulin receptor on the cells and demonstrates the action on the metabolism as well as the other effects. And insulin is degraded by endocytosis of insulin receptor complex, and subsequent action of enzymes are excreted by the organs liver, the endogenous insulin, and kidney, the exogenous insulin. Each and every letter in these lines represent the future slides. What are the practical implications of this? And if you see that what is the metabolism of the insulin? So insulin acts to the GLUT2 receptors and to the enzyme glucokinase, converts into this glucose 6-phosphate, and the ATP channels, potassium channels are getting closed. Insulin acts on the liver by inhibits the glucose production, promotes the formation of the glycogen and its storage. Insulin acts on the muscle, promotes the uptake and utilization of the glucose, and on the adipose tissue, which promotes the uptake of the glucose and suppresses the lipolysis. And you have to understand one important thing. There is a pulsatile secretion of the insulin. Many of the people may be asking us, why do you want to give 2 times, 3 times? And if you want treating a type 1 diabetic patient, why do you want to give 4 doses of this kind of insulin? This is very, very important because the numbers may vary. The latest ADA says that the fasting plasma glucose should be if less than 126 milligrams per deciliter, and PPBS should be less than 200 milligrams per deciliter. So this pulsatile secretion is very, very important. What is the other important effects of the insulins? Because always we think only the lowering of the blood sugars. When we want to start the insulin for a patient immediately the first answer will be, no, I don't want to take insulin. If it is the insulin, it is a lifelong insulin. When I am only 2 or 3 years old of diabetes, why do you want to start insulin with my 400 blood sugar? And everybody will be facing this kind of questions. But you have to understand that in some clinical situations, we are adding insulins for a cardioprotective, a neuroprotective, anti-apoptotic, and vasodilatation and platelet inhibition mechanism is there. Beta cell rest and improvement in function. This is very, very important. A newly detected diabetic patient comes with a fasting blood sugar of 300, postprandial blood sugar of 400. He is a 25 years old diabetic and he is a newly detected diabetic and his BMI is high. He is having blood pressure of 140/90. I am justified in starting insulin because I want to give the rest to the beta cells and I want to decrease the glucotoxicity, and we have to allow the patient to have the secretion of the insulin. What are the other important effects of the insulins? Antithrombotic, antioxidant, anti-inflammatory. So it's not the glucose lowering effect alone when we are starting an insulin, because many of the times when we start insulin, For some clinical situations, the primary care doctor says that no, you need not use insulin or continue the insulin. Then comes why the need for exogenous insulin. We have to understand that gradually the beta cell mass is reduced in diabetes due to increased apoptosis. So if you can see in these pictures, there are increased numbers of islet associated macrophages detected by immunostaining, and these are the thing. So what are the clinical situations where you want to give the insulin? Well, like a type 1 diabetes, everybody knows we are giving insulin. In type 2 diabetes, when the patient is having not control of a diabetes with a HbA1c of 10, 11, 12, 13, with 3 or 4 all the oral anti-diabetic drugs, in spite of that, the patient is not getting good control, you are justified in starting the insulin. The other thing is the gestational diabetes or the pre-gestational diabetes or the hyperglycemia in pregnancy. Many of the gynecologists may be having and we had a debate also that whether we can continue the metformin. Why do you want to use the insulin if the metformin is there? But there are so many trials that you are justified in giving the insulin because that is the best drug which is approved. Then comes the hyperglycemic emergencies like diabetic ketoacidosis or hyperosmolar or coma. And in the physiological stress, if you are planning for any surgery, elective surgery or emergency surgery or any road traffic accidents or anything, you are justified in starting the insulins. And in any infections, a complicated urinary tract infections or a severe respiratory infections or a skin and soft tissue infections or a gangrene, you are justified in starting the insulin. When the patient is not able to take orally, when the patient is taking only the parenteral nutrition, when the patient is admitted in ICUs, you should give insulin. And when the patient is having a diabetes of a progressive complications like nephropathy, neuropathy, particularly the retinopathy, definitely insulin is going to be helpful. And all the patients of the CKD or a chronic renal failure or a AKI on a CKD, you should start insulin. Then comes why early insulinization? Because you may start insulin after 10 to 15 years of diabetic. You may start insulin once the patient had a severe proliferative retinopathy. You may start insulin when the creatinine is 2.5. No, we don't want that kind of situations because insulin is the most effective and powerful glucose lowering agent. Insulin induces temporary remission of the diabetes. What you are seeing in the advertisements of a cure for diabetes, remission for diabetes, reversal of the diabetes is we have good number of patients on the de novo diabetic patients. You start insulin, you decrease the glucotoxicity, body starts producing the insulin. For 3 to 4 years, patients need not have any treatment. And early insulin therapy in newly diagnosed type 2 diabetes patients, favorable outcomes on recovery and maintenance of the beta cell function, reduced effects of the glucotoxicity and lipotoxicity, improves both insulin sensitivity and insulin secretion. Short-term insulin treatment in a newly detected diabetic may have long-lasting effects when introduced in the early stages of type 2 diabetes. When used appropriately, near normal glycemia, what happens is because of inappropriate dose for an inappropriate patient not by a right doctor, not for a right patient. If you start 10 to 20 units of insulin, a patient experiences a hypoglycemic episode, he will never take insulin. Beware of that, and you should know when to give, how to give, why to give, and which dose you have to give. So we want to decrease the blood sugars, but it should not have a hypoglycemic. And we want to decrease the HbA1c levels. We want to decrease as the complications. When there are so many anti-diabetic drugs, why do you want to prefer the insulin? Because they have been observing that the percentage of reduction of blood sugars and the HbA1c is more with the insulin than you compare with the anti-diabetic drugs. So the patient with metformin and you compare with the sulfonylureas, the percentage of HbA1c reduction is less when you compare with the insulin. Then you may be asking a doubt. When you have a combination of sulfonylurea with metformin, when you have a combination of DPP4 inhibitors and SGLT2 inhibitors, the percentage of reduction is still less, but not when compared with the insulin level. So you have to understand that insulin delivers superior glucose reductions when compared to other agents. One important point you have to understand is the metabolic memory. Metabolic memory means, for example, today I have been diagnosed as diabetes and my blood sugar is 300. And if I am not given adequate, appropriate, correct doses of therapy, and if my body is exposed to this high blood sugar for at least 3 to 6 months or 7 months, your body will be recognizing this 300 blood sugar for a longer period. After 6 months, after 8 months, if your blood sugar is coming down, but your cells will have this metabolic memory, and it is very difficult for you to have the long-term benefits of this control. So type 2 diabetes is characterized by early progressive insulin deficiency. No oral therapy alters the decline in beta cell function. Mind you, I have to remind you that by the time you are diagnosed as diabetic, more than 50% of your beta cell function is lost. So today you are detected as diabetic. You may be having a pre-diabetic phase for more than 6 to 8 years prior to the diagnosis of the diabetes. So poor glycemic control is an important driver for diabetes complications. So early insulinization is a physiological intelligent decision, practically not possible, not accepted by the patients, and definitely it is not going to have the better thing. So now comes when to start in the insulin, which insulin you have to start, and what we need to understand. This was a conventional stepwise approach, like when you are detected as a diabetic, a diet, lifestyle modification, add metformin, then you add a sulfonylurea. Now you are having an armamentarium of a combination of DPP-4 inhibitors, SGLT2 inhibitors. Now every cardiologist, every nephrologist, everybody is claiming that SGLT2 is a miracle drug. You need not go for insulin. These are all the things how we were practicing all these days. But the stepwise strategy can delay the patients in achieving the goals and increasing the complications. So you can't wait for 3 to 4 years to start insulin in some patients. When the patient is coming with 600 blood sugar, with a HbA1c of 15, the patient is having blood pressure of 200 by 100. The patient is 90 kilos weight, a 30 years old gentleman, and patient doesn't want to have insulin. I want to use DPP-4. I want to use SGLT2. Are you justified? Yes, you have to give an explanation to the patient that these are all the possibilities, these are all the disadvantages, these are all the advantages. I am justified in starting the insulin, because not only for the patient, you have to know where exactly you stand. And I'm not going in the history of the insulins, where the discovery started in 1921. Now we almost crossed 1 or 2 years of the discovery of insulin. So many insulins were there based on the duration of action, action on the plasma glucose levels, based on the source, amino acid sequence, and the strength of the preparation. But for the practical purposes, all the senior doctors, senior clinicians, senior primary care physicians might have an experience on the bovine insulin and porcine insulin. At the initial days of my postgraduate days, we had this experience, but now we are not used to it. Now we are only in the market dealing with the human insulins obtained from the microorganisms, now using the recombinant DNA technologies. These are all the most common insulins in our practice. Then comes, what are the regular insulins? What are the analog insulins? So these are the regular human insulins, which are identical to the insulin produced in the human body in terms of the amino acid sequence, like a short-acting insulins, what you routinely call soluble insulins, like some companies like Actapid, Insugen R, or Humulin R, or combinations. The intermediate acting insulin was there, like a NPH insulin, neutral protamine head-on insulin. The action was there around for 8 to 10 hours. And that was the time which was during the intermediate acting insulins. Now we have the analogs insulins. These are identical to the insulin produced in the human body, but with a different amino acid sequence. So we have A chain and B chain with an amino acid. So the interposition of the amino acids do occur. Now we are having the rapid acting insulins, the short acting insulins, insulin aspart, insulin disflow, insulin glulisine, where in emergencies, you need not wait for an half an hour. You can like an executive insulins. The long-acting insulins are there, where the duration has been extended to 18 hours, 20 hours, 24 hours, like an insulin glargine and insulin detima. Based on the action on the plasma glucose levels, because we have discussed in the physiology that there is a pulsatile secretion of the insulin and there is a basal secretion of the insulin will be there. So continuously, patient will need to have a supplementation of the basal insulins, which will be controlling the blood glucose levels in between the meals and in the overnight. You see in our clinical practice, my postprandial sugars are getting controlled with my oral anti-diabetic drugs, but always my fasting blood sugar is coming around 130, 140, 150. It's not coming down in spite of my metformin, in spite of the drugs. So these are the patients where we can use the basal insulins. The bolus insulins, like my fasting sugar is always normal, but once I take my meal, it comes around 200, 190, 220. Whatever medication I am taking, these are the things. This you see mostly in the hyperglycemia in pregnancy. When you check the 1 hour postprandial glucose, the pregnant woman may be having 160, 180, 200, and definitely you need a bolus insulins. These are the short-acting insulins. Based on the strength of the preparation, 40 IU insulin, 100 IU insulin. This is very, very important in our practice. When the patient is taking with an insulin vial and syringe, the 40 IU insulin should be matched with the 40 IU syringe, because many patients coming from the UAE countries like Kuwait, Dubai and everything, or US, they are getting the 100 IU insulin. If the syringes are over, they are buying here 40 IU syringes. So it is the responsibility of the practicing physician to check what is the type of the insulin, 40 IU or 100 IU insulin, the syringes are matching or not. This is very, very important. So the evolution, we have seen all these things what we discussed, but in future, you may be having a once a week insulin or a very long acting insulin. All these are progress. Why I want to keep this figure is, whenever patient wants to say that, is this a new drug? I don't want to take insulin. Once I take insulin, you have any side effects or not? I tell the patient, this is a time-tested molecule. It is there in the market for more than 100 years. Metformin is there for more than 60 years. So you have to understand that I am writing an insulin. I know what is the expected side effect. I know what is the precaution I have to given. I know what is the hypoglycemic risk I have to tell for a CKD patient. So you should be confident enough when you are writing a prescription to the patient, when you are writing an insulin. Patient will be having so many doubts and talking to us, but the treating doctor should be very, very confident. So in a nutshell, rapid acting insulins, the onset of action will be starting within 15 minutes, peaks within 1 hour. The duration may be 2 to 4 hours, glulisine, Lispro, and Aspart. If you take a regular insulin, the onset of action is 30 minutes, peaks to 2 to 3 hours. It will be there for 3 to 6 hours. Normally, it will be giving for 8-hourly insulin. The intermediate acting insulin, the onset of action is 2 to 4. The peak is around 4 to 12 hours. The duration is 12 to 8 hours. Still, we use this. And the long-acting insulins, 24 hours, 16 to 18 hours is the minimum guarantee period where you can have the Glargine, Levima, Degludec insulins, the very good basal insulins we have been using for more than 2 decades. Definitely patients are having. If you understand this figure, that itself is very, very important, like that, how you will be having the peak of action, rapid, the short acting, intermediate acting, long acting, and an ultra long acting. So whenever you want to have a patient with which type of insulin you want to give, depending on your blood sugars, these days patients are coming with, I am having HbA1c of 8, you treat. What is the fasting? What is the postprandial? Which time I have to give the which drug? Patients think that this is sufficient for us, but always be sticking on to your protocol and guidelines, you will be safe. Then comes, what is the for paying the right balance? One thing is the basal insulin therapy, the other is the basal bolus therapy, the other is the prefix. Normally, a long-standing type 2 diabetic patient is on 2 to 3 oral anti-diabetic drugs. When you want to add an insulin, I will add a basal insulin, which will be at a bedtime, and this will be giving. Whenever I start a basal insulin, the next immediate question is, Madam, if you are starting insulin, you want to stop all these drugs? No, I want to add on basal insulin therapy so that this insulin will make all your anti-diabetic drugs to affect functionally. So then comes the basal bolus therapy, like type 1 diabetic, pregnant diabetic, brittle diabetic, a very complicated patient. So these times you require multiple insulin injections, but the main thing is the hypoglycemia and weight gain. But unless patient doesn't understand patient should have a self-monitoring of the blood glucose. We will not be successful with this kind. So the other comes the pre-mixed insulins like a Mixtard or other 30/70 or 50/70, which is patient friendly, patient convenient. When you are in a very safe zone, you can offer this kind of premix and co-formulations. You can easily teach the patient, very simple to the patient. Compliance is also very good, and patient will give even a disposable pen for him initially to understand it, and when a single prick, very small prick, very painless prick, then definitely patients start getting motivated for insulinization. So always the HbA1c is more than 9%, start a basal plus insulin. If the patient is having high HbA1c of 7 to 9%, depending on the comorbid conditions, depending on the duration of the diabetes, you can start the basal insulin. What are all the various insulin regimens? Basal supported oral therapy, basal plus insulin therapy, once a day or twice a day premixed therapy, basal bolus insulin therapy, intravenous insulin therapy in hyperglycemic emergencies. So I'm not going in detail, but I want to give information about the latest insulins like that. What is that? The insulin Lispro insulin, and there is no difference in kinetics with the normal Lispro, and the concentrated insulins are there. So the half-life of the insulin is 1 hour. So the duration of action is 3 hours. Now the latest insulins are pegylated insulins and Lispro. That means a short-acting insulin is converted like a long-acting insulins. Now, normally we see 40 IU per ml or 100 IU per ml. Now we are seeing 200 IU per ml and 500 IU per insulin. So what is this advantages is, if you are giving high doses of bolus insulin, then definitely concentrated insulins can be given. Then comes the concentrated basal insulins like glargine insulin. Normally you call the Lantus insulin. This is the latest Tosio insulin, 300 units insulin. For example, you want to give 30 to 40 units of basal insulin at bedtime. So that much of quantity patient feels like that. You can use this concentrated insulin where only 20 units or 50 units of concentrated insulin can be given. The pharmacokinetics and the pharmacodynamics are different. The other thing is the other degludec insulin, the ultra long acting insulin. So where the extended mechanism of action is expected up to 42 hours, though we say the half-life is 25 hours, but the steady state, for example, if the patient misses 1 day insulin or the alternate day insulin, definitely this kind of concentrated insulins are useful. The other important thing is the insulin injection techniques. I am not going in detail about what are all the various companies. This is only a bird's eye view and the practice pearls that insulins are there. Why you want to give the early insulinization? And most important thing is there are short-acting insulins, regular insulins, bolus insulins. There are long-acting insulins and basal insulins. But in our practice, what is more important is you should understand the insulin injection techniques. When you ask the patient to go for take an insulin, the first thing is patient says that I know I cannot take and I'm afraid of an insulin. I'm afraid of a prick. I'm afraid of an injection. But when you were telling to a rheumatoid arthritis patient or a vision decreasing patient, and patient is an elderly patient, patient is a dementia patient, patient is unable to understand understand what we are telling, patient is a stroke patient or a paralysis patient, all these factors makes lot of role in our management, because injection technique is highly variable, operator dependent, a right-handed or a left-handed person is very important. So many misconceptions in the society about the insulin is there, health literacy, numeracy, fear of pain, financial constraints, and always appropriate injection technique is crucial for success of insulin therapy. What I have told earlier, this is a very, very important for all the primary care physicians, even in the government sector. You should understand, check the insulin syringe, check the numbers, 40 IU or 100 IU, and what is the insulin you have prescribed, and is it matching or not. So this is very, very important, because if you are giving a 40 IU and 100 IU, reversal is there, the dose is mismatched. Sometimes the patient is going for a hypoglycemia. So another thing is, patient doesn't want to have a insulin and thing, we can advise as the devices like insulin pens can be given. But now the government of Andhra Pradesh is giving insulin vials in all the primary care structures where they are getting the free insulins. And we have to make the patient to understand that how to take insulin correct. This is very, very important. The lifting of skin fold matters a lot. It should not be intradermal. It should not be intramuscular. It should be in the subcutaneous. I repeat, it should not be the intradermal. It should not be the intramuscular. It should be in the subcutaneous. If it is a fat, obese, chunk person, you are safe. If it is a lean person, a type 1 diabetic or emaciated, where the subcutaneous fat is very less, it is very difficult for you to lift the skin fold. That is very, very important. And the most important thing is the rotation of the sides. Always we tell the patient to take on the abdomen. That is the best thing. But for a gestational diabetic or a pregnant diabetic, patients are afraid to take on the abdomen. We ask them to take on the lateral side of the thighs. In spite of our repeated telling, patient comes on the, saying that they are taking on the medial side of the thighs, where there is a high vasculature. Patient is taking the intramuscular, patient will come with lots and lots of problems. So the site of injection, rotation of the site, always check the site of the insulin injection when a patient is coming for your visit, because each and every day patient will teach you a good lesson for you. So rotation may be abdomen, eyes, buttocks, backs and upper arms. But always we say that abdomen is the best, where the absorption of the insulin is very good. But this is the thing where orthodox communities are there, where they are taking insulin from the third person, where they are unable to take. For example, extensive tinea corporis is there on abdomen. Extensive fungal infections are there, or a herpes is there. We don't ask them to take on the abdomen. So alternative sites of the insulin injection you have to understand. And one most important thing is a right-handed person, a self-taking person, always keep on only one single side. That causes the lipohypertrophy. So always the patient says that I'm taking insulin, why my blood sugars are not coming down? You have to check the insulin injection technique, systemic rotation policy, and taking of the skin fold, and they should not massage like a normal injection site. That is a very, very important. So always advise the patient to take the insulin injection correctly with us following a rotation technique. So the value of experience is not seeing, but seeing in wisely. So talk to the patient. He is a good teacher for you. And most important is the insulin storage recommendations, because unopened insulin vial can be stored at 2 degrees to 8 degrees. Normally we say them in the fridge door is never freeze the insulin. You should not keep in the deep freeze. You should not keep in the sunlight exposures. And patient says that I'm not having fridge. The official RSSDA recommendation says that you can use an earthen pot, matti kunda. So what they can keep is 3/4 of the vial can be kept in the earthen pot with a filled of water. And you can keep it for 20 days also, it's okay. The temperature can be maintained. So always when the patient is unable to refrigerate, he should not buy more insulin vials. Let him have from the pharmacy one after the other, so that if the insulin is exposed to direct sunlight or a heat, the viability is lost, the efficacy is lost. The patient may thinking he is taking insulin, he will not have the benefits of the insulin. Then comes, this is a very important thing. I have seen in my own colleagues that there are so many myths about insulinization. Patient barriers are there, physician barriers are there. Physician barriers, when I start insulin, patient may change the doctor. I may lose the patient. So I don't want to tell the patient. This is for most of the young doctors. Excess weight gain, excess hypoglycemia, overweight patient says, I don't want to have insulin. Patient will not come back to you. And if you are giving a wrong dose, hypoglycemia may occur. And lack of resources, you are not having enough time to explain about the insulin. You should train your staff, like with the diabetes educators. Patient says that, doctor, I don't want to have insulin. So you are unable to convince for the patient. Patient barriers in any family. If an elderly patient takes the insulin, if a kidney patient takes the insulin, if a dialysis patient takes the insulin, patient thinks that is the end stage. So never patient accepts the insulin in the first visit. So negative impact on the social life, job, marriages, divorces, so many things are there, social issues are there, we have to understand. So each and every patient is a different thing. Tailor-made prescription is very, very important. Don't threaten the patient. I will give insulin if your sugars are not coming down. Tell the patient, you may require insulin. Be prepared for it. Accept it. The way you convince to the patient matters a lot. So make a behavioral changes recommendations. Keep things flexible and simple, and don't complicate the regimes and everything. Devices, if they are affordable, is very, very comfortable. So always tackle the injection phobias, educate the patients, emphasize the importance of starting an insulin to the patient, and do not use insulin past the expiry date, because when they are going to the America, 6 months they buy the insulins and they will not see that they will get, I'm having so many insulins in reserve. So they don't store at the adequate temperatures. And once you are removing from the fridge, ensure that it should come to the room temperature by rolling down. And if the insulin is having any discoloration or particles are there, don't use that insulin. Always believe in yourself that insulin is a lifesaver. The new promising futures are once a week insulin. Active Icodoc is coming down. It is in the pipeline, we are seeing. And already the inhaled insulins came into the market and left. Oral insulin, nasal insulin, buccal insulins, transdermal insulins, intraperitoneal insulins. Patient may be having all the internet knowledge. Many patients are there on the insulin pumps. The future is for glucose responsive insulin. A designer insulin is coming there in future, not yet. So always understand what is the past, what is the future, talk to the patient, go to the community, increase the importance of the educating the patients, talk to the patients in a large numbers, they will understand. Once again, I thank all my teachers who taught me the clinical medicine, and to all my patients who made me to understand the clinical medicine day in and day out. Thank you very much for your patient hearing.
Thank you, Krishnashanti. It's a very good presentation explaining the need of insulin beyond glycemic control. And whatever it is a prick which every patient is afraid of. And insulin initiation is always delayed from both the patient side and also from the physician side. But with insulin pens, though they are a little bit costly, the training of insulin technique is very easy. And with continuous glucose monitoring, we can explain the pattern, why we are starting insulin, why we are giving it once daily or twice daily or thrice daily. Then we can convince people who can afford at least. So with this, I thank you all.
Madam, two questions are there, madam, in chat box. I'll take up that question. The first question is the brittle diabetes case. What would be the plan of action? Once the brittle diabetes is there, that is a glycemic variability is there. First, you do the AGP and see where exactly the patient is having the hypo and hyper. Then you plan the type of the insulin, either a basal bolus therapy or a oral anti-diabetic drug and a basal insulin, so that we can have a smooth glycemic control. So before planning the therapy, estimating almost the 14 days, the blood sugar levels, and you can get the real way of doing justice to the patient. The second question is the emergence of the gene therapy which can cure of the type 1 diabetes. I have not gone into that part because that is not my topic schedule. But one thing I can tell you, sir, we are going for a gene estimation all these days, not only for type 1 and type 2 diabetes. Almost 16 genes have been identified for an young diabetic, type 1.5 diabetic, type 3 diabetic, or a LADA and a MODI. We are regularly doing the genetic estimation. Gene therapy right now, it's not in the very near future for type 1 diabetes. That much I can say, because type 1 diabetes, the types of genes, the number of genes is a huge number. The HLA mapping is totally different. For a type 2 diabetes, we are getting the genes, but type 1 diabetic, getting the genes identification itself is a problem. The only thing is you can go for a beta cell transplantation or an islet cell transplantation, which may be cured for type 1 diabetes. The new oral anti-diabetic drugs are being tried to be checked in the management of the type 1 diabetes.
Thank you. Thank you, Padmavati madam. Please round up. We call Padmavati madam.
Yeah, yes.
Done. You can round up, madam. We'll call the next.
Yeah,
Yeah.
thank you, madam. Thank you very much.
It's very well presented. I appreciate. And then we'll go on to the next session.
Thank you, ma'am. Now for the next topic, and the moderator we have is Dr. Pavni Priyanka. She's a pediatrician from Tenali. Ma'am, have you joined? Dr. Pavni Priyanka, ma'am.
You announce yourself.
The speaker we have with us is Dr. P. Nagasri Harita, MD DM cardiologist, Aster Ramesh Hospital, Guntur. Dr. Priyanka, ma'am, please introduce our speaker. Our another moderator is Dr. Priyanka Ansuri, MD, physician from Rajahmundry. Ma'am, have you joined?
Good morning, Dr. Nagasri Harita madam. We are very happy to have you here for this Evecon of IMA AP. Please, the board is yours. You can start your topic, ma'am. Recent advances in dyslipidemias. Your time starts now, ma'am.
Dr. Harita, yeah.
Madam, Nagasri Harita madam, are you there with us?
I think we have lost her, ma'am.
What's her name? She's there. She has been there. Madam?
Ma'am, she's not in the Zoom as of now. We have to check with her, ma'am.
Shyam, can you help us out? I could see her.
Yes, ma'am. She was here, but then right now she's not on the Zoom, ma'am. We have to check with her, ma'am. If someone from the team can call her up and then check, ma'am. If thank you.
You just call Nagasri Harita.
It looks she has a problem with the power cut. Not able to.
She seems to have the next speaker. Dr. Shushmita, madam, are you there? Dr. Shushmita?
Dr. Harita is back, ma'am.
She's back? Okay, she can start then.
We are able to see her screen. Yeah.
Madam, can you hear me?
Dr.
Yes, ma'am.
Harita, madam, are you there?
Yes, ma'am.
You can start, ma'am. Thank you.
Can you see the slides, ma'am?
No.
No, ma'am.
I'm there, ma'am.
Actually, we had a power cut, so we could not. 1 second, ma'am.
We are able to see Dr.
Madam, it is shared asthma in pregnancy.
Yes, ma'am.
Yes,
Come slide show more.
Can I share my slides?
They're already shared, I think.
Mastermind pregnancy, we are able to see, ma'am.
We're able to see, just change to the slideshow mode, ma'am. Yes, you can start now.
I think it's better we go ahead with Susmita's presentation, madam.
It's not her.
We are able to see, madam. Please continue.
But it is not her topic.
You change the slide, ma'am.
Can you see it now?
Oh, this is asthma and pregnancy.
Should I stop sharing? Okay.
Yes,
You
yes.
stop
Yeah,
sharing.
oh, now fine.
Sushmita.
Yeah, I stopped sharing now.
Yeah, can you see my slides, madam? Recent advances.
No, just a minute. Let her stop sharing. Sushmita, please stop sharing.
Yeah, I stopped sharing, ma'am.
Still we can see.
No, I have stopped sharing.
Yes.
Yeah.
Ma'am, now you can continue.
Can you see the slides, ma'am?
Yes,
Yeah.
ma'am.
Okay. So I'm extremely sorry for the power cut here we had. So sorry for the delay. So today's topic is on the recent advances in dyslipidemia. So we all know very well, and we are very much confused about what treatment we have to go ahead whenever the patient is having high LDL, and what are the drugs we should give, whether we should give it in primary prevention or in the secondary prevention. So today's topic, I have no conflict of interest, and we know pretty well that LDL is the root cause for the atherosclerosis and the systemic diseases we have. Atherosclerosis, it affects the coronary arteries primarily, and it can lead to acute coronary syndrome. We know very well that it is a stable angina or silent ischemia the patient can present. Madam, can you hear me?
Ma'am, please go ahead, ma'am. Harita, ma'am, doctor.
And it can affect the abdominal aorta, causing aortic occlusion or aortic aneurysms. And in the peripheral arteries, it can present with peripheral arterial occlusion or intermittent claudication of the lower limbs. Apart from even if the patient is having diabetes, hypertension, even if we do a relative risk or an absolute risk marker, LDL is proven to be the cause for atherosclerosis in the arteries. So coming to the atherosclerosis that is there in the carotids and cerebral arteries, it presents as stroke and TIA. Thoracic aorta, frequently nowadays we are seeing so many cases of aortic dissection and aortic rupture with aneurysms. And renal artery occlusion, it is rare. Renal artery stenosis is rare, and it is more because of Takayasu arthritis or any other vasculitis rather than LDL causing renal artery stenosis. And superior mesenteric and inferior mesenteric arteries, definitely yes, we are seeing so many patients with weight loss despite taking adequate food. And these patients present very atypically, and it is the physician's role that we have to diagnose these diseases and treat them early. So LDL is the causative agent, we all know very well. From the epidemiological studies and the observational studies which we do, even in the clinic, when we see a high LDL cholesterol, that patient, when we do a CT coronary angiogram or a CT calcium score, it itself reflects that the patient is having disease. So high LDL cholesterol is the marker, and it is the absolute cause for atherosclerosis. And if we see the genetic analysis or the Mendelian randomization, which I will show you in the next slide, and from the randomized clinical trials also, LDL is the cause for atherosclerosis. So nowadays, this is the slide which shows that the randomization studies which involved around 2 lakh patients shows that there is a significant association with the LDL. And if we lower the LDL cholesterol to less than 0.7, the risk becomes almost equivalent to 0. So these studies are done around 52 years. Studies are there, and randomized control trials, most of them are restricted to only 5 years, wherein you can see that
the patient is having, these are that is shown in the pink line. This is the red line. These are all the randomized control trials, prove it trial, ideal trial. These trials we know well, and these trials show that if we treat the patient and decrease the LDL cholesterol, then the proportional risk of cardiovascular disease is less. So we are treating many of the patients with the statin therapy, but still, if we see these studies, forest study, lipid study and care study, wherein we can see that wherein the statins are given for secondary prevention. In these studies, we can see that there is a significant amount of events. There are significant amount of events that are still persisting even after treatment with statins. So in high risk groups, if we give it in primary prevention also, there is a significant, there is some reduction, but still there are events, cardiovascular events that are happening. So in primary prevention studies, which is the latest trial is the Jupiter trial, wherein the risk decreases, but it is not nil or zero. So finally, residual cardiovascular risk is likely not only because of the lipid factors, that is the direct measurement of the LDL, but the small dense LDL or the factors like ApoB, which we are not measuring, and the triglycerides, which we neglected since so many years. Previously, 3 years back, we used to say if the triglycerides is only more than 200, let us treat it, or else we can leave it. But now the recent trials show that we have to decrease the triglycerides levels to less than 150 in medium risk patients, and in high risk patients, we have to decrease it to less than 100. So additional LDL lowering therapy in patients with statin monotherapy, if we see, there is a significant divergence in the curves that are measured, and the events are also less. And these are proven in these studies like Improve It, 4-year and Odyssey, and the p-value is very much significant. If we see the life course trajectory of an atherosclerotic plaque progression, so if we see an individual who is at very high risk, that is a patient with familial hypercholesterolemia, where the LDL is 390 at the time of detection. So at birth itself, the early plaque will start. So this yellow, it represents the early plaque. Yellow, in between yellow and orange is the advanced plaque, and the red indicates a very advanced plaque. So if we see here, in familial hypercholesterolemia patients, we can see that at birth itself, the patient is going to, immediately after the birth, the person will have an early plaque, and it progresses to an advanced, very advanced plaque by the age of 20 years, and the patient mortality is very high. Previously, we used to initiate statins somewhere around an early plaque and an advanced plaque, and this prolongs the duration of the patient to around 45 years or 50 years, not more than that. So after familial hypercholesterolemia, if you see a person with the cardiovascular risk factors, by the time we identify the patient itself, we could see that there is some amount of plaque deposited in the coronaries. So if the patient LDL cholesterol is around 130 and the patient is having cardiovascular risk factors, we initiated statins. So this will prolong the life to around 60 and 65 years. So the recent developments in the cardiovascular diseases and lipids being, we have to regress the LDL significantly in those patients who are at high risk. Now the studies say it is a class 2A indication, and who are at high risk, we have to decrease the LDL to around 30 milligrams per deciliter, and the regression of plaque is significant if we modify the PCSK9. I will tell in the next slides what is PCSK9 and how it will act, and it will regress the plaque. And if we decrease the LDL to around 100 lifetime, plaque is significantly reduced, and the patient the life expectancy of the patient is increased to around 80 years of age. So they have found out that loss of function of PCSK9 in some patients. There is a mutation in the PCSK9 and there is no functioning of PCSK9 in some of the patients, wherein they found that the longevity of the patients is around 80 years. So the target was to inhibit the PCSK9, and they found out PCSK9 inhibitors which are now available in the market. So whether there is any difference in the sex, if we by intensive LDL cholesterol lowering, is there any effect based on the sex? It is studied in around 53 randomized trials in around 3 lakh patients, wherein there is no difference in the by sex. So coming to the lipid lowering drugs that are available and the comparison between the lipid lowering drugs. So these are all the drugs that are available. First one being the statin, which we all know pretty well. It acts on the HMG-CoA reductase inhibitor. So here if we see this cycle, this is the hepatocyte wherein the metabolism of the cholesterol happens. So if we see here, initially from the Krebs cycle or from the arginine cycle, there is citrate that is released, and this is converted to acetyl-CoA. So this acetyl-CoA conversion is done by ATP citrate lyase. So the drug which acts on this ATP citrate lyase is the bempedoic acid. So nowadays, maybe all the physicians here who are there in this meeting know pretty well about bempedoic acid also. Now we are using it regularly. So from acetyl-CoA, 2 molecules of acetyl-CoA combine to form the HMG-CoA. So this HMG-CoA is the rate limiting step. So wherein when it converts into malonate, squalene and cholesterol, so this is the cholesterol synthesis pathway, wherein HMG-CoA reductase inhibitor is the statin. So there are many types of statins that are available in the market, and we have to choose the statin based on the patient LDL levels and the patient morphology. So from here, from the cholesterol synthesis cycle comes the PCSK9 gene. So from this gene, that is there in the hepatocyte, PCSK9 mRNA is synthesized. So this mRNA is inhibited by recent molecules like inclisiran. So these molecules inhibit the mRNA and inhibit the formation of PCSK9 itself. So the protein is not synthesized in the liver. So next comes when the PCSK9 is released into the blood. So what happens when PCSK9 is released into the blood means it combines, this PCSK9 combines with the LDL receptor, and when that slide I will show you better, you can understand in the next slides. So the PCSK9 inhibitor, this blue color one is the PCSK9 inhibitor, and it inhibits the PCSK9 protein. So next comes the Niemann-Pick-like protein inhibitor, that is estimib. It is present in the intestinal villi, and these intestinal epithelial cells, and this inhibits the cholesterol transport into the blood. So this protein, this estimib is the inhibitor of this protein, and this inhibits the absorption of cholesterol into the blood. So as I told, this PCSK9 inhibitors is the latest concentration, and so many drugs are there, erilocumab, evolocumab, and many other are in ongoing trials are there. But these 2 drugs are available in the market. So what happens normally is this LDL particles which are taken by the hepatocyte, when they bind these receptors, this is the LDL receptor, this violet color one is the LDL receptor, and this binds to the LDL, and these endosomes will take this particle and digest and release the LDL receptor again onto the liver cell. So what happens is, if the number of LDL receptors are more, these LDL particles will be taken by the hepatocyte and get digested, and the recycling of the LDL particles is more. If we see familial hypercholesterolemia, these LDL receptors are in homozygous patients, they are almost less than 5%. So they have a very high LDL cholesterol levels, and they are subjected at 20 years age, they are subjected to early death. So what happens when there is PCSK9 in between? So when there is PCSK9 that adds to the LDL particle, this endocytosed LDL receptor and PCSK9, all of them together get degenerated, and there is no overexpression of these LDL receptors on the hepatocyte. So if we have the inhibitor of this molecule, there will be more expression of LDL receptors, and that will consume the LDL particles into the hepatocyte, thereby decreasing the LDL levels. Here, this is the molecule wherein this everolocumab binds to PCSK9, and this is inhibited, and the receptors, the number of receptors that get expressed onto the hepatocyte increase. So these are the trials wherein they show that there is significant. In practice, we do see that the LDL levels come to around 25-30 whenever we give these injections. But whom to give these injections is those who are at very high risk or extremely high risk patients only. We have to subject them to these injectables. So coming to the scores, if we see, this is the high risk, very high risk person wherein they have repeated episodes of angina despite treatment. So this next mark is the patients with CKD, stable CVD, ongoing ACVD on imaging, and heterologous familial hypercholesterolemia patients. Next comes the lighter mode, no CVD risk, but heterologous familial hypercholesterolemia, mild form of CKD, LDL around 90, BP more than. So these persons, all this sector, we have to keep the LDL around 70. And in the next subgroup, it is around 55. And those who are having repeated events, it should be less than 40. This is the present target 2022 guidelines. ESC says the target of LDL should be maintained like this. So these are all the trials which say newer evidence, and there are so many popping up evidence also to how to keep the LDL less. Next coming molecule is the LPA. LPA is nothing but an ApoA added to LDL. So ApoA is a protein that is genetically determined. The levels of ApoA are genetically determined, and a patient having high ApoA levels and which bind to LDL act 6 times more aggressively than the normal LDL. So the LDL gets oxidized when it is added to LPA, and it is a very high risk factor for premature heart disease and those who are having already having high LDL levels. Even if the patient is having an LDL of 75, but if LPA is added, it becomes around 200 and 250 like that. So the level of LPA is very much important, and where we should consider the testing of LPA. Patients having premature heart disease, or those who are having family history of premature heart disease, or family history of high LPA levels, familial hypercholesterolemia patients, or those who are having recurrent cardiovascular events despite optimal LDL lowering, and those who are having 5% risk in the next 10 years. So this is how we have to treat. The risk of major adverse cardiovascular events, MACE, is definitely higher in those who are having a LPA of more than 100. It is around 114%, which is very, very significant. So this is normal LPA is considered less than 30, and above which it is considered very much significant. So the gray zone, the zone between 50 to 100, we have seen 2,500 normal personnel in the public who are exposed to high LPA, and regularly the indications of LPA measurement also I have shown you. So how can we reduce LPA, which is a genetic component? So there are now there are now studies done with these drugs which show that LPA reduction is possible whenever we give the injectable drugs. And these are new upcoming drugs, and inclisiran is one of the promising drug injectable which reduces the LPA by 25%, and it is available in the market. So triglycerides, previously we used to think they are not at all significant even if it is 250, but they are the inflammatory triggers for the acute plaque rupture. So what happens in the atherosclerotic tree is initially it is a fatty plaque, later it ruptures again, so the plaque size increases, and later it again ruptures slowly, and at one point it ruptures significantly so that there is 100% occlusion of the artery. So what triggers this inflammation inside the artery? During COVID time, we used to see so many acute thrombosis in the arteries, which happened because of the COVID virus. And there are so many other infectious agents that trigger this inflammation. At the same time, adipose tissue itself is, when it gets oxidized, it is one of the trigger for occlusion or fast progression of the atherosclerotic plaque. The next coming is the triglyceride rich lipoproteins. So this is very important, and if the LDL cholesterol is rich in triglycerides, which we used to mention as the small dense LDL, is very important, and it triggers the inflammation, and it triggers the acute events like acute heart stroke, acute MI, or acute unstable angina. So here we can see the plaque which gets repeatedly, whenever a plaque ruptures, it causes acute occlusion of the artery and leads to complete closure. We may think that the patient is not having acute MI, but sometimes it happens that this plaque ruptures in small sizes, and the plaque size increases, and the percentage of stenosis also increases because of acute plaque rupture. So what is the therapy? So whenever we give statin, it is a good drug for all the patients, whether for the plaque therapy or for the prevention. So next comes when the LDL is around 100, we can try estimate to bring the LDL to 100. But after less than 85, to bring the LDL to less than 85 levels, we need the therapies that are targeted, like PCSK9 inhibitors, and the addition of icosapentaethyl, that is omega-3 fatty acid, which we neglect most of the times. It is there, it controls the triglycerides and controls the inflammation inside the plaque, and causes, it is very much useful for the reduction of the risk. So here we can see the p-value is very much significant. Whenever we use previous studies, at one point they gave lesser doses of omega-3 fatty acids like 500 milligrams and around 1 gram, and the results were not very good. The dosage that is recommended is 2 grams per day, which is effective and decreases 25%, reduces the risk by 25%. So whom to give this omega-3 fatty acids? Those patients who are having severe hypertriglyceridemia, that is more than 500, and whom we target is those who need cardiovascular risk reduction, or as an adjunct to maximally tolerated statin therapy to reduce acute MI, stroke, or revascularization. And in those who are having established cardiovascular disease, or in a patient with the diabetes who have 2 or more risk factors for cardiovascular disease. So next comes the drug angiopoietin receptor. Angiopoietin is angiopoietin-like protein. So this angiopoietin-like protein is present in the liver, and it is secreted by the liver, and it acts there are 3 types of this protein: 3, 8, and 4. So this 3 is circulated in the blood, and 4 is on the adipose tissue itself. It is not in the circulation. This angiopoietin 3 acts during the fasting phase, whereas it binds to angiopoietin-like protein 8 when the patient is fed completely. So when it binds to it, it acts significantly and inhibits the lipoprotein lipase that is in the liver, skeletal muscle, and also on the adipose tissue. Inhibition of lipoprotein lipase stops the action of triglycerides on the particular tissue. So this inhibition leads to significant arrest of the progression of the inflammation inside the plaque. So these drugs normally we are not using in all the patients. Only we use it when the patient is having homozygous familial hypercholesterolemia. And in India, it is available as Equiza. So coming to the outcome trials, which we did in our hospital, Odyssey trial and Fourier and Spire 1 and 2, we in our hospital we did in some patients, and the follow-up was around 2 years and 3 years in some of the studies. And all the studies, this erilocumab and evolocumab, these are monoclonal antibodies. So these two drugs are now available and they are useful, but the rest of the drugs are still in trials, and one of the study is interimly stopped because of the toxicity of the drug. So this is the slide wherein I just want to project for secondary prevention and primary prevention, which patients we have to use statins. Nowadays, statins are being used rampantly, and almost all the doctors and many of the doctors, we are very much apprehensive of coronary artery disease, and we started using statins in many of the patients also. But these are the indications wherein in the guidelines that are mentioned, wherein we have to use statins in primary prevention. So LDLC management, previously it was only done in the high risk atherosclerotic CVD events. Initial most important in the last slide I would just like to mention is these events. We have to identify the patient before the event happens. So that how we should do is I will tell you. So to overcome the barriers, previously there are no drugs which we can give whenever we have to lower the LDL to less than 80. Now we have so many drugs which complement statins. And how to go about whenever you see a patient, initially we have to educate all the patients to have a lifestyle management. Later you have to assess the risk factors and the lipid biomarkers. So we have to check for if there is any subclinical atherosclerosis. There are many methods, so many methods to assess the subclinical atherosclerosis that is there in the carotids to assess by carotid Doppler, coronaries to check the coronary calcification that is there, or if the patient is at high risk to get a CT coronary angiogram done. And then comes whenever the patient is having an event. So after the event, we have to see that the patient will not progress to recurrent events, and we have to arrest the disease. Initially, we have to arrest the disease at this level itself so that they won't progress into atherosclerosis and later into events. So these are the latest ESC guidelines, so which I mentioned previously also. So coming to the combination therapy, we can combine statins with PCSK9 inhibitor or inclisiran, which is the mRNA inhibitor. And we can combine statins with bempedoic acid, which is very easy. And both are oral drugs, or statins with ezetimibe, or only bempedoic acid with ezetimibe in those patients who have significant musculoskeletal symptoms. So those who are having pre-diabetes, I would like to skip the slide because of the lack of, in the interest of time. So all the drugs, whichever we give, they have side effects and they are not free of adverse events. Before giving the drugs, we should know about the drug properly, and then only we have to start the therapy. So patients having high uric acid levels, we should not start them on bempedoic acid. Those who have diarrhea, omega-3 fatty acids should be avoided. And patients who have atrial fibrillations, we have to avoid omega-3 fatty acids. Like that, we have to see whenever we are giving the drugs. So these slides I would just skip away. So future of lipid lowering therapy is still going on, and we are awaiting vaccination and genetic editing, which is the best form of therapy that is present, and we can individualize the patient whenever we do the genetic editing and treat the patient. So one most important thing which I would like to emphasize is drugs work very well, but the problem is with the patients who never take the patients. We prescribe statins and they stop it after 1 month or 2 months. So thank you. I just don't want to extend more. Thank you very much.
Thank you. Thank you so much, madam. With your very nice, elaborate, illustrative presentation, you have cleared many myths regarding the hyperlipidemias and the drugs that are available. Thank you very much for being with us for this conference. Now it's the time for inauguration. Now the next, as per the instructions of our leaders, we are proceeding for the inaugural function. Dr. G. Ravikrishna sir, shall we start?
No, we have told the guests to join at 10:30.
Okay.
5 minutes, you can have any discussion.
Okay. I request the delegates to pose any questions for speakers that have concluded till now, including
Madam, there
Naga
are
sir.
recommendations. There are some questions.
Yes, ma'am. Please, you can
okay.
open the chat box and you can question, ma'am.
Which statin is better?
Diabetes and hypertension patients in spite of normal cholesterol, ma'am. That you have a question.
Yes, ma'am. What is meant by normal cholesterol levels? That which I should like to emphasize first. Why? Because there is nothing like a normal cholesterol nowadays. So the target for the LDL or the sugars, whatever is there, it is coming down significantly. Why? Because recent studies say we can stop aspirin also, and we have to continue statins in spite of aspirin. Why? Because there is a risk of significant bleed, and the bleeding risk is more. So there is nothing like a normal cholesterol level for anybody. We have to see the risk score, in the slides which I have projected. If you see this patient, diabetes and hypertension, it means that the patient is having diabetes, and on the top of it, one ASCVD risk score. So if the patient is having one risk score along with the diabetes, we have to keep the LDL cholesterol below 100. So that is the present recommendation. Similarly, we have to see the level of hypertension and level of diabetes also. There are risk score related adjuncts that are available on website. If we enter the fasting blood sugar level, hypertension, systolic blood pressure and diastolic blood pressure, and risk factors like smoking and the lipid profile, in that it will show the score, and according to that score we can treat the LDL levels. So that is normal for that patient, but not that all the patients and normal cholesterol. There is nothing like a normal cholesterol level that is defined. And coming to which statin is better, at present we are using atorvastatin and rosuvastatin. Rosuvastatin is slightly more potent than atorvastatin, and but we have to check the HDL levels also whenever we are giving these drugs. And if the HDL is very low, better switch from rosuvastatin to atorvastatin.
Madam, there is a myth that they produce little dementia. Is it correct, madam, on using statins for long?
Madam, actually, every drug has its own problems. There are studies saying that there is some amount of new onset diabetes that is present with statins, but dementia is relative. Many patients, they don't like, maybe we are not checking properly, but still we do give it to our parents also, many of the close relatives, wherein we are not encountering any problem of dementia, who are given statins for many years.
Ma'am, we are also facing muscle atrophy and muscle weaknesses, ma'am. Statins. The muscle mass also it is decreasing, it seems.
Muscle pain is significant in
but
patients.
muscle mass also reducing.
Muscle mass reduction, if we encounter these problems, if we encounter these problems, we have to check the other things. What is madam was saying, diabetes, whether it is the cause, or if the patient is not ambulating much, like that, we can't conclude saying that this is because of statins only. But muscle pains, definitely yes. Why? Because after we stop the statins, patients will have good improvement in the pain, will have pain relief. So in such patients, we can try estimab or bempedoic acid.
Ma'am, for many patients, we are seeing HDL on the lower side, ma'am. Below 35, below 50 is considered to be low. For most of the times, we are seeing between 40 to 50. So how much is very low? As you said, rosuvastatin should be shifted to atorvastatin if HDL is very low.
HDL as such is good cholesterol, which we have to see maintain around more than 50, ma'am. For males more than 45, females more than 55. So we have to maintain it like that. If it is less than that, better see switch the drug to other statin and see whether it is good. Or we can try omega-3 fatty acids, which increase the HDL levels a bit. Or we can give fibrates, add on statins and fibrates, and definitely if the triglyceride levels are less, the HDL levels will improve.
Thank you, ma'am.
Thank you.
Madam, we can start inviting the guests.
Yes.
Some guests are already there. Dr. Ashokan sir is there and Srinivasa sir. Meanwhile, after joining the guests, we can ask them to give messages.
Sharad Kumar sir is there, sir. Sharad Kumar sir.
You invite all the names given, madam, and after inviting, after my opening address, I will ask the guests on the board to address the gathering.
Yes, sir. With the first session going smoothly for this Evecon, now let us move on to the inaugural function of this great conference, where only women speakers and the moderators are taking part. I now call upon our dynamic, down-to-earth workhorse of IMA AP State, Dr. G. Ravikrishna sir, President of IMA AP State, to come on to the virtual platform to preside the inaugural function, sir. Dr. G. Ravikrishna, sir.
Yes, thank you.
I request Dr. Sharad Kumar Agarwal, National President IMA, who is omnipresent and solving the many problems of the IMA states in everywhere and anywhere attending. Dr. Sharad Kumar Agarwal, sir, I request you to come on to this virtual platform. I now call upon Dr. Babji, K. Babji, who is Vice Chancellor of Dr. YSR University of Health Sciences, who is our own Professor of Surgery. We are fortunate to have worked with him, under him. He was our teacher, direct teacher. We are very happy to have you here, sir, for this inaugural function as the guest of honor. Dr. K. Babji, sir. I now call upon Dr. R.V. Ashokan, President-elect of IMA, National President-elect of IMA, who is dedicated to the cause of IMA and aptly honored with the post of President-elect of this great country and IMA, Indian Medical Association. We welcome you to this function, sir, as a one of the guests of honor. And
Thank you. Thank you. I am here. I am already here.
thank you, sir. Thank you, sir. I now request Dr. Anil Kumar J. Nayak, who is the IMA National Honorary Secretary General, right hand of National President, to please accept our invitation and attend to this virtual platform, sir. Thank you, sir. Thank you.
Okay, thank you. I am here.
Thank you, sir. I now call upon Dr. G. Srihari Rao. I am a National Vice President, our own big brother, who is large-hearted philanthropic worker of AP IMA State, aptly honored with the National Vice President post. Dr. G. Srihari Rao, sir, please accept your seat on this virtual dais of inaugural function of IMA Evecon. I request Dr. Pankaj Mutneja, sir, IMA AMS National Chairperson, who has brought the AMS Academy of Medical Science to forefront with various programs and increased its importance, to please come over to the dais and occupy the chair on this virtual platform. Dr. Pankaj Mutneja, sir. I now call upon Dr. C. Srinivasa Raju, immediate past state president of Andhra Pradesh, IMA, who was instrumental in solving many problems of IMA AP state, to please come over and occupy the seat on the dais of this virtual platform, sir. Dr. C. Srinivas Raju. Thank you, sir. I now call upon Dr. J.C. Naidu, IMA AP state president-elect, young, dynamic, waiting in the wings to take the charge of president of IMA AP state. Dr. J.C. Naidu, sir. Please take your seat on this virtual platform. I now call upon Dr. P. Khanidar, sir, IMA AP State Honorary Secretary, General Secretary, our think tank, a silent worker, walking encyclopedia of all the laws and bylaws of Indian Medical Association, be it the center or the state. Dr. Khanidar, sir, please.
Thank you, ma'am. I am here.
Virtual dais.
Yeah. Thank you, ma'am. I am here.
Thank you, sir. I now call upon Dr. Ananda Kumari, a gynecologist and the observer of Andhra Pradesh Medical Council of this conference. Please come over to the dais.
Good morning, everyone. Good morning, everyone. Thank you, Ramni madam, for
thank you.
introduction.
Thank you. I now call upon Dr. M. Ravindranath, Honorary Finance Secretary of IMA AP State, the able worker and one of the Trimurtis of our IMA AP State, to please come over and occupy a seat on this virtual platform.
Thank you, madam.
Ravindranath, sir. Thank you. I now hand over the function to our president and preside the function of inauguration, Dr. G. Ravi Krishna, sir. Thank you.
Thank you, madam. Indian Medical Association, Andhra Pradesh State is organizing for the first time an Evecon, an exclusive women doctor speakers, and all the moderators also women doctors, to ascertain the increasing role of women doctors in the modern medicine in the country in various specialties. And for the inaugural session, present on the virtual platform, Dr. Sharad Kumar Agarwal sir, National IMA President, who will join shortly, and Dr. R.V. Ashokan sir, IMA National President-elect, and Dr. Anil Kumar J. Nayak sir, Honorary Secretary General of IMA AP State, and D. Srihari Rao, National President, National Vice President, Dr. Pankaj Mutneja, AMS IMA National Chairperson, and Dr. Srinivas Raj sir, immediate past state president, and Dr. Panidar sir, Honorary General Secretary, IMA AP State, Dr. Ravindranath, Honorary Finance Secretary, IMA AP State, and especially the organizing team, IMA AP State AMS Chairperson, Dr. P.A. Ramani, and Dr. GTB Ramesh, Secretary, and Women Doctors Wing Chairperson, Dr. G. Hemalata, and Secretary, Dr. Vasudha Rani, and Mission Pink Health Chairperson Dr. P.V. Durga Rani and Secretary Dr. Lakshmi Saujanya, and the delegates who are attending the program on the live stream. We have arranged this program on both Zoom and also live stream because more than 2,000 delegates have registered for the program. Right now, 879 people are in the live stream at this time. Only those people, speakers, guests are on the Zoom platform. The delegates are in the live stream, and the total data will be given by the technology when they have joined and how much time they have spent in the Zoom platform to send their CME credit hour certificates. At the outset, I would like to thank the national leaders for joining this program, unique program. IMA AP State is continuously organizing several academic activities as per the objectives of the IMA headquarters or IMA to realize the IMA objectives. We have strengthened the Academy of Medical Specialties with a full team, and CGP team also formed with a full-fledged team. And regularly we are organizing monthly CMEs. And apart from the monthly CMEs, recently this month only on behalf of the Academy of Medical Specialties, we have organized 2-day CME with 6 CME APMC credit hours. And today we are organizing exclusive women doctors Evecon Cme with 4 CME credit hours. And again on September 3rd, we are organizing CGP CME 1-day CME program with 4 CME credit hours. So not only the state IMA and all the branches in the state, all the 98 branches in the state are regularly organizing CME programs for the benefit of the doctors to upgrade their knowledge, to upgrade their information and newer technologies. And upgrading our knowledge is not only for the sake of doctors, it is going to help the people. When we get our knowledge updated, definitely we are going to deliver the better management to the patients. So indirectly, all these CME programs are in the interest of the public only, not only in the interest of the doctors. With these few introductory words, I request Dr. R.V. Ashokan sir, IMA National President-elect, a good advisor to the IMA AP State since long. I request sir to address this gathering. Please, sir.
Beloved President of IMA AP State Branch, Dr. Ravi Krishna, and Vice President at the National Dr. Dagubati Srihari Rao, HSG Dr. Anil Kumar Nayak ji, Dr. Fanidar, Dr. Ravindranath, Dr. Pankaj Mutneja, Srirang Akbari, Dr. Ramani Madam, Dr. Hamalada Madam, Dr. Durga Rani, Dr. GTV Ramesh, Dr. Vasudha Rani, Dr. Lakshmi Saujanya, our guest, Dr. A. Babji, Srinivas Raj, and JP Naidu, my dear friends from Andhra Pradesh. I have stopped counting your inventions for IMA, the newest one being the Evecon. You also came out to the Olympiad. I think this is coming out like magic, rabbits coming out of the AP Hats leadership. These are very, very forward-looking dimensions in Indian Medical Association. Indian Medical Association is committed to empowerment of women, not only women doctors, empowerment of women. And this very significant step of showcasing our own women doctors, their reach, outreach into the profession and the society. This is showcasing. This is empowering. I'm so happy that this is happening, and you are forming again a role model for the entire IMA to follow. Two very significant things. One is the CME funding of by pharma was one issue, and the generic drugs issue. Both these issues have been right now stalemated. I would not say that it's a victory. It's a stalemate. because, the government has understood there are, more issues which are linked to this. And the rightful case of Indian Medical Association, that patient care and safety may be impacted unless until the entire drug spectrum of the generic drugs is quality tested. And also, if doctors cannot write branded generic, then what is the purpose of allowing a prescription drug out there in the market? It all went on very well, and IMA was able to spearhead and give an outlet to the anger and frustration of the medical profession over what was happening. And also the CME funding. While IMA has taken a stand that it may not be appropriate for an individual doctor to take the help for travel, accommodation, even that can be discussed. But as an organization, there are a lot of professional societies. They are the only available forums for us to interact and enrich the knowledge. As your president put it, it's the only way that, the pharma profit can reach the patient. Is there any other way the pharma profit can be shared with the patient? So the only way is to enrich the knowledge of their caregivers so that they give better care. But it has to be regulated, it has to be transparent, it has to be bona fide. All these are agreed. So this is a stalemate right now, though, we will come out of it. And let me say that this has happened because of the increased stature of Indian Medical Association. You could see what happened in Rajasthan. We could reverse an ordinance. We could see what happened in Kerala. We could produce an ordinance. And these two things ended up in stalemating generic medicine and CME funding. So ultimately, it is the strengthening of Indian Medical Association that the aspirations of the medical profession can be legitimately met. I am so happy that you have a very good team. The leadership that is being provided by IMA AP State is a role model for all other states to follow. I congratulate the team led by Dr. Ramesh Krishna. Let me conclude my intervention. Thank you so much for inviting me to this meeting.
Thank you, sir, for your kind, encouraging words and kind words towards our IMA AP State. Now, I request Dr. K. Babji, sir, Vice Chancellor of Dr. YSR University of Health Sciences, to address this August gathering, sir. There are 899 viewers in the
Babji,
live
sir, you have to unmute, sir. Unmute. Yes.
Yeah.
Dr. K. Babji, sir, Vice Chancellor, Dr. YSR University of Health Sciences. Please.
Good morning, everybody. Especially Dr. Ravi Kumar and Dr. Ramesh Krishna. Thank you for inviting me for this good, very good medical education activity. And I must congratulate you for arranging such a wonderful women empowerment is being shown now in this CME program. And I was very happy that all the speakers are women. And you all know that the medical colleges are now dominated by women. The medical students from first year to final year and even in PG, 70-30. So we have the problem of giving accommodation to the women students. But of course, we are able to manage, and women dominate in every field, and we accept it. Women as a teacher, as a leader, as a mother, and an entrepreneur. And the role has been identified by the IMA, and the IMA has made this medical education, continuous medical education, a wonderful event organized by Dr. Ravi Kumar and Dr. Ramesh Krishna. And it's university's aim is to educate everybody, to do good research, and finally the end product is patient care. So we are doing the same, and I'm very happy that recently our national president also has visited the Vijayawada, and he is also encouraging the educative activity taken by the AP state. And now this is a very, very illustrative example for this medical education. And with congratulations and thanks, I'm concluding. Thank you very much for giving me this opportunity.
Thank you, Sir Dr. Babji, sir, Vice Chancellor Dr. YSR University of Health Sciences, for gracing the occasion, giving a nice message to the delegates. Now I request Dr. Anil J. Nayak, sir, Honorary Secretary General of IMA AP State, IMA National, to address this gathering. Sir. Sir, unmute, sir. Sir, thank you, sir. Thank you, sir.
Yes, sir. Good morning to everybody. Dr. Ashokan, sir, President-elect, Dr. G. Ravi Krishna, President, and Dr. P. Pandidhar, Secretary, all the Vice Chancellors, sir, YSR Health University, all the dignitaries on the dais, of the dais.
Sir, you have muted, sir. Anil, sir. Muted and video also gone, sir. Anil Kumar, sir.
Yes, sir.
Yes.
Now, am I audible?
Audible, sir, not visible, sir. The video not done.
Oh, what happened? I don't know.
Go ahead, Anilji. Go ahead, address.
Yes, now you are watching. We are seeing, sir. We are seeing and listening.
He is in an airport. He is in an airport.
Thank you, Ashokan, sir. Thank you for inviting me in this wonderful conference, which is unique in nature because all the speakers are women, and it is organized by the Indian Medical Association, IMA AMS Specialty of Andhra, and Women Dr. Wings and Mission Pink Health. All came together and organized this webinar. I congratulate the President and Secretary and all the office bearers of various wings who have joined this webinar, and all my distinguished guests and the delegates who have joined for this webinar. As you know, women empowerment is a world of the Western world. We have more powerful women in compared to Western part of the world, as all our women are powerful. Because what we want, we have to go to goddesses. Just if you want to have money, so we have to go to Lakshmi. If you want to education, we want to go to Ma Saraswati. So everywhere, women empowerment is there in Sanatana Dharma and Hindu religion. So women are already empowered. But now IMA is giving opportunity by giving all the posts in office bearers, just like in Dhule. All the office bearers were women in before 2 years. In this webinar, all the women are speakers. So I congratulate for giving promotion, not empowerment. They are already powered. Because in Gujarati, it is said, women is Shakti and male is a Sahan Shakti. So you are powerful and you with your support, because all the male leaders and men are working for IMA, but if you join with us, our power will be doubled. So your support in all the problems arise by the government or otherwise, your support is main. So kindly support wholeheartedly to IMA to resolve their problems, because you are guiding force to the IMA. So I am thankful to IMA AP branch for inviting me and allow me to say few words in front of all the delegates and my distinguished President-elect Dr. Ashokan sir. So thank you very much to all of you. Thank you very much. I wish the conference grand success. Thank you.
Thank you, sir, for joining the inaugural session and giving a nice message and encouraging the women doctors with the nice words. And today we are having 16 women doctors speaking on different topics ranging from endocrinology, from neurology, and different topics, sir. Thank you very much, sir, once again. Now I request Dr. D. Sriharirao, Vice President, IMA National, to address the delegates in this delegates and other.
Good morning, everybody. Good morning, everybody. Thank you, sir. First, I'll let to congratulate Dr. Ravi Krishna for getting all the 3 chairmans, AMS, Women Doctors Wing, and Mission Pink Health Program, Dr. Ramani, Dr. Hemalata, and Dr. Durga Rani, madam. And at the outset, I congratulate the first time they are conducting the women doctors, speakers and moderators. That is a good thing. And recently also, our president has given 50% award to the national award by our national president to the women doctors. And they are regularly conducting both, all the 3 are active, and because the dynamic ladies are there, Ganga, Saraswati, Yamuna, last time I told them, and they are conducting all the things regularly. And yesterday also I informed our executive meeting, we have discussed about our national Olympiad that is coming on November 22nd and 26th. So in future also you can continue all these programs, and thank you for giving this opportunity. Thank you.
Thank you, Dr. Sriharirao, sir. I am a national Vice President and from the IMA AP State. As you rightly said, all the 3 women leaders from 3 zones, along with the Dr. Hemalata, Dr. Durga Rani, and Dr. P.A. Ramani, Dr. Vasudha Rani, and Dr. Lakshmi Saujanya, and several other women doctors from various branches are actively being involved in the programs, either the academic activities or in the social service activities also. They are taking the IMA to the next level by their active involvement in the social service activities and in the academic service activities. Now I request Dr. Venkatachalapati sir, IMA National Joint Secretary, is past State President of Karnataka, to address the gathering, sir. Dr. M. Venkatachalapati sir, IMA National Joint Secretary from South India, is from Karnataka. Sir, Venkatachalapati sir, unmute yourself and address, sir. He's on the line, Dr. Venkatachalapati sir.
Yeah. Good morning, everybody. At the outset, I would like to thank Dr. Ravi Krishna Garu for inviting me to this grand function. I don't want to take much of the time. Just I want to make one quote. Yatra naryastu pujyante tatra ramante devataha. Where women are respected, their angels will make it a walkway. So that thing has come true today by our State AP President, Dr. Ravi Krishna Garu. So I congratulate him for organizing such a wonderful event exclusively with women doctors. And I wish this function and this conference a very grand success. Thank you very much, sir.
Thank you, sir. This is an exclusive women doctor speaker, sir. Delegates are both male and female. There are online at right now 926 people are watching, sir. Both male and female speakers and the moderators are only doctors. And we have not restricted only subjects like gynecology and varied subjects we are covering today. Sir, thank you very much, sir. Now I request Dr. Pankaj Mutneja, sir, IMA National AMS Chairman, to address the gathering, sir. Dr. Pankaj Mutneja, sir, Chairman, IMA AMS, Academy of Medical Specialties, National Chairman. Dr. Pankaj Mutneja, sir, please unmute yourself and address the gathering, sir. Dr. Pankaj Mutneja, sir. IMA AMS National Chairperson.
Hello. Can you hear me?
Yes, sir. Yes, sir. Please.
Good morning, and thank you very much, Dr. G. Ravi Krishna, AP President, for inviting me over on this online CME, especially with the lady speaker. Honorable HSG Dr. Anil Nayak, our President-elect, learned, respectable Dr. Ashokan, and other leaders of the AP, which a lot of names have already been taken. Our Vice Chancellor, worthy Vice Chancellor. I know AP IMAMS is extremely active, making sure that the knowledge reaches till the last village of Andhra Pradesh and as well as involving the nation. We are very, very happy and to see this body, which is actually very vibrant. And Dr. Ashokan has recently just said a lot of words about the importance of IMA national level, and we are seeing that the dictates of the NMC were immediately neutralized or stalemated, in the words of Dr. Ashokan, in a virtually a knee-jerk reaction led by our Honorable HSG Anil Naik ji and National President and other national. My only contention is that we are distributing a lot of knowledge to him. These dictates and these small issues which come up, we must also conduct a sort of a survey and give it to the national IMA. So when they go to the honorable ministers, they can show that this is the feedback of our cadres who are serving in the state. And that is where we will be able to achieve certainly much more. And so that the issues which are adverse to our community, our fraternity, are immediately addressed. I shall not take much time because it's an academic feast which I've just gone through the various topics, and wish you all the well, all well, and thank you very much for inviting me. Thanks.
Thank you, sir. Thank you for coming and gracing the occasion and wishing the program a grand success. Now, I request Dr. C. Srinivasarao, sir, immediate past President of IMA AP State, to address the gathering and the delegates on this occasion.
Thank you, sir. And good morning to all, especially our national IMA team led by H.G. Naik sir and Ashokan sir and Venkatachalapati sir, and also state IMA led by Ravi Krishna and Fanidar, and especially most importantly, the EVES wing, especially Mission wing, Women's wing, and CGP and AMS wings, especially superbly led by the so many women leaders, Kamalata Garu, Durga Rani Garu, and Saujanya, so many leaders are there. I am not touching everybody. Definitely, it is a great opportunity for to showcase the promise of the women leaders, especially in AP state, to various ways. And I take this opportunity to extend my congratulations to our national IMA team for successfully stalling the controversial NMC Code of Ethics. And at the same time, I request my request to the Babji sir, who is the dynamic Vice Chancellor of the YSR University of Health Sciences, to authenticate the CME programs organized by the IMA state in the future itself. And also, I request him to go through the syllabus and curriculum we are producing on behalf of CGP and AMS and authenticate the stamp of the university. Definitely, it will give a lot of carriage and lot of mileage to all the programs, especially educational programs conducted by the IMA state. And lastly, I must congratulate all the EVES wing, and also at the same time, almost the sea of delegates, almost 2,000 delegates are registered. And as on now,
Mute, sir.
To all the leaders here all the delegates here please strengthen the hands of the IMA leaders by enrolling the more and more young doctors of the MBBS. And at the same time, I must congratulate once again Dr. Ravi Krishna, Dr. Fanidar, and Dr. Ravindranath for successfully arranging the so many educational programs, whether you take AMS or CGP, and it gives a lot of enthusiasm and inspiration to all the other states. As Dr. Ashokan sir well pointed out. And at the same time, long live IMA, Jai Hind. Thank you very much, sir.
Thank you, sir. Thank you very much, sir, for gracing the occasion. Now, I request Dr. M. Anand Kumari, Madam, observer for today's CME program on behalf of the AP Medical Council to address the gathering and delegates, Madam.
Good morning, everyone. It is at the outset, I thank IMA AP chapter for giving me this opportunity, and AP Medical Council also. And I'm honored for this observership, and I'm very much happy for the initiative, the involving women, so to raise a voice, and not only in CMEs, but also to raise a voice and to say something and to involve in the activities of the IMA, both in the state and in the country. And with this, I conclude. Thank you, everyone.
Thank you, Madam. Because this is a Evecon and all the speakers and moderators are women, we have requested the registrar also to send a woman doctor as a APMC observer. And we
yes, sir. That's what I'm overwhelmed for involving us. Actually, there are so many issues that we need to solve.
Yes.
We are seeing so many setbacks in our profession, so it is better to involve women with gender equality and to represent to all our governments.
Thank you. Thank you very much, Madam. Not only in academics, Madam, even in IMA organization also, we have included women doctors in all, each and every committees. We have formed nearly 25 committees. For the first time, we have included women doctors in all the committees, including Constitution Committee.
Sir, it's a good change, sir. After a long years of observation as a doctor, it's a good initiative from your side. Thank you so much.
Thank you, Madam, for being the observer for today's program. Now, I request Dr. P. Panidhar, sir, IMA Honorary General Secretary of AP State, the three team, rightly said, Trimurthulu, and I'm very thankful to IMA AP State for giving such a great General Secretary with such knowledge and guidance, and an elderly person for guiding the IMA. We are organizing these programs combinedly. We regularly interact with each other, even for a small issue also, small banner or a small guest list, whatever that we three of us discuss all the time, and we are organizing these programs. Now I request Dr. P. Panidhar, sir, Honorary General Secretary, AP State, to address the delegates and the speakers.
Good morning to the dais and also to the delegates of the platform. I'm indeed happy that what we planned, have been planning for the past 15-20 days for this Evecon has come true and also fruitful. I think by evening, everyone will be overwhelmed with the performance of the speakers and the moderators. All the speakers and moderators are not only specialist women or super specialist women in the field of medicine. So I thank my president also for giving me little leave on my personal work to attend. So I also thank Dr. Ashokan and the team led by Dr. Anil J. Naik and Sharad Dagat sir, who was in Andhra Pradesh on the other day. I think it is a great achievement that we could stall the certain policies done by NMC or the central government. So if we can build up this pressure, I think we'll definitely open the door and enter the policy making room of the NMC or the government of India on all the health issues. So it is a great achievement, and that we will also, from our state or from on behalf of the states of IMA. We also keep up the pressure building on various policy matters which are against people mainly and profession in the interest of the people. Thank you, sir, for giving this Evecon to IMA AP State. Dr. Ravi Krishna should be complimented for envisaging the idea and the implementation part done by our Ganga Yamuna Saraswati. Thank you, sir.
Thank you, sir. Before I request the Finance Secretary Ravindranath to address, I would like to once again introduce the three women wings to the audience gatherings. Dr. P.A. Ramani Madam, who is now organizing the first session, the chairperson of IMA AMS AP State. She is also past state vice president of IMA AP State and president of IMA Vizag also. She executed the work. Thank you, madam, for taking a lot of interest for the program. And Dr. G. Hemalata, president, chairperson of Women Doctors Wing IMA AP State. She bagged the best branch president award last year as president of IMA Anantapuram, and secretary of IMA Women Doctors Wing, Dr. S. Vasudha Rani, for actively involving in all the programs regularly, and Dr. P.V. Durga Rani, madam, Mission Pink Health chairperson, and secretary of Mission Pink Health chairperson, Dr. Lakshmi Saujanya. Because of all your continuous hard work, IMA is getting a lot of good image in the eyes of the public because of your academic activity, not only academic activity, because of your service activities being done everywhere with your women doctor wings. Once again, I express my sincere thanks to all the women doctors, women doctor leaders on behalf of the IMA AP State. And I wish you should all become leaders in the IMA mainstream in the coming years. Thank you with these words, and I request now Dr. M. Ravindranath, Finance Secretary. As Panidhar sir is going on leave for some time, but he will be available on Zoom and he will be preparing all the drafts. Ravindranath will have to take over as a temporary responsibility at Vijayawada, and I will request Ravindranath to address the gathering.
Respected national leaders, our state president, and the women power of AP State, I congratulate all the women who have worked hard to make this program a wonderful event and successful program with excellent topics and excellent moderators, and completely envisaging all the important aspects of medicine. And I thank all the delegates also being part of this event and making this one a grand success. I take this opportunity to welcome all the national leaders and women doctors to be part of the National Olympiad, which is to be held in November 22nd to 26th. And I thank our national president-elect, Dr. Ashokan sir, and all the senior leaders, our national vice president, Srihari sir, Anil sir, Venkatachalam sir, and all the senior leaders for gracing this occasion and making this a memorable one for all the women doctors. And your encouragement will make our women power strengthen. And I wish good luck to the success of this conference. Thank you very much. Thank you, Anand.
Thank you, Ravindra, and rightly reminded about the Olympics as you are organizing the program at Vijayawada. And at this juncture, I would like to recognize the presence of eminent personalities on the platform. Dr. Vengamma Madam, ex-Director of SWIMS, she is going to address the delegates in the afternoon session about a topic, and also the presence of Dr. Alla Prashanti, ISA AP State Chairperson on the platform. She is also going to deliver a lecture in the program, and Dr. P. Krishna Prashanti already delivered her lecture, and she is the chairperson of the AP Association of Physicians of India chapter. And other dignitaries in the program. I think Dr. Sharad Kumar Agarwal sir is engaged in some program where past national president is organizing a felicitation program for the sir. So he could not able to attend, but he asked me to convey the greetings to all the delegates, speakers and moderators on behalf of the IMA National. We thank IMA National President-elect Dr. R.V. Ashokan sir, HSG, Dr. Anil J. Nayak sir, Dr. Pankaj Mutneja, IMA AMS Chairperson, Dr. D. Srihari Rao, IMA National Vice President, and also Dr. Venkata Chalpati sir, Joint Secretary IMA National, and Dr. Srinivas Raj sir, immediate past State President IMA AP State, and all other IMA dignitaries who have attended the program, and especially Dr. K. Babji sir, Vice Chancellor of Dr. YSR University of Health Sciences, and Dr. M. Anand Kumari Madam, APMC Medical Observer, for attending this inaugural session. So I request Dr. Ramani Madam to continue the program, CME program, and we will be on the board to watch these programs. And in the valedictory function, some more guests will be joining in the evening at 5 p.m. Madam. Thank you very much, madam. Thank you very much.
We are indeed honored to have your presence encouraging our conference, sir. Thank you. Now we'll proceed with the next speaker and the next session. Asthma in Pregnancy by Dr. Sushmita, who is a pulmonologist from Nellore. Madam Sushmita, are you there? Sushmita?
Sushmita, Dr. Sushmita is here, ma'am, but then
Yes.
Please share your screen, madam.
Am I audible?
Yes, ma'am, you're audible now. Please go ahead.
Yeah. Good morning, everybody. So my topic for the next 25 minutes would be regarding asthma in pregnancy. So what is asthma? What happens in asthma? Let's just go to the basics. Asthma, as you all know, is a chronic airway disease, and it is characterized by recurrent attacks of shortness of breath, wheezing, cough, and expectoration. And these symptoms usually vary during the day, and it has seasonal and diurnal variations, and these symptoms respond to treatment. So this is a characteristic of asthma. It's a chronic disease, but it's variable and it is responsive to treatment. So what happens in asthma? Asthma occurs in persons who have a predisposition to develop a Th2 response. As you can see, whenever a person who has predisposition to asthma encounters an antigen, let it be a viral infection, a viral antigen, or it could be a particles in the dust or pollen or some antigen from the food you have consumed. Whatever antigen the person encounters, it triggers a Th2 response. As you all know, there is Th1 and Th2 response, but it is a Th2 response that plays a predominant role in patients with asthma. So what happens when the Th2 response is triggered in the body? It produces a number of interleukins like IL-4, IL-13, and IL-3, 5, and GM-CSF factors, and these result in activation of various cells that produce inflammation, like mast cells, basophils, and eosinophils. So when these cells are activated, they produce certain inflammatory mediators like histamine, prostaglandins, leukotrienes, and other enzymes. And these inflammatory mediators produce the airway inflammation. What happens in the airway inflammation? As you can see, the airways are lined by the mucosa, followed by the submucosa, followed by a smooth muscle layer. Because of the inflammation, there is mucosal edema. There is increased production of mucus from the submucosal glands, because of which there is increased amount of secretions and swelling of the mucosal membranes. This results in narrowing of the airway. Additionally, because of the inflammatory mediators, there also occurs smooth muscle contraction in the airways, which results in further airway narrowing. Because the airways are narrowed and filled with secretions, this produces symptoms like wheezing, cough, shortness of breath, and expectoration. So these are the symptoms of asthma, and they respond well to inhalational drugs. So what happens in pregnancy associated with asthma, and how does it present? In women who are having a prior history of asthma, who are asthmatics, it may flare up during pregnancy. As you can see from the statistics, in pregnancy, 1/3 of the patients with asthma, the symptoms will get worse. Whereas 1/3 of the time, the asthma symptoms may remain the same, and 1/3 of the time, the asthma symptoms will improve. And why does this happen? Because of the hormonal changes, anatomical and functional changes that happens during pregnancy. As you can see, as per the data and statistics, usually the symptoms of asthma peaks in the late second or early third trimester. That is, usually the patients present with these asthmatic symptoms in the weeks between 17 to 24. As you can see, even though the patients are asthmatic, the first trimester, they usually do not present with these symptoms. But you can see whenever they enter the second trimester, they come to you saying that I had a cold or cough, and following that, I'm continuously having cough from the past 1 month. And this usually happens in the second trimester and the early third trimester. This is because the viral infections or the changes in the climate has triggered this asthmatic response in these patients. And you can also note that these exacerbations are comparatively less during the late trimester, that is during the labor and peripartum period. This could be because of various factors like increase in progesterone levels or increase in the maternal cortisol levels in the late trimester and during the labor. And if you can see, we often encounter questions like, in my first pregnancy, I had an attack of asthma during the pregnancy time. Now I am again pregnant. Can I encounter similar problem? Yes, as we can see, usually the severity of asthma symptoms, usually they mimic in the subsequent pregnancies. And what happens during pregnancy that the asthma can worsen? So usually there is this hormonal effects, there is changes in the estrogen and progesterone levels during pregnancy. So estrogen is said to cause increased mucosal permeability and increased congestion, because of which there will be mucosal membrane edema even in the upper respiratory tract. And because there is more amount of tissue edema, there is increased mucus gland hyperplasia due to estrogen, there is more amount of chances of URTI and allergic response in pregnant women due to the estrogen effect. And when these patients have the increased mucus secretions, there is also a chance that they are more predisposed to develop URTI infections, which can once again trigger asthma. Coming to progesterone, progesterone is said to cause certain effects both in favor of asthma and against asthma. So usually there is increased minute ventilation in pregnancy, and this is said to be due to progesterone. Progesterone is also said to have a beneficial smooth muscle relaxation effect and can induce bronchodilation through cyclic AMP affected mechanism on the beta-2 receptors. Also, progesterone is said to have a certain glucocorticoid agonist activity, and this glucocorticoid agonist activity is said to cause mast cell stabilization and decreased histamine and inflammatory marker release. However, progesterone may also make the beta-2 receptors more sensitive, resulting in bronchospasm in response to an inflammatory response. Also, there is variation in the prostaglandin levels in the amniotic fluid and maternal serum, like PGE2, PGF2, and PGD2, out of which prostaglandin E2 is said to cause bronchodilation, it is said to have a positive effect, whereas PGF2 is said to cause bronchospasm. Also, during pregnancy, especially in the late trimester, the maternal plasma cortisol levels also increase, and increased cortisol levels is said to have a beneficial effect for asthma. And as I said, there are also certain anatomical changes and functional changes that occur during pregnancy. During pregnancy, because of the estrogen levels, there is increased airway edema, mucosal congestion, and mucosal friability, because of which they are predisposed to upper respiratory tract infections and also airway hyperresponsiveness. Also, because of the growing uterine size, there is elevated diaphragm. The subcostal angle also increases, and the EAB and transverse diameter of the chest also changes. And certain functional changes you can also note in pregnancy, out of which one thing is important. Because of the maternal and fetal demand, the oxygen consumption in pregnancy is increased by 20 to 30%. Hence, it is very important to maintain the maternal oxygen levels to prevent fetal hypoxia. And there are certain risk factors which increase the pregnant woman to develop asthma attack. And out of this, the single most important factor is smoking. Even though the incidence of smoking is very less in India, but still, lot of pregnant women are said to expose to cigarette smoking. And this is because of passive smoking. So even though the women do not smoke to a greater extent in India, still they are exposed to the smoke that is exhaled by the family member, either husband or some other elderly person in the home. And the smoke that is coming from the tip of the burning cigarette and which is exhaled is said to create a catastrophic effect on the maternal lungs. It is said to increase the risk of asthma. In addition to that, it is also said to have a very bad effect on the fetus. Even the fetus whom in utero are exposed to cigarette smoke are said to develop asthma in the later life. And there is also chances of preterm delivery, low birth weight, IUGR for the children in utero who are exposed to smoking. So smoking is said to be the one important factor for getting exposed to developing asthma. And also in certain conditions like overweight, depression, anxiety, where the stress levels are high, the different inflammatory mediators are released, which may predispose the person to develop asthma. Also in individuals who are priorly asthmatics, who are priorly on medication, their asthma will be so poorly controlled that pregnancy may exacerbate the pre-existing condition. This is because most of the women who are on asthma medications, once they become pregnant, they become more concerned about the fetus that they stop all the other medications and take the medications only prescribed by the gynecologist for pregnancy, because they think that these are teratogenic, they may harm the fetus. But this may cause exacerbations of asthma and this may further harm the fetus. So priorly poorly controlled asthma and poor adherence to asthma medications are also said to be risk factors for flare-ups of asthma during pregnancy. So how do you evaluate a patient who present to you with these symptoms? So as you all know, the predominant symptoms of asthma are chest tightness, wheeze, shortness of breath, cough, and expectorations. And they are variable over time, that the symptoms are not persistent. The patient may be fine during the morning, but they may experience more symptoms during the night and early mornings. So usually the patients present to you like this. They usually present at around 18 to 20 weeks. They say that I had a cough, or I had a change of weather. I went somewhere, ate this or that, then I had cough and it is not subsiding at all. And in the mornings I am fine, in the evenings I am developing these symptoms. And sometimes the patient may not present to you with symptoms like chest tightness, wheeze, breathlessness or anything. She may only present with early morning expectoration, cough, and some foreign body sensation in the throat. This you can call as cough variant asthma. So if the patient presents to you with these symptoms, then you have to evaluate if the patient is having asthma. Also, you have to look for other differential diagnosis, other causes in which patient may present with cough-like symptoms like GERD. GERD is also said to precipitate cough. Postnasal drip, where after URTI, the postnasal drip could be the cause of nocturnal cough, vocal cord dysfunction, and other hyperventilation symptoms, so anxiety, and in rare cases, pulmonary embolism patient may present with shortness of breath. So if at all the patient presents with these symptoms, let alone cough, or even with chest tightness, wheezing, you have to evaluate for bronchial asthma. And how do you assess the patient? You can objectively assess the patient for asthma using spirometry. Spirometry, also known as pulmonary function test, is a test wherein the patient is asked to breathe into a device which is analyzed by using a computer. So there you can assess the lung function, the airway obstruction, the lung capacity. Thereby you can assess whether the symptoms are functional or it is asthma. Also, newer diagnostic facilities like FeNO is available. FeNO is fractional expiratory nitric oxide, where the patient is asked to exhale the air into a device which measures the amount of nitric oxide in the exhaled air. And this expired nitric oxide levels helps you in assessing if the patient is having asthma. So why should you be worried? If asthma is not treated properly, it may cause certain complications like preeclampsia, PIH, preterm labor and premature death. Also, recurrent attacks of asthma causing maternal hypoxia may lead to hypoxic injury to the fetus, resulting in congenital anomalies, low birth weight, and sometimes seizures immediately. So, asthma can also cause respiratory failure in the woman, and this may result in need for mechanical ventilation, higher doses of IV parenteral usage of drugs, antibiotics, and other complications associated with mechanical ventilations like barotrauma, ventilator-associated pneumonias, hospital-acquired pneumonias, etc. So when asthma is treated properly, you can avoid all these complications, and this has to be counseled to the patient. So what is the primary aim of treating bronchial asthma in pregnancy? It is to control the symptoms of the patient, to maintain the optimal lung function, to avoid any exacerbations leading to the prior mentioned morbidities in a pregnancy, and to maintain fetal oxygenation, thereby preventing both maternal and fetal hypoxia. So management of asthma in pregnancy mainly focuses on patient education, avoidance of triggers, smoking cessation, counseling, and adherence to medications and inhaler technique. So coming to patient education, usually the patients with asthma have to be counseled regarding the nature of the disease, that the symptoms may vary, and they have to be counseled on how to identify their symptoms early so that they can be treated early. They have to be counseled regarding the medications, that the use of medications is more beneficial, that the benefits outweigh the risks, and they have to adhere to the medication. They also have to be counseled regarding how to use the medications, that is especially the adherence to inhalers, which I'll be discussing later. Also, they can be given a written asthma plan, and they can be counseled how to monitor their asthma symptoms. This image you can see here is a peak flow meter, which you can advise to the patient to use it at home. This is a very simple device. It measures around size of a 200 ml water bottle, and the patient is asked to blow into that with as much force as possible every day. She is asked to do it once upon awakening, again 12 hours later, and she is asked to note down the amount of recording. As you can see, the yellow line, it shows the amount of ml of air that is forcefully expired. That is a peak expiratory flow rate. And she is asked to note down the value. And if at all she notes down that there is a decline of more than 200 ml in the reading, then it implies that her lung function has decreased and she is prone to an asthma attack. So she can herself monitor if her lung function is declining using the peak flow meter. Then she is asked to report to the OPD and to follow with the doctor and escalate the medication so that the asthma exacerbation is not precipitated. So also, not only the patient, but the family members also have to be counseled regarding smoking cessation and to avoid the triggers. Regarding the triggers, the patient has to be educated about the possible triggers that can precipitate asthma. Like certain foods, if they're allergic to, they have to avoid it. They have to avoid exposure to the dust, the curtains, the beddings, everything have to be cleaned weekly, and the patient should not be exposed to the dust while cleaning. And one more important point is, one of the most common trigger which is neglected by the pregnant woman or the families is when the people are having pets at their home. the hair on the pets, the dandruff on the pets is one of the most important triggering factor for developing asthma. So if at all your patient is following your treatment and still she is having this asthma attacks and triggers, it is very important to search for the triggers and if possible to avoid the closer contact with the pets and also to get the pets treated for the hair fall and dandruff. This is very important because this is one factor which we will be encountering in the routine practice which is triggering asthma. Coming to the adherence regarding medications and inhaler technique, we'll go in the next slide. And the pregnant woman with asthma usually have to be on follow-up for every 4 to 6 weeks with both the gynecologist and your pulmonologist or the doctor from which you are taking treatment from asthma. And also in the late trimester, if you are having acute exacerbations of asthma, the fetal activity monitoring should be done. The fetal heart rate and activity should be monitored. And if after 32 weeks, the patient is still having a severe asthma, the non-stress test can be done to assess the severity of asthma. As I said regarding inhalers, there are different types of inhalers available in the market. And it is very likely that the patients may not have idea regarding the inhalers. They may sometimes purchase a certain inhaler from over the counter and they keep on using. And they say, I have been using the inhaler, still I don't have the response. This is because there are different types of inhalers. There are different types of devices. There are different types of medications. And it has to be individualized based on patient severity of asthma and patient compliance. And coming to the medications, there are relievers and controllers. Both relievers and controllers have to be used based on the condition. If the patient is having recurrent attacks of asthma and is using only relievers without using controller medication, her asthma and lung function may not improve. And she says that I am not having any relief and I have been continuously using inhalers. So this is where the point of and role of use of inhalers, adherence, and patient education comes into role. So as you can see, there are different types of inhalers, like meter dose inhaler, that is MDI. MDI is like a pressure pump, which you can usually see in the movies, like it's like a pump with a canister where you press the canister, and because of the propellant and canister mechanism, the drug is pumped into the patient airways. That is, the energy is given from the device. Similarly, you have nebulizers where the drug is made into smaller particles and you can inhale the drug without any effort. There are also certain devices like dry powder inhalers, where the dry powder inhalers, you take the dry powder in a capsule, the capsule you put in a device like rotahaler or nebulizer, and the patient is asked to inhale the drug. And this is controlled by the patient, but the patient has to take the drug forcefully, hence she has to take a deep inspiration to deposit the drug in the lungs. So which device you use for the patient is based on patient compliance and is individualized. Both meter dose inhalers, dry powder inhalers, the deposition rate depends on patient effort and compliance. In patients who can't use the meter dose inhaler or dry powder inhaler, you can use nebulizers for the patient. Also, there is something called as spacer. What is a spacer? Spacer is a device like this, where you can put the pressure meter dose inhaler here, and you can just pump the drug into this, and this end of the mouth has to be kept in the patient's mouth, and patient is asked to inhale slowly. And this use of spacer can be particularly beneficial in pregnant women because it reduces the oral deposition, it reduces the effort needed, it reduces the effort for patient and inhaler coordination. As you can see, the adherence and technique is very important. There is something called as poor inhaler technique. Many times we prescribe inhaler to the patient, but the patient may not use it properly. Usually the common mistakes being done, or the patient will not shake the inhaler properly, or they will not exhale the air before using the inhaler, and the coordination, the pumping of the drug and inhaling will not be coordinated. Also, after inhalation, the patient may not hold the breath, and all these result in poor inhaler technique. Also, the most common mistakes we encounter is the patient may not identify that the inhaler is empty. So they keep on using an empty inhaler. Now that dose counters are available, the problem is less. And sometimes we advise an inhaler to the patient, we ask them to take 2 puffs. And you can see as in the first image, they don't know how to hold the inhaler. Many times they say that the inhaler is not giving the pulse, because instead of holding the mouthpiece down, they reverse and hold the inhaler. This is a very common mistake we encounter with patients. And sometimes they don't even know to open the cap and use the inhaler, because sometimes this asthma may precipitate first time in pregnancy. And when we ask them to take the inhaler, sometimes they take it for a very long distance. Sometimes they take it through their nose. When we say inhaler, the first thing that comes to the mind of the pregnant lady is a Vicks inhaler, and so she keeps it near the mouth and takes. These are the common things we encounter. So proper adherence, how to hold the inhaler, how to open the cap, proper shaking of the inhaler, keeping the inhaler into the mouth, proper seal around the mouth, and taking one puff at a time, breath holding, then repeating the step after 30 seconds to 1 minute, and then breath holding is what you have to advise to the patient during the use of inhaler. If at all the breath holding or the patient coordination is not fine, you can use the spacer for the patients as I have advised. And certain precautions you also have to advise to the patients, like the patient has to clean her mouth after using the inhaler. Otherwise, there will be oral deposition and systemic absorption, because of which there may be certain side effects. But if the technique is properly done, you have to counsel the patient that the side effects due to the drugs is very less. Coming to the medications used in treatment of asthma, as you can see, the most common drugs that help in relieving the symptoms of the bronchodilators. There are two types of bronchodilators, that is short-acting bronchodilators and long-acting bronchodilators. So coming to short-acting bronchodilators, they are usually salbutamol, levosalbutamol, formoterol, salmeterol. Out of these short-acting or the salbutamol and levosalbutamol, the short-acting bronchodilators, they start acting within 5 minutes, and usually their action stays for half an hour. So if you use a short-acting bronchodilator, it may not produce a persistent response. So you have to use a long-acting beta bronchodilator, which is like formoterol and salmeterol. Usually the bronchodilators, when used inhalationally and in correct dosage, are well tolerated. Certain side effects like phlegmus and mild tachycardia may be encountered, which are usually manageable with proper dosing. And coming to the inhaled glucocorticoids, inhaled glucocorticoids play a very important role in management of asthma, and the guidelines suggest that you have to use a inhaled corticosteroid along with long-acting long-acting bronchodilator, beta 2 agonist, preferably to maintain maintain the lung function in patients with asthma. Usually inhaled corticosteroids commonly used are budesonide, beclomethasone, and fluticasone. And if properly used and if the mouth is properly cleaned after using, the side effects are very less. Usually the most common problems you encounter are cough, dysphonia, oral candidiasis, etc. But these can be reduced with the use of spacer and proper mouth washing. Oral glucocorticoids can be used if the symptoms are not controlled with inhalational bronchodilators and glucocorticoids. But there is a very small risk of cleft lip and cleft palate if used in the first 13 weeks. And there is chance that patient may develop gestational diabetes and PIH, not PIH, and little bit high blood pressure. And if you can see, most of the drugs are FDA-C category approved, but when the benefit outweighs the risk, you have to use these drugs, and it has to be properly counseled to the patient and patient family. Other drugs like leukotriene receptor antagonists like montelukast, we commonly see gefileucast, can also be used. Montelukast is in fact a category B drug, and sometimes in severe asthma, you can use theophylline, either doxyphylline or deriphyllin, as an add-on therapy, but within the prescribed dosage. And regarding antihistamines and decongestants, antihistamines like chlorpheniramine maleate, cetirizine, fexofenadine, desloratadine can be used, out of which the drugs like cetirizine, chlorpheniramine maleate, and loratadine are category B drugs, and fexofenadine is a category C drug. But these all category C drugs we have been using from the past 10 to 15 years for pregnant ladies, and we have not encountered much pregnancy-related complications in these patients. And coming to immunotherapy and regarding biological agents, these are the modalities we use in very severe patients, and use of biological agents is usually avoided during pregnancy. And if at all the patient is not adhered to treatment, like patient is not responding to a long-acting bronchodilator and inhalational corticosteroid, you can use an add-on therapy of long-acting muscarinic agent like tiotropium or glycopyrronium. These are also category C drugs, and add-on therapy with theophylline agonist and leukotriene receptor antagonists and antihistamines. And patient can be maintained with these drugs if additionally required. Oral glucocorticoids in a very low dose and ranging from less than for less than 5 days can be given. And if required, the patient has to be treated with antibiotics in case of infection. And coming to the other precautions patient has to take regarding the flu shot. Yes, flu shot can be taken during pregnancy. And because once the patient develops a viral pneumonia, the consequences are more dangerous. It is advisable to take a influenza flu shot for all patients with pregnancy with related to asthma. And regarding the key points to be noted in patients with asthma during labor, delivery, and postpartum period, only 10 to 20% of the patients develop asthma exacerbations during labor. And oxytocin is safe to use during pregnancy for patients with labor. And if possible, spinal anesthesia and epidural is preferred and is safe than general anesthesia for patients with asthma. And if at all general anesthesia becomes necessary, choice of general anesthetic to be used is ketamine. And as I said, certain prostaglandins have a positive effect and certain have a negative effect on asthma. PGE2, the most common prostaglandins like misoprostol, is said to be safer in pregnancy, whereas PGF2 and LOX like carboprost have to be avoided during pregnancy. And if systemic steroids, as I said, oral glucocorticosteroids or IV steroids are used during the last 1 month of pregnancy, or they have been used before labor, then IV testosterone should be given during labor to prevent withdrawal effects. And if high doses of short-acting beta-2 agonists, recurrent nebulizations are given, then neonatal blood glucose levels have to be monitored during the first 24 hours. So, concluding the topic, asthma in pregnancy is commonly encountered and is usually misdiagnosed as a simple URTI. But asthma has to be treated to maintain the lung function and to prevent the maternal and fetal hypoxia. And the pregnant ladies have to be counseled regarding the symptoms of asthma. And regarding breastfeeding, usually you can do breastfeeding while using asthma medications. The inhaled medications are 100% safer because the absorption from the inhaled medications is very less. And once you clean your mouth after using inhaled corticosteroids or inhaled bronchodilators, the systemic absorption is very low and the drug is directly deposited in the lungs. Hence, breastfeeding also improves the immunity and reduces the risk of infections in the fetus. Hence, breastfeeding has to be encouraged even in patients on medications for asthma. Thank you.
The moderators of this session, Dr. Pavani, Priyanka, Dr. Anasuri, Priyanka, Prasuna. If you are there, please unmute and respond to the speakers. Okay. I can see them in the gallery, but they're not responding. Okay. Dr. Sushmita, it was a wonderful presentation, very in detail presentation. Illustriously, you have described everything regarding the management of the very important condition. It is a life-threatening condition. I have seen one of a fellow doctor dying with asthma during pregnancy, a pathology medical student, pathology postgraduate. When I was doing my post-graduation, and that was a indelible mark on my memory. You have done an excellent job. Thank you so much. If there are any doubts, the delegates can put in the chat. You please wait. We'll get back to you, madam. Thank you.
I thank Dr. Ravikrishna Garu and I thank Dr. Ramani Garu for giving me this opportunity and meticulously organizing this CME. Thank you. Thank you, sir. Thank you.
Thank you. Now, The next topic is by none other than our own sweet Hemalata Madam, Dr. G. Hemalata Anantapur, who
Good morning,
is the
madam.
chairperson of IMA Women Doctors Wing of IMA AP State, is going to speak on the topic, what are the red flags of autism in toddlers? Madam Hemalata, no
Madam, good
words
morning,
to-
madam.
Good
morning,
morning. She is a very active academician, social worker, and then she spends most of her time with IMA. Though she is doing up and down because of the job, still she has a heart with IMA, and she is in the forefront for any requirement of IMA Epistate. Madam Hemalata, I request you to start your topic. Thank you.
Thank you, madam. Thank you very much. Thank you, Dr. Ravikrishna, sir. Good morning, sir. Good morning, everyone. I am Dr. G. Hemalata, pediatrician, chairperson IMA Women Doctors Wing, Andhra Pradesh. My topic is about the red flags of autism in toddlers. Nowadays, autism disease is high and underrated because so many parents don't even know that if their children are suffering from autism. According to the Center for Disease Control and Prevention, autism spectrum disorder is one of the most commonly diagnosed developmental disorder. It is commonly seen in 1 in 100 live borns. The ratio of urban versus rural is 9:1. It is commonly seen in nuclear families. Infants need to be exposed to more than 10,000 spoken words with emotions every day. It is commonly possible in combined families than compared to nuclear families. Exposure to mobile phones before 1 year of age for more than 3 hours a day can also cause autism. Identification of red flag signs early in a child life, giving them a better chance at healthy development. What is the history of autism? The term autism first was used by psychiatrist Dr. Eugen Bleuler in 1908, first described by Leo Kanner in 1943 as early infant autism. Autism means locked within themselves. For next 30 years, considered to be an emotional disturbance. In 1943, Donald Triplett was the first person to be diagnosed with autism. The country with the lowest diagnosed autism rate is France. It is about 1 in 144 children. The first time the term autism appeared in India was in 1959. The number of children known to have autism has been increased dramatically since 1980s. In 1980s, approximately 7,69,620 births were occurred. About this, a study was conducted to 489 children. Out of this, 241 children were found with autism disease, which is approximately 49%. Going to definition, it is defined by the presence of abnormal and impaired development is manifest before the age of 3 years, characterized by abnormalities of social development, communication, and restriction of behavior and interest. Autism is developmental disorder that appears in the first 3 years of life and affects the brain normal development of social and communication skills. The prevalence rate is 2 to 6 per 1,000 individuals, 4 times more common in boys. No known racial, ethnic, and social boundaries. Next slide. Developmental milestones. Development refers to maturation of functional and acquisition of various skills for optimal functioning of an individual. The maturation and myelination of the nervous system is reflected in the sequential attainment of developmental milestones. Infancy and early childhood are the most crucial phases during which development takes place. Development is a continuous process. It depends on the functional maturation of the nervous system. The sequence of attainment of milestones is the same in all children. The process of development progresses in cephalocaudal direction. Certain primitive reflexes have to be lost before relevant milestones are attained. The initial disorganized mass activity is gradually replaced by the specific actions. In India, many families celebrate their babies' milestones when they were attained. All milestones in babies' first year are special. The important milestones are gross motor, fine motor, social, and language. The gross motor milestones attained at the age of 3 months neck holding, 5 months rolls over, 6 months sitting with support, 8 months sitting without support, 9 months standing with support, 11 months crawling and creeping, 12 months standing without support, 15 months walking alone, 18 months running, 12 years walking upstairs, 3 years riding tricycle, 4 years standing with 1 foot. The fine motor milestones are 4 months bidextrous grasp, 6 months unidextrous grasp, 9 months immature pincer grasp, 12 months mature pincer grasp. The important social milestones are social smile at the age of 2 months, recognizing mother at the age of 3 months, recognizing strangers at the age of 6 months. The important language milestones are alert to sounds 1 year, cooing 3 months, and laugh loudly 4 months, monosyllabus 6 months, bisyllabus 9 months, 1 to 2 words with meaning 12 months, 8 to 10 words with meaning 18 months, simple sentences 3 years, ask questions 3 years, telling stories 4 years, ask meaning of the words at the age of 5 years. And then interpretation of milestones. While drawing any conclusion about development, repeated examination is desirable in child who does not have a gross delay. Some factors are very, very important. These are recent illness, significant malnutrition, emotional deprivation, slow maturation, sensory deficit, neuromuscular disorders, and preterm should be kept into the consideration. As per WHO, the bars illustrated in the given figure about the age range for normal children to attain the particular milestone. The range of normal pattern should always be kept in mind while assessing the development. A child who does not attain the milestones by the recommended limit should be evaluated for cause of developmental delay. Upper limit of age for attaining of milestones. This is called red flag signs in child development. These are more important. The visual fixation does not attain at the age of 2 months. Vocalization does not attain at the age of 6 months. Sitting without support does not attain at the age of 10 months. Standing alone does not attain at the age of 12 months. Crawling and creeping does not attain at the 14 months. Standing alone does not attain 17 months. Walking alone does not attain at the age of 18 months. Single words does not attain at the age of 18 months. Imaginary play does not attain at 3 years. Loss of comprehension, single words and phrases at any age. Most of the parents worry a lot and panic when their children does not attain the milestones at appropriate age. Parents need not to worry about that. First, they need to consult the doctor. So, autism always unique, totally interesting, sometimes mysterious. The main types of autism, there are mainly 5 types: Asperger's syndrome, Rett syndrome, childhood disintegrative disorder, Kanner syndrome, pervasive developmental disorder. And then go to Asperger's syndrome. This is the level 1 spectrum disorder. will have above average intelligence and strong verbal skills, but will experience challenges with social communication. The main symptoms are inflexibility in thoughts and behavior, challenges in suffering between activities, executive functioning problems, flat monotone speech, the inability to express feelings in their speech, difficulty in interesting with peers at school or home. And then Rett syndrome. It is the rare neurodevelopmental disorder commonly seen in infant period. Girls are most commonly affected. It affects the every aspect of children's life. The good thing is child can still enjoy and live a fulfilling with life with the proper care and support of the family members. Childhood disintegrative disorder, otherwise called Heller syndrome, otherwise called disintegrative psychosis. A child experiences normal development up to the age of 3 years and then starts developmental problems in language, motor skills, social functions after the age of 3 years and up to the age of 10 years. The developmental loss can be very heartbreaking for parents who had no idea about their children having autism. Boys are commonly affected, commonly lose these developmental milestones. Toileting skills, if these had already been established, acquired language and vocabularies, social and motor skills, adaptive behavior. Kanner syndrome. Infantile autism. This is classical autistic disorder. The symptoms are lack of emotional attachment to others, communication and interaction challenges, uncontrolled speech, and then mostly affects the motor and learning difficulties. Pervasive developmental disorder, mild type of autism. The most common symptoms are challenges in social and language development, also called subthreshold autism, because the persons that has some but not all symptoms of autism. Problem with using and understanding languages, difficulty relating to people, objects and events, different modes of playing with toys, difficulty with the changes in routine and surroundings, repetitive body movements and behavioral patterns. And then go to etiology. Genetic factors are commonly genetic factors, biochemical factors, medical factors, perinatal factors, neuroanatomical studies, parenting influence and social environmental factors. Genetic factors, more in monozygotic twins than dizygotic twins. Biochemical factors, 1/3 of clients with autistic disorder have elevated plasma serotonin. In the fetus, serotonin helps neurons to form and travel to their correct location. It also helps them link to other neurons at junctions called the synapses. Too much or too little serotonin can cause harmful. Too much serotonin affected the development of brain that causes the whisker movements. Very little serotonin causes the repetitive behavior and social difficulties. Medical factors, postnatal neurological infections, Fragile X syndrome, perinatal factors, maternal bleeding after first trimester, and amniotic fluid, extremely preterm babies, the baby born less than 26 gestational age. Neuroanatomical studies, enlargement of lateral ventricle and cerebellar degeneration. Parenting influence and social environmental factors, family breakup, parental rejection, family stress, faculty fault communication patterns, child born to old age parents, first child affected by autism increases the risk of getting autism to the second children. In this aspect, the relationship between the kids and parents is also taken into the consideration. When they become violent and clash each other, it leads to fear and emotional stress to the kid. If the parents continues this, then the kid's stress may take next stage, which finally leads to the autistic effect. Clinical features: no social interaction, impairment in communication, behavioral abnormalities, cognitive abnormalities. These children are not interacted with public, inability to make warm relation with people. Children do not respond to their parents' affection, responds very less even to their own name. They tend to their own things regardless of who is around or what is happening in the environment. Poor use of social signals and weak interaction of social, emotion and communication behavior. Failure to make eye-to-eye contact with people. Impairment of communication. Failure to develop normal speech. Failure to communicate by gestures, body movements and facial expression. Lack of social usage of Whatever language skills are present, delayed onset of unusual gestures, diminished responsiveness, and vocal pattern that are not synchronized with caregivers. Behavioral abnormalities, restricted, repetitive, and stereotyped pattern of behavior, tendency to impose rigidity and routine as a wide range of aspects of day-to-day functioning, gets very upset by minor changes in routine, difficulty in generalized newly learned skills to new situations, stereotyped and repetitive play. Rituals behavior like checking and touching rituals and dressing up in particular way. When rituals are interrupted, children may become anxious and anger. Rocking, headbanging, similar repetitive behavior are often seen in autistic children. Overactivity, destructive behavior, temper tantrum, which may occur for little or no response. Phobias, eating and sleeping disturbances are very common. Cognitive abnormalities, poor at symbolization, understanding abstract ideas, and grasping theoretical concepts. Memory may be excellent. Other features, many autistic children enjoy music particularly. The complications are in school and successful learning, employment problems, inability to live independently, social isolation, stress within the family, victimization and being bullied. The topic regarding diagnosis and treatment of autism spectrum disorder will be explained by Dr. Pratyusha, pediatrician.
Thank you very much, madam. You have explained excellently what are all the red flag signs, what are all the developmental milestones, and when we should suspect autism in the children. Now I'll be dealing with the topic, how to diagnose, in whom to diagnose the autism and what is the treatment strategies available. So when it comes to the diagnosis of autism, so there are many overlapping syndromes like OCD, Tourette, ADHD, learning disability, mental retardation, autism. These are all many overlapping syndromes in one brain. Okay, so of course, it is a very controversial when and how to diagnose a autism. So first we should know what are all the knowledge we have about autism. So now we can define autism because we have a definite criteria how to diagnose autism. We almost have no idea what causes it. As mentioned by Dr. Hemalata madam, it is an interplay of various factors like genetic and all. And we don't know if it is increasing now or is it being diagnosed more now. Maybe it is already existing, but we didn't know. So if it is increasing now, we don't know why it is increasing. But what we know for sure is we can make it better if you consider it a problem. So if you don't diagnose it, there is no way we can make it better. So when can autism be diagnosed? So research shows that autism spectrum disorder can be diagnosed as early as 1 year of age. So what are all the red flags when we should suspect autism? So when there is no big smiles in the child by 6 months of age, no back and forth sharing of sounds by 9 months of age, no babbling by 12 months of age, no using of pointing, showing or reaching or waving by 12 months of age, no usage of words by 16 months, and no usage of 2-word phrases by 24 months, and any loss of speech, babbling or social skills at any age. These are all the red flag signs as mentioned by the madam where we should suspect autism in a child. So suspicion itself is not enough. We should have a set of criteria how to diagnose definitely as an autistic spectrum disorder. So what is the best practice for the autistic spectrum disorder assessment? So early assessment and intervention is very crucial for the progress of the child. So who can diagnose this? Trained professionals, psychologists, neurologists, pediatricians, and psychiatrists. Usually it is an interdisciplinary assessment is the best method. And what are all the histories we have to take? We have to take the developmental history. We need some observations, direct interaction with the patient, and interview with the parents, and evaluation of the social communication, sensory, emotional, and the cognitive behavior of the child. And a single setting is never enough to diagnose a case as autistic spectrum disorder. So it needs multiple settings. So according to the DSM criteria, DSM-5 criteria, all the disorders as mentioned by the madam, like pervasive developmental disorders, Asperger's syndrome, autistic disorder, all are now grouped into one disorder, that is the autistic spectrum disorder. So autistic spectrum disorder has various factors, various symptoms like cognitive abnormalities, behavior abnormalities, medical abnormalities, which are all explained by the madam. But the core of the autistic spectrum disorder is the two main things. One is the impaired social communication and interaction. Second one is the restricted and repetitive behavior. So according to the DSM-5 criteria, these two things have to be present in the child to label that child as a autistic spectrum disorder. So what are they? First one is the deficit in the social communication. So deficit in social communication indicates deficits in non-verbal communication, deficits in social and emotional reciprocity, and deficits in maintaining the relationships. All the three should be present according to the criteria. And the second one is the restricted repetitive patterns of behavior. So what are all the restricted repetitive patterns of the behavior? Number one is the stereotyped motor or verbal behavior, or unusual sensory behaviors, or excessive adherence to the routines or rituals. Then fourth one is the restricted interests. So any two of these can be present to consider it as a criteria. So in social deficits of social communication, all the three should be present. Whereas in the restricted repetitive patterns, any two of the four things, if it is present, then we can diagnose this child is having autistic spectrum disorder. And one more important thing we should notice, these symptoms should be present since the early childhood and clinically significant and persistent. They have to be clinically significant and persistent. So coming into the diagnosis, so this diagnosis is entirely based on the behavioral criteria and it encompasses the entire range of severity. So other associated symptoms like the other pathologies like seizures or any other disorders, they can be present, they can be related to other biological etiologies. Coming into the screening and diagnosis of the ASD disorder. So there are two steps in this. First one is the developmental screening. Second one is the comprehensive diagnostic evaluation. So in the developmental screening, so every child, when a child comes to a well-child doctor visit at 9 months of age, 18 months of age, and 24 to 30 months of age, the child should be assessed for the normal developmental milestones, which were all clearly described by Madam. So whenever there is any delay or deviation from these milestones, then additional screening should be done and comprehensive evaluation should be done for the autistic spectrum disorder. So these are all the different signs of autism. So like inappropriate playing with toys, inability to relate. I'm not describing them again because Madam has very elaborately described all the signs of autism. I'll go into the diagnostic evaluation. So the comprehensive diagnostic evaluation, who are all we have suspected the autistic spectrum disorder, they should undergo thorough behavior and developmental evaluation. And there will be an interviewing of the parents, and the additional tests like the hearing and vision screening, genetic testing, and neurological testing can be done. So coming into some of the standardized behavioral diagnostic tests which are used for the autism diagnosis are, one is the CARS, that is the Childhood Autism Rating Scale. And the second one is the Autism Diagnostic Interview. Third one is the Autistic Diagnostic Observation Schedule. And the last one is the Modified Checklist for Autism in Toddlers, that is the MCHAT test. So the most widely used test for diagnosing autism in the children or for further evaluation of diagnosis in the children of autism is the MCHAT, that is Modified Checklist for the Autism in the Toddlers. So in whom this should be done? So it can be applied to the children in between the 16 months to 2 years of age. And the accuracy or the sensitivity of this test is nearly about 90% and specificity is 99%. So once we can make an appropriate diagnosis with MCHAT, we can directly label that child as ASD. Okay. So what is done in this modified checklist is we provide a checklist to the parents. So it consists of 23 questions. Okay. So in these 23 questions, they are like yes or no questions. So the parent need to answer every question. So in that, if the behavior is very rare, like you have seen it only once or twice, then the answer should be no. So if you have seen, for example, does your child enjoy being swung or bounced on your knee? So if it is only seen once or twice, then it is a no. So if it is repeatedly seen in the child, then they have to answer it as yes. So like that, 23 questions will be there with which the parent have to answer. So after answering all these 23 questions, we can categorize it depending upon the score into low risk, medium risk, and the high risk. Low risk, the score is in between 0 to 2. Then it indicates that the child does not have any indication of the risk factors for the ASD, that is the autism. So if the child score is between 3 to 7, then it indicates that child is having some risk of developing the autism. So we have to do one more follow-up test. So if the follow-up test also indicates the child is still having higher scores, more than 2, that is medium risk scores, 3 to 7, it indicates that the child requires autism evaluation or the child requires autism treatment. Third one is high risk. If the total score is 8 to 20, then we need not even do a follow-up test. It directly indicates the child is having a very high risk score for the autism, and we have to appropriately treat the child. So based on this MCHAT, we can categorize the children who is having the low risk, who is having medium risk and high risk, and then we can appropriately follow. It is a simple OP test which we can just put a form in our OPD and children can be screened based on the parents' questionnaire. Then coming into the treatments for autism spectrum disorder. So there it is like a maze. It is not a single treatment which is effective for the treatment of the autism. It is an interplay of various factors and interplay of various professionals and interplay of various environmental change. So coming into the treatments available. So first one is the behavioral analysis. Second one is the pharmacological intervention. And the third one is some dietary alterations or the other environmental alterations. Coming into the treatment strategies, there are various treatment strategies. Behavioral management therapy is the main golden role in the management of the autism. So the various behavioral management strategies available right now are the cognitive behavioral therapy, social skills training, joint attention therapy, parent-mediated therapy, physical therapy, and speech and language therapy, including the occupational therapy. So coming into the first one, that is the cognitive behavioral or the comprehensive behavioral treatment of young children. This is mainly based upon the principle of the applied behavioral analysis, and it can be utilized in a various settings, but it requires 1-to-1 ratio. So what is this acquired behavioral analysis? So it is a 3-step procedure. So we provide an antecedent like a verbal or physical stimulus to the child, and we see the result of the child, that is the behavioral response of the child to the stimulus. So either the child will give some response or there will be some lack of response. Then the third step is we give a positive reinforcement, and then we see what is the change in the behavior of the child. So based on this 3-step procedure, we can modify the behavior of the child. And when we go into the studies, applying this ABA analysis for the autistic children and using this for the behavioral changes, there is very drastic increase in the IQ scores of the children. So it is very useful in the management of the autism children. Second one is the joint attention intervention. It mainly focuses specifically on enhancing or developing a skill of joint attention, and it is usually done in discrete training. Third one is the play therapy. The play therapy mainly focuses on the communication skills of the child. Okay, in this play therapy, we give a floor time, means the child and along with his guardian, either the parent or the caregiver, they'll spend a lot of time on the floor playing with the toys, and that time is utilized to improve the communication skills of the child by building a rapport with the parent or the caregiver. Then the fourth one is the integrated play group. Here in the integrated play group, what we do is we mingle the children of like autism along with their non-disabled peers. Okay, so integrated play groups are used so that socialization and imagination of the autistic children will be developed. In this integrated play groups, usually we follow a set of rules. There will be appropriate play environment that is created, selection of materials will be there, and the preparation of peers is also very important so that it won't cause any inconvenience to the autistic children. Then coming into the fourth one, that is a modeling. So we'll show the child how to do a behavior. So and this is usually used in the children between 3 to 18 years, elder children. And this modeling can be done by live modeling or showing some tapes. Okay, that is tape model. Then the next one is the story-based intervention. So here some stories are used to understand certain situations or develop new skills in the child. So both this modeling and the intervention, that story-based intervention, these can be used in the elder children, that is 6 to 14 years, above 3 or 6 years. Here we can use social stories, scripts, or comic strip conversations, which are interesting to the child, so that situations are shown and how the development of new skills is inculcated in the child. Then next one is the antecedent package. It is shown to be very effective in the children in the age group of 3 to 8. Here certain strategies like teach strategies are used. What is teach means teach, but a training education of the autistic and related communication for handicapped children. It is a highly structured program which is based on the culture of the autism. It mainly refers to increase the strengths and difficulties shared by the people with autism. Then coming into the next strategy, that is the skirts, social communication, emotional regulation, and transactional support. which usually focuses mainly on the social communication and the emotional regulation. And there is an approach called the Hannon approach. So what is important in this Hannon approach is mainly based on the belief that the parent should be the child's language teachers, means the children should learn their language skills mainly from the parent. So here the parents of the autistic children are trained how to train their children, and they are certified. That is called as Hannon certification, so that they can train their children in the language skills at their home. And the other therapies are the communication therapy and the PECS therapy. PECS therapy is nothing but picture exchange communication system. Here, this enables the autistic people to communicate using various pictures that represents ideas, activities, or items. Here, the individual is able to convey their requests or needs by simply handing those pictures to the caregiver. So these are certain PECS therapy aids which can be used to train the autistic children. So coming into the pharmacological intervention, currently there is no medication that can say that it is going to cure the autistic spectrum disorder. Okay, so but there are many medications which are being approved by the FDA to decrease the symptoms in these children, but there is no single drug like it can cure autism. Okay, so what are the various drugs which are used in autistic children? One is, as Madam told, serotonin is a very important, plays a very important role in the neurological connections in these autism children. So SSRIs can be used. They might reduce the frequency and intensity of the repetitive behaviors. They can decrease anxiety, irritability, and they can also improve the eye contact. Then the second drug which can be used is the tricyclic antidepressants. These are mainly used to treat depression and the OCD behaviors present in the autistic children. Third one is the antipsychotic or the psychoactive medications, especially the risperidone, which usually reduces the irritability, especially in the elder children, like 5 to 16-year-olds. Okay, these drugs are also known to decrease hyperactivity and reduce aggression among the people with autism. Then coming into the stimulant drugs mainly help in increase in the focusing and decrease the hyperactivity in the children. They are particularly helpful when the symptoms are very mild. And anti-anxiety medications and anti-convulsant medication. Almost 1/3 of the people with autism symptoms are being known to have seizures or the seizure disorder. So anti-convulsants can be used in those children. Coming into the dietary modifications, there are very false beliefs like autism is sometimes related to some diet. So use of gluten or casein or eliminating gluten can cause or can cure autism. That is a very false thing. So usually eliminating foods that contain gluten will not have any effect on the treatment. Okay, and they might even have side effects like gluten deficiency can occur, leading to some deficiencies. So no diet can be excluded. But the studies have shown that including more of vitamin D, magnesium, and cod liver supplements, they can improve behavior and eye contact in the children. So vitamin D, magnesium, and cod liver supplements can be used to increase the eye contact, improve the behavior, and increase the attention span in those children. Vitamin C has also been known to increase the learning abilities in these autistic children. So these are the only dietary things which we have to add. There is no diet that should be excluded in autistic children. So all the diets can be given, and particularly vitamin B, magnesium, liver supplements, and the vitamin C, they are very much known to improve the behavior, eye contact, and the attention span. So coming into what are the poor prognostic factors. So we have seen what is the diagnosis, what is the treatment we can give, and what are the poor prognostic factors. So whenever there is coexisting mental retardation or any environmental toxin effects in the advanced parental age, and if the diseases coexist along with other syndromes like Fragile X syndrome or Down syndrome, usually they have very poor prognosis. Okay, and when we see the poor prognostic factors, genetic predisposition, that is, if there is almost in autism, 10 to 15 can have chromosomal abnormalities. Whenever these chromosomal abnormalities are there, the prognosis is very poor. So coming into the conclusion, so autism can be treated only if it is identified. The first step in the treatment of autism is to know that there is something wrong with the child. So we cannot just exclude, like the child did not have friends, the child is being just withdrawn, he is having a lack of empathy. It is not autism. Autism is a neurological difference. The first step in the diagnosis or management or in improving the autism outcome is, first we should know there is something wrong with the child. We should then have a proper developmental assessment and evaluation and diagnose the autistic spectrum disorder. Then we have to take the child to the continuous behavioral therapy and various behavioral approaches which I have described. Then the outcome will be very. Handing over to Dr. Hemalata Madam. Thank you. And on behalf of Women Doctor Wing, Anantapur, and Dr. G. Hemalata Madam, Women Doctor Wing, I am Dr. Pratyusha, Assistant Professor of Pediatrics. So we thank Dr. G. Ravikrishna sir and the whole team of the IMA AP
Dr.
State.
Fanidhar sir, Dr. Ravindranath sir.
Dr. Fanidhar sir, Dr. Ravindranath sir, Dr. Durga Rani madam, and a special thanks to Dr. Hemalata madam for giving me this chance, and Dr. Ramani madam, AMS president. We thank everyone from the bottom of our hearts for giving this chance to have a speech on autism, which is a very burning issue right now. Thank you. Thank you so much.
Dr. Pavani Priyanka.
Yes.
Priyanka Anasuri. Dr. Prasuna, if you are there, please react, give your comments to the speakers. You are the moderator of this session. I'm not able to see.
Good morning, madam. I'd like to say that first of all, I would like to thank Dr. Hemalata Garu. That's such a beautiful presentation. And Ms. Pratyusha, Dr. Pratyusha Garu, that's well said about the diagnostic symptoms. She has explained it very clearly. And regarding the Robin et al. Chart, that charts, most of the time, of the pediatricians will be seeing the cases of autism nowadays. But most of them don't have these charts with us. So that's a really very good tip for us to go back and bring back all this knowledge. You poured such a beautiful presentation out. And one more thing I'd like to include today, because of this COVID, there's a drastic changes in behaviors of the children. Mostly because of there's a single point, maybe it must be skipped, the role of caregivers. Most of the time, the child who are with the parents before COVID scenario, the parents used to work somewhere. Now they are working from home. Suddenly, the use of gadgets at home has increased a lot. Suddenly, the child is seeing their parents working on the gadgets, phones, laptops, and everything. The screen time has increased drastically before and after COVID. That is a gross difference, because before that, you have said that there is an increase in the autism cases. Like previously, the autism cases are detected. Nowadays, you're saying that autism cases are detected more. That's also another factor. But autism cases are relatively increased more because of the increased screen time. Because most of the children are exposed to the mobiles and the laptops because of the work from home parents. And sudden change of caregivers is there, because previously they used to stay with the parents or some other caretaker. Suddenly they have changed their location. Because of COVID, people are changing their location to the remote areas like villages, and there the total scenario is changed, and language also is changing. That's one of the main reason for the increase in autistic spectrum in nowadays in children. I agree with you, the diagnosis increased. That we are detecting more number of cases. At the same time, the cases number also increased because of the increase in screen time. And the use of the charts is very essential in all the pediatric OPDs. It's a really very good point, Ms. Dr. Pratyusha. You have given a very good insight about it, and I really appreciate, and thank you so much for giving me this opportunity, madam. Thank you.
Thank you, madam.
Thank you, madam. Thank you.
Thank you, sir. Now the IMA-AMS part is done. I request the Women Doctors Wing to take over the conduction of the rest of the conference. Thank you.
Okay, madam. Thank you. Thank you very much.
Thank you, madam, Ramani madam, for organizing the first session in an excellent manner.
Thank you, sir.
I'm Dr. Sumana Gopichan speaking.
I'm Assistant Professor, Department of Community Medicine, as well as IMA Women Doctors Wing, Anantapur Secretary. So I would like to introduce the moderators as well as session speakers from the next onwards, just within 2 minutes. So the moderators for the session are Dr. A. Padmaja ma'am, Professor and HOD, Department of Anesthesiology, Andhra Medical College, King George Hospital, Visakhapatnam. And the second moderator would be Dr. K. Madhavi Shamala ma'am. She is a general surgeon. She had done her graduation from KMC as well as post-graduation from Usmania Medical College, Hyderabad. Now she is currently working as Professor of Surgery. Ma'am had done several works. One of it is Medical Officer for RCH Pilot Project at Alur, Kurnool District. Received 4 commendation awards as Best Doctor, and her areas of interest are laparoscopic surgery and academic teaching, gender sensitization and women rights. And she had been chairperson for District Gender Harassment Committee as well as chairperson Indian Medical Association, Women Wing, Kurnool. And ma'am had presented papers in national conferences, published papers in national journals, and she had been examiner for undergraduates and postgraduates. Dr. Padmalata Anusuri ma'am is a third moderator, and she's a pulmonologist. She had done her MBBS from Rangaraya Medical College, Kakinada, 1984 batch. And ma'am is also a gold medalist. She had done her post-graduation from Andhra Medical College, Vizag, 99 batch. And the speaker for the session is Dr. P.V. Durgarani ma'am, DGO Surgery, Associate Professor from Siddharth Medical College, Vijayawada, as well as Chairperson IMA Andhra Pradesh, Mission Pink Health. And the topic for the session is Increasing Colorectal Cancer Screening and Prevention. Now, I would like to hand over to Dr. Durgarani ma'am, as well as moderators. Moderators ma'am, please. Padmaja ma'am.
Good morning, everyone.
Padmaja ma'am. Yeah. Hi ma'am.
Hi.
Madhavi Shamla ma'am.
Hi.
And Padmalata Anusuri ma'am. Hi ma'am.
Hi, everyone. Hi.
Hi,
Yeah.
ma'am. Good morning.
Good morning.
Good morning, everyone. Madam. It's a great U conference happening. And Dr. Ramlata, madam.
Madam, try clicking on that arrow that is there, ma'am. Upward arrow. Yeah. Now same as system. Can you, if you can see? Same as system. First option. Same as system, yes. Try it. No, ma'am, you're not audible. Click on that lock button that is there. Yeah. Here you can allow. Yeah, down second. Try leaving the meeting and rejoin, ma'am, once. Yes, ma'am. Leave the meeting and then rejoin once.
Meanwhile, shall we have our panel discussion? Shall we, before the things settle?
Ma'am,
Hemlata
small
madam.
submission from me, ma'am.
Huh? Because I
Dr.
have
Prashant.
elderly people, principals, retired principals and all waiting in the wings. I cannot.
Okay, ma'am. Okay, ma'am. One minute, ma'am.
Very seniors are waiting.
Just we are communicating to Durga Rani, ma'am.
Or meanwhile, we can finish our PAC also, ma'am.
Already 8 minutes lost and we are 1 hour late, I think. Shall we start?
Panel discussion, ma'am.
Yes.
Yes.
Mahalakshmi
Okay.
madam, you are there, no madam? Mahalakshmi madam? Mahalakshmi madam, please unmute. Dr. Padmavati madam?
Yes, ma. Good morning,
Namaste,
Ramani
madam.
garu.
Namaste, madam. I can see you. Dr. Mahalakshmi madam? Dr. Lalita?
Mahalakshmi, you have to unmute.
Yes, ma'am. I'm here, ma'am. Lalita is there. Dr. Mahalakshmi madam? She was there all the time.
No, she has to unmute.
Mad sir?
She has to unmute. May not be knowing
She has to
how.
unmute. Madam, please unmute, madam. Mahalakshmi
Call
madam.
her.
I will call her.
Ma'am, it seems that Durga Rani ma'am is ready.
Hello.
Hello, ma'am.
You are ready, madam? Okay, ma'am. Shall we start, or Durgarani madam is there? Hemlata? Hemlata?
Madam.
Whatever, because very senior madams are there.
Durgarani ma'am is ready, ma'am. Within 2 minutes.
Get ready, no? 2 minutes are there.
1 minute, madam.
Because shall I share my screen?
Durgarani ma'am. Ma'am is ready, ma'am.
Whatever you say, I'm ready here.
I think Durgarani ma'am can unmute. I think unmute option. Unmute yes.
Madam, ready ఉన్నారా? Ready, madam.
Ma'am, Ramani ma'am, you can just start, ma'am.
Yes, ma'am.
I will. Durgarani ma'am. Okay, ma'am.
Are you able to see my screen?
Yes, Ramani.
Are you able to see, madam?
Yeah, of course. Am I audible, Dr. Ramani?
Yes, ma'am, you are audible.
Yes.
I will
It's
just
there. It's there.
I will have to. I'm not able to see you all, but I can hear you, madam. Now I'm starting with the permission of the moderators, Women Doctors Wing, Dr. Hemalata, and our esteemed President of IMA AP State, Dr. G. Ravi Krishna, sir. I'm starting this panel discussion on lump breast in this prestigious Evecon, which is the special feature of which is the speakers, moderators are the women doctors. Lump breast is often a question that is in the minds of women. They may feel normal breast as lump. They may feel a breast lump at any stage of their life. Is it significant? What is the important that we should give, and how should we proceed? That is a message that we want to give during this this session. I have with me my own teacher, Dr. R. Mahalakshmi madam, who is like an elder sister for me, under whom I have done my post-graduation in Kakinada. I'm fortunate to have her as one of the panelists. She is former superintendent, Government General Hospital, Kakinada. She was former additional director and principal, Rangaraya Medical College, Kakinada. I welcome Dr. R. Mahalakshmi madam onto the panel. Next is none other than Dr. C. Padmavati madam, MD Pathology. I was fortunate to madam. I was fortunate to work under Dr. C. Padmavati Devi madam when she was additional director and principal Guntur Medical College, Guntur, for a stint of 2 years. I have observed her from close quarters, how much academically she is oriented, administratively, showing both skills as a affectionate mother as well as strict disciplinarian. I welcome Dr. Padmavati madam onto the panel. Welcome, madam. Are you able to hear
Yeah,
me?
very well, Dr. Ramani, and thank you so much.
Thank you, ma'am. Thank you. Now I have Nanhi Pari, who is nothing but a professor of radiology, Dr. Lalita. She is from SRMC and Nandyal, in the midst of us to give us the knowledge upon the screening of lump breast. Dr. Lalita madam, please come on. I request you to be the panelist. And
Thank you, ma'am.
myself,
Thank you.
I'm working presently as professor in HOD Department of General Surgery, Vijayanagaram. So with this, we'll start today's panel discussion. As you know, it is on the breast. The mammary gland is used for the lactation. The sole purpose is lactation. This is a dynamic organ having influence of several hormones from the puberty till post-menopause. Even after the menopause also, the estrogens outside ovary are influencing the breast. So it has a developmental stage, it has an involutional stage, and some aberrations can occur in these stages, producing aberrations of normal development and involutions. So briefly, I want to tell you what are the symptoms of a benign breast disease. The three core symptoms are the pain, discharge, lump. The pain can be cyclical, non-cyclical. Discharge can be serous, brownish, greenish, milky, virulent, bloody, and lump may be there sometimes, may not be there sometimes. Sometimes a hard, discrete lump can be there. So let us also know what are the symptoms of a malignant breast disease in brief. So this malignant disease can be locally confined to breast in the early stages, later spreading onto the axilla and later entire body as metastatic disease. During locally, if it starts locally infiltrating, several changes occur like nipple retraction, nipple destruction, dimpling, puckering, then ulcerative growth, pure orange, that is orange peel appearance of the breast. And then axillary lymph nodes can be palpable as lumps in the axilla. Metastatic spread can be due to the bone, lung, liver, peritoneum, brain, etc., each giving symptoms of the local organ. So now you can see how the cancer breast distorts the beautiful breast, the dimpling, the distortion of nipple, the retraction of nipple, and all these we should prevent by only early recognition. So we know that the symptoms of benign breast disease and a locally confined breast disease are the same, lump. So the sole purpose of this moderation panel is how to differentiate between the two, and but the case capsules that we and how to approach these cases. So the first case that I have kept is a 18-year-old girl who is brought by mother with history of several lumps in both the breasts. She could feel several lumps, and then she also saw that they are slowly growing. So on palpation, we could find multiple lumps which are ranging from 5 centimeters to 7 centimeters to 2 centimeters in size, 5 in the right breast and one big one in the left breast, which are mobile, painless. So now, what is the diagnosis? So I've given a color code for the 3 panelists. The green color is for the surgeon, Dr. Mahalakshmi madam. Pink color is for the pathologist, Dr. Padmavati madam. And the gray or dark gray color is for the Lalita madam. So please, accordingly, you answer the questions, ma'am, as they come. So, Madam Mahalakshmi madam, what could be the diagnosis of this multiple lump in young woman, madam? Mahalakshmi madam, are you able to hear me?
Yes, ma'am, we are able to hear you, ma'am.
Madam Mahalakshmi madam, please unmute. Madam?
Good morning, everyone.
Somebody, Shyam, can you help Mahalakshmi madam? What happened?
Good morning, everyone.
Mahalakshmi madam, please. What is the cause of these multiple lumps in this young female, madam?
Good morning.
We can hear you, madam. We are audible, madam.
In a young female of 18 years old, the multiple lumps may be due to a benign, most
Madam, your voice is breaking.
Am I audible? Ramani?
Yes, ma'am, very low. Your voice is low and you're audible and your voice is breaking. Please, ma'am, carry on.
Okay, okay. In a 18-year-old girl, multiple lumps in the breast, which are freely mobile within the breast. That's why it is called mouse in the breast. This may be due to the multiple fibromata in the both breasts of the girl. For this condition, we have to do ultrasound examination because she is only 18 years old and followed by FNAC of the lump breast.
Okay, madam. So you want to do an... okay, ma'am.
Immunology and FNAC will proceed for further.
Okay, thank you, ma'am. So clinically, you thought this is a benign lump basing on the age, but still we should have an imageology and confirm pathologically. Okay, madam. So now the imageology, Dr. Lalita, madam, can you just explain the images that we are seeing? How is it, how do we decide that this is benign and the fibroadenoma, madam? Lalita,
Yes,
madam?
ma'am. Yes, ma'am. As this is a young female, we preferably go for ultrasound rather than mammo because of radiation. Ultrasound is free of radiation, and in ultrasound we can see clearly the well-defined, well-marginated lesion with no adjacent architectural distortion. The lesion is homogeneous, and rest of the breast parenchyma shows no obvious other lesions. Sometimes these fibroadenomas, if they are in young female, if they are of small size, they will be well circumscribed. If they are going for a bigger size for more than 5 centimeters or so, they will be having some partial obscuration. So with these features suggesting of benign nature, most probably this will be the fibroadenoma. If it is if the case scenario is more than 40 years, we will preferably go for mammo also to look for the calcifications. In mammo also the same will be revealed along with microcalcification pattern. Thank you, ma'am.
Okay.
Okay.
We
Dr.
wanted to do
Ramani.
an FNST, madam. What features would tell us that this is a fibroadenoma?
Yeah, thank you. Thanks for adding me in the group first. So fine needle aspiration cytology of fibroadenoma is absolutely diagnostic. There is no controversy in that because here you are seeing all tightly clustered benign ductal epithelial cells, which tight clustering and no overlapping indicates benign nature of the lesion. And these are all the naked nuclei or myoepithelial cells. And once you see myoepithelial cells in the background, it shows that it is benign. And so tight clusters of ductal epithelial cells and myoepithelial cells means it is fibroadenoma. Pathologically, fibroadenoma is a diagnosis which can be 100% made on FNAC.
Thank you, ma'am. Thank you so much. Now that the fibroadenoma is confirmed by FNAC, what course of action you want to take, madam, Malakshmi madam, for this lady? What will you advise the young girl? Malakshmi madam? Madam, are you there?
Voice is muted.
Malakshmi madam, please unmute. Madam, you keep unmute continuously. Don't mute at all. Ma'am, what is the treatment you want to give, madam?
Young girl with multiple lumps in the breast, we can go for excision as some of the lesions are large in size, 7 to 8 centimeters in size. And after excision, we have to subject for histopathological examination to rule out any further changes like cystosarcoma, phylloids like that.
Okay, ma'am. So you want to go to excision because they're very large, 7 to 8 centimeters each side. So you prefer excision. So what are the features histologically of fibroadenoma, madam, Padmavati madam? How can you say that this is not carcinoma? What is it?
Okay, fine. So this is a tumor. I think the mouse I am moving is being seen by everybody else.
No, ma'am. We can see. I have to move. We want to show the...
Okay, fine. So you are seeing a gray white tumor with thin slit-like spaces and a well circumscribed and probably capsulated, but a well circumscribed lesion. Grossly, it is fibroadenoma. So next slide. Okay, this is a microscopic view. fibroadenoma will have two components. One is the epithelial component, where you are seeing like thin strands, or Dr. Ramni is anyway moving. All those thin strands are the compressed benign glandular structures, and the stromal component which is seen in between the glands. So this is fibroadenoma. So what is the differential diagnosis for this tumor? We will see subsequently when we talk about Pilot's tumor. But for right now, this is an intracanalicular pattern of fibroadenoma where the glands are compressed into slit-like spaces. Suppose the glands are regular round with intervening stroma, then we call it as pericanalicular, but that has no clinical significance. So we need not report that. It is suffice if we say this is fibroadenoma.
Okay. So for this case, now we know that young female, the most common cause is the fibroadenoma in the if it is a lump in the breast, and the way of course of action is first imageology, after good clinical examination, then FNAC, then if needed, we go for excision and submit it for an histopathological examination. Now let us go for the second case. Now we have a lactating mother with a history of very painful swelling of the breast, and then she's also having fever. So on examination, there are signs of inflammation like redness, edema, and then thinning of skin is also there. Sometimes even pure orange is also seen. What is the cause of this enlargement? What is the management of this case, madam? What is the cause of breast abscess? We know with the diagnosis of the inflammation that this is a breast abscess, but then why is it common in lactating mothers? And what is the course of action?
In case of lactating mothers, the mastitis or breast abscess are more common because of the blockage of the ducts with insulated milk and saliva of the baby insulated, associated with cracks of the nipple. In the oral cavity of the baby, Staph aureus may be present, and the commonest organism in case of breast abscess is Staph aureus. How to confirm the aspiration first, and on examination you can say as your objective aspiration for culture and sensitivity. Depending on that, we can start the proper antibiotic.
Okay, ma'am.
We have to plan for less than 2 centimeters in size. After 2 to 3 aspirations, if it is persisting, then you have to go for incision and drainage of the abscess and daily dressing of the abscess.
Okay,
This is
thank you, ma'am. Now we understand that gram-positive organs are the cause.
Breast abscess.
Okay, ma'am. Thank you, ma'am. So now the guidelines are initially we have to do an ultrasound guided aspiration. So I'd like Lalita madam to tell what are the features of a breast abscess on ultrasound briefly.
Yes, ma'am. When the patient comes for the ultrasound, routinely we start doing the case. We have to take care whether there are any ulcerations are there or not. After that, when we go for the, madam, previous slide, please. When we do the ultrasound, we can see the inversion. Next slide, madam. We can see the inversion of the nipple. The U-shaped thing which we are seeing here is the U-shaped thing. That is the inversion of the nipple because of the inflammation and all those puckering. Behind it, we are seeing the dense acoustic shadowing. After that, we are seeing a well circumscribed mass because since the abscess is in very early stages, we are not seeing a well-defined wall formation for that. And we are seeing the posterior acoustic enhancement, the black, the white shadow which we are seeing behind the oval lesion, that suggests that there is a fluid component rather than a solid component. And we are seeing also, apart from these changes, we are seeing the overlying subcutaneous fat plane thickening.
Yes,
along with the history and all those things, we can tell this is a breast abscess.
Yes. So now we know that the cause of breast abscess in the early stages itself is due to the damage to the nipple, because the early initiation of lactation, there is a chance of the nipple getting eroded because of wrong techniques of root suckling. There can be an injury to the nipple, which produces accumulation. If on top of it there's accumulation of insufficient milk, and then the saliva of the baby carries staphylococcus, so there's an ascending infection which produces early mastitis. Later on, if not treated in the early part, breast abscess can form, so which can be which needs to be treated by repeated aspirations or an IND if necessary. But then similar appearance are there any clinical conditions having similar redness, edema and skin changes on the breast, which may not be exactly a lactational breast abscess? Madam Mahalakshmi, madam, are you there? Yes.
Inflammatory carcinoma is one condition which needs mastitis. In inflammatory breast carcinoma, the skin is red in color and irritation over skin, and sometimes associated axillary lymph is also in some lymph nodes may be filled also. It is for 1 to 4% of the breast case.
So this
clinical examination and how to do examination and mammography, as it is a painful carcinoma. Okay, ma'am.
So inflammatory breast carcinoma has all the appearances of a breast malignancy except for systemic symptoms like fever, and mostly there are cutaneous changes that occur, and definite lump may not be palpable, but then this is considered as a T4 stage if you take the T stage. Now, madam, Padmavati madam, can you tell what is the underlying changes that occur in this histopathological changes in this inflammatory breast carcinoma, which is different from a normal serous type of more common breast carcinoma?
Okay. So you have answered half of the question. Inflammatory breast carcinoma usually is a high-grade breast carcinoma, but when we talk about inflammatory breast carcinoma, it means there is a widespread carcinomatous emboli involving many of the subdermal lymphatic vessels. So that gives the kind of signs of inflammation what you are seeing clinically. But other than this, there is one more entity which I wanted to point out here, that is an occult inflammatory carcinoma, where clinically you will not see the signs of inflammation, but under histopathology, again, you will see widespread carcinomatous emboli. And because this is stage 4 tumor, it is very important to diagnose this case as early as possible.
Thank you, ma'am. Lalita madam, can you just say how the mammography shows in a case of an inflammatory carcinoma? What are the changes?
Yes, ma'am. As this is a malignancy, we will be most commonly seeing the microcalcification. As like madam has told, there will be a microemboli involving the dermal lymphatics. There will be increase in the thickness of skin and subcutaneous fat planes also. In rather than in mammo, we can appreciate in ultrasound more of that, and we can see in diffuse breast density increment also we can see. Along with that, in ultrasound, if you were given a chance, we can see whether there is any infiltration of the pectoralis muscles, underlying pectoral muscles, axillary involvement also. And again, with all these things, we have to go for DDs like locally advanced invasive breast carcinoma, lymphomatous breast carcinoma involvement. And we have to rule out the other breast edema changes like SVC syndrome and lymphatic obstruction.
Thank you, madam. Now we'll go to the third scenario. That is a perimenopausal woman with a history of bloody discharge from nipple. Sometimes she's feeling small lump in the subareolar region. Sometimes she's not feeling. So what could be the cause of this bloody discharge in the woman? Madam, Mahalakshmi madam. Mahalakshmi madam.
Bloody discharge in a woman.
Yes.
Am I audible, Ramani?
Yes, yes, ma'am. You're audible.
Bloody discharge is most common.
Madam, Mahalakshmi madam. Madam, please carry on.
Duct papilloma is most common condition, bloody discharge.
Somebody has two connections, madam, here. I think from one side.
Condition where you see the bloody discharge. Where invasive carcinoma of the breast, you can see bloody discharge. Yes, Rami.
Yes.
Audible.
Yes, you're audible, madam. You're audible, madam.
Yes, ma'am.
Hello.
Madam, you're audible. Yes, ma'am. Am I audible, first of all?
Yes, ma'am.
One condition where you see bloody discharge. Rarely invasive carcinoma of breast. We rarely see the bloody discharge. Rarely in early phases of lactation also we can see bloody discharge. Is otherwise called rusty pipe syndrome. In case of bloody discharge, we have to advise mammography and ultrasound examination in women below 40 years. And if the ultrasound examination and the mammography are inconclusive, if the bloody discharge is persisting, you have to go for ductography. On doing ductography, you can see the papilloma, that is the filling defect you can see. And you can subject the discharge for cytology.
Let us see how this duct papilloma looks by imagiology. Madam Lalita, can you explain to us what we are seeing here?
Yes, madam. As this is a malignant lesion, it is causing the distortion, and there is a speculated lesion with filling with decreased density in the retroareolar region. Coming to the next slide, ma'am. Next slide, ma'am. In ultrasound, we can see the blue arrow indicates the nipple. From the nipple, there is previous slide, ma'am. Back slide.
This.
Yes, ma'am. Here, no, next slide. Yes, ma'am. This one. Here, the blue arrow is indicating the nipple, normal anatomical nipple. Previous slide, ma'am. Yes, ma'am. The blue slide, the blue color arrow indicates the nipple, and from that nipple region, we are seeing a black arrow and a linear tubular structure which is extending from the nipple towards the white color arrow, the lesion marked site. That is the dilated duct. From that, behind that dilated duct, we are seeing the mass. This is the reason for the dilatation of the duct from that, and because of that, there is a nipple discharge. If we can do the FNAC, we can get the through the ultrasound guidance, we can directly point out towards the lesion, and we can take directly the sample, ma'am.
How is this different, madam, from the earlier slide?
Sometimes there will be adjacent area distortion is there. Sometimes if it is a chronicity, that ductal atresia will be there, and adjacent architectural distortion is there. We may not find the communication with the duct sometimes, ma'am.
Suppose we are not finding communication, do we have any other special investigation? What is the ductography, madam?
Yes, ma'am. If we can see on mechanical this one palpation and all those things, if we can see the duct which is giving the secretions, we can access through the duct, and we can inject the contrast through the duct. After injecting the contrast, we can well delineate the duct. Previously it may be like a collapsed duct. After injecting the duct, we can see the margin of the duct margins very clearly, and we can also we can see the filling defects, the large white arrow showing the filling defects, that is papillomas, ma'am.
Okay. Now the discharge is subjected for cytological examination. A smear is taken. What will be the findings, madam? Padmavati, madam?
Okay. Basically nipple discharge. For that matter, all papillary lesions of the breast wherein you see the nipple discharge. From the point of pathologist, first we will see cyst macrophages, which are not clearly depicted in this picture, but plenty of cyst macrophages are generally seen. Then here you are seeing more or less uniform kind of cells which are arranged in a vague papillary configuration. So probably we will say cytological picture is in favor of cystic lesion of breast. The possibility of duct papilloma is to be considered, will be the report from many pathologists. But generally, when other than this case, diagnosis. Generally, when we are seeing papillary lesions on cytology, no pathologist will give any any conclusive diagnosis like this is benign,
Yes.
borderline, or malignant.
Yes.
We will say papillary lesion of the breast, histopathology advised.
Okay.
Thank you.
So now this is heart pills operation was done. The duct was excised. Can you explain this picture, madam?
So somehow this duct ectasia, I don't know how it has come into the picture. Please pardon me, but this duct ectasia might also can give rise to a nipple discharge. I am not sure. Then
yes,
the other one, yes, ma'am, yeah. And then the other one is the papilloma, duct papilloma, which you are seeing the epithelium which is thrown into papillary configurations, and you are seeing fibrovascular core. You are seeing fibrovascular core in this. Then for duct papilloma, in situ duct carcinoma, and solid papillary carcinoma of the breast, the main point that we have to see is the presence of myoepithelial lining. If we are seeing myoepithelial lining, we'll say it is duct papilloma. Otherwise, it is in situ papillary or solid papillary. And for all the doctors who are in this, I want to specify one point which is not known to everybody else. If somebody reports, some pathologist reports as invasive papillary carcinoma of breast, that means it is metastatic. Invasive papillary carcinoma of breast, 99% of the times it is metastatic coming from somewhere else. Primary invasive papillary carcinoma of breast is extremely rare, and no pathologist should give a diagnosis primarily unless absolutely proved with histochemistry. Thank you.
Okay, madam. So this can become a duct cell carcinoma, madam?
No.
It
Papillary
won't be a
configuration.
adenocarcinoma, but it is
It is
a different entity, duct papilloma. Oh, thank you, ma'am. Now, as already Mahalakshmi madam told, we'll excise a single duct if single opening and blood is coming through single duct. Or if wider area of ectatic ducts are present, we will do a duct wide excision of that area and subject to histopathological examination. Now let us go to the case number 4. When this is a 30-year-old woman having cyclical mastalgia. Just premenstrually, she's feeling the breasts are heavy. Sometimes she's feeling small nodules, and then she's also having heaviness of the breast. Madam Mahalakshmi Garu, what is the initial approach for this woman who is having only a cyclical mastalgia? What is any imagiology that you want to undertake? What any role for FNAC, and how do you manage this woman, madam? Mahalakshmi madam?
Okay, Ramani. In case of cyclical mastalgia in a 30-year-old female, we have to take the history, thorough history, and we have to do complete examination of all the quadrants of the breast with the flat of the fingers, not with the flat of the hands. We have to examine, not with the fingers, so that we can appreciate whether lump is palpable or not. If no lump is palpable, only tenderness, there may not be any need for imagology. But if any lump is palpable, we have to advise ultrasound examination, as the lady is only 30-year-old, and we have to see for any lump that is present. If necessary, we have to go for cytology, FNAC of the lump we have to go for. And most of the times, reassurance of the patient after doing imagology and cytology, we have to give support to the breast and analgesics and evening primose oil or danazole. We can tamoxifen, we can try to oppose the action of the estrogen. In case of cyclical mastalgia, there will be excessive estrogen hormone will be there. So that to oppose the action of the estrogen, we have to give anti-estrogen.
Okay.
This will give relief to the patient.
So, okay, ma'am. As you said, cyclical mastalgia means it is the effect of hormone, cyclical hormonal changes that occur in that also produce menstrual cycle producing changes in the breast. So most of the times it is reassurance, but if any discrete lump is present, then only we go for any imagiology or FNAC. Thank you, ma'am. Now, what is the risk of BBD turning malignant, madam? Before, for reassurance of the woman, we should know which woman has to be reassured, which woman has to go for thorough checkup. Madam, can you just enlighten us regarding the risk of malignancy in a benign breast disease? Padmavati, madam.
Okay, so benign breast diseases are generally three types, previously called as fibrocystic change of the breast, but now it is three types. One is non-proliferative change, where there is no need for, they will not go for any malignant transformation, because here you will see adenosis, fibrosis, apocrine metaplasia and all that. Proliferative disease without atypia, there is some chance of going into malignancy, but atypical hyperplasia is one where there is a 5 to 10-fold increase in the risk of developing malignancy. So atypical hyperplasia can be atypical ductal hyperplasia or atypical lobular hyperplasia. Now coming to the pathologist point of view for making a diagnosis, you have done the excision, you sent us the sample and asked what is it. Then suppose I say it is an atypical ductal hyperplasia, you will just remove it and probably, I'm not sure about the treatment options, but you will just keep quiet. But if it is in situ duct carcinoma or in situ lobular carcinoma, you may need to probably follow the patient and all that. But for us, the differentiation between atypical hyperplasia and in situ carcinoma is so subtle, it's very difficult to diagnose. There are some features probably not very useful to the general community of doctors except for pathologists. So what I would like to say here is, if you are making an FNAC in this particular case, we will say proliferative breast disease with atypia or without atypia. Malignancy cannot be ruled out, will be the reply, because with proliferative breast disease with atypia or atypical hyperplasia, if you see a usual ductal hyperplasia, or if it involves less than 50% of terminal duct lobular system, we'll call it as atypical hyperplasia. If it is more than 50% of terminal ductal lobular system, then it is in situ. So the line of distinction is very thin, and if such a report comes, you ask a senior pathologist about the exact opinion. Thank you.
Okay, ma'am. So we understand that atypical hyperplasia has some risk of turning malignant. So if the pathologist gives that opinion, we have to keep this woman under regular follow-up with imagiology. And if any discrete lump is evident, we may have to again go for a wide excision and confirm the diagnosis. Thank you, ma'am. Now, just let us know little about mammogram in detail, because everyone now is asking for a mammogram, is undergoing mammogram. What is this mammogram, madam? What is this BI-RADS scoring? How do you report basing on that? What is sensitivity and specificity of reporting, madam? Lalita, madam.
Yes,
Just
ma'am.
a brief.
Like we do for a chest X-ray, we will do X-ray for the breast tissue, but it is a little bit a painful procedure, because we do compression of the breast in craniocaudal direction and mediolateral oblique direction, so that we have to cover all the quadrants of the breast, including the axillary tail region and axilla region. So with this, we are giving a little bit of a high MA and KV for better evaluation of the soft tissue lesions. Coming to the BI-RADS classification, according to the shape of the lesion, extent of the lesion, and size of the lesion, with the adjacent architectural distortion, satellite lesions, lymph node involvement, and with the other breast involvement, and seeing the other metastatic involvement, we will categorize the lesion into BI-RADS staging. Next, subsequently, we will go for that. The BI-RADS category is like in 6 categories. In first 2 are like previously madam told, if it is a fibrocystic disease, then we need not be worried. If it is a breast disease, we know breast abscess, we know that it is not going to be a carcinoma. Those comes under like benign or negative category. Then routine screening is enough. After the complaint is subsided, we need not go and follow up there for these lesions. If it is a lesion, if it is a suspicious lesion, young female or a female after 40 years coming with a well-defined lesion, we will go for probably benign, and we will call her back after the 6 months, or we will suggest her for histopathology. If there is any distortion of the shape, if there is a partial obscuration of the margin, if the lesion is not well marginated. Next slide, madam. If there is obscuration, partial obscuration of the margin, microlabulations, margins, they all go in favor of malignancy. So then we will, if the density, coming to the other part, the density of the lesion, whether it is a mammo or ultrasound, according to the consistency of the lesion, there will be increase in the, when the cells are very much tightly packed, then the density of the lesion increases. If it is a low dense lesion, it is benign. If it is a high dense, it again goes in favor of malignancy. After, with all this consideration in mammo and ultrasound, we will categorize whether the lesion is in the anterior, middle or posterior third of the breast, and according to the clockwise position, we will categorize that. As previously explained, if it is a fatty breast, then the lesions are well more obviously seen. If it is a partial glandular, the second one, and heterogeneously patchy increased fibroglandular tissue, then there is a less chance that we may miss the lesion. If it is a dense fatty breast, dense fibroglandular parenchyma with a thick breast, in mammo,
what is the age group, madam?
Like fatty
breast, basing on the age.
Yeah, basing this first slide, they will be like elderly. Fatty infiltration will be there more in the elderly
Atrophy
patients.
glands, only fatty breasts. Most
Yes,
of the
ma'am, yes.
gland tissue is atrophied.
The breasts are dense. We have to go for ultrasound or MRI for characterization of the lesion, ma'am. And coming to the calcifications on mammography, like if we see skin calcifications are
What type of calcifications have significance of a malignancy, madam? Can you just tell?
Yes, ma'am. Amorphous calcifications, in the first two slides which we are seeing, there will be calcification, but we will not be seeing the borders, well-defined borders will not be there. Those are suspicious. Yes, ma'am. Calcifications we are seeing, but it is very much hazy. The borders are not well delineated. And other calcification like fine pleomorphic and linear branching pattern and fine linear pattern and coarse heterogeneous pattern, they are more in favor of malignancy rather than benign things.
Okay. So all these calcification, the fine calcifications, coarse calcification, linear, along with distortion of the parenchyma. These are suggestive of malignancy. Okay, ma'am. So when should we order a mammogram? Who should be advised, madam? What is the best age? What is the best time of the month if she is a menstruating woman? When should we repeat? And what if the woman has a carcinoma breast history in the first and second degree relatives? Anything that to do with MRI, ma'am?
Yes, ma'am. If the age is less than 30 years, because of radiation, we preferably go for ultrasound rather than mammo. If the female age is more than 30 years, then we will combine both mammo along with the ultrasound. After that, we categorize the lesions as BI-RADS category 1, 2, 3, and all those things. If it is a BI-RADS category 1 or 2, then clinical breast examination will be sufficient unless there will be a palpable lump. If it is a category 3 lesion, we will follow it after 3 months or 6 months according to the suspicious grading, and we can do for HPE also. If there is a grade 4 or grade 5, which are more in favoring of malignancy, more in favor of malignancy, then we directly go for the FNAC or biopsy of the lesion.
Okay. Thank you. Yes, now we know why should we go from 30th year onwards. Why not 40, 50 years as in Western countries? Because in India, in our country, the breast carcinoma occurs good 10 years ahead of the Western population. So we have to start screening from 30th onwards. But the screening is different for 30 and above 30, as madam said. Now we'll go to the fifth case of a 45-year-old female came with history of rapidly increasing size of one of the breasts. Painless, and she has no other complaints. Clinically, the picture has not come. How is it different from carcinoma of the breast? What is the diagnosis in this picture?
Because in this picture,
Madam,
you can see the uniform enlargement of the whole breast is seen. There is no skin changes are not seen like dimpling or fluid orange appearance. And you can see the nipple retraction is not seen. Areola and nipple are normal. And in this case, we have to think about a benign condition, most probably a giant fibroadenoma or a case of cystosarcoma phylloides. In cystosarcoma phylloides, you can see sometimes a bacillated appearance can be seen. Sometimes There may be because of the enlarged, rapid enlargement in the size of the lump, we can see ulceration of the skin also will be seen. But in this case, as the skin involvement is not seen, we have to think about cystosarcoma phylloids or giant fibroadenoma. How to subject the patient for imagology and FNAC or true-cut needle biopsy. True-cut needle biopsy may be more helpful in this case rather than FNAC.
Okay, madam. So now, what is this mammogram, Lalita madam? How is it different from the malignancy? How do we know that this is a malignant? I'm afraid this can be a medullary carcinoma, which again will be a big enlarged breast, 4-quadrant tumor.
This mammo will be of little significance in this case of phylloids and also suspicious lesions, ma'am. When we go for ultrasound, the lesion in mammo, it will be seen as a dense mass, that much only. If there are microcalcifications, it may point towards a suspicious nature of malignancy. Then we have to go for the ultrasound. In ultrasound, the lesion will be of inhomogeneous in echo texture. There will be having some multiple few areas of multiple cystic round clefts like cystic areas. There will be increase in vascularity also. Again, there will be differential diagnosis of giant fibroadenoma with the cystosarcoma phylloids. Okay. If we go for the dynamic contrast MRI, then we will be plotting the curves, kinetic curve pattern we will see. In that, after the uptake of contrast, if it is a gradual slow pattern or a rapid uptake and washout pattern, with that we can tell whether it is a benign or malignant, whether it is going more in favor of malignancy, ma'am.
Okay, thank you, ma'am. Now, Padmavati madam, our panelists are saying giant fibroadenoma, phyllodes tumor, cystosarcoma phyllodes. Can you enlighten upon which terminology to be used, madam?
Yeah, right. So, giant fibroadenoma is one. I mean, all four are stromal tumors. Giant fibroadenoma is one. Second is, pathologists call it as phyllodes because cystosarcoma phyllodes is obsolete and we call it as phyllodes. And in phyllodes, we have benign, borderline and malignant categories. Now, the difference between giant fibroadenoma and benign phyllodes is stromal hypercellularity. Once you see the hypercellularity of the stroma, then it goes in favor of phyllodes. Otherwise, it is giant fibroadenoma or fibroadenoma. In addition to stromal hypercellularity, the other thing is the inequality of distribution between glands and stroma also makes a difference for phyllodes. Now, phyllodes is at the benign end of the spectrum where you are seeing the compressed glandular structures and stromal cellularity. But the most important criteria to say that it is benign phyllodes is mitotic activity, which is less than 5 per 10 hyperphils. Now, coming to malignant phyllodes, the stromal hypercellularity is so much, yet low magnification, you will see only stroma and it appears like a stromal sarcoma with, unless you put it in high power and search a lot, then only you can see the benign glandular component. Borderline is in between. Again, in borderline, the mitotic activity is between 5 to 10 per 10 hyperphils, whereas if it is more than 10, mitotic figures are more than 10 per 10 hyperphils, we are going to say that it is malignant phyllodes. Now, mitotic activity is single most important criteria. Atypicality can be seen both in borderline and in malignant. Here, the problem is not only with phyllodes, but if you are seeing a picture of phyllodes with something like a stromal sarcoma, the differential diagnosis is with metaplastic carcinoma spindle cell variant. Metaplastic carcinoma, as all the surgeons knew, is a highly malignant tumor. And a spindle cell variant of metaplastic carcinoma has to be differentiated when immunohistochemistry plays a role. We have to subject it for IHC to say that it is phyllodes, which is CD34 positive, and metaplastic carcinoma is epithelial markers, which are positive. Then as pathologists, the other things which we look at when we are seeing the slides is phyllodes is, you people will do wide local excision, and unless you have a good rim of wide normal tissue, the chances of recurrence is very high. So wide local excision is essential. And if you have intraoperative cryostat, send the margins for the tumor. If the margins are showing tumor extension, okay, go extend your dissection, or else a good amount of normal tissue will help in the diagnosis. Here in this grossly, you are saying, can you go back, Dr. Ramani? You are seeing
yes.
a gray-white tumor and a well-circumscribed tumor. Then it has to be benign phyllodes. Malignant phyllodes will have infiltrative margins. And here you are seeing hypercellular stroma in benign phyllodes along with epithelial component. Thank you.
Thank you, ma'am. Ma'am, in the Mahalakshmi madam, we have seen
Okay, Ramani.
Hello, ma'am. We have seen a very huge. Madam, are you able to hear?
Yes, yes, Ramani. The tumor is occupying all the quadrants of the lump.
Even then, we want to do a simple mastectomy only. Why, madam? We don't want to clear the axilla. Hello, madam. Are you able to hear me?
Yes, yes, you are able to hear me. Ramani, am I audible, Ramani?
Yes, ma'am, you are audible. Why we decide upon simple mastectomy even for a borderline or a malignant phyllodes? Why don't we remove the axillary lymph nodes, madam?
In case of cystosarcoma phyllodes, lymph nodal involvement will not be seen. Cystosarcoma phyllodes is a misnomer. It is not a sarcoma. But because of the inflammatory features and the fleshiness of the tumor, it is named, and because of the leaf-like pattern, it is named as cystosarcoma phyllodes. As the lymphatics are not invaded in case of cystosarcoma phyllodes, simple mastectomy is sufficient. There is no need for axillary dissection in case of cystosarcoma
Now we'll go
phyllodes.
for the sixth case, madam. Maybe time I'm not able to see.
Okay.
We have a perimenopausal woman with lump breast. We're having a 2 to 3 centimeters hard, ill-defined borders on the course of action. So here two things. One is perimenopausal, the other one is hard lump.
Okay, Ramani. A 45-year-old female with a 2 centimeters lump, hard in consistency, not moving freely within the breast, and it is fixed to the surrounding breast tissue. It is moving along with the breast tissue. There may be associated nipple retraction may be seen. If you examine the patient in all the 3 positions with the hands by the side, elevated hands position and stooping forwards, you examine, you may appreciate the nipple.
Ma'am, this lady has no some signs, only a lump.
Only a lump is seen.
Now, what is the course of action, madam?
Examine.
How do you proceed with this lady?
In this lady, we have to go for triple assessment. Triple assessment means thorough history, clinical examination for staging of the disease, and we have to go for imagology, that is mammography, this sonomammography, both ultrasound and mammography, we have to do it. Then followed by true cut needle biopsy. Nowadays, we prefer true cut needle biopsy over FNAC because true cut needle biopsy gives us information regarding the histopathological pattern, and we can know the ERPR status and HER2 receptor status and K67 status also we can know. That is why if you plan for breast conservating surgery, we have to do true cut needle biopsy and all the ERPR status and the histopathology. Basing on that, we can go for breast conservating surgery. And if the lymph nodes are not palpable clinically, you have to go for sentinel node biopsy. And if the lymph nodes are palpable, we have to go for separate lumpectomy or breast conserving surgery or oncoplastic breast surgery to preserve the aesthetics of the breast. Then if the lymph nodes are palpable, you have to go for axillary dissection. In case of breast conservative surgery, we have to subject the remaining breast for radiotherapy.
Okay, ma'am. Okay, ma'am. Now I want Padmavati madam to say why true cut, why not FNAC? What is the advantage? What more we want to assess with the true cut biopsy specimen, madam? Padmavati madam?
Yeah. Right. So FNAC is 100% confirmative for malignancy. It is not a very difficult diagnosis to make invasive breast carcinoma, and subtypes also we can make to a large extent. But true cut biopsy, as you have said, we can make out the receptor status and other prognostic markers. So it's better you go for true cut biopsy. Then, madam, the next slide.
So this is an
So
invasive
this
breast
is
carcinoma specimen,
this is
madam.
yeah, right. And we are seeing that gray white infiltrative margin of the tumor. And when we are seeing the tumor, we have to see the size of the tumor, because basing on the size, our pathological staging will change. And here in the microscopic field, we are seeing the malignant epithelial cells, which are arranged in sheets and which are arranged in gland patterns, tubular patterns, infiltrating into the fibrous stroma. So looking at this also, we have to give what is called as NBR score, wherein we give a score of, NBR score we have to give, basing on that, we will say whether it's grade 1, 2, or 3. The NBR score is mostly dependent on tubule formation, pleomorphism, and mitotic activity. Tubule formation is given three scores. Mitotic
Bloom-Richardson score, madam. Bloom-Richardson score.
Yeah, right. And basing on that, we'll give that. Then finally, when you are giving the entire breast specimen, here I would like to take few minutes of your time. We will give what is called as pathological TNM basing on CAP protocol. Now the excision specimens or the protocol is College of American Pathologists, wherein we will see what is the type of tumor. Like suppose some tumors are with good prognosis, like mucinous carcinoma, tubular carcinoma has got excellent prognosis, whereas metaplastic carcinoma has got bad prognosis. So first we will talk about the histological type, then NBR score or NBR grade, wherein it is grade 1 to grade 3 tumor. Then if there is any in situ component, if there is any necrosis, then what are the margins? Because basal cut margin, if it is infiltrative, then again the treatment protocols will change. Once we do all that, the next is the IHC. Immunohistochemistry is mandatory, like how Dr. Ramani and Dr. Mahalakshmi madam said. We will do hormonal receptor status like estrogen receptor, progesterone receptor, and one tumor suppressor gene, HER2, and then Ki67, like just Mahalakshmi garu said, it is a proliferation marker. And basing on that, we will divide it into various subtypes. Either it is ER/PR positive and HER2 negative, or only HER2 rich, or triple negative, which is basal-like, which has got worse prognosis. And then coming to molecular, it is your clinician's choice whether you want to go for BRCA1 or 2. So this is how the malignancy protocol goes.
Thank you, ma'am. So now this lady is having only 2 to 3 centimeters lump, ma'am. Which surgery you want to give? We know that it's a carcinoma approved. Stage-wise, it is confined to the breast. Mahalakshmi madam, which one you want to prefer? The breast conservative surgery or a mastectomy? And what is this newer terminology of oncoplastic surgery? Can you just enlighten us, ma'am?
Hardy. Stage 1 disease or stage 2 early carcinoma of breast, we can go for breast conservative surgery, but there are some contraindications for breast conservative surgery, where the breast is very small in size.
In this lady, she has adequate breast. So what is
adequate breast? We can go for breast conservative surgery, and associated with that, we can go for
mammoplasty, madam. What is mammoplasty, oncoplastic breast conservative surgery, and what is normal breast conservative surgery? Because the ladies should have an opinion so that they can decide which one they want to undergo. Because if at all,
in case of oncoplastic breast surgery, we can remove the tumor with wide excision without compromising the oncological principles. We can combine
and
the
also the shape.
oncological principles with the plastic surgery procedures to maintain the contour of the breast, to aesthetics of the breast we can maintain with this oncoplastic breast surgery. We have to explain the patient regarding the surgical procedure, and we have to take the consent of the patient whether we should go for oncoplastic surgery, breast conservation surgery, or MRI, depending upon the wish of the patient. We have can proceed for
suppose
the
ma'am,
surgery.
T3 tumor is there. Is it different from the 2 centimeter tumor? How the protocol changes a bit?
In case of T3 tumor with local invasion, that is called locally advanced breast carcinoma. In case of locally advanced breast carcinoma with involvement of the lymph nodes, which may be fixed or free, we have to go for neoadjuvant chemotherapy. And before that, we have to go for two-cut needle biopsy for confirmation of the histopathology and ER/PR status. And we have to plan after 2 to 3 cycles.
Modified radical mastectomy, what all are removed, madam?
We have to remove the tumor along with the nipple areolar complex, and we have to remove the fat from the clavicle up to the rectus sheath, laterally up to the medial border of the latissimus dorsi. We have to remove, and we have to preserve the axillary vein, cephalic vein, and the nerve to serratus anterior. That's the nerve of Bell. We have to preserve.
Okay, thank you so much. Now I just like to summarize now what all the panelists have spoken to you, because of the time constraint. We are speaking so much of the breast carcinoma because we know early recognition saves lives. The 5-year survival for an early carcinoma is almost 100%. It decreases, survival drops down to 20, less than 20% for 5 if it is a distant breast carcinoma or a metastatic carcinoma. So to summarize, according to the panel, fibroadenoma is the most common type of breast lump in a breast, and premenstrual heaviness, serous discharge are physiological and nothing to worry. Lactational mastitis is the most common infection of the breast. Only 10% of bloody nipple discharges are due to carcinoma breast. Other things like ectasia, ductal papillomas are there, which we have to rule out. But breast lump in a peri and postmenopausal woman, unless proved otherwise, we have to think in terms of carcinoma and then exclude and investigate. But then when should we start this follow-up? So every woman should undergo risk assessment, whether she's going to have a breast cancer by 30th year onwards, start self-breast examination, start screening mammogram from 40th year onwards, get a risk assessed, again a basal mammogram, because a mammogram can catch a hold of a cancer breast a good 10 years ahead with the presence of the microcalcification. So everyone has to undergo a basal mammogram by 40th year and then should be under follow-up basing on her clinical risk and the mammogram findings. So the take-home messages are: not all breast lumps are cancers. Carcinoma breast is now slowly replacing cancer cervix as the most common cancer in women. So every doctor, whatever may be the specialty, be it a gynec, ophthalm, radiologist, they should know about carcinoma breast and talk about that to the woman that comes to them. As early breast cancer is 95% curable, and we should not let our women be detected with so much locally advanced breast cancers. I thank my wonderful panels, Dr. Mahalakshmi Madam, Dr. Padmavati Madam. I'm humbled to talk in front of you, Madam. I'm privileged to be with you. And Dr. Lalita, with your knowledge. Thank you. I thank IMA for giving me this opportunity, and I thank WDW for allowing me this. Thank you. Thank you, one and all.
Thank you, Dr. Ramani.
Thank you.
Your conduction of panel discussion is excellent. When you asked me first, I was wondering how you are going to coordinate all the speakers who are at distinct places, and we don't know what the other person is.
Treasure trove of knowledge. What would I ask you, Madam? I was trembling.
Absolutely good. You have shown how a moderator for a panelist should be.
Thank you.
My congratulations to you. Thank you. Thanks the organizers.
Thank you. Madam, Malish Madam.
We have a lot of clarification.
Unmute, Madam. Mahalakshmi, Madam. Madam, unmute చేసుకోలేదు.
ఎవరు సార్ అన్మ్యూట్ చేసుకోలేదు?
మహాలక్ష్మి మేడం మాట్లాడుతున్నారు కానీ మీరు పిలిచినప్పుడు అన్మ్యూట్ చేయలేదు.
అవును సార్, మాది అయిపోయింది సార్. హోప్ వి హావ్ నాట్ టేకెన్ మచ్ టైమ్. అవర్ panelists are so knowledgeable, I cannot stop them. Thank you sir for giving the wonderful opportunity.
Thank you all seniors for letting me. It's an honor to share academic session with you. Thank you all. Thank you sir.
Anantaramani madam.
Ramani madam, it is awesome. Very nice and very elaborative, ma'am.
Thank you so much, ma'am. Thank you.
Anantaramani madam.
Ma'am.
Congratulations.
Madam, you have picked a good number of cases, and the discussion is very useful to all doctors to pick which one should be picked or which should not be picked like that. And I want to say one thing, madam. In Sri Lanka government, mammogram is compulsory for increment after 40 years.
Oh, ma'am. Thank you.
That should be
We should also
implemented.
have, ma'am.
Yes,
But,
madam.
They should be literate enough to understand, madam. That's
Yes. It should make mandatory to all women above 40 years. And one more thing, madam. Lalita madam, radiologist, has given a good picture of mammogram, and usually postgraduates will think that when should be done mammogram if the established case of carcinoma breast is there. Is it necessary? Is it a screening program or is it a evaluation test like that? So nowadays we are doing mammogram even for the cases with breast lump. Because
we should
yes,
do, ma'am.
that concept also should be spread, madam.
Yes,
And Mahalakshmi madam and Padmavati madam has given very nice thing.
Thank you.
Thank you, madam.
Thank you.
Yeah,
Thank you.
right, yes.
Thank you so much, ma'am, Ramani ma'am, and the senior most respected faculty members, Mahalakshmi ma'am, Padmavati ma'am, and Lalita ma'am, for their information regarding breast cancer, because it's these are the cases which are on rise, especially very important topic for women. Thank you so much, ma'am. Thank you, Madhavi Shamla ma'am, also for briefing in the end of the session. Very thanks, ma'am. So shall we go ahead to the next session, ma'am? Durga Rani ma'am is waiting, I think.
Am I audible, Sumana?
Yes, ma'am. Yes, ma'am. I would like to just introduce regarding Durga Rani ma'am. So ma'am had done her graduation and post-graduation from Andhra Medical College, Visakhapatnam. Presently working as Associate Professor General Surgery, Siddharth Medical College, Vijayawada. And she had worked as Honorary General Secretary, IMA Vijayawada, Convener, SMC Medical Student Network, IMA Vijayawada, Chairperson, IMA Mission Pink Health AP, Member of Lions Club, FOGSI, ASI, and IAGES, Bharata Jatiya Kirti Pataka Award, and President Appreciation Award. These are all her ma'am's achievements. Conducted many health camps and awareness programs and scientific sessions. So I had also seen Durga Rani ma'am personally also. She is a very kind woman and very knowledgeable person. So now I request ma'am to take on the session. And the topic is and prevention. Welcome, ma'am, Durga ma'am.
Thank you, Sumana, for your beautiful introduction. And thank you, Hemlata, for your introduction. I thank our IMA leaders, Ravi Krishna Garu, Pandit sir, and Ravindranath, and all the AMS members for giving me this opportunity. And without much wasting, I'll go to my topic is in increasing colorectal cancer screening and prevention. So definition, colorectal cancer is a cancer affecting cecum, colon and rectum. Anal canal and appendix are not considered in the definition and they are treated as separate entities. So what is the burden of the colorectal cancer? And is the third most cancer and is the second most cause of cancer related deaths in the worldwide. And if you look at on the left side, by 2030, the global burden is expected to be increased by 60% with 2.2 million new cases and 1.1 million cases per death. And because of the increased sedentary life and BMI weight, it going to be take the chance of second most common cancer in the women and third most in the men. It is more common in highly developed countries and highest incidence is seen in resource dependent countries. So this is the picture showing the worldwide distribution of the cancers of both sexes, being the first breast, lung, and the third occupation by colorectal carcinomas. And it starts in the colon and the second cause of leading death in adults. This year it is estimated that nearly 130,000 men and women will be diagnosed. And excluding skin cancers, colorectal cancer is the third most common diagnosed both in men and women, and is the second leading cause of cancer deaths in both men and women. Why I am stretching is, my topic is to give with the audience that there are increasing incidence of the colorectal cancers, and along with the what are the screening techniques we are doing for both men and women, this also should be included, because this is more apt for suiting. Early recognition by screening will have more survival chances. And it is expected to cause about 52,500 deaths during 2023. And in India, the new cases are emerging. The top 10 cases, colorectal cancer has occupied the 4th position. And in the men and women, if you take, these are the pictures, incidents, I am skipping, already laid. This is a chart showing the incidents, men, women, and all ages. And these are the figures. You can see how the cancer, all the cancers are spreading along the country. Even though we are thinking some cancers are more common in Western, but now the people are more westernized, even food and lifestyle, everything. So all the Western cancers we are thinking more common in the Westerns are become more common to us. So this is a picture showing the age standard-wise incidence and mortality in the top 10 cancer. It has now raised to the level of the 4th and 5th position. The overall diagnosis has decreased in 1980s, but the rates in the younger patients have been steadily increasing. To improve the chance of finding colorectal cancer in early stages and in younger population, the recommended screening age was recently reduced to 45. The death from the colorectal cancer among the older adults have been dropping in both men and women for several decades. That is due to regular colonoscopies and lower rate of smoking. So it's more common after 50. So naturally, the person who is above 50, they regularly go for screening. But nowadays, because of all the sporadic factors like environmental and behavioral, it is more common in the young people. By the time it is diagnosed, it is showing that high stage, and there are more chances of deaths are more common in young people. However, since 1990s, the rate of colorectal cancer has been rising steadily among the younger adults below 50. Not only that, more younger people are dying from the disease. And American Cancer Society reports that people born in 1990 have double the risk of colon cancer and quadruple the risk of rectal cancer as the people born in 1950. The reasons why it is increase in young population: sedentary lifestyles, overweight and obesity, smoking, low fiber diet, high fatty diet, and diet rich in processed meat, and environmental factors. What are the, so we have seen these are the causes, and they're all present in the risk factors that are attributed to the carcinoma of the colon. Apart from taking the familial and hereditary family history, the other causes are poor diet, smoking, diabetes, and bacteremia or post-erythrosigmoidostomy. So in this, you can take the modifiable risk factors and the modifiable risk factors that increase and decrease. So if you take the modifiable risk factors that are increased are smoking, processed meat, alcohol, red meat, and intake of low fruits and vegetables and body fat. And the modifiable risk factors that are decreasing the disease are physical activity, whole grains, dietary fiber, dietary products, fish intake, and tree nuts, vitamins, and calcium supplement. So there is an interrelation between the dietary factors, gut bacteria, and inflammatory changes. The factors we are taking, they are causing more protective bacteria we are losing and producing the more carcinogenic. They are causing the inflammatory changes and they are prone for precancerous lesions. These are risk factors from the various familial carcinomas. If you take the colorectal carcinoma, the porodic and the familial And the sporadic is more common compared to that of the familial. It is less common of 5%. So what are the genetic changes that are happening? The genetic changes are there is activation of the proto-oncogene KRAS and loss of tumor suppressor genes, FTC, abnormalities in the DNA repair genes. The overall mechanism is the mutation activation of an oncogene, which is followed by and coupled with the loss of genes that are normally suppress the tumor genesis. So this is a model of adenoma carcinoma sequence. You can see the normal mucosa with an early adenoma. These are all we are very well versed when we are in final years. We all study the model, and a small picture showing the how the polyps in the bowel. And what are the clinical features? Most of them are asymptomatic, or there may be a hematochezia or melena, a pain abdomen, or change in bowel habits. Along with that, they may have an anemia which is attributed to weakness and weight loss, or a palpable mass, more common on the right side. Obstruction is more common on the left side. Spread by direct lymphatic or hematogenous, peritoneal sleeding, or interluminal spread. Clinical presentation, right, left, and rectum. So on the right side, these are exophytic growths, bleeding tendency is more, and they are palpable masses. And if you take the left side, they are annular growths with alteration in the bowel habits. With the intestinal obstruction, they usually present. And the rectum, they are ulcerated with the obstruction as well as bleeding. These are the investigation before going for any symptomatic patients like colonoscopy, FOBT, or metastatic workup with the chest X-ray, abdominal, CT, ultrasound, bone. And this is the TNM classification for completion, T1, 2, 3, 4. And these are the stages. You can see stage 0, 1, 2, 3, 4. Stage 1 up to the invading the mucosa and submucosa to the muscularis. Then next within the muscularis, invading up to the serosa. And stage 3 to spread to the lymph nodes. Stage 4 is the distant metastasis. Treatment options, surgery and radiotherapy and chemotherapy. The surgery is curative with a wide resection of centimeter margin lesions, the nodes and mesentery. Palliative if there is a distant spread, then local control of the hemorrhage and obstruction. 80% of the recurrence will occur within 2 years after resection. Improved survival if metastasis consists of solitary or hepatic mass that is resected. And colectomies we can undergo like primary anastomosis, colectomy, hemicolectomy, or LAR or APR, and complications that are attributed to the major surgeries, so the anastomotic leak, stricture, recurrent disease, pelvic abscess, central. Even though there are surgeries, various are available, but it has become a major surgery once it is diagnosed as a colorectal cancer. Then attributed that we can add radiotherapy and chemotherapy. The survival rate, if you look at the survival, it is 92.2 and stage 2 of 70 to 80. And so the screening is given importance after seeing all survivals, those who in early. So 80% first year, 6.4%. When it is detected early, the 5-year survival is as high as 90%. But only approximately 40% of the tumors are diagnosed due to the screening process. So what are the screening? The most common whenever the patient comes to bleeding here, but that is not included in the screening tool. The fecal occult blood test or fecal immunochemistry. Colonoscopy can remove or a biopsy of the lesions can be taken during the procedure, and it can identify the proximal lesions which are missed by sigmoidoscopy. and use the follow-up to other tests if lesions are found. Disadvantages are it is expensive, not always available, poor compliance, and requires sedation, and there is a risk of chances 0.2%. And virtual colonoscopy, that is a 91% sensitive, and there are false positive rate of 17%. The colonoscopy, it is only required every 5 to 10 years. And
Ma'am, you have to unmute, ma'am. Dr. Durga.
Yeah.
We have also unable to see your screen share. If you
Yeah,
can, please screen share again, ma'am. Yes.
Yeah, am I audible?
Yes, you're audible, ma'am. You can continue from that slide, ma'am, wherever you are going.
Colonoscopy, every 5 to 10 years.
Go ahead, ma'am.
Fecal immunochemical test, it is done in privacy at home, and no dietary or medications are restricted as that of the fecal occult blood test, where we have to give a dietary restriction of 2 days, and no bowel preparation. It is non-invasive, no risk of pain, bleeding, and perforation, and no need for patient travel, and reduces the need for colonoscopy, required only if the stool-based blood testing is abnormal. And this is the picture showing one of the gold standard or the common method we are using for the colorectal cancer screening, that is the colonoscopy. You can pass the colonoscope up to the ileocecal junction and you can visualize the lesions. Small pictures in between the presentation, you can have a small pleasure. Stigmatoscopy, the scopy is flexible and non-traumatic. It can go up to the splenic flexure. This is the CT colonoscopy or virtual colonoscopy. These are pictures. So with the CT, multiple serial sections are taken with the air-based contrast. And this is the barium enema. And these are the beautiful pictures we can see. These are all the pictures we'll study from our final year, that the right side, the polypoid growth and polyp in the left and transverse colon, and the left colon or descending colon, you can see the annular growth that gives an apple core appearance. So why it is so important? Because it can be caught early before it is even starts. And screening looks for polyps in the colon or traces of the blood in the stool that might indicate a cancer. And other thing is the polyp can take 10 to 15 years to grow into cancer. Early screening can catch them before they have a chance to develop into cancer. So more than 95% of the colorectal cancers follows this adenoma carcinoma sequence that put based for the screening as colonoscopy to find the polyps. Then what are the 2023 recommendations? Recent screening guidelines recommend that anyone with average risk of colorectal cancer development should be screened starting at the age of 45. 50, they have reduced it to 45. And the screening guidelines ages may be 45 to 75. Colonoscopy for every 10 years for the average risk patients. What are the average risk patients? We'll discuss in the next slide. And 76 to 85 years. Selective testing based on the individual factors such as the overall health of the patient, life expectancy, and the previous screening history. And 85 and above, it is not recommended, as by the time the patient may be diagnosed in advanced stage, or it may take 10 years to get developed. So these are NCCN guidelines for colorectal cancer screening, the 1.23. You can see the patients with average risk and increased risk. So here it is given patients with average risk more than 45 years, and there is no personal history of adenoma, or inflammatory bowel, or high risk cystic fibrosis, other childhood, or no family history. Even then, they are classified under average risk. And the increased risk, or they are having history of any polyps or family history or IBD or cystic fibrosis, positive family history, they are classified under increased risk. To simplify these two small slides, what is an average risk? There is no history of colorectal cancer or polyps, no family history, and no history of Crohn's or ulcerative, and no history of suspected hereditary cancer syndrome, and no history of previous cancer treatment in the abdomen or pelvis. Even then, they have to get screened by 45 years with whatever the screening modalities that are available. Increased risk, first degree relatives are having polyps or cancer previously, and the presence of ulcerative colitis or Crohn's, and the family history of genetic syndromes like FAP or Lynch syndrome, HNPCC, and had cancer with radiation to the pelvic or abdomen, that is a direct attack to the pelvic organs. So these are the screening modalities that are available. We'll have the increased, we'll have to start by 45. So adenomas, colorectal, ulcerative, these are the guidelines. If you take this NCCN guidelines, what is the average risk, how to follow? So first you go for colonoscopy. If there are no polyps, rescreen with any other modality in every 10 years. If there are polyps are present, do a polypectomy and send it for histopathology. And if it is hyperplastic of more than 1 centimeter, then you can follow the less than 1 centimeter, you can follow the colonoscopy. And adenomas are serrated lesions, sessile or a stratified lesions with this hyperplastic polyp of more than 1 centimeter in size. Then you have to follow polyp and clinical findings as that of the NCC guidelines. And stool-based test, GOIC test or immunochemical or multi-targeted DNA. First GOIC test, the peroxidase will detect the heme, whereas in fecal immunochemical test, the antibodies will detect the heme. And multi-targeted stool test, then the cells that are shed from the polyps, the DNA is subjected to histopathology to see any precancerous lesions are there. So after the stool test, if it is negative, rescreen with every year fecal based test. Or if it is positive, colonoscopy within 9 months. And if you think any positive or negative, then you have to follow colonoscopy pathway above. Sham, I am getting this timer this side. It can it be placed in the above? Because it is obscure. My screen is not visible. 1/4 scale. Okay. A multi-targeted stool DNA test is positive. Colonoscopy within 9 months and follow the colonoscopy pathway. If it is negative, rescreen with any modality in every 3 years. So FOB for annual test, whereas a multi-targeted you can go for every 3 years. Other is a flexible sigmoidoscopy. If the polyps are present, biopsy or do a polypectomy. Then see if it is hyperplastic of less than 1 centimeter, go for colonoscopy and follow according to the lesion. If it is no polyps, then rescreen with any modality like 5 years flexible sigmoidoscopy or 10 years colonoscopy. If it is a CT colonography, then what will? CT colonography is very accurate. We can detect lesions of less than 6 mm. So according to that, if it is 6 to 9 polyps are there, 1 to 2 polyps are there, continue CT every 3 years. More than 3, then you have to go for colonoscopy. If it is more than 10 mm or 1 centimeter, then go for colonoscopy. So negative or no polyps are there, no, not there, then you rescreen every 5 years with CT colonography. These are all summarized in next slide. So according to NCCN guidance, screening should be above 45 years. And annually you can do a sensitivity, FOBT or FIET. Multi-targeted stool DNA testing every 3 years. Flexible sigmoidoscopy every 5 years. Colonoscopy every 10 years. And double contrast enema every 5 years. CT colonography every 5 years. European Standard Medical Oncologist and US Preventive and Screening Task Force guidelines, same as that, but they have added flexible sigmoidoscopy with annual fecal blood test. So these are the advantages and disadvantages of all the screening modalities. If you take the fecal occult blood test, even though it is low cost, good sensitivity, but patient has to come if there are 1 or 2, 3 lesions. And if it is FIT or multi-targeted DNA test, they may not detect the polyps, but colonoscopy is required if it is positive. And multi-targeted, even though it is sensitive than FIT, but is less specific. And if you take the sigmoidoscopy, you can examine the colon up to the splenic fracture. And the advantage is fiber optic and most of the cancers on the left side. But the one thing is, it is invasive. Colonoscopy, it examines the entire colon, highly sensitive, both therapeutic and specific. We can remove the polyp and send it for histopathology. But it is more invasive, uncomfortable, and requires a bowel preparation. At least 2 days before the test, it has to be on liquid diet, and before the day, laxative should be given. And double contrast enema, it examines the entire colon, sensitivity for more than 1 centimeter polyp. And computed tomography, most of them are preferring non-invasive, sensitive may be as good of that of colonoscopy. But the problem with this is only we can see the we can say that the polyp is present or not, but we cannot take a biopsy. These are the recommendations for familial cancers, where we have to start very early, like 40 years, and we have to take the personal history of the patient. Then according to the personal history, we have to reduce the age by 10 years younger than the relatives occurrence of the disease. And these are the guidelines for NCCN. If there are polyps are present, or if they are at increased stage of the disease, how to follow up. These are all I am skipping because I am already explained in the previous slide. So this is one slide. I usually put one slide in my mother tongue because that will go to the audience very closely. The key point of this presentation is the screening or prevention of the cancer. How? By changing our habits, food habits and all. So పెద్ద ఆరోగ్యంగా ఉండాలంటే ఈ పదార్థాలు తప్పనిసరి, లైక్ పీచు పదార్థాలు, వెజిటబుల్స్, ఫ్రెష్ వెజిటబుల్స్ ప్లస్ ఫ్రూట్స్, పళ్ళు, ఇవన్నీ ఎక్కువగా తీసుకుంటే we can have a less chances of getting not only that in any other cancers. So prevention, always prevention is better than cure. So increase fiber in the diet, decrease animal fat and red meat, decrease smoking and alcohol, increase exercise and BMI, decrease BMI. Secondary prevention with screening. Take home message, 7 tips for cancer prevention. Be active, know your family history, get screened, keep a healthy weight, drink less alcohol, stop smoking and eat more fiber. If you inculcate all these things, then it will give a good quality of life. So why I have chosen, I already said, we are doing so many screening cancers, cancer awareness programs, everything that we have to include this also, because nowadays it is not in only men. Women are equally potentially risk for the colonic cancer, and they won't come as that we have seen in mammography for breast cancer. They won't come not even for colonoscopy also. So let the patient get interacted, they know the risk and they get screened early, because the chance of survival is more if it is detected very early. And if it is very detected late, there are obscure surgeries like removal of the entire colon or colostomies, అంటే పేక్ తీసుకొచ్చి బయటపడడం ఉంటుంది, అది ఇంకా జీవితాంతం ఉండాల్సి వస్తుంది. So there are obscure large major surgeries. So prevention is always better than cure. I have seen 2 to 3 persons surrounding me with a colon cancer. 2 of them are survived with the basic surgery what we have discussed. 1 is struggling and 1 is no more. So they are absolutely asymptomatic before they are diagnosed. Asymptomatic, asymptomatic, they are mixing with that, they are talking, they are moving up. Suddenly they have diagnosed in late stages. Thank you for your attention.
Thank you, Durgarani ma'am. Thank you so much for vast information on colorectal cancer, ma'am. It was very wonderful. Now I request Dr. Allu Padmaja ma'am to speak about this.
Madam, it is an elaborative and a very explanative lecture, madam.
Thank you.
An excellent lecture, Dr. Durgarani. A different facet, a crusader of Mission Pink Health. how she is finding time to present so well with nice pictorial presentations, guidelines, and prevention. Thank you, Durga Rani Madam, for elaborately touching upon this topic.
Thank you, madam. Thank you for your appreciation.
Thank you, ma'am. So we request the next speaker for the session, Dr. Saivani, ma'am. Ma'am, Durga Rani, ma'am, if you stop that screen sharing, I can just go ahead, ma'am.
Leave meeting, screen sharing.
Screen sharing.
They'll remove, no? They'll remove.
It's taken care, ma'am.
Ma'am.
Yeah.
So, Saivani, ma'am.
Good morning,
So, the
ma'am.
next speaker for the session of Nephrology, Shantram Medical College. Ma'am completed her MBBS from SVMC Tirupati, MD General Medicine from Karnool Medical College, and DM Nephrology from. Here, I would like to tell one thing. I don't know whether ma'am remembers me or not, but I had worked with ma'am when I was in KM. I was doing my intern. So next, she was a recipient of gold medals, MBBS Biochem and ENT, and MD General Medicine. Secured first rank in DM Nephrology in the year 2012. Authored a book titled Home Isolation in COVID. Currently Joint Secretary APSN and Scientific Head. Guest speaker in many regional conferences. She has over 9 publications in national and international journals. And the topic is complicated UTI. So I now welcome Saivani ma'am to take over the topic. Thank you, ma'am.
Welcome, Saivani madam. Thank you, madam. Thank you for the wonderful introduction. I do remember your face, madam. Okay.
Thank you, ma'am. Thank you. Thank you, ma'am. Because you were training a lot at that time. Thank you, ma'am.
Thank you. Okay. So, at the outset, I would like to thank all the IMA members and Dr. Ravi Krishna sir for giving me this opportunity to enlighten upon complicated UTI. It's a very complicated topic, but day in and day out, we are encountering so many cases of urinary tract infection. So outline of my talk is complicated UTI definition and burden, and the special population who are prone for complicated UTI, and interesting case scenario and retrospective analysis of complicated UTI patients admitted at our nephrology department. So the challenges of complicated UTI are, there is no consensus definition to diagnose complicated UTI, and the wide variety of causative pathogens and patient populations, and the rising antimicrobial resistance, which is most common in India, what we are facing here, make treating these infections challenging. So there are so many definitions: IDSA, AUA, European Association of Urology, UFFTA, and EMA. And now I'll take to you with European Association of Urology definition. Here they have reasonably represented the clinical presentation like urethritis, cystitis, pyelonephritis, urosepsis, and male genital glands. And they have differentiated severity grade also. 1 is low, 2 is moderate pyelonephritis, 3 is severe pyelonephritis, and 4 is urosepsis with SIRS, and 5 is urosepsis with organ dysfunction, that is nothing but severe sepsis, and 6 is US with organ failure. And the high risk factors, those who are more prone for complicated UTIs. 1 is no risk factors, O, R is recurrent UTIs, E is extra-urogenital risk factors, N is nephropathic diseases like nephrotic syndromes and all, on immunosuppression patients, and U is urological, and C is permanent urinary catheters. And pathogen-related risk factors. Some bacterial species, and they are susceptibility grade: susceptible, reduced susceptible, and multi-drug resistance. So to summarize, uncomplicated UTI and complicated UTI. In complicated, immunity is decreased, and they will have comorbidities like diabetes, and they will be on immunosuppression. And pregnant women, childhood UTIs and menopausal UTIs are complicated, and they may be having urological obstructions, ADPKD, neurogenic bladders, and the location of infection is beyond the bladder. That is called complicated. And symptoms also, the symptoms are beyond the bladder. So to sum up, except the UTI in healthy non-pregnant women are complicated UTI, and UTIs that not confined to the bladder are complicated. So approach is acute complicated UTI is the patient may present with fever, chills, rigors, fatigue, malaise, flank pains, costovertebral angle tenderness, pelvic pain, perineal pain, in men. Or special population like pregnant women, renal transplant recipient. The burden is very high. In US, about 1.8% of all admissions are UTIs, and among that, antibiotic resistance is causing 7 lakh deaths yearly due to drug-resistant strains. So the pathogen pattern according to the order of incidence is in uncomplicated UTI and complicated E. coli is most common, but with complicated, the multiple pathogens makes the complicated. That is some gram-negative organism plus gram-positive organisms may be present. And suspect multi-drug resistant gram-negative urinary tract infection whenever you approach a case of inpatient persons like hospital, nursing home, long-term acute care facilities, they might be having multi-drug resistant. And use of fluoroquinolones and septrons previous past within 3 months. So they might have multi-drug resistant, and travel to the parts of the world like India where multi-drug resistant organisms were high. And coming to antimicrobial resistance, day in and day out, we are facing this problem very high. And we call the bacteria as multi-drug resistance when the drug is resistant to fluoroquinolone or third generation cephalosporin or carbapenem, either of them. So the fluoroquinolone resistance is most common, that is 10 to 80%, and third generation cephalosporin is more second common, that is 10 to 70%. Even now the tragedy is the carbapenem resistance, that is meropenem resistance is picking up, it is up to 5 to 35%. And this resistance is more common in gram-negative organisms. So why the emergence, what is the reason for emergence of antimicrobial resistance? So treating the uncomplicated UTI for longer periods, irrational use of antibiotics, and treating asymptomatic bacteriuria. It is very important. Presence of urine pustules, they treat from RMPs and all, everyone treat with the antibiotics. If the patient is not having any symptoms, simple culture is positive, don't treat the patient. If the patient is having symptoms, then treat the patient. So asymptomatic bacteriuria need not treated in all, except only 2 conditions. One is pregnancy and other is the urological emergencies. In these 2 cases, you have to treat any urological surgeries, you have to treat the asymptomatic bacteriuria. So, and also lack of awareness and antibiotic stewardship. After 3 days of antibiotics, if the symptoms subside, we have to stop or de-escalate the antibiotics. And clinicians fear that there is we have to manage the balance. Imminent risk of infection and the long-term risk of antibiotic resistance. Now we are facing the infection. So if we don't treat, it may complicate. And we don't think about the long-term risk of antibiotic resistance and all. So if we keep all these in mind, we can decrease the emergence of antimicrobial resistance. And lack of enthusiasm in pharma companies in producing newer antibiotics. So only we have some set of antibiotics, and newer antibiotics are not being produced because they are not getting some revenues with these antibiotics. And coming to evaluation of the patient. So whenever you see a complicated UTI patient, first you send for ultrasound abdomen and pelvis, and don't forget about the prostate, pre-void and post-void residual urine. These are the most common culprits which cause the recurrent infections, complicated infections and all. And these are the common cause of obstruction. In elderly male, we'll see prostate hypertrophy, prostatic cancer, which cause the post-voidal residual urine. So whenever you order a ultrasound scan for a patient of UTI, don't forget about pre-void, post-void and prostate in males and post-void residual urine in females, because this is the most common cause of recurrent infections and complicated UTIs. And CT KUB is the imaging of choice. It gives us so many knowledge, because in ultrasound we can see the kidneys and bladder, and the ureter we can't trace completely, but in CT we can trace completely ureter, and any calculi missed in ultrasound also we can get in CT. And MRI is not advantageous except for to exclude radiation, like pregnancies and all. Coming to the diagnosis, the patient having symptoms of cystitis with fever, burning micturition, dysuria associated with chills and rigors, altered mentation, costovertebral tenderness, perineal pain, all these indicates the patient is having complicated UTI, and imaging ultrasound and CT will show us the location of infection, whether upper tract like kidneys are involved. So pyelonephritis or hydronephrosis. Hydronephrosis indicates some obstruction is there. Pyelonephritis means perinephric fat stranding or radiolucences, which indicates the neutrophilic deposition. So they give us some clue where is the site of obstruction, where is the site of infection in complicated UTI. And urine showing plenty of pus cells. Any complicated UTI, urine showing pus cells is the dictum. And urine culture and sensitivity, the tragedy is whenever you send culture and sensitivity, already the patient might have used antibiotics, and so they may get negative culture. So many times negative culture, but urine culture and sensitivity guide us to narrow the spectrum of antibiotics to give and proper duration of time. Coming to the management, the indication for hospitalization are severe sepsis, critically ill patients, and urinary tract obstruction. All these are indication for hospitalization, and persistent high fever associated with pain, monocle debility, and inability to maintain oral hydration and taking oral medications. So these are the major indications for hospitalization. Coming to the management, here after hospitalizing, we'll divide the cases into two. One is critical illness and other is not critical illness. That is, critical illness is the patient is having severe sepsis, that is organ dysfunction with SIRS and renal shutdown. They should be initiated within 1 hour broad spectrum antibiotics covering both gram-positive and gram-negative organisms. And if imagiology shows any obstruction, pyelonephritis, you can seek the help of urologist for interventions like BJ stenting. And other than critical illness, if the patient is stable, admit in ward, select antibiotic according to the sensitivity pattern of local area. Because multi-drug resistant infections are common, so we have to know the sensitivity pattern in our area. Fluoroquinolone resistance, beta-lactamase resistance, and carbapenem resistance. So according to that, we have to start the antibiotics. So after completing critically ill and normal hospital admission, outpatient treatment, we can give treat complicated UTIs with the outpatient also, but the patient should be under regular follow-up. If the patient if you suspect high multi-drug resistant, give injection ertapenem single dose followed by advised oral carbapenems like orpenem. If the patient is having low multi-drug resistant UTIs, you advise fluoroquinolones. So coming to directed antimicrobial therapy, urine culture gives us lot of information. The organism gram-positive or gram-negative, and the sensitivity pattern. So coming to enterobacterials, E. coli, Klebsiella, Proteus, these gram-negative organisms are the most common causes of complicated UTI, and we have to know the susceptibility pattern and resistance pattern. Whenever you see a urine culture report, you have to check whether it is gram-positive organism or gram-negative organism. In gram-negative pattern, whether the organism is sensitivity to fluoroquinolones or beta-lactams or carbamazepines. If the patient is having fluoroquinolone resistant, next choice of drug will be beta-lactams. If the patient is resistant to beta-lactams also, the next choice is carbapenem. If the patient is having resistance to all the 3 drugs, you have to go with the newer drugs and precious drugs like colistin, polymyxin. And coming to enterococci, the treatment is amoxicillin. And in Pseudomonas, what you have to remember is you have to start with the dual antibiotics, dual anti-pseudomonal drugs like carbapenems and fluoroquinolones like that. So that early you can curtail the pseudomonal infection. Coming to staphylococcal. So staphylococcal septicemia should be treated early. Otherwise, it causes abscesses in different organs. And for this, we can first start with vancomycin and or linezolid, daptomycin and tigecycline. So the duration of therapy. After initiation of your treatment, you reassess the patient. If the patient is having symptomatic improvement within 48 hours, you can discontinue the therapy within 5 to 7 days. But if there is no symptomatic improvement, you have to go for imaging to treat why he is not improving, and also culture, whether the treatment you have prescribed may not be susceptible to that organism. So these patients require long duration of treatment, and we have to check for the nidus of infection anywhere. Addressing the urinary tract abnormalities like neurogenic bladder. So spinal cord abnormalities may have some neurogenic bladder. The bladder can't eject the urine out, and presence of post-void residual urine more than 30 ml. These patients are more prone for recurrent urinary tract infection. So for these people, you have to advise the continuous Foley's catheter or clean intermittent self-catheterization. That is morning and evening, keeping the infant feeding tube and letting out the urine that was remaining in the bladder, because the stasis of urine is the nidus for the bacteria. And inhaling bladder catheters for longer duration, they are also more prone for urinary tract infection. And nephrostomy tubes for CA cervix and renal stones, pelviureteric junction stones, we keep nephrostomy, percutaneous nephrostomy tubes. So those who are having all these tubes and artificial things in the bladder, they are more prone for urinary tract infection. And urethral stents also. Nowadays, urethral stents are commonly used for stones, obstruction, pyelonephritis, and this is a two-way. Urethral stents are used to treat UTIs, and urethral stents can introduce infection from bladder to kidneys. So whenever you are prescribing urethral stents, also make double sure that you are giving antibiotics prior, and there is no bladder infection. We are giving urethral stents for pyelonephritis, as already infection is present in the kidneys. Coming to the follow-up, symptoms should improve promptly if antimicrobial therapy is effective. Outpatients should have close follow-up. Whenever you are treating UTI patients on OP basis, you should have their phone numbers, and you have to inquire within 48 to 72 hours they are improved or not. If they are not improving and they have persistent symptoms, they should get admitted, or you should evaluate them for further with improved imaging and cultures. Coming to special patient populations, coming to catheter-associated UTIs. The most common nosocomial infection in hospital and long-term health care facilities is catheter-associated UTIs. Short-term catheterization had risk of 3 to 80%. So mostly those who are admitted and who gets admitted in intensive care units, urine catheter is commonly inserted, and they are more prone for UTIs afterwards. And long-term catheterization, already I have discussed neurogenic bladder having significant PVR. They might have kept on Foley's catheters, and they are more prone for 100% catheter-related infections. And most common cause of bacteremia in the bedridden people is urinary tract infection. And among these individuals, distinguish asymptomatic bacteriuria and UTI is very important. Yeah, every time if you send urine culture, some or other organism will be positive. If the patient is not having any symptoms of fever, dysuria, you should not treat in catheter-associated UTIs. If the patient is having symptoms, you have to treat, otherwise they progress to sepsis, septic shock, and deaths early. So these are the people who are prone for complications, and without any symptoms, you should not treat. And here, actually, when the colony count more than 10^5 is significant, but in catheter-associated UTI, colony count more than 10^3 or one bacterial species is taken as urinary infection, but treatment should be with symptoms, not without symptoms. Coming to ureteral dysfunction, impaired ureteral function with high intravesical pressure and vesico-ureteric function predisposed to upper ureteric infections, and it is commonly seen in the children. They will have reflux nephropathies, and which results in scarring of the kidney and infection of the kidney. With the antibiotic prophylaxis, you can treat the infection of the kidney, decrease the infection of the kidney, but you can't decrease the scarring, and this scarring is most prone for recurrent UTIs. So we have to think about decrease the maneuvers to decrease the scarring in reflux nephropathy. And coming to impaired host response, this is most challenging to treat, as a nephrologist will face day in and day out diabetic mellitus patients who are having severe UTIs, and our CKDs are more common with the diabetes mellitus. And recently, the SGLT2 inhibitors, we are using left and right, that is UDAPA, dapagliflozin, empagliflozin, canagliflozin. They are helpful to prevent cardiac events and also progression of CKD, and many plethoric effects are there with the SGLT2 inhibitor. As a physician, I will also write SGLT2 inhibitor, but whenever you are prescribing SGLT2 inhibitor, beware of UTIs. And when the patient comes you with the burning micturition, and you think of this SGLT2 inhibitor. And ESRD patients also having less immunity. So CKD patients have less immunity, so they are more prone for complicated UTIs. They cannot be treated like normal persons, and they might require the dual antibiotics also, and they are more prone for resistant organisms also. And coming to solid organ transplant, as a nephrologist, we commonly come across kidney transplant recipients. Early post-renal transplant, they are more prone for urinary tract infections. But here also, asymptomatic bacteriuria we won't treat. When the patient is having urinary tract infection symptoms only, we will treat. And CKD patients are high risk for UTI because of loss of antimicrobial properties and immunosuppression because of CKD, and inhibition of protective mucosal production in the urothelium. And the most common CKD patients having UTIs are ADPKD and diabetic kidney disease. And coming to kidney transplant recipient, if the patient is having a UTIs infection compared to normal person, they have high morbidity and mortality. Now mortality is decreased to less than 5%, but 40 to 50% of all infectious complications in kidney transplant recipient is UTI, because they have been kept on degestant for 1 month, and also the bladder was intervened. So these people are more prone for UTIs. And factors favoring UTI in these individuals are elderly age and immunosuppression, having the azathioprine, MMF, and anti-thymocyte globulin induction, and duration since transplantation also. Early post-transplant period, they are more prone for infections. But keep in mind, asymptomatic bacteriuria in kidney transplant recipients also we don't treat. Coming to pregnancy, this is the one indication where asymptomatic bacteriuria is to be treated, because otherwise abortions and preterm pregnancy risk will be there. And for every pregnant woman, early pregnancies, sending urine culture and sensitivity is very important, and this gives a lot of information and lots of prognosis to the pregnancy patient. And every gynecologist faces the UTI is the most common complication during pregnancy period, but don't hurry in starting antibiotics before giving the urine culture. First give one urine culture, then start the antibiotics, and you have to screen urine culture regularly. If the urine culture is positive, if 2 urine cultures are positive, you have to keep antibiotic prophylaxis till the delivery. Coming to antibiotic exposure, congenital anomalies will be there. For that only, we will select antibiotics without any toxicity like beta-lactams, nitrofurantoin, metronidazole, vancomycin, and phosphocin. Coming to case scenario, before going to one case scenario, an interesting case of complicated UTI of mine, we should know some wordings about sepsis. That is SIRS, having temperature more than 100 or less than 96, having tachypnea, tachycardia, and WBC count, leukocytosis and leukopenia, all will come under SIRS. In sepsis, 2 components of SIRS positive with confirmed infection, like cultures are positive or anything. Coming to severe sepsis, sepsis plus end organ damage, and having SBP of less than 90 and lactates of more than 4. And in coming to septic shock, persistent end organ damage with hypotension and lactates more than 4. Coming to sepsis, life-threatening organ dysfunction because of dysregulated host response to infection. Actually, the host response to the infection is not going in correct pathway. It is damaging the patient. And so far score of 2 at presentation is sepsis. And coming to septic shock, sepsis plus vasoactive therapy to maintain MAP of more than 65 or rise in lactate of more than 2 millimole per liter despite adequate volume resuscitation is septic shock. And another score is SOFA score, Q SOFA, respiratory rate more than 22 or altered mentation, and SBP having less than 100. All these parameters we should know properly, because this case is very interesting. And this is a continuum. The patient from SARS going to sepsis, going to severe sepsis, and going to septic shock. And the predicting factors for early sepsis are Q-SOFA score and the National Early Warning score are very important to know the sepsis. And we evaluate sepsis patient with the SOFA score, and it gives us the morbidity and mortality of the patient. So we diagnose AKI by staging. We diagnose AKI staging by Rifle, Akin, and Kedigo. This is the staging. And all AKIs due to complicated UTI won't recover completely. This is the continuum of AKI prognosis. Within 7 days, if he recovers, it is called AKI. If he won't recover within 7 days, and if he recovers within 90 days, it is called AKD, acute kidney disease. And if it progresses more than 90 days, it is called chronic kidney disease. These are the terminologies we should know before approaching to our case. So she is a female, 62-year-old female, diabetic since 10 years, not a known hypertensive, presented with persistent vomiting. Vomiting is an important symptom where UTI presents, but without any burning micturition also, vomiting and fever may be UTI. And persistent vomiting, fever associated with chills and rigor since 3 days. And she does not have any urinary complaints or cough or any significant history to localize the fever. Her vitals are, she is febrile with pulse rate of 145 and BP of 120/70, saturation is 93%, respiratory rate of 30, and temperature of 102. She was having all SIRS criteria, and her reports were creatinine of 3.4, CUE of albumin 3+, and WBC of 3. Even WBC of 3 cells also is important. Culture might be positive. And lactate is 4. And at the time of admission, her SOFA score is 2, which indicates less than 10% mortality. And after 1 day of admission, she was deteriorated and her SOFA score was increased from 2 to 7, 7 to 8, and 8 to 12. And I will discuss this later. And for our case, it's a case of sepsis. So whenever you approach a case of sepsis, you have to treat 2 times. One is infection-directed management, other is supportive care. Coming to infection-directed management, you have to diagnose rapid infection diagnosis, whether the infection is in lung or kidney or bladder, and early antimicrobial initiation, source control, and prevention of nosocomial infection. Coming to supportive care, you have to maintain her vitals, take fluid, give fluid bolus, minimize unnecessary nephrotoxins, conservative resuscitation, give fluid bolus, but should not be overloaded. Ati sarvatra varjayat. Whenever you give patients irrational fluids also, it increases intrarenal pressure and deteriorates the patient, and lactates will increase. And when patient looks like she is overloaded, tailor the vasopressor targets, avoid fluid overload, and adjust the drug dosages. Here, in our patient, we have done POCUS, that is point of care ultrasound, lung ultrasound, abdomen ultrasound, heart, CT abdomen and chest. In our case, lung ultrasound was bilateral minimal pleural effusion, but abdominal ultrasound was showing bulky right kidney, and CT KUB was showing right kidney bulky with perinephric fat stranding. So the source of infection is kidney. So we have initiated her on antibiotics within 1 hour with higher antibiotics. As the patient is deteriorating, we have given broad spectrum antibiotic meropenem 1 gram in 100 ml NS, followed as the creatinine is high, we have modified the dose of meropenem, and not initiated an gram positive coverage, as she was not having any risk of gram positive coverage. After 2 days of hospital admission, that patient deteriorated, went into septic shock, even on a meropenem. SOFA was 10, severe metabolic acidosis. She was anuric for more than 12 hours, and stage of AKI progressed to stage 3. So we have initiated her on 2 antimicrobials for gram-negative coverage, thinking of Pseudomonas, and so colistin added in renal modified dosages. And along with this, we have started an MRSA coverage, vancomycin also. And we thought for source control, the ultrasound and CT was showing bulky kidney, pyelonephritis of right kidney, urology consultation was taken, and DCA stent was inserted. And she was having hyperglycemia. With insulin infusion, we have decreased the glucose, and we have initiated her on supportive care. IV fluids, we have given oral of 30 ml per kg, and in the IV fluids, crystalloids are better than colloids. In the crystalloids, ringer lactate is better than normal saline, as normal saline has the inherent risk of severe metabolic acidosis. And so we have given oral, and after that also, after IV fluid bolus also, her MAP was not improved. Mean arterial pressure was 40. The target MAP to keep for her was 65. So we have initiated on vasopressors, noradrenaline. With noradrenaline also, maximum dose also not improved. So we have initiated her on vasopressin, dual vasopressors, and given steroids, hydrocortisone 200 mg per day. After 2 hours, and she has, we have done 2D echo. It was cardiomyopathy, might be uremic or septic. So we have initiated her on inotrope dobutamine and with noradrenaline and vasopressin. And we have intubated her to reduce the workout breathing with tidal volume of 6 ml per kg, plateau pressure of 30, and PEEP of 8. Initially managed with NIV, but she was deteriorated, so we have intubated. And we have proceeded with the source control with the right digest stenting. after source control and in view of severe metabolic acidosis and high procalcitonin inotropic support thrombocytopenia, she was initiated on kidney replacement therapy. As she was having hypotension, we have given her as a CRRT and we have advised them heme adsorption therapy to absorb the cytokines which are the culprit for hypotension. They have accepted the cost and all. So we have initiated an Oxiris, kept the blood flow at 100 with convective dose of 25 ml per kg per hour and initiated an heparin-free dialysis. After the source control by degestenting, she was improved, inotropic support tapered, gradually weaned from mechanical ventilator and extubated after 3 days, and de-escalation of antibiotics of MRSA was started. So vancomycin was stopped, culture was positive for Klebsiella, which was sensitive to marrow. So we have given meropenem for 7 days. And after that, her SOFA score was declining and she was improved. And her ejection fraction was also improved from 30% to 48%. And our data at Santiram Super Speciality Hospital in Nephro ICU from January 2023 to till date, the total complicated UTI cases were 49. And the males were 24 and females were 35. Commonly, complicated UTIs are more common in females. And we have initiated an hemodialysis in 16 of these patients, and remaining we have managed conservatively. And we have inserted degestant to decrease the intrarenal pressures so that and any obstructions so that they recover faster with in 11 cases. And biopsy was done when there was no recovery in 9 cases as per indication. 3 were showed acute tubulointerstitial nephritis and 3 were acute tubular nephritis and 1 was cortical necrosis, 2 were infection related glomerulonephritis. And
Okay,
urine culture was positive in 25 cases. Urine culture was done in all cases, but I could extract the 25 urine culture reports, and positive in 9, negative in 13. So whenever you give prior antibiotics and send urine culture after that, we'll get culture negative report. So before treating the patient, take the urine culture sample, and gram positive in 1, gram negative in 13 cases. Most common organism is E. coli, next is Pseudomonas, next is Klebsiella. Among them also, carbapenem resistant were 2, fluoroquinolone resistant were 8, and third generation cephalosporin resistant were 7. So even meropenem resistance also is increasing in our area. So we should be cautious about this. And coming to the outcome, as I have explained, complete recovery was seen in within 7 days is called AKI, within 7 to 90 days is called AKD, and within more than 90 days is called CKD. So these patients are not having fruitful outcome. 26 went into CKD and 13 went into AKD and 11 were AKI. So all complicated UTIs won't recover completely and they may progress to CKD. So, at nutshell, complicated UTI are commonly encountered in day-to-day practice. Timely management, early referral to an expert is very important. Beware of antibiotic sensitivities in your area, and all urosepsis would not recover completely, make progress to CKD. So, thank you on one and all for giving me this opportunity.
Welcome, ma'am. Welcome, Saivani, ma'am. Now I request Dr. Padmalata, ma'am, to moderate the session. Padmalata, ma'am.
Yeah, next is my topic, no? No, another Padmalata.
Okay. Moderator Padmalata, ma'am. Ma'am, Ala Prashanti, ma'am, we just want to introduce you, so you can just. Padma. Padmalata, Padmalata, ma'am.
Yeah.
Ma'am.
I'm speaker. I'm not a moderator. No.
Okay,
another
ma'am.
Padmalata.
Another Padmalata, ma'am, is there, ma'am. Pulmonologist.
Yeah.
Okay, ma'am. Sorry. I request Dr. Allu Padmaja ma'am to moderate the session because ma'am is available.
Thank you, Sumana.
Welcome, ma'am.
And it's a privilege to introduce the dynamic lady, Ala Prashanti garu of our specialty. She is an ISA state president.
Excuse me, ma'am, to speak about Saivani ma'am's presentation regarding complicated UTI.
Sorry.
Yes.
Madam,
Yes, ma'am.
topic. Sorry, Saivani.
Okay, it's okay,
It
ma'am.
was an excellent presentation, in fact, with especially the case scenarios.
Yes.
The case you have shown with the SOFA scores, how you have reduced with the beautiful treatment, Saivani garu. That was a wonderful presentation indeed.
Thank you, madam. Thank you.
Especially with increasing UTI, and we deal them in ICUs. And it was a very informative and well touched upon topic, madam. Thank you, Saivan garu.
Thank you, madam. Thank you very much. And I thank the organizers for giving me this opportunity and Ravi Krishna sir for giving me this opportunity. Thank you.
Thank you very much.
చెప్పండి.
Excellent presentation, Saivani. Thank you very much.
Thank you, ma'am. It is the most common problem among females. Thank you so much for your valuable information, Saivani ma'am. So I request Dr. Vasudha ma'am to introduce Dr. Ala Prashanti ma'am.
Hello. Good
Hello.
evening. Good
No.
evening, all. Can you see me?
Yeah.
Good afternoon, all of you. We are running little
Excuse me, ma'am. I just request Ala Prashanti ma'am to stop sharing so that we can share your slide, introduction slide, ma'am.
Yeah, sure.
Yeah, ma'am.
Good afternoon. It is my pleasure to introduce you, Ala Prashanti, the special doctor, lawyer, specialist anesthetist, and accident and emergency specialist. And she's president of ISA AP State. So I've seen her many times. She's the coolest doctor, and she has nothing impossible in her list, in her dictionary. It's my pleasure, ma'am. Please continue with your topic.
Good afternoon, Ala Prashanti.
Good afternoon, everyone. Thank you, Vasudha ma'am, for your kind introduction. Yeah, can I now share my screen?
Yes, ma'am. The
Yes,
topic is prerequisites for preoperative checkup. I welcome Ala Prashanti ma'am. Yeah, ma'am. You can go ahead.
Yeah, I think you should.
Yes, ma'am. I stop. Thank you, ma'am.
Yeah, is this visible? Shall I start?
Yes, ma'am. It's visible, ma'am. You can start, ma'am.
Yeah.
Yes.
Good evening, everyone. Thank you. I thank the moderators, Dr. Allu Padmaja ma'am, Dr. Madhvi Shamla ma'am, and Dr. Padmalata ma'am for moderating this session. It's actually prerequisites for pre-anesthetic checkup. So,
Madam, you can do
Why-
slideshow mode, ma'am. Slideshow mode. please.
what?
Slideshow.
Yeah, slideshow only I'm doing.
Okay, ma'am. Go ahead, ma'am.
Yeah. So what is actually a pre-anesthetic checkup? Actually, what is anesthesia for? Anesthesia is for facilitating the surgical procedure. But anesthesia itself poses risk. So to conduct the surgery in a safe mode and to administer anesthesia safely, we have to do a pre-anesthetic checkup. That is, we have to examine the patient beforehand and we have to plan, optimize the patient if he has got any comorbidities or any other problems. And we have to plan the anesthesia and post-op care. For that, we have to do a pre-anesthetic checkup. A pre-anesthetic checkup should be done logically 24 hours before, or in case of emergency, we can do just before taking the patient for surgery also. So what are the prerequisites for PAC? It is a history. A detailed history itself is 56% enough for a pre-anesthetic checkup to identify all the problems of that patient undergoing surgery. And a detailed physical examination and the review of the lab investigations done, and we should assign the ASA physical status. American Society of Anesthesiologists, they have introduced ASA grading for patients. So that is ASA physical status. And then we have to formulate and discuss the anesthesia plan. So what we should do is, so this is, we do a PAC, and if everything, if the anesthetist thinks that everything is fine, we can proceed to surgery as planned. And preparation for surgery, preoperative instructions for surgical patient, discuss the perioperative care, arrange appropriate level of postoperative care, and once the surgery is finished, postoperative follow-up, specialist follow-up facilitated by the pre-anesthesia evaluation, and follow-up by anesthesiologist-led service, acute pair service. And if at all there is some problem, we
Madam,
have
your slide is still on the first slide itself. So if you can stop the screen share and redo it, because we are unable to see the screen.
Yes, ma'am. Only the first slide is visible. The title slide. You can just move to the slide you are presenting, ma'am. A small request.
Yes, can you do that for me?
No, ma'am. You have to do by yourself. We do not have access for that.
Oh, sure.
You can just go and click the slide you are presenting, ma'am. That's enough. It will be automatically shared.
Madam, you will have a cup shape in the down bar.
Yes, yes, it is there. Now you are able to see.
We are able to see, but only if the slide has to come. You
Title slide.
click on that cup shaped icon.
Okay.
It's like a bubble.
Ma'am, stop the screen.
Now you are able to visualize.
No, ma'am, you can
Stop
stop
share.
Yeah, and reshare it, ma'am.
Okay.
Please. Try to do that.
Sharing. Share. Okay.
Yes, ma'am. Yes, ma'am. Now it's gone to second slide.
Okay.
Use up and down arrow, ma'am.
Yes.
Yeah.
Yes, ma'am. Third slide. Yes, ma'am.
It's changing.
Okay.
Yes, yes, ma'am.
So when the preoperative in the preoperative evaluation, if you find some difficulties or problems, we can advise the delay in surgery, and this is for optimizing the patient. You optimize the comorbid diseases, refer to other specialists, refer to specialized testing, initiate interventions if at all intended to decrease the perioperative risk, and identify the previously unrecognized comorbid conditions. Or you have to defer the surgery, and we have to think of non-operative or less invasive treatment, and then follow-up of conditions identified by preoperative assessment. This is the thing that happens. So coming to the history. So we have to start with the patient interview. We can do it to the patient directly as a dialogue, or we can fill the questionnaire by the patient. We should allow appropriate amount of time. It should not be either too long or too short. And we should remain non-judgmental. General questions should be there initially. Have you ever had surgery before? Were there any problems? Anyone in the family had a problem with anesthesia? What are all the medical conditions you are being treated with, and what type of work you do, like that. So coming to the present and past medical history, we have to be very cautious in this history, because patients will not tell you proper detail. You should be like a detective when you are asking the history. You should ask leading questions. You should be probing into certain things. When we ask, do you have hypertension? He will say, no, my BP is normal. Just now the sister has checked. But he is having hypertension. He is on antihypertensive drugs. That you won't be telling. So we should be very interrogative mode, in a probing manner, and we should ask leading questions. And we should ask the surgical history. Any surgeries before, any problems he had during the surgery, and regarding the current surgery for which he has come admitted, and all that. And coexisting medical illness history, whether he has any diabetes, hypertension, hypothyroid or hyperthyroid, respiratory problems like asthma, COPD, any recent history of admission for pneumonias, all that we have to ask, and any neurological problems also we have to ask. Then cardiac history, we should ask for history of hypertension, any coronary artery diseases, valvular artery diseases, any treatment he is on for heart problems, any pedal edema, if he can walk, his exercise tolerance, all that history we have to ask. Then we should ask for the family history of certain diseases like hemophilia, sickle cell disease, all that stuff. And a social history, smoking, alcohol, illicit drug use, all that we have to ask the patient. Regarding smoking, we should ask how many cigarettes he is smoking per day. One pack contains 20 cigarettes, and into number of years he is smoking, so that comes to pack years of smoking, and so that we can assess the smoking index. If it is less than 100, mild risk. If it is more than 300, he is got a high risk for perioperative complications. And allergy history, this is very important. If he has got any general allergies, allergy to certain drugs, we should ask the patient. And current and recent drug history should be noted carefully, so that we have to advise him at the end of the PAC which drugs he has to continue, which drugs he has to stop on the day of surgery. And anesthesia history, whether he underwent anesthesia before for any procedure, any problems regarding previous anesthesia, and any delayed recovery, all that we have to ask in history. So in the other conditions in the medical history, we have to look for is any history of chronic renal failure, whether he is on dialysis or he has got a fistula or anything, and to look out for all these things, uremia, anemia, electrolyte imbalance, because these all affect the drug excretion, and these restrict the choice of the anesthetic agents. That is why we should ask in the history for any chronic renal failure. And diabetes, this is the important thing most of us will be focusing on, because patients having diabetes will have an increased incidence of ischemic heart disease, renal dysfunction, autonomic and peripheral neuropathy, intra and post-operative complications. And uncontrolled blood sugars, as you all know, they will hinder the healing and infection, post-operative infection. Other conditions in the medical history, musculoskeletal, main concentration on rheumatoid arthritis, because they will be chronically anemic, they will have severely limited movements of the joints. So this makes positioning for surgery and airway maintenance very difficult. And there is tendency for dislocation of the atlanto-occipital joint when we are trying to intubate the patient, maneuvering the neck. And restriction of movement and deformities, reduced muscle mass, peripheral neuropathy, they will have a pulmonary involvement also, and particular attention to the patient's cervical spine and temporomandibular joint. So next, we should ask for in the history, any history of sickle cell diseases or clotting disorders, or we should ask for any DVT history, and we should ask for pregnancy, increased risk of regurgitation and aspiration, and because we generally postpone elective surgeries until after delivery. So, and all the patients should be asked regarding the inherited conditions in the family, history of prolonged apnea, unexplained deaths, in the families, history of malignant hyperpyrexia in the family, any person having had any anesthesia problems during surgeries, and any surgery postponed for this particular patient previously. We should also ask for history of difficulty with venous access, thrombosis of veins in the previous surgeries or previous admissions, and look for tattooing also, because that poses a risk for thrombosis of the nearby veins and also infections. And we should assess the patient's exercise tolerance in terms of METs. MET is metabolic equivalent. It represents the oxygen consumption of resting adult, that is 3.5 ml per kg per minute. So standard light home activities, walk around the house, walk 1 to 2 blocks on level ground, it's all 1 to 4 METs. And if you can do a better activity like climbing stairs, walking with more than 6 kilometers per hour, running a short distance, dancing, mountain walk, it all comes under 5 to 9 METs, and strenuous sports more than 10 METs. More than 4 METs is adequate for a administering anesthesia. So people usually ask, just for anesthesia fitness, do we need to run all the blood reports, ECG, X-ray and all? But if at all it is necessary, regarding depending on the patient, we have to do the. So after a good history, we should go for the physical examination. Good physical examination is a prerequisite. So we have to see the vitals, assess the airway, look at the back, see the spine. If at all we are planning for regional anesthesia, neuraxial blockade, and we have to examine the CNS, CVS, and the respiratory systems. So in the vital signs, we should see the, as we all know, the pulse, resting pulse, rate, rhythm, fullness, the blood pressure, and respiration rate, depth, pattern at rest, body temperature, pain scoring, and before going to the airway examination, we have to examine our standard pickle, pallor, icterus, cyanosis, clubbing, lymphadenopathy. All these we have to examine and note. And the very important task for the anesthesiologist is airway examination. We should salute Dr. Mallampati Seshagiri Rao for giving us this Mallampati classification. He is an American settled doctor who was born in Andhra Pradesh. So he classified the airway in an easy manner. I will come to that later. We should see the interincisor gap. It should be more than 2 fingers. The thyromental distance more than 6.5. And we should see whether the patient is able to move the mandible forward, and range of cervical motion, flexion and extension. We should document loose or chipped teeth, and we should look for tracheal deviation. So if you are seeing this picture of the airway, we should ask the patient to sit and open the mouth with tongue protruded. So in the class 1, the soft palate, hard palate, the vivula, the pillars also are seen. This is class 1. This indicates or prognosticates easier intubation. And class 2, only the uvula can be seen. Here, class 3, uvula cannot be visualized. Class 4, only the hard palate can be seen. So when there is a Mallampati classification of class 4, we usually expect difficult intubation. So we will keep all the armamentarium ready. So these are all the various, see this patient, there is hypognathia. She will not be able to move the mandible forward. And here the mouth opening is very much restricted. This is post-born contracture. And in this obese patient, it's a typical difficult intubation. And in hydrocephalus, in this child, there is difficulty due to the large head. So these are the various difficult airway. Then we have to go for Classification of surgeries, risk as per their risk and procedure, minor, intermediate, and major. You all know what is this classification. Minor is brief, very low risk, very few complications, and intermediate might require overnight stay, moderate complication, major, prolonged surgeries, high degree of risk, and they involve major body organs procedures, greater risk for post-operative complications. So then comes the complete blood count, hemoglobin, CBP we will be doing, hemoglobin, WBC count, platelets, and so the hemoglobin, anemia, it hinders the wound healing, blood loss, it is essential for blood loss estimation, blood transfusion readiness also. And the platelets, when you have a thrombocytopenia, there will be oozing, and when there is increased platelets, you will have thrombotic complications. Platelets are very essential. If you have thrombocytopenia, you might have to withhold the neuroaxial blockade procedure. Then the serum creatinine and electrolytes, alteration, when it comes to electrolytes, alterations in serum sodium and serum potassium may be associated with medical and surgical disorders, drug intake, and have a potential to affect the anesthetic management and the outcomes. So, and coming to blood glucose, random blood sugars, fasting or postprandial, and HbA1c is a commonly advised test, especially when the patient has crossed 40 years of age. But NICE guidelines mention that there is no role of offering a HbA1c in patients without a diagnosed diabetes mellitus. So in patients with diagnosed diabetes mellitus, they should have the latest HbA1c or do it if not done in the last 3 months. And ECG. So what is the, usually we order ECG routinely. There is a very low prevalence of abnormal ECG in a young patient of less than 45 years of age. So, but there is usually a consensus among surgeons and anesthesia providers. We don't order routine ECGs in this population. For patients more than 45 years of age only, we will be ordering ECGs. So finding a significantly abnormal ECG in a patient with no history of cardiac disease is very rare. So in the absence of a known cardiac disease, the yield of preoperative ECG is very poor in predicting the perioperative complications. But so ECG should be reserved for patients with positive physical findings or limited to selected high-risk group of patients. And chest X-ray. A routine preoperative screening of chest X-ray is not indicated according to the international guidelines. Exposure to radiation, economic cost, low incidence of clinically significant findings leading to change in anesthetic management are the reasons cited for this. But in India, because of the high prevalence of tuberculosis, chest X-ray is generally done by surgeons and anesthesiologists as a part of preoperative screening. And coming to the coagulation studies, these are all indicated only if we counter any liver problems or if there is any problem with hemophilias or if we are suspecting any platelet deficiencies or DIC or something. So these are the preoperative diagnosis based investigations before elective surgery. So a complete blood count is indicated in all types of surgeries: major surgery, neonates, males more than 70, females more than 45, chronic renal, liver, lung disease, anemia, malignancy, poor nutritional states, vascular aneurysms, and serum creatinine and electrolytes only in kidney disease, hypertension, diabetes, poor nutritional states, stroke, and on if they are on medications like digoxin, diuretics, steroids, chemotherapy. And blood glucose only if they have diabetes, family history of diabetes, obese, stroke, steroids use, Cushing's or Addison's. And ECG for males more than 45, females more than 55, morbid obesity, thyroid disease, diabetes, chronic lung disease, hypertension, cardiac disease. And a chest X-ray for chronic lung disease, heavy smoker, radiation therapy, aortic aneurysm, cardiomegaly. And coagulation studies only when there is a liver disease or renal dysfunction or family history of bleeding disorder or on oral anticoagulant drugs. So, and the other investigations, pulmonary function tests, thyroid function tests, coagulation screening, and sickle cell screening as per the patient's associated comorbidities. So echo, we all will be is echo done or not? For every case, for most of the major cases, we will be asking for echo. But what are the indications for echo in a pre-anesthetic checkup? Documented ischemic heart disease with reduced functional capacity, less than 4 metabolic equivalents, or if there is an unexplained shortness of breath in the absence of clinical signs of heart failure, if the ECG or chest X-ray is abnormal, or there is a murmur in the presence of a cardiac or there are respiratory symptoms. Murmur in an asymptomatic individual in whom clinical features or other investigations suggest severe structural heart disease. But there is one thing called focus, that is focused cardiac ultrasound. This we call focused echo. In a suspected cardiac disease, this we can do it, the intensivist or anesthesiologist who is well versed with doing ultrasound, they can do this focus. A suspected cardiac disease, undifferentiated shock, hypotension, chest pain, dyspnea are ideal candidates for focus. In addition, any patient in whom the diagnosis of pericardial effusion or tamponade, pulmonary embolism, or left ventricular dysfunction is suspected, they will benefit from focus. So what are the factors to be considered when we assess the cardiac risk? These are patient-related factors: age, chronic disease like coronary artery disease, diabetes mellitus, hypertension, functional status as per NYHA classification, and medical history, if there are any implantable devices, previous surgeries, type of surgery, and urgency status, surgical duration, possibility of blood loss, fluid shifts, etc. And this is a cardiac risk estimation for non-cardiac surgeries. This is revised RCRI. This is called what are the components and the expected cardiac risk is high risk surgeries, points assigned are 1. Ischemic heart disease by any diagnostic criteria, 1 point. History of congestive heart failure, 1 point. History of cerebrovascular disease, 1 point. Diabetes mellitus requiring insulin also is a cardiac risk, 1 point. And creatinine more than 2 also carries 1 point. So the revised cardiac risk score, we score it as 0, 1, 2, and 3. If it is more than 3, there is risk of major cardiac events. So then, after all the investigations, labs, ECGs, echo if required, chest X-rays, and cardiac risk stratification, we should do the ASA physical status classification. So American Society of Anesthesiologists physical status classification. This is class 1 is no systemic disturbance, class 2 is moderate, and class 3 severe systemic disturbance. 4 extreme disturbance, that there is threat to life regardless of the type of treatment. Class 5 is emergency surgery that would otherwise be graded as 1 or 2. Class 6 is emergency surgery otherwise graded as 3 or 4. 7, it's added at a later date. Moribund patient expected to survive 24 hours, not expected to survive 24 hours with or without an operation. So, and we will be asking the patient whether he drug history. In the drug history, we will be asking him whether he is taking antiplatelet agents, aspirin, NSAIDs, all these things. When there is aspirin, the neuroaxial blockade can be performed. No additional precautions. It need not be stopped. And NSAIDs also, no additional precautions. When the patient is on clopidogrel only, we have to stop the drug for 5 to 7 days, and then only we have to do the procedure. Then in abciximab and dipyridamole, it is 24 to 48 hours. We have to be cautious, and then we have to perform the neuroaxial blockade. So we have to ask the history of antiplatelet usage of antiplatelet agents. And this slide I have put because usually we won't be advising the patient to stop smoking. Even though we advise them to stop smoking, they won't be listening to us. if we put this slide in our OP, maybe 1% or 2% can follow this, and it will be of utmost help to us during the procedure to prevent the perioperative complications. Duration of smoking cessation before surgery, 24 hours, significantly reduced carbon monoxide and nicotine levels, which improve the oxygen delivery, which is very essential during the general anesthesia administration. And if he stops 3 weeks, for 3 weeks, reduced wound complication rates, 6 to 8 weeks, improved respiratory function and reduced sputum volumes, 6 months, improved immune function. So these are the ISA guidelines. Till now, we are talking about the international guidelines, American Society of Anesthesia guidelines. These are the ISA guidelines, the preoperative investigations practice guidelines from Indian Society of Anesthesiologists. These were given in 2021. So all the greens are complete blood count for all the major, intermediate, minor and major surgeries, and 2 months. They are valid for 2 months. But the patient's general condition should not have changed. And renal function tests not required for minor cases, only for intermediate surgeries and major surgeries, and their validity is also for 2 months. And liver function tests not advised for minor or intermediate cases in case there are no associated liver problems in history, or they have some medical problems, associated liver disease. If they don't have that, you need not do the liver function tests. Only for major surgeries, liver function tests are advised, and their validity is also 2 months. A 12-lead ECG even for minor surgeries, if the patient is more than 45 years, we have to do that, and all the intermediate and major surgeries, we can do that. If the cardiac status of the patient remain unchanged, we can validate for 12 months. But in the history, if we have noted any change in his exercise tolerance or in dyspnea, anything, we can take a fresh ECG. And chest X-ray not indicated for minor, and for more than 50 years in case of intermediate and major surgeries, if they don't have any associated pulmonary or cardiac problems. And serum electrolytes and coagulation profile, they are indicated only when there are associated comorbidities. So ordering a routine investigations as a response to litigious environment, is the medical legal concern valid? These days we are very much concerned about medical legal issues. All the litigations are increasing. So even though the umbrella is expanding, there are still chances of litigations. So routine investigations are not always as harmless as they may be perceived. This slide I have specially put because we are increasing the number of investigations, and we are doing all the special investigations as routine, but they are not always as harmless as they may be perceived, because false positive preoperative test can lead the patient and physicians onto a non-specific path of unnecessary investigation. This not only increases the cost, but potentially exposes the patient to the risk of the test and can potentially delay the surgery. In addition to this inappropriateness of this test and the abnormal test can lead to the risk of litigation itself. The number of lawsuits related to healthcare is rising in India. There has been a 400% increase in the number of medical malpractice cases over the last few years in Supreme Court. Then after the lab investigations and all that history, physical examination, lab investigations, we have to think if there is any necessity for the medical referral. We have to refer to a cardiologist only when there is a cardiovascular disease of untreated or poorly controlled hypertension or heart failure, symptomatic ischemic heart disease, dysrhythmias, uncontrolled AF, paroxysmal supraventricular tachycardia, second and third degree heart block, or congenital heart disease, or symptomatic valvular heart disease. And in case of these respiratory problems, we have to refer to a pulmonologist only if the patient has a COPD and if he is dyspneic at rest or bronchiectasis, unstable asthmatics, taking oral steroids, or having a forced expiratory volume of only 60% of the predicted. And endocrine disorders, uncontrolled blood sugars, or is having ketonuria, or is in DKA, or hyperosmolar or non-ketotic coma, we have to refer to a endocrinologist for the optimization of the patient. And hypo or hyperthyroidism, which is uncontrolled, and in case of any Cushing's, Addison's disease, or hypopituitarism, we can take the help of an endocrinologist in optimizing the patient's condition. In case of a CRF or patients undergoing chronic dialysis, we can take the referral of a nephrologist, and we can plan the dialysis accordingly just 24 hours before the surgery, and post-operative renal care also. And a hematologist opinion can be taken when there are bleeding diathesis, therapeutic anticoagulation, hemoglobinopathies, polycythemia, hemolytic anemias, or leukemias. So last comes the informing the patient. We have to talk to the patient regarding the plan of anesthesia. It is our duty to inform the patient. The choice of the anesthetic technique rests with the anesthesiologist, but most of the patients appreciate some details of what to expect. So they want to know how long to start prior to surgery, how long they should not eat, how long they should not drink, all that. And we should be very clear in giving the orders, nil per oral orders. And patient will ask about their immediate recovery. They will ask whether I will be able to wake up immediately after the surgery, or I will be drowsy, and reassure the patients about the post-operative pain control. Please, we have to plan a very good post-operative pain management, and we have to reassure the patients, and we have to inform about the technique, what type of anesthesia we are going to administer, what are the various risks associated with it. And lastly, we should not forget to take the consent for anesthesia. Then I just put this slide. This is the slide. This is the thing. We have to inform the patient antihypertensive medications continue on the day of surgery. Possibly, if they are undergoing any procedure with major fluid shifts on, or they have medical conditions in which hypotension is particularly dangerous, it may be prudent to discontinue the ACEs or ARBs before the surgery. And cardiac medications, beta blockers, digoxins continue on the day of surgery. And to continue on the day of surgery, antidepressants, anxiolytics, and other psychiatric medications and thyroid medications continue on the day of surgery. And eye drops to continue on the day of surgery. Heartburn or reflex medications to continue. Narcotics to continue. Anticonvulsants also should be continued. Asthma drugs, steroids also should be continued. And aspirin, consider selectively continuing aspirin in patients where the risks of cardiac events is felt to exceed the risk of major bleeding. So this, we should congratulate our Indian team of scientists, ISRO scientists, for successfully landing the Chandrayaan. And they are like our anesthesiologists also think in the same way as our ISRO scientists to make minimal investigations and to make a precise, safe landing. Thank you very much.
Thank you, Alla Prashanti ma'am. Now I request Allu Padmaja ma'am to moderate the session. Allu Padmaja ma'am.
Madam Prasanthi madam, that was an elaborate, very well explained preoperative evaluation, which is very much useful, as we are perioperative physicians, we know how much it affects the outcomes since before surgery, during and after surgery. And she has given all the guidelines. So this was a wonderful and the opportunity given to me to moderate this session. I thank Dr. Hemlata Madam, Dr. Sumana Gopichand.
Thank you, ma'am.
Hemlata Madam and Durga Rani Madam have taken even pains to organize this wonderful session. This was more unexpectedly. I didn't expect so much. From 8 o'clock, I've been there. It is being conducted smoothly, except that a little bit of lag of half an hour I find. Dr. Ravikrishnan sir, thank you, sir, for bringing about this Women Evecon conference. And this was a wonderful session, sir. Thank you, madam.
Thank you, ma'am. Thank you, Padmaja, ma'am. I thank all the organizers and I thank Dr. Ravikrishnan sir for giving me this opportunity. I appreciate my heartfelt congratulations to our women leaders, Dr. Ramani madam, Dr. Durga Rani madam and Dr. Hemlata madam and all the team who are working since morning, not since morning, since past 2 weeks. Tremendous efforts, more than 2000 registrations.
Yes.
Now also the total live viewers are 1125 visible on the screen. Thank you so much for giving me this opportunity. Thank you, Padmaja ma'am, for being my moderator. Did I exceed the time limit, madam?
Thank you. Madam,
did I exceed the time limit?
Yeah. You're
Okay, thank you. Because it was not visible on my screen, I was like rushing. Thank you so much. This is a wonderful experience for me. Thank you.
Thank you.
Thank you so much, Ala Prashanti ma'am. Thank you so much, ma'am, as well as Alu Padmaja ma'am also for moderating the session. So for the next session, I would like to introduce the moderator, Dr. Nagamani ma'am. Nagamani ma'am, education, she had and DGO, NTR UHS in 1990. Presently, ma'am is working as senior consultant gynecologist and surgeon running 50-bedded ENT super specialty hospital. So interested hobbies are Kalaradhana, co-founder, president of cultural organization, Madhumani Charitable Society Service, activities in health, education, arts, sports, and personal. Been working as Vice President Foxy Karnul since 2023, Founder President Mission Pink Health, IMN Nandyal, and ma'am's spouse is Dr. C. Madhusudan Rao, ENT specialist, and her children are C. Manideep, MS ENT, C. Madhupriti, MD Dermatology. Now with this, I would welcome Dr. Nagamani ma'am, and ma'am is a founder of Mission Pink Health, Nandyal chairperson. The next speaker for the session is Dr. Padmalata ma'am.
Yeah. Can I start?
Ma'am, Dr. Nagamani ma'am, I request to introduce Dr. Padmalata ma'am. I had shared the screen. 1 minute, ma'am. Yes, ma'am. Can just introduce Dr. Padmalata ma'am, Nagamani ma'am to introduce Padmalata ma'am. Or else I will introduce the ma'am. Okay.
Nagamani madam.
Hi ma'am, this is Dr. Padmalata here.
Yeah,
Nice
madam
meeting
వస్తున్నారు
you all.
లైన్ లోకి. మేడం అన్మ్యూట్ చేసుకుంటున్నారు.
Parvaleen madam, go ahead. Already my introduction was done. Please go ahead.
Yes,
with
ma'am.
your
No,
program.
ma'am. I'm requesting you to introduce Padmalata ma'am.
No, ma'am, It's
Shall I
already, we are running late. I'm Dr. Padmalata, respiratory physician.
Yes.
My graduation is from Rangana Medical College and my
No, no,
PG
no,
diploma
ma'am.
is from
Ma'am,
Andhra Medical College.
This is gynecologist topic.
Madam,
yes.
continue the topic, madam.
Yeah, I'll continue.
Yes.
No
Yeah,
problem.
ma'am.
Please, madam.
Yeah.
Let us save time. Already my introduction is over. Thank you.
Okay, 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 ma'am. Dr. Padmalata Yarasi, ma'am, is a renowned obstetrician, gynecologist, and fertility specialist. She has received her graduation from KMC and post-graduation for Kasturba Medical College, Manipal. She has trained in infertility in Kiel University, Germany, Warwick and Homerton Universities, London. She has graduated in Advanced Management Program in Healthcare from Indian School of Business. She is a person gifted with specialized skills, both clinically and surgically, and a highly qualified professional with 22 years of experience. She is known for her dedicated patient care. She is now running successfully Padma Test Tube Baby Center and heading the team Matrutva Fertility Centers, president of AP State AP Chapter ISAR, and also a president of APOG in Prodhutur. So the topic for the session is present lifestyle impact on fertility, how to overcome.
Nagamani madam.
Now I request Padmalata ma'am to go ahead, ma'am. Welcome, Padmalata ma'am.
Madam, please unmute, ma'am. Padma, ma'am.
Madam, I'm confused. Which Padmalata is a speaker or a child moderator?
Yeah.
Padmalata ma'am, speaker ma'am. Speaker Padmalata ma'am, gynecology.
Okay.
From Prodhutur. Yes, ma'am.
Yeah. Are you able to see my screen?
Yes. Yes, Padmalata.
Good afternoon, everyone. I thank organizers for giving me this opportunity, and my special thanks to Dr. Ravi Krishna sir for giving me this opportunity, and my special thanks to Dr. Vasudha who gave me this opportunity, because I told her I couldn't attend this conference because of my busy schedule with my new project, but she insisted me to participate in the conference, and I'm very happy to be part of this conference since morning. I have attended all the lectures since the morning, and usually I was very much impressed with the panel discussion on breast lump. Usually most of the females comes to the gynecologist only in the first visit for the breast lumps, because I feel that is a big gray area for the gynecologist. At least today I got to know something, what to do and what not to do if the patient comes with the breast lump. Yeah. My topic,
Padma, ma'am.
topic for my presentation is present lifestyle impact on fertility, how to overcome.
Ma'am, excuse me, ma'am. I request you to please share the screen, ma'am. PPT screen.
Yeah, I did.
But it's not visible, ma'am. It's not seen.
Can you help me how to do?
Yes, ma'am. In the bottom, you will be seeing share screen. Before that, you can just open your PPT you are presenting. After opening the PPT, you can just click on the share screen.
After opening the PPT, I'm not able to see that thing, that share screen.
Otherwise, you do one thing, ma'am. You just click on the share screen. You will get share button. Once you share it, you can just select the PPT you are sharing.
Yeah.
Yes, ma'am. Yes, ma'am. Yes, ma'am.
Yes. Yes.
Yes, ma'am. Title. Yes, ma'am. Yes. Yes. Thank you, ma'am. Thank you.
Yeah. Today's topic for my presentation is present lifestyle impact on fertility, how to overcome. What are the lifestyle factors and how they affect the fertility? The lifestyle factors are amendable habits and ways of life that can greatly influence overall health and well-being. It also includes the fertility also. What are the major lifestyle factors that impact on the fertility are age, BMI, nutrition, occupation, smoking, alcohol, recreational drugs, caffeine, sports, psychological stress and oxidative stress. If you see the diagram, apart from the things which I have mentioned in the flow chart, those are important. Other important things are physical activities, mainly sedentary or excessive exercises, anxiety and depression, mobile phones, drug abuse, etc. What is fertility? We all know that capability of producing offspring is called as fertility. The entire opposite thing is infertility. What is infertility? Infertility is failure to conceive after 12 months of unprotected intercourse is called as infertility. Usually 1 in 7 couples all over the world is affected with the infertility. 85% of the couple by the end of the first year will become pregnant. 15% half of the remaining people will become pregnant by end of the second year. So finally 7% people only becoming infertile by end of the second year. If you see in the lifestyle factors, age is the most important, and age affects both males and females, but the most significant impact on the reproduction is maternal age. Coming to the maternal age, woman born with all egg cells she will ever have. That means the baby girl born at the time of the birth, she has maximum number of oocytes in the ovary. They reduce in number and quality over the years. By the time she gets 10 years, her fertility, 35 years, her fertility is declined. Incidence of genetic abnormalities, spontaneous abortions are increased along with the maternal age. The rate of pregnancies are decreased with the increased maternal age. Coming to the advanced paternal age, the assumption that men can reproduce into advanced age is totally untrue. After 35 years, the reproductive potential of men drops sharply as DNA in the sperm nucleus fragments. The increased paternal age adversely affects testicular function, sex hormones, sperm quality, sperm DNA fragmentation, telomere length, and epigenetic factors. Paternal age has been linked with autism, schizophrenia, bipolar disorders, and achondroplasia of the newborns. It also affects, these effects are characterized mainly by the de novo point mutation and not the chromosomal aneuploidy. Epigenetics and DNA fragmentation changes along with the paternal age. The paternal age effects on offspring are single gene mutation, sex chromosome anomaly, miscarriage, preterm birth, fetal death, and birth defects. Coming to the BMI. According to the WHO definition, BMI more than or equal to 18.5 is normal weight BMI. If BMI is more than 25, we used to call as overweight. BMI more than 30, we used to call it as obesity. We all know BMI calculations, weight in kgs by height in meter space. If you see, obesity causes by long-term positive energy balance. If you see the energy intake, if the energy intake is more, it converted into fat stores, and from the fat stores, the energy expenditure will come. This is the one rule. And another, the energy intake will go to the energy expenditure. If the fat stores are one second, please. If the fat stores are increased by 2%, there is 2.3 kg per year weight gain. What are the types of obesity? We used to see two types of obesity. One is android variety and one is gynoid variety. In the android variety, excessive fat on the abdomen, we used to see the abdomen fat accumulation in the abdomen. It is more common in men, and there is significant correlation with metabolic syndrome in case of android obesity. Coming to the gynoid obesity, excessive fat on the thighs and buttocks, common in men, and not significant correlation with the metabolic syndrome. What are the medical complications of obesity? Obesity will affect each and every part of the body. Each and every organ will be affected by the obesity. If you see this diagram, obesity and health risk, if you see, almost all the organs are affected. Diabetes, hypertension, depression, heart disease, every part of the body will be affected by the obesity. Coming to the factors responsible for the obesity. The first and foremost important thing is changes in the lifestyle, that is urbanization. In the last 2 decades, there is tremendous increase the population movement from the rural area to the urban area. So it has led to the unhealthy eating patterns, wrong choices of food, increased portions also they are taking instead of taking wrong choices of food. There is increased oil consumption, snacks and cola, etc. also very frequently children are taking. Coming to the sedentary pursuits, long school hours. After the school hours, again children are forced to go to the tuition, and because of the long sitting hours, there is an increased chance of obesity in the childhood also. Coming to the other factors which are responsible for the obesity are high glycemic index of food, genetic or constitutional predisposition, early life origins programmed to accumulate fat. That means if the mother is having any gestational diabetes or anything, usually the obesity will start in the pregnancy time only. The silent genes unmasked and thrifty genotype is very important. Gestational diabetes is also very important in case of obesity. The insulin resistance and obesity aggravates each other. If you see, the obesity causes pre-inflammatory cytokines release. This pre-inflammatory cytokines causes increased insulin resistance. This causes hyperinsulinemia. And this, because of this hyperinsulinemia, there is unutilized glucose, which goes into the fat deposition in adipose tissue and leads to the obesity. Coming to the obesity and male infertility. Obesity will cause both physical disorders, genetic disorders, and hormonal disorders. All three disorders put together will produce erectile dysfunction and altered semen parameters. Because of the altered semen parameters, the infertility is common in males. Again, if you see the obesity and diabetes, the environmental factors and genetic factors and lifestyle changes causes the obesity and diabetes. All this leads to hyperestrogenemia. Because of this hyperestrogenemia, there is suppressed HPG axis and altered spermatogenesis. All this lead to the infertility. Coming to the female infertility, because of environmental factors and lifestyle changes, obesity increases. Because of this obesity, there is hyperestrogenemia. This causes chronic anovulation, and it also causes decreased progesterone levels, which is the important cause for the luteal phase defect also. How will you manage the obesity? There are lifestyle modifications are very, very important. Dietary changes should be there. Low fat and high carbohydrate should be avoided. Fixed energy deficit diet should be taken. Meal replacement should be taken with protein supplements like that. Very low calorie diet should be preferred. High protein and low carbohydrate diets are preferable in the case of to manage the obesity. Managing obesity with exercise also is very important. And managing the obesity with anti-obesity drugs also, it's like trending nowadays. But all these informations are not a replacement for a medical advice. In the obese management, please consult your doctor for precise medical solution. Coming to the nutrition. Nutrition is divided into the two types, that nutritional problems in the developing countries and nutritional problems in the developed countries are entirely different. In the developing countries, there are deprivation, undernutrition, and malnutrition. In case of developed countries, eating disorders are main, that is bulimia nervosa and anorexia nervosa, and obesity also one of the reasons. According to the Giachi et al. In 2016 study, they said that the preponderance of cheap, high-calorie diet but nutrient-poor foods of the last 4 decades have contributed to the high prevalence of obesity all over the world. In the females, ovarian activity is suppressed with eating disorders and exercise-induced amenorrhea. The combined prevalence of bulimia nervosa and anorexia nervosa is 5% among the women of reproductive age group. In case of bulimia nervosa, the main features are binge eating, followed by the fasting and self-induced vomiting. This is the emotional disorder, distorted body image, and obsessive desire to lose weight. Coming to the anorexia nervosa, more of physical, psychological disorder, extreme self-starvation due to distorted body image. In the male, the nutrition directly affects the sperm. Direct association between the nutrition and food sperm quality. High-fat diets inhibit the reproduction by affecting the physical and molecular structure of the not only sperm cells, but also the developing fetus and offspring, according to Rato et al. In 2014. The testicular metabolism can be affected by intake of high-energy fats and in people with obesity. The reproductive health can be enhanced by modification of dietary intake such as fruits, vegetables, legumes, and fish. The regular intake of these foods associated with the better sperm quality and lower DNA fragmentation index that subjects who do not take these foods. Regular intake of red meat was inversely associated with the sperm quality. The increased production of estrogen by the fat cells and primary sex organs that occur in a state of high body fat is interrupted as a birth control by the body, because in the obesity people, the fat cells, mainly the main estrogen production is by the fat cells and it acts as a contraception, hence limiting the chances of conception. The infertile women are therefore counseled to maintain healthy eating habits to avoid the accumulation of body fats which may impair ovulation, according to Moon X et al. At 2016. What is the fertility diet? If you see, the food with antioxidant properties are very important when the couple is planning for the family. We should advise the cheese, oranges, sunflower seeds, fish, broccoli, and beans. Coming to the occupation, men at work exposed to pesticides, heavy metals, heat are at risk. DNA damage in sperms and early pregnancy losses and genetic mutations are more common because of the occupational disorders. Men work at high temperature professions with long hours in seating position, tight underweight, and use of laptops on the lap for a long period of time mainly affect the sperm quality and concentration. Coming to the sports, genital injuries are more common during the sports. Testicular injuries should be treated without delay. They should take extreme care during sports in which testes are not properly protected, including martial arts, cycling, and horse riding. Coming to the mobile phones. Today, nowadays, from 1 year of age, everybody is using mobile phones. Even newborns are also using mobile phones. The radiation effect is very more, but although there is a significant debate in the scientific literature, the impact of mobile phone irradiation on male infertility, it is recommended to keep mobile away from the scrotum. Mobile phones has been suggested as a source of damaging irradiation of the male reproductive organs. Increased levels of DNA fragmentation has been reported in mobile users. These gadgets transmit or receive radio frequency electromagnetic waves that have adverse effects on the sperm motility, number, and morphology. High serum free testosterone and lower LH levels were reported in men using mobile when compared with non-mobile users. Coming to the smoking. How does smoking affect the sperm and semen quality? The smoking affects decreases the sperm concentration, decreases the sperm motility, fewer healthier shaped sperms, and increased DNA fragmentation. If you see the effects of the smoking on the sperm structure and proteins are affected. That means 9+2 axonium and acrosine are mainly affected. Oxidative stress increases because of this increased reactive oxygen species release. Semen parameters like concentration, viability, motility, and morphology all are decreased. Chromosomal abnormalities and seminal plasma and sex gland function has decreased. The sperm counts are 19% lower than non-smoker when you compare the smokers with non-smokers, and the sperm motility also decreased. There is abnormal morphology has increased in the semen sample of the smokers, and there is increased DNA mutations in the smokers. Usually, the cigarette smoke contains more than 7,000 chemicals. It includes highly carcinogenic tobacco-specific nitrosamine. Apart from that, nicotine, cadmium, lead, superoxide, and hydroxyl radicals adversely affect the reproductive health. The effect of smoking on sperm quality is more in heavy smokers and moderate smokers than in the mild smokers. In females, the smoking causes thickening of the zona pellucida, which makes the sperm penetration is very difficult. Smoking in women significantly decreases the chances of conception by disturbing the ovarian function and depleting its reserve. Harmful substances in cigarettes found in follicular microenvironment of the smokers. They alter the hormone levels in the luteal phase and affect the developing follicle, and it is responsible for the luteal phase defect also. Coming to the alcohol. Alcohol consumption decreases the fertility. We all know that alcohol is a teratogen. The influence of alcohol consumption on the quality of semen has dose effect and time effect relationship. That means since how many days they are taking the alcohol and how much quantity they are taking is mainly influence the sperm quality and other reproductive problems also. Chronic ingestion of the high concentration of alcohol may have adverse effects on sex hormones, testes, epididymis, ultimately fertility potential. Alcohol suppresses the synthesis of hormones at the levels of the hypothalamus, anterior pituitary, and gonads. Damage to the nervous system in men can result in sexual impotence and to loss of libido and erection. In females, Alcohol consumption resulted in the changes in ovulation and menstrual cycle irregularities. Chronic overconsumption of alcohol may lead to decline in the ovarian reserve and fertility potentials in women. FSH, AMH, and AFC lower in alcohol users. If she is pregnant, there may be a increased risk of abortion, low birth weight, and congenital anomalies in case of alcohol users. Coming to the recreational drugs. Cannabis are commonly referred to as marijuana is the most abused illicit drug globally, and it has predominantly male users. Usually the recreational drugs used by both males and females, but the females are mostly affected and most vulnerable for the effects of the recreational drugs. Marijuana smoking more than once a week causes lower sperm concentration and lower total sperm count. Coming to the cocaine, long-term users, that is more than 5 years of cocaine users, has decreased sperm concentration and motility, increased abnormal sperm morphology. Coming to the anabolic steroids, it causes hypogonadism, testicular atrophy, transient azoospermia, loss of libido, erectile dysfunction. Coming to the caffeine, Belloc et al. Found that nearly 76% of the caffeine consumers had a slight increase in the semen volume. If they are taking 3 plus or minus 1.8 cups of the coffee per day, there is a slight increase in the semen volume. Clinical pregnancy and live birth per ART cycle, particularly in men, consuming more than 272 milligrams of caffeine per day or less. So in the small quantity of the caffeine, it increases the semen volume. Coming to the soft drinks. Soft drinks causes 20% increase in the infertility. If you see that if the persons are taking more than 1 liter per day during the past 1 week, the reduced sperm count we can observe in the semen sample. If they are taking more than two soft drinks in a day, the ovulatory dysfunction will occur in the females. Coming to the physical exercise. Physical exercise is beneficial to overcome the weight or obese overweight or obese infertile women. Physical exercise combined with weight loss was associated with the improved fertility among obese women. You have to remember that physical exercise is very important in case of obese women with fertility. In a healthy BMI range, vigorous exercise was inversely associated with the fertility potential. In the obese patient, it is directly associated with the fertility. Here, it is inversely proportional with the fertility potentials. Women who engage in vigorous exercise may be at risk of infertility due to anovulation and implantation defect. In males, regular exercise is recommended and may improve fertility potential among infertile subjects. Vigorous physical exercise might expose individuals to an increased risk of poor reproductive function. Coming to the stress. Psychological stress inhibits sympathetic nervous system, and in the HPA axis inhibits the HPG axis, and it also acts on the testes and it inhibits the LH cells and the production of the testosterone. Gonadotropin inhibiting hormone inhibits the spermatogenesis by lowering the levels of testosterone. The corticotropin releasing hormone in the females inhibits the GnRH secretion, and glucocorticoids inhibits the pituitary LH, ovarian estrogen and progesterone secretion in the females, and it also causes hypothalamic amenorrhea in females. What causes reactive oxygen species? Obesity, infections, environmental hazards, unhealthy lifestyle, and immature and abnormal spermatozoa are responsible for the ROS. What are the environmental factors that are responsible for the reduced fertility? Air, water, soil, climate, and plastics. Coming to the air pollution, FIGO identifies the strong link between air pollution and fertility, altered production of sperm and eggs because of the air pollution. Epigenetic changes and birth defects are also more common if the air is polluted, and there is prematurity. You have to reduce the toxic chemicals in your home and body to prevent the pollutions. Coming to the contraception, because of their education or career, many people are postponing their pregnancies and family. So all those people many people are using contraception today nowadays in couple. So my sincere advice for those couple who wanted to postpone their pregnancy or family because of the career or education, better not to postpone the family. You have to finish the family as early as possible. So we have to avoid the contraception in case if you want to need any barrier methods or anything they can use, but not for the long time. Coming to the conclusion, most life factors are modifiable habits that can be reversed. If the person is having strong determination by the affected subjects. Public enlightenment by the healthcare providers is very, very important. Counseling of infertile couple regarding lifestyle behaviors is very important. Educational and career pursuits should be combined with the childbearing. Public health awareness on harmful effects of the drug and substances abuse should be intensified. Regular intake of foods rich in fruits and vegetables, legumes, fish and green vegetables should be encouraged. Thank you so much for your patience hearing. Thank you very much.
Thank you so much, Padmalata madam.
Am I audible? I'm Dr. Nagamani.
Yeah, ma'am.
Nice session, Padmalata.
Thank you, ma'am.
Elaborately described, and it's a very dry topic, and you made it interesting. Thank you.
Thank you, ma'am.
Thank you so much, Padmalata madam. Thank you so much, Nagamani madam. It was a nice discussion of the topic, and Nagamani madam, thank you so much for moderating the session. Now we hand over the next proceedings to Dr. IMA Mission Pink Health Chairperson.
And Dr. Sauzanya, Secretary, IMA. Thank you, Madam Padmalata madam.
Thank you.
Hello.
Nagamani madam.
Yes, I'm.
Thank you, madam. Thank you.
Okay. Okay, madam.
Okay. Durgarani madam, you can please unmute and continue the session, madam. Madam, you have to unmute, madam. Durgarani madam. Yours is still muted.
Durgarani ma'am.
Durgarani ma'am, you have to unmute.
Am I audible?
Yeah, madam. Saujanya madam, you are audible, madam.
Yes, sir.
Hello, am I audible? Pratyusha?
Yes, ma'am. Yes.
Okay. Dr. Vijaya, madam?
Yes, I am there.
I am there, ma'am. I request, I am Dr. Durgarani, Chairperson Mission Pink, and Dr. Saujanya, Secretary Mission Pink AP. I request Saujanya to introduce our Chairperson, Dr. Vijaya Garu, DM Neurology. Saujanya, over to you.
Good afternoon, everyone.
Madam, sorry, madam. As we are running late, we can skip the introduction. You can just say neurologist from Guntur.
Dr. P. Vijaya from Lalita Hospitals, Guntur, EC member, Indian Stroke Association, President AP Neuroscientists Association. She is a fellow of World Stroke Organization and director, Ankinidu Stroke Center. She did her PG and UG from Chandigarh.
Madam,
over to you.
Speaker.
Yes.
Thank you, madam. Thank you.
Vengamma, madam.
Yeah, now I think it's my pleasure.
Madam, are you there?
I am here, madam. I am here. Can you see me?
Yeah.
I can see all of you.
Okay.
Okay. Good afternoon, everyone. Thanks for making me a part of this nice session. I enjoyed the previous lecture. So, madam, stroke, which is always important for. Madam was here. She was here when I messaged her.
Yeah, I told, but she's there. She's not responding. Vengamma, madam, are you there?
In fact, I was chatting with her, and she's there. After this, she knows that her talk is after this. Maybe she's
she told that she's online, but she's not responding.
Madam, మీరు లోపల call చేయండి. I'll keep talking about stroke. Okay. Is this about women and stroke, or is it general topics, madam? What is it that you expect? Is this about women's health, this whole session?
It is early recognition of stroke, madam.
No, I understand that. Is this relevant to women, or it is a general topics only, all this symposium?
It is general topic.
It is a general topic. Stroke.
Okay.
Vengamma madam, where is she?
Meer call cheyanడి Vengamma garu. She is there. She was here. Adugo madam is there. Good afternoon, madam. Dr. Vengamma madam.
Good afternoon. Sorry, there was, I think here it is heavily raining.
Okay, okay.
That's why that the internet was little. Actually, I wasn't suddenly before I started it. Okay, should I start sharing the screen?
Madam, 1 minute, 1 minute. Dr. P. Vengamagaru, it's my privilege to introduce today's speaker, Dr. B. Vengamagaru, qualification DM Neurology, NIMHANS, Bangalore, FRCP, FAMS, FSCP, FAN, PGD, and President, Indian Epilepsy Association, and she is former Director cum Vice Chancellor, Professor, Department of Neurology, Sri Venkateswara Institute of Medical Sciences, and publications. There are more than 10 publications in reputed index journals. She is Associate Editor of Annals of Indian Academy of Neurology, and areas of specialization are epilepsy, stroke, clinical neurophysiology. Achievements: Harish Chandra Bojra Award for Social Activities in Epilepsy in 2004. AASM Mini Fellowship Program for International Scholars by American Academy of Sleep Medicine, and Vikruti Ugadi Visishta Purushkaram in 2010 for exemplary services in the field of healthcare services, and Spirit of Humanity Award in 2012. Founder and Honorary Editor-in-Chief of the Journal of Clinical and Scientific Research since 2012. And this is a wonderful program, madam. You are organizing monthly free epilepsy camp uninterrupted since February 1999 for the last 25 years. I think you are more suited for this program. Madam, please welcome.
Thank you. I think you should unshare so that I can screen your screen should be.
Yeah.
Is my screen visible? Am I audible and visible, Vijaya?
Yeah, madam. Yes. First slide came.
Yes, madam.
Okay. Anyway, I'm very happy to be part of this Evecon online CME, which is being organized by IMA, and very happy that the person who is the stroke specialist in amongst us, among the India, one of the stroke specialists, Dr. Vijaya, being the moderator for this session. The topic given to me was, it's not moving. I think when I put onto the slides, topic given to me was early recognition of stroke. Yeah. What is stroke? Stroke is called brain attack, occurs when the blood flow to the brain disrupted. It is two types, ischemic and hemorrhagic. When there is a blood flow is disruption to the blood flow, either by blood clot blocks one's vital vessels, it is ischemic stroke. When it is blood vessel ruptures, it is a hemorrhagic stroke. In a simplified form, when there is a block occurs to the blood vessels, there is an ischemic area, and then if there is a bleeding, it is called hemorrhagic. And basically, there is another why early recognition is important is to recognize transient ischemic attacks or mini strokes, which is otherwise called mini stroke or warning stroke, where the stroke symptoms resolve within 24 hours. And stroke basically defined as the rapidly developing clinical signs of focal or at times global disturbance of cerebral function lasting more than 24 hours or leading to death with no apparent cause other than vascular origin. It's a global health problem. It is commonest cause of disability, second common cause of dementia, third common cause of disability worldwide. Globally, the incidence is 13.7 million and prevalence is almost 80 million respectively. In India, urban population is slightly more compared to the rural population. And stroke, women and stroke, because it is being the more women than men die from the stroke. Women over the age of 30 who smoke and take higher estrogen oral contraceptives have stroke risk of 20 times higher than the average. And if you take compared to the other breast cancer, the stroke kills more than twice as many as women as year as breast cancer, almost double the number compared to the breast cancer. The stroke kills especially in women. And women and stroke, mainly the lifetime risk in women is 1 in 5 compared to 1 in 6 in men. and women have a higher stroke mortality than men. 6 in 10 strokes cause death in women largely due to stroke. And stroke is largely preventable, basically lifestyle management. Yet to beat the stroke, women need sex-specific information on their risk and preventive practices. In this woman, the risk of stroke goes high because of pregnancy and eclampsia, birth control pills, hormone replacement, migraine is very common, and atrial fibrillation. If you take the numbers, about 55,000 women, more women than men, have a stroke each year. Stroke is the third cause of death in women, contrast fourth cause of death in men. The number of stroke deaths in 1 year in women, it is definitely more, almost 77,000 compared to men. It is 52,000. Alarming. People have a misconception that stroke in women is very less, but in contrast, the mortality is very high. Like to say that there is 1 in 6 people experience stroke in their lifetime, 16 million people in a year experience stroke. Someone dies of a stroke in every 6 seconds. Stroke can occur at any age, any time, and any of those occur in people with low or to medium risk having a stroke. And basically, to again highlight, especially in the last decade, there is a 25% increase in number of strokes each year, number of deaths from stroke, and there is a number of incidents of hemorrhagic stroke also are very high. Why early recognition is required, but people come very late because there is reasons for not accessing or not coming for treatment. Majority reason don't recognize the symptom, there is denial, they're thinking nothing can be done. Symptoms, people think the symptom will disappear and fear of hospitals. And there are many myths. The stroke is not preventable, definitely preventable. People think that the stroke cannot be treated. It can be treated if detected early. And people think that the stroke can strike only elderly, but any age can have a stroke. Sometimes it is stroke is thing they happen in the heart, but it is actually the brain. That's why now the term brain attack and concept of that is being highlighted. Stroke recovery ends after 6 months, but stroke recovery can last for a lifetime. Parsis are more susceptible, but anybody can. Stroke do not recur, but stroke can recur more than once. Second attack can be life-threatening. Usually they think, like I mentioned, that women usually do not get a stroke, but women can suffer a stroke. Same reason as the men and reproductive age. Stroke lead to permanent condition, but in most cases curable if treated within 4.5 hours of onset. There are a lot of myths we have to clear. And basically that there are 2 types of ischemic stroke, which accounts for almost 84%, and out of which thrombosis is 51% and embolism is 31%, and thrombosis, large vessel occlusion is 30% and small vessel disease is 20%. Hemorrhagic around 16%, majority is intracerebral followed by subarachnoid hemorrhage. This is to highlight same thing, the ischemic stroke is common, it is thrombotic, embolic and systemic hypoperfusion. And hemorrhagic stroke predominantly intracerebral followed by subarachnoid. This is the mechanism, like to explain that could be because of occlusion by thrombus or embolus, which causes infarction 85%, rupture of vessel which can cause hemorrhage. In addition to these 2 causes, there could be some disturbances in the normal properties of the body that could be responsible, like polycythemia, hematological disturbance. They can cause either it is a venous thrombosis or arterial thrombosis, or sometimes hemorrhagic changes also can occur. Basically, stroke subtypes differ by age, race, and vascular factors. Prognosis depends because you have to differentiate whether it's ischemic or hemorrhagic, because the prognosis, mortality, and stroke recurrences are different, and treatment implications also different because treatment for both things are entirely different. Like to show the examples, there's an intracerebral hematoma, there's a subarachnoid hemorrhage, atherosclerotic thrombosis. There is a source from the heart, it is a cardioembolic. The small lesion could be a lacunar among the ischemic strokes. This is a summary of classification of stroke. Ischemic, you have a large artery thrombosis, small artery penetrating thrombosis like a lacunar stroke 20%, cardiogenic, cryptogenic or others. Now they call stroke of other determined etiology and stroke of undetermined etiology. Among the hemorrhagic stroke, it is subarachnoid hemorrhage and intracerebral hemorrhage. Basically, what happens when there is a, suppose it could have a three mechanisms. Once there is an occlusion, there could be early clot lysis of this thrombus or embolus. Then there could be recovery of entire symptom. This is called early clot lysis. The symptoms could recover, and this is called TIA. Or this clot, whichever blocks, could propagate further and then cause a distal occlusion. Migration of embolus can cause a branch occlusion, or it can remain there and then can subsequently cause a late clot lysis. There is a large hemorrhage. That's why the mechanism of the pathogenesis will differentiate, will have a different clinical manifestation. Why it is important? The threshold is most important is the average blood flow. Normal cerebral blood flow is 75 ml per 100 grams. But when it falls less than 20 ml per 100 gram per minute, that is the critical threshold below which you have a certain changes of the cerebral metabolism and then the cerebral ischemia. This again shows when it is less than 20, you start getting electrocortical function, failure, ion pump failure, and cell death. This is called the tissue at risk. That's why you have to maintain the perfusion at least minimum of 20. And again, the duration also is important. More the duration, again, there is a irreversible changes can occur, and comorbid factors like diabetes, hypertension can aggravate. Most important, when it is less than 650 to 20 ml, you get acidosis, reversible and irreversible brain injury. That's why the concept of penumbra and the treatment of early detection is definitely helpful. The ischemic but not yet infarcted portion, that is P, that is a penumbra, is the not yet infarct, is called penumbra. Current therapy of acute stroke is focused on determining the extent of size of reversible ischemia, improving it by re-establishing the blood flow. In the last decades, the good thing is imaging technology has been introduced that allows the physician to make physiological distinction among the normal ischemic and infarcted tissues, and salvageable brain tissue in the acute phase of stroke can be delineated by these methods. This approach to stroke guides the next generation that has already put back in the direction of the research. Basically, to re-emphasize that whatever intervention we should do is at the stage of penumbra that surrounds the infarct, but that has passed under upper threshold of electrical signs, capacity to recover if perfusion is restored. That's why now we can detect this. Quantitative assessment of penumbra can be done by PET scan, MR imaging, and vision imaging. Why one should be very fast in recognizing? Most important, you have to recognize signs and act quickly, because the difference between life and death or difference between full recovery and lasting disability. That is, these are the two only outcomes if you don't recognize early. Because every minute, 2 million brain cells die every minute. The more delay, the more brain cells die, the lasting. And 15 million synapses die every minute. That's why be fast in ischemic stroke. I will explain again what is meant by be fast. The mnemonic stands for it. But for the earlier intervention, stroke is time is brain. I think these are the three words you should remember: brain attack, stroke, time is brain, and be fast. This is again to show that as the minutes and hours goes, the area of ischemic penumbra will become infarct like a black structure. The transition depends on both the severity and duration of the definition of the. What is the ideal time stroke patient should reach the hospital? The earlier is better. The ideal is within first 4.5 hours. The glassbuster injection helps to clearing the heart clot and helps in near normal recovery, which patient can sometimes permanent disability. Coming to the risk factors, most of you are aware, non-modifiable like age, gender, ethnicity, family history, and genetic factors. Modifiable risk factors discussed the previous topics like hypertension, diabetes, cardioembolic source, hyperlipidemia, obesity, hyperhomocystinuria, tobacco use, alcohol, and most important recently added is the all these things you should look for it. There are many causes. Again, it depends upon the age of this one. It could occur in prenatal hypoxic ischemic injury. In infancy, it could be mitochondrial disorders or moya disease or a bacterial endocarditis. In an adolescence, the causes are different, like vasculitis, vascular malformation, sickle cell anemia. In middle age, it is a cardioembolic stroke and fibromuscular. In late life, it is an embolic disease, brain hemorrhage. Depending upon the age, the causes could be different. The effects of stroke vary from person to person based on the severity and location, because brain is a complex structure. Each area of the brain is responsible for specific function and ability. When the area of the brain is damaged, which typically occurs with the stroke, an impairment may result. Sometimes impairment may result in disability or inability to perform act in a normal way. Specific treatment of stroke will be determined by patient's age, overall health, medical history, and associated comorbidities, severity of the stroke, location of the stroke, cause of the stroke, and patient tolerance for specific medication procedures and type of the stroke. Analysis first and foremost, there are 4 steps. First step is clinician must determine whether the event is a stroke rather than some other process that may have similar sudden onset, migraine, seizure, syncope can mimic stroke. After second, if the event is likely to be stroke or a TIA, then pathophysiology must be ascertained whether it is an embolism from a heart or a proximal artery, or it is a large vessel atherosclerotic occlusion or a vein. Third, then have to start an acute treatment if the tissue plasminogen activator or endovascular thrombectomy is initiated if appropriate. And fourth, again, a plan for prevention of future stroke is undertaken. Clinical assessment directs the diagnostic workup, deciding which laboratory tests are essential. Therapeutic decisions are based on neurological deficits, not purely on imaging techniques. Clinical assessment is the currently best guide for the defining prognosis, because high technology MRIs sometimes help you, but it may not be available in many centers. Clinical decision is based on the clinical decision. The most important differentiation from other neurological diseases, the diagnosis of vascular lesion rests essentially on the recognition of the stroke syndrome. Without evidence of this, the diagnosis must be in doubt. The 3 criteria you should remember. One is a rapid temporal profile of the clinical syndrome, evidence of focal brain disease, mainly in the vascular territory. Third, the clinical setting by which mean potential causes of embolic or other types of stroke, such as atrial fibrillation. The definition of temporal profile requires a clear history of premonitory phenomena, mode of onset, evolution of neurological disturbance in relation to the patient's medical status. And most important, what we have seen is inadequate history is the most frequent cause of the diagnostic. Stroke-like onset of cerebral symptom in young adults sometimes raises suspicion of demyelinating. Stroke developing over a period of several days usually progress in a stepwise fashion, increments of deficits being added abruptly from time to time. That stepwise progression could be seen. But a slow, gradual downhill course over a period of 2 weeks or more indicates that lesion is probably not vascular, but rather neoplastic demyelinating infection. That's why the history temporal profile of illness is definitely important. That's this demyelinating diseases, abscess, granulomatous, subdural hematomas sometimes can mimic stroke. There are, well, like to take etiology, stroke mimics, you remember that 9S, that is seizure, syncope, infection, sepsis, tumor, space occupying lesion, metabolic hypernatremia, hypoglycemia, hyperglycemia, migraine, alcohol, substance misuse, functional subfill. These are all the 9 at least stroke mimics. 9, yes, can remember. They can mimic. Before you make a diagnosis of stroke, please see that you are not missing, excluding these stroke. Role of clinical examination is very essential. They should look for focal features. Neurological deficits usually reflects location and size of the infarct. Hemiplegia stands as the most typical sign of the stroke, whether the cerebral hemisphere or brainstem, but there are other manifestations for recognizable combination. Most important is they can have a sensory deficit, aphasia, diplopia, dizziness. The neurovascular syndrome enables the physician to localize lesion on a clinical ground, sometimes so precisely that even the affected arterial branch can be specified and to indicate whether the lesion is an infarct or hemorrhage. Sometimes the distinction between hemorrhagic and infarction can be done with the history of headache, vomiting at the onset, rapid progression to coma, and severe hypertension can favor more of an hemorrhagic, but sometimes this distinction may not be so clear because of sudden onset. But otherwise, presence of severe headache, vomiting, rapid progression to this. How to spot a stroke? Initially, it was started with the FAST. FAST means F stands for face drooping, A stands for arm weakness, C for the speech. They could have other symptoms like trouble walking, headache, and other things. Now, currently, for that, you should ask for FAST. Show me your teeth. The smile test used to check one-sided facial weakness stands for F. Close your eyes and raise your arms. Stroke patients usually cannot raise both arms to the same height, signs of eye weakness. Third, don't cry or spill milk. Ask the person to repeat this simple sentence to check for the slurring of speech. That is FAST, or everybody should remember face, arm, and speech. This is the rapid way of detecting early stroke. Now, currently, the 2 things also added, be fast. There are some post-circulation strokes can come with a sudden onset of balance and visual symptom. That's why now it is changed to be fast. Balance, eyes, face, arms, speech, and then all 9. Basically, these are all that can be have a trouble of walking, giddiness. They can have a severe unexplained headache, subarachnoid hemorrhage, or it could be numbness, vertigo, vision, and confusion, which I already mentioned. Most common is the weakness followed by visual problems. Again, it depends upon which part of the brain has got affected based on that symptoms. Most important, you have to check what are the important items you elicit in the history. There seems to be circadian rhythm variation in stroke onset. That ischemic stroke often occurs in repose and in the morning. That is time of onset. Precipitating events like aneurysmal rupture, arterial dissection can occur during extreme physical activity, embolization through foramen ovale, muscle ovale. Often abrupt embolic strokes are abrupt in onset, and thrombotic could be stepwise progression. There may be fluctuations in small vessels. Level of consciousness usually often associated with hemorrhagic stroke. Presence of severe headache suggests SAH, or in ischemic stroke, it could be because of arterial dissection, more commonly with the posterior strokes. Presence of vomiting indicates SAH, intracerebral hemorrhage, or it could be brainstem or fossa infarct. Presence of seizures suggests cortical stroke, usually embolism. Vertigo and hiccups always suggest a posterior circulation. Presence of visual symptoms helps in identifying the lesion, amaurosis, physics, works, or a carotid artery. Always inquire about all the risk factors I mentioned, hypertension, diabetes, hypercholesterol. That will definitely help in establishing the stroke etiology and explain about the prognosis. Basically, anterior circulation, posterior circulation, and lacunar I think again you should do the good thorough physical examination of all the patients. Blood pressure, peripheral pulses, skin examination, neck vessels, palpation and auscultation of cervical and facial arteries to be done. Classical neurological examination, cognitive examination, look for it. If there is a history of blindness, it may be a symptom of carotid artery disease. Again, you look in the face, neck, for in the carotid, and face look for a superficial temporal artery, and retina you can look for retinal infarcts, fundus examination, cholesterol, crystals, all those things you can do. Basically, there are three: this one, carotid, vertebral, and lacunar strokes are ataxic hemiparesis. Again, it depends upon which territory. If it is an ACA, it is a contralateral overlimb weakness. Again, it depends upon right or left speech area involvement. You can get a language infection, ACA territory infarct. Or again, if it is a middle cerebral MC artery, you get a contralateral hemiplegia. Depending upon which side, right and left, you get a language involvement. And if it is a posterior circulation, you could be, there is a occipital infarct, you get a homonymous anemia. If there is a brainstem infarct, you get a Weber syndrome. There could be mesial temporal memory loss. There could be thalamic infarct. Again, it depends upon the way. For that, you should know the good anatomical. And there are brainstem syndromes. It's like knowing the stroke, the cranial nerve examination with its temporal relation to the hemiparesis can decide where is the level of lesion. Is it brain, medulla? This you can do. This is a lateral medullary syndrome, Wallenberg syndrome, caused by impairment. Vascular supply is posterior inferior cerebellar artery syndrome. There could be medial medullary artery, anterior inferior cerebellar artery, medial fontanelle. These are all classical. We can, like a mathematics, if you thoroughly do the examination, you can definitely say where is the localization based on the cranial nerve involvement, relation, and exact etiology you can make out. And the lacunar syndrome may be an initial component or a warning sign of a deep territory infarct in the middle, posterior, and basilar arteries. There could be pure motor hemiplegia, 60% in posterior limb of capsule, pure sensory stroke in the thalamus, or it could be the anterior limb of capsule. You get a dysarthria, clumsiness, facial weakness, or it could be in the pons, you get a dysarthria, clumsy hand syndrome, ataxic hemiparesis. Basically, the investigation is imaging. The importance, the objective of imaging is to differentiate hemorrhagic from ischemic infarct, to determine the extent and location of the brain hemorrhage, brain damage, to assess the current and impending herniation, to differentiate from the stroke mimics, identify the potential areas of reversible and salvageable brain tissue, and imaging of cerebral vessels. Again, I mentioned CT scan brain plane, CT angio perfusion, MR, stand T1, T2, player, GRE sequence, DWI, and HC maps. And perfusion diffusion will help you if you're not sure of the time of the onset, or in angiography for the vessel imaging. Sonography, you can do cardiac echo, should be done, both transesophageal as well as transthoracic, Doppler and transcranial Doppler angiography to be done. This is to show you this is a CT scan showing the large left MCA infarct, MCA showing, MRI showing the large MCA infarct, and diffusion perfusion mismatch. This is again to show hemorrhage. It will, CT scan is the best to detect the hemorrhage. It will show as a hyperdense section, and this is the hemorrhage, and this was on the left side is the infarct. MRI is useful for infarct, but not for the hemorrhage. These are all the examples of MCA infarct, both left side. This is for MRI brain, again showing the infarct in the left to MCA, and this is for the PCA infarct, right PCA, and the left cerebellum, and again this is showing the posterior circulation infarct, again the right PCA, And these are all the cerebellar infarcts. This is the vessel wall imaging. Just last few, this one, like 3 typical treatment strategies. Prevention, why we should do early recognition is for prevention, therapy, and after the stroke and post-rehabilitation. Prevention therapy which assists in preventing an initial and recurrent stroke, focus on individual underlying risk factors. You should look for hypertension, atrial fibrillation, and diabetes. Therapy should be immediately after the stroke. Designate attempt to quickly dissolve the blood clot causing the ischemic stroke to stop the bleeding. Most important in ischemic stroke, thrombolytic therapy, antiplatelets, statins, and anticoagulants. This is for hemorrhagic stroke. It is a tissue glass buster tissue plasminogen activator. Devices is the Mercy device example. For aneurysm, clipping and coiling. Again, to re-emphasize, the time is brain. For each second, 30,000 neurons are lost, 30 millions are lost. And that's why when you explain, you should always see the earlier is better. If you intervene within first 3 hours, 32 patients will be benefited compared to 3 patients. That is risk versus benefit ratio of IV tissue plasminogen. It's good if you intervene in first 3 hours, 32 patients will be benefited. In contrast, if it is between 3 and 4 hours, only the benefit is only for 16 patients. Basically, emergency treatment, I think these are all the guidelines by NINDS. Door to stroke team notification, 15 minutes. Door to needle should be 60 minutes. Important guidelines, if the patient comes less than 4.5 hours, thrombolysis, if required, thrombectomy based on the vessel wall imaging. If it is more than 4.5 hours, up to 24 hours, you can benefit with the thrombectomy. More than 24 hours, of course, standard care. What is standard care is giving antithrombotic drugs, lipid-lowering drugs, controlling the blood pressure, behavioral and lifestyle changes, neurorehabilitation. Rapid intervention is crucial in management of ischemic stroke. To say, if the patient comes with 0 hours, within 10 minutes, you should be complete assessment. 15 minutes stroke team and less than 25 minutes CT scan, and 45 minutes we should do the CT scan, and 60 minutes we should do the injection. And to summarize, stroke is a brain attack. Brain attack is an emergency. Time is brain. The diagnosis fulfill 3 criteria I mentioned: the temporal profile of clinical syndrome, evidence of focal brain disease, the clinical setting. You should always take it. Stroke is not a diagnosis of exhaustion. 3 Yes about the stroke. Be fast, I mentioned. Scan, CT scan is a must. Save the brain at 2 years. Syringe and stent. To spot a stroke, be fast, like balance, eye vision, face, arm movement. To rule out stroke minute, be too smart, like blood pressure, hypertension, encephalopathy, encephalopathy. S is for sugars and subarachnoid hemorrhage. M is for migraine, abscess, and then psychologist. To remember, be too smart. Basically, all the physicians have a role to play in prevention of stroke by encouraging the reduction of stroke factors such as hypertension, smoking, hyperlipidemia, and identification of signs of potential impeding stroke such as TIA, carotid artery stenosis. 90% of strokes could be preventable. I think all these things already mentioned. Control of high blood pressure, do moderate exercise 5 times a week. Eat a healthy, balanced diet, reduce your cholesterol, maintain your BMI, weight to hip ratio. Stop smoking, reduce alcohol intake, identify and treat atrial fibrillation, reduce your risk from diabetes. Most important is get educated about the stroke. I think you know your riskometer, so that stroke riskometer is a unique and easy tool. Assess your individual risk. Based on that, you can assess. Thank you for your.
Thank you, madam.
I request Vijaya madam, please.
Yeah. Thank you, Madam Dr. Vengamagaru, for that nice comprehensive talk starting from risk factors prevention and especially the clinical features, which are very, very nice and treatment. You covered everything in 30 minutes. Thank you so much. As you said, stroke can affect anybody at any age, and it can come to any department, including pediatrics to gynecology to dermatology and ophthalmology. Therefore, it is important for a learning a knowledge of stroke to everybody. Madam, is there any interaction or only this is only a panel type of thing? Any other? Only there is no interaction, no, madam. Only the audience can only post questions.
Yeah. Yes, madam.
Are there any questions in the question box? Madam can answer. Just see. So early recognition of stroke is important, and stroke symptoms be fast and fast should be popularized across public as well as all the physicians, so that at least whenever they come across a possible stroke, they should intimate the neurologist immediately, do a CT scan and thrombolize immediately. Are there any questions, madam?
Yeah, at present they are not displaying, madam. Actually, they are supposed to be posted in chat box.
Okay.
As of now, there are no questions.
Okay. Okay.
Yes.
Okay.
Thank you.
There are no questions. Madam, Vijaya madam, please stay back, madam. Next topic is by Radhika Reddy, madam. You are the moderator.
Madam.
Thank you, Dr. Rangamma, madam, on behalf of the IMA AP State for accepting to be the faculty for today's program. It's a great privilege and pleasure to have you as a speaker, madam.
Thank you, sir. Thank you, sir.
Thank you. Thank you.
Thank you, madam. Now our next topic is by Dr. V. Radhika Reddy, madam, Registrar YSRHS, Suicidal Behaviors, Intervention and Prevention. One second, madam, 1 second.
Madam, it is in the first PowerPoint, madam.
Yeah.
Shall I start or Dr. Vijaya is going to speak?
Good evening, madam. Dr. Radhika Reddy garu.
Madam, good evening.
It's a nice topic, of course, and it's more and more. It's now alarming, hysterical. What should I say? Mass hysteria is going on in students. Everywhere we are hearing of suicides.
Good evening, madam. It's my privilege to introduce Dr. V. Radhika Reddy, MD Psychiatry. And she did her MD Psychiatry in 1997 from Venkateswara Medical College, Tirupati, and MBBS 1991 from Venkateswara Medical College, Tirupati, Andhra Pradesh. Current and previous positions is a registrar from January 2023, Dr. YSR University of Health Sciences, Vijayawada, Andhra Pradesh. Joint Director from 22 to 23, Director of Medical Education, Vijayawada, Andhra Pradesh. Professor and HOD from 2011 to 2022, 11 years. Government Siddhartha Medical College, Vijayawada, Andhra Pradesh. And membership to professional bodies and others. International member of APA since 2004. WPA member since 2009. Fellow IPS since 1997. Past Secretary of AP IPS Vijayawada Chapter. President IPS Vijayawada Chapter since 2018. Forum Advisor in Bharat Mahila Mandal Vijayawada. Women Empowerment Committee Chairman IPS, Indian Psychiatric Society, South Zone, and National Women Empowerment Committee Convener IPS, and seminar and presentations in national level conferences, several awareness programs and talks through print and electronic media. Madam, I think this is very less you have given. And with that, I'll request you to start your program.
Thank you, madam. Thank you for your kind introduction. And on behalf of the university, I congratulate the IMA, the Pink organization, which has taken up this all-women program. And it is very apt also, the topic, suicide intervention and prevention. Next. Because September 10th is designated as World Suicide Prevention Day. And we are listening every day. We are seeing many students, youth, and everywhere the suicidal tendencies are increasing in the world. Next.
So I want to just give you a brief introduction about the suicide, and then we'll go for the prevention and other aspects. The suicide is a Latin word, and it indicates it means that it is self-murder, and it's a fatal act which represents the person's wish to die. So the death wish is more important here, whether the intention to die is there or not. So it's like, like sometimes it is a misclassification also. So we can see this like in accidents of undermine causes and chronic suicides. Like sometimes in diabetic patients or any terminal ill patients, they don't take treatment, especially diabetics or all, they don't take treatment and they are reluctant to follow the advices. And in one way, their wish to die is represented there. So next is the intention, the ideation, the thought that a person wants to commit suicide. There should be an intent to die, and sometimes it may not be any intent. So the intent is important here. So suicidal ideation, everybody will get. Like sometimes when you are vexed up or when you are really stressed, you think like just like that, like let me die. But the intention is not there really. So that is more important. And a word called parasuicide. This is like a miniature kind of thing. Like it more often they injure themselves, they don't feel pain, and more often it is seen in females. And many hospitals get this kind of patients that self-infliction will be there, and to release their tension and anger, sometimes they commit this kind of acts. Most often seen in some personality disorders, especially borderline personalities, and females are very common in this kind of acts. And one more term, which is we all need to know and define, is the suicidal attempt. So we often say a person wants to commit suicide. So there is an attempt in that. It can be a non-fatal always. A person attempts, but he doesn't succeed. He or she may not succeed in suicide. So this is a non-fatal act. So, but there is an intent to die. So aborted attempt is an event close to almost they are about to die, but that they could not complete the act. That means there is no injury at all. And the next one is the survivors of suicide. So one of the survivors are even the therapists and the psychiatrists. We psychiatrists also feel a lot of guilt sometimes when we lose a patient to suicide, because we often have an idea that we could not help the patient and we could not really recover the patient. So the loved ones, the family members who have also may have the same kind of feelings, and a person who attempted also sometimes, and the emotional toll here is very, very greater, and strong feelings of guilt will be there in the survivors of suicide. So coming to the epidemiology, it is a major public health issue. There is no doubt about it, and globally and also in our country, leading cause of death. When it is in youth, it is the second leading cause of death, they say. And the WHO report as per 2019, so there are 9 per 1 lakh population as per the WHO report. And if you see, so the orange mark, it's around the prevalence is 12%, 12 per 1 lakh. And India is in that zone. And the Indian scenario, you see, every year we lose more than 1 lakh people, 1 lakh lives are lost every year to suicide. And that the past 3 years, especially in the COVID period, if you see, the suicidal rate has been increased. It was 10 earlier, now it has reached 11.3. So the most common, the common states with large burden of suicides, you can see here, Maharashtra, Tamil Nadu, and Madhya Pradesh, West Bengal, and Karnataka. So these are the figures, if you see. So 2017, the rate of suicide is 9.9%, and 21, it has become 12%. And this is the data given by all the states and UTs in 2021. The Andhra Pradesh AP stands in the middle with 12.5. So it's the average national figure is 12 and Andhra Pradesh is at 12.5. So if you see by age and sex, above 60 years, males are more and females are less. And the last line in this below 18 years, if you see, both male and female ratio is almost equal. So when there are reasons for this, I will let you know. And we'll go through the factors which are increasing the risk for suicide. The first thing is the suicidal thoughts. Suicide, whenever the suicidal ideas or plans or the suicidal behaviors, if there is history of this kind of stuff, there is a higher risk. And any psychiatric diagnosis is there, like a depression or a schizophrenia or alcohol, any substance abuse, and cluster B personalities, definitely there is a high risk of suicide. And physical illnesses, again, the most commonly related to nervous system, any malignancies, HIV, AIDS, and any other pain syndromes also, the risk is more. And psychosocial factors, we always concentrate on the psychosocial factors, thinking that because of some stress or some unemployment or some relationship problem and a recent any domestic partner violence, these kind of things will lead to suicide. These are again a risk factors only, but these are not the only factors which can lead to suicide. And childhood traumas like abuse, sexual or physical, can also lead to increased risk. And genetic factors. So we frequently ask a question like family history of suicide is there or not. If there is a family history, definitely there is a risk of suicide in that person. Many other psychological factors like hopelessness, panic attacks, and shame, humiliation, all this can lead to increased risk. And also demographic factors like males, single and elderly age group, and especially transgenders and all. And the access to the lethal arms also is one of the risk factors. So we come to the risk factors once again, like men kill themselves more than women. The reason why there is attempts are more in women and successful suicides are more in men. So the reason would be like men are exposed to more, they are more successful in committing suicide, like they are exposed more to the successful lethal methods like either Western countries, firearms, and in India, like South Asian countries, hanging is very, very common. But women are most commonly there, like they take some poisons or some tablets, etc. And marital status, divorce, separated, a single person is more affected, and marriage is a protective factor for suicide. And physical health, any terminal illness, chronic and illness and severe pain, these are also risk factors. I told you why, and every 4 people express the desire of ending their life in terminally ill patients. So the mental illnesses, they say depression is very common, but schizophrenia is again the most common cause of death in schizophrenia patients is by suicide. And even in alcohol and substance abuses, dementia, delirium, and sometimes even anxiety disorders. So when coming to psychiatric patients, so inpatients very commonly commit suicide than the outpatients, and high risk in the first week of admission, suicidal rate is high. And that will come down after the 3 to 5 weeks of inpatient stay. And even it is related to staff rotation also, like rather than night rotation, the suicides are more. Most commonly, they occur in the early hours of the day. So previous attempts is again a very risk factor, unemployed, helplessness, hopelessness, and the access to lethal agents is again, if you have an access, the committing is very high. And fantasy of reunion with deceased loved ones, history of childhood abuse, and history of impulsive aggressive behaviors. So there are some protective effects also. When you have children at home, even they get the ideation and intention, they may not act upon those ideas. And a sense of responsibility is a positive factor. Pregnancy and religiosity and spirituality again is a protective factor. And satisfaction in life, reality testing ability, if it is high, it is a protective factor. And positive coping skills, positive problem solving skills, social support, and therapeutic relation. Even the relationship with the treating doctor or the staff itself can be a protective factor. Who are the vulnerable groups for committing suicide? As the most common is the youth and middle-aged adults, and males are very vulnerable, and those who have problems with the family and illness, sick patients. And high level of education may be a protective factor. And majority of suicides occur amongst people earning less than 1 lakh per annum. That is when the socio-economic status is below the rank, then also the suicides are a problem. So when coming to the vulnerable groups, we were talking about the youth and youth. So the college time is a significant transition time. So where you have, the children are exposed to a lot of things, like lot of new things, when they are not in a protective environment of the family at home. There is increased freedom, increased independence, and the students face nowadays they are facing a lot of stress with academic demands, and they have to adjust to the new environment of the college and a new support system they have to develop, and they have the opportunity to experiment. Nowadays, this has become more, and we are seeing many youngsters in getting involved, indulged in all other substances like alcohol, cannabis, and others, extra. So there are problems with the mood is common in this age group. And most important, now the live wire of youth is the internet and social media. So these are the factors which are causing a lot of problems to the youth. So the methods of suicide, we can discuss about the methods, like in high income countries, firearms are the most common one, and hanging is around 50% in all suicides. And most commonly in Asian countries, and especially in South Asia, South India, hanging is very common. And the self-poisonings, the pesticides. This is again, we were talking about the access, like when it is available, which is available, people will try to commit suicide with those things, like the pesticides, which is available very much in very household. It is a household thing in all the villages, and especially in rural areas. So this has become a common mode of committing suicide. So jumping from high buildings is one, again, has become recently a common method of suicide. So this can be either hanging or jumping into water, or sometimes in front of the train, and even drowning, jumping from high buildings. All these are the modes of committing suicide. So every suicide has a warning sign. So recently one student has committed suicide, and he has written mails, and he has acknowledged his mistakes, and he called upon his friends, and he was saying sorry. All those things were people came to know that only after his death. So they were never recognized that that is the thing which he is indicating something. So these are the signs which a suicidal patient can present with. They may talk about wanting to die or kill oneself, and they may look for a way to kill oneself, like searching online suicide sites. So there are many sites where one can know how to commit suicide. And talking about feeling hopeless or having no reason to live. So I don't want to live, and something like that they may tell. And they may tell that this is my last meal and I don't want to be a burden to others, or I don't want to, this is my last call to you, something like that they may express. And unwillingness to provide enough information. Sometimes when doctors ask them and clinician is asking them and trying to assess the risk, they may not give enough information, they may conceal their thoughts. This can be again a warning sign. So increased use of drugs and alcohol and acting anxious, agitated, withdrawing or isolating himself, and he's not sleeping, he's behaving recklessly, showing rage or talking about seeking revenges, displaying extreme mood swings, and preparatory behaviors. So giving away the belongings or collecting medicines or collecting pesticides like that. So these are the warning signs. So taking high risks that could lead to death. Giving away important possessions, talking about feeling empty or helpless. So talking about they are wanting to die. So these are the things which sometimes they may just say goodbye to family, and there's some leave a suicide note also. So this is the tip of the iceberg. So hidden causes are many for suicide attempts and self-harm. But the surveillance system is focusing is the suicides, the suicide attempts, or the self-harm attempts presenting to a general hospital, suicide attempts and harm presenting to a primary care services. So how to prevent these? So everybody is very much worried about the suicides, which are always preventable. So these deaths can be preventable, and sometimes we are helpless in this regard. So we will see what are the how better we can function in this aspect. The first thing is the healthcare services. So we have to identify the risk groups, and we have to improve the diagnostic things and the treatment modalities, and also the better rehabilitation. So these things can help. And the public health approaches. So we have to come the strategies which aim to increase the awareness about the role of protective factors for mental health, and attitude towards the mentally ill has to change, and or the suicidal persons. So suicidal persons, we usually, when they are survived from their attempt, usually the society sees them as there is a stigma for them that has to be prevented. And we have to promote measures to eliminate fears and misunderstandings that surround the suicide. So we can, there are 3 steps here. So who are the individuals at risk? So universal prevention can be done by increasing the access to help and strengthening the protective factors and removing the barriers to care. So the help at a primary care level, we have to try to help the patient. And selective prevention, like training the healthcare forces in effective identification of the warning signs. So we can bring awareness in the, for example, the nurses, the ANMs, the primary care healthcare professionals. So we can train them, and we can see that they can identify the warning signs and management of person at the risk of suicide. And indicated prevention is personal. So aimed at vulnerable population, those expressing suicidal ideas. So you have to consider the need for a referral. So the prevention, intervention, and post-vention. So prevention would be regular education about the mental well-being. So we are focusing more on the positive mental care rather than the disease aspect. So anyway, the depression or other psychosis, if a person is identified with an illness, we can treat it. but you better concentrate on the mental well-being of the society also. And we have to give information about the warning signs and provide adequate time, and active empathetic listening is very important when a person is really seeking help. And complete risk assessment has to be done, and a crisis should be made, and referral to appropriate personnel has to be made. And the post-pension is immediate medical help should be done, and aftercare and ongoing care. So like when a person is admitted in a hospital with an attempt, so unsuccessful attempt, and the person survives, and immediate medical help will be given, and immediately we have to refer. That is a mandatory thing, that any single attempt cannot be neglected. So one attempt is a high risk factor for further attempts and more successful suicides. So we have to refer the patient to the professional, especially a psychiatrist or a counselor. So the psychosocial treatments, anyway, the problem solving methods, the psychotherapies. If it is a personality problem, so DBT is one option we can give, and family therapy and community outreach programs, and even providing emergency cards. This kind of psychosocial aspects of this treatment also can be done. And pharmacotherapy, so everybody knows, like if you give antidepressant, so there are again FDA warnings, like some antidepressants can lead to increased risk of suicide. There was an uproar about this, especially with paroxetine and all, SSRI, and clozapine, lithium. These are helpful in preventing suicides. And what about the population strategies? What can be done? High risk strategies, what can be done? So population strategies. So we have to reduce the availability of means of suicide. So if we know that there is a risk of suicide in a particular person, in a particular family, so we can reduce the availability of means. Like especially, I can give you a better example. Like recently, we have seen many students committing suicide in coaching centers in Rajasthan. So what they have done is, most of the students were trying to hang themselves. So what they have done is, they have designed a special fans there, like that when a person attempts to or tries to hang himself to that fan, there is an elastic thing within the rod. So they will not, that the fan will come down and that suicide is prevented. So that kind of technical this thing they have used there. So that is one thing. And one more is like media portrayal of suicide. This is very, very important. So educating the public about mental illness and this treatment has to be done through media. And the suicide is portrayed as a wrong thing, or a hype that is given to suicide in many newspapers and media has to be avoided. And I will just to give you few note also on this. And population strategies, educational approaches in schools. We can have a suicide prevention helplines and telephone lines, etc. So economic factors is one thing which can again lead to suicidal behaviors. So this has to be, though it is a policy matter, this has to be addressed, and which can reduce the suicides and suicidal behaviors. And high risk strategies, those who are having psychiatric illnesses, we may have to be more careful in this. And elderly who are all alone, and nowadays we see this, there is a lot of changes in the society, and parents are left alone, and they are more often living alone and single. So these are the high risk groups. And some occupations are high risk, especially doctors. So reporting. So this is how news has to be covered, which is very, very important. So news coverage should be Always neutral. Present facts in a manner of fact language without sensitizing and be objective. Do not romanticize or glorify the event. Do not indicate blame unless clearly justified. Instead, acknowledge that a combination of triggers, vulnerabilities were probably responsible. And news coverage should be discreet. Avoid front page reporting, presentation in boxes, large headlines, lengthy reports, and photographs of the deceased. Do not provide detailed descriptions of the method of suicide. So do not publish any suicide note. And news coverage should be sensitive. Consider how the news coverage might occasion psychological and social harm to the survivors of the event. As Vijaya Madam told, there is a wave of like mass suicide. If one student commits or one person commits suicide, so that will influence the way you are reporting, will influence, and many people are suggestible if they are in a dilly-dally kind of thinking. This kind of sensitization can lead to successful suicide in them. So you have to take care of that, especially the media. Respect the privacy of the survivors. And other matters like do not repeatedly play on the event or theme. Do not allow readers to form the impression that suicide was a way of coping with personal problems or a way to teach others a lesson. So exercise particular caution when reporting celebrity suicides too. So WHO guidance on suicide prevention, live life is the concept. So live leadership in policy and multi-sectorial collaboration, interventions for implementation, and vision for innovation, financing, delivery platforms. Evaluation is monitoring, surveillance, and research. So less means by restricting the access, interaction with media for responsible reporting, form the young in their life skills, early identification, management, and follow. So here the interventions, I would like to let you know that earlier suicide was a punishable offense, and in recent Mental Health Care Act that was revised, and there is no need to punish the suicide survivors. So earlier days they used to take if they attempt suicide, they need to go and sign in the police station every day, something like that was there in earlier acts. Now it has been reviewed, and even the judiciary system has understood that the person who commits suicide shall be presumed, unless proved otherwise, to have severe stress and shall not be tried and punished under the said code. So there are many national programs who are which work on this National Mental Health Program, National Palliative Care Program, and Ayushman Bharat, where many psychiatric illnesses come under this Pradhan Mantri Jan Arogya Yojana. Many packages are there, and even prevention of cancer, diabetes, and CVS and strokes. So there is one Nasha Mukti Bharat program, Nasha Mukti Abhiyan task force is there. So government has given is trying to implement many national programs to prevent to maybe for positive mental health, I can say. And this is a wonderful program, Telemanas. And we in Vijayawada also we have a center in Siddhartha Medical College, where there is the aim to provide universal access to affordable, equitable, and quality mental health care through these tele services. This idea was evolved in the period of COVID, and now they are implementing this. So this is a telecalling system. Even as a suicidal patient or who is having that ideation, if they call this helpline number, it connects to IVRS based system, and some counselors will take up the call. And if they require a special care, that call is diverted to mental health specialist, and the person is taken care of. And it is proud to say that with this telemanas program here, after a period of 6 months, they have saved around 40 lives. So the goals, objectives of National Suicide Prevention Strategy is to reduce the mortality by 10% by 2030. So they want to reinforce the leadership things, enhance the capacity of health services, develop community resilience, and strengthen the surveillance. So these are the objectives of the program. In next 3 years, they want to establish effective surveillances, and they want everywhere they want to have a suicide prevention services in psychiatry OPD. In regular psychiatry OPD, they see along with they were seen along with all other patients, but they want to have a dedicated OPD for suicide prevention services. So these are the objectives and multi-sectoral approach of all families, individuals, corporates, professional bodies, non-governmental organization, local self-government, panchayat, and local health services, educational institutions, all are stakeholders in this national prevention strategy, the central government ministries, and all. So this is how this national suicide prevention strategy, multi-sectoral approach works. So the conclusion is, suicide risk level is assessed by balancing the individual risk factors are there and against their protective factors. So this balance should be there always. So the stressors might come in lives, but if there are individual risk factors and the protective factors are less, there is a chance of suicide. So this balance of risk factors and protective factors can be affected by significant events in their one person's life, and so risk level may change. So suicidal ideas, acts may appear to be unpredictable, but warning signs can often be identified before the person acts. So effective recognition of the warning signs and timely assessments can reduce the risk of suicide in the community by providing early interventions for someone at risk. So suicide risk assessments are essential to plan suicide intervention and prevention, and are based on the level of risk identified. So thank you once again for giving me this opportunity, and especially the upcoming Suicide Prevention Day is very apt that we have discussed about suicide in the community, and thank you very much.
Hello.
Yes, madam.
Thank you, madam. That's very nice and simplified and practical guide that you have given. And being the policy maker and a compassionate psychiatrist, you are the most appropriate person to talk on this. Thank you so much. And actually, I wanted to ask my first question written was whether seeing papers and seeing in TVs will instigate more suicides. And you have already answered that question. I think we should send as a professional body the guidance to all the newspapers and the media to kindly take care of this. It may work to some extent, at least for the standard media. We should do that. Please let us send that representation both from neurological and the psychiatric associations.
Sure. I accept that.
The second one, madam, one more question. This postpartum depression, what is the timeline that we have to consider it? 3 months, 6 months, till what time it will go into that vulnerable time?
The postpartum, usually the first 10 days, we consider it as maternal blues. But when the symptoms are more, usually it will resolve. If the symptoms are more and if there is a lot of depressive symptoms or any psychosis symptoms, we have to keep the lady on watch. So people say, so 3 months, 6 months, always there is a dilemma, but a depression, if it is set in, the treatment lines are up to 9 months as per the treatment guidelines. So we have to be careful up to that period. And what we say is, so though we treat the depression, so it will take time to the thoughts and all other things. The suicidal thoughts are the last one to resolve. So we may, initially the sleep pattern, the mood and the appetite, all those things will resolve and come to normalcy. But the ideation, the thinking process is the last one to recover. So it is better to take continue the treatment for the full 1 year, and the suicidal risk also in the later stage. And one more thing is, whenever we are treating depression, so the first year, any antidepressant, it will take around 10 to 15 days to act. So though they feel better, the patient may feel better with the medication, but the plasma level reaches at least by 2 to 3 weeks. And initially, if the mood and they may become more energetic and the thought process remains the same, there is a high risk of suicide, committing suicide in the 3rd week, 4th week. Because already with the depression, they are little lethargic and they may not be active and all. Fatigue and other things will be there. Once we are giving antidepressants, so the thought process is the same, but they develop this energy and other things. So we warn the patients that they have to be more careful in the later weeks, in the 3rd and 4th weeks, etc. So first 6 weeks, if we are careful, later on the thoughts may come down.
That's a very nice point, madam. Paradoxical response to treatment.
Yes.
Yes, thank you. Thank you. Anybody else, any questions, madam? It's a very important topic.
I think there is one question in how to prevent suicides in agricultural field workers.
Yeah.
Students.
This is again. Yes. So as we have seen in the risk factors, the psychosocial factors, the life events, the financial things are the major risk factors. And added to that, if there is any the personality issue and the family issues are added upon. So when there are more risk factors, there is more risk for suicide. So in farmers, especially I will give you an example, like in Tamil Nadu, there is in a village, the most common mode of suicide is taking pesticides. So what they have done is, they have to reduce the access for pesticides. They have put a pesticide bank in that village, so that everybody, they will go and keep their pesticides, whatever they bought for the agricultural purpose, they will keep in that bank. Whenever there is a need, they will take it and go directly to the field, and then they utilize it like that. So they will not keep the pesticides at home. So this is, they have prevented suicide in that way. So bringing down the access to the lethal substances or the modes can help them. And in farmers, there are many psychological, psychosocial factors which are has to be, these are the policies matters which has to be really taken care. There's nothing like these farmers, they are more vulnerable to suicide. So like occupation, I have especially told you, like certain occupations where there is more stress, like doctors and a few people who work for 6 months in ocean and 6 months somewhere like that. So there is a lot of risk. Similarly, for farmers, financial problems or their socio-economical grounds can be one of the reasons for high risk of suicide.
Dr. Ravikrishna sir.
Thank you, madam. Thank you, Dr. Radhika Reddy madam, for kindly accepting to present a topic in this unique Evecon conference. Thank you. On behalf of IMA AP State, we extend our thanks.
Thank you, madam. Thank you very much for a wonderful session. The talk is also pleasant as like you. Thank you, madam.
Thank you.
Madam,
For
can I also take
this
leave?
opportunity. Thank you.
Madam, can I also take leave? Dr. Durga madam and
Thank you, madam.
Thank you, Dr. Vijay madam, for accepting to be the moderator and chairperson for this session. It's a great privilege and honor, madam, Dr. Vijay madam.
Thank you, Andy. Thank you. All the best. Thank you.
We next move on next session by dermatology. Dr. Haritha, moderator for this session. Are you there?
Yes, madam.
I'm here.
Yeah, Dr. Harita, MBBS and MD
Saujanya, please
dermatology.
introduce Harita.
Yeah. Dr. Harita did her MBBS and MD dermatology from MBBS from Andhra Medical College and MD dermatology from Gandhi Medical College. And currently she is IMA AMS Nandyal branch secretary. She is very dynamic in her field and the other activities.
Thank you. And next, our speaker, Dr. P. Radharani. The eminent hair transplant chief surgeon at Radha International Institute of Hair Transplant Surgery. And she did her post-graduation and undergraduate from AMC Visakhapatnam. She is my classmate and from intermediate. And she did American Board of Hair Restoration Surgery from village of Munster, Indiana. And fellowship in hair restorative surgery from DHT Clinic, Bangkok. Advanced dermatology workshop from National Skin Center, Singapore. And she's a life member of AHRS. And till date, she had so many hair plant surgeries and performed 2,000 surgeries from various places. With this introduction, I request Dr. Radha present her topic, that is hair loss in teenagers and adults, causes and preventive measures. Radha, over to you.
Thank you, Durga. Thank you so much. It's a privilege for me to be a part of this program. And good evening to everybody. I thank Dr. P.A. Ramani, Madam, and IMA AP for giving me this opportunity. My topic is hair loss in teenagers and adults, the causes and prevention. I would like to cover as much as possible, but it is quite extensive. Let's see how much we can do. So my presentation is an overview of the clinical spectrum of alopecia in teenagers and adults, the causes of alopecia, and preventive measures, if any. So broadly, alopecia is classified as scarring alopecias or non-scarring alopecias, which otherwise are called cicatricial or non-cicatricial alopecias. To be able to give you a quick message, what are cicatricial alopecias? These are the ones where you cannot restore hair. So it is quite distressing. But what is the pathology behind that? There is an inflammatory condition destroying the follicle. It destroys the epithelial bulge, the stem cells at the bulge level. Therefore, there is never getting back the hair. Whereas if the bulb is involved, hair can regrow. So visually, if you see a patient in your clinic or in a hospital in OPD, if you see a hair loss, either multiple patches or extensive patches with no follicular ostia. Actually, my talk today, the purpose is to be able to give you little information so that you yourself can differentiate these conditions in your OPD or in your practice, so that the patient does not lose more time and goes to the concerned specialties like dermatology or hair transplant surgeons. So lack of ostia is one thing that you can identify to clearly say it is cicatrix. It is cicatricial alopecia. If you see the picture on the right side, there are multiple miniaturized, tiny, small hair. So the skin is normal, the scalp is normal. That's a picture of androgenetic alopecia. So again, cicatricial alopecias are classified into primary and secondary. Primary, where the bulge is targeted. Conditions like lichen planopilaris, chronic cutaneous lupus erythematosus, pseudopelade of Brock, central centrifugal cicatricial alopecia, folliculitis decalvans, and dissecting cellulitis. Like I said, we are not going into the details, but if you know, this is for your information, just an overview. Okay, look at the secondary cicatricial alopecias, where the follicular damage is incidental as a consequence of thermal burns or metastatic cancer, trauma, or radiation. Now, coming to the topic. What are the common causes of alopecia in children or teenagers? So we cannot completely say teenagers because, children are in that age group when they come to you. Either they are 13 or they're 16. So I just put them together. So commonly you would see tinea capitis, that is fungal infection of the scalp, the folliculitis, the fungal infection of the follicle on the scalp. Then there is alopecia areata and telogen effluvium, chronic diffuse patterns of hair loss, nutritional deficiencies, bacterial infections, traction alopecia, which is like very confined to the hairstyle that they adapt to. We know that the Sikh community in our country, as well as the African community, Afro-American communities, they braid their hair very tight, thus causing traction alopecia. And trichotillomania is one anxiety disorder where the patient continuously, on a regular basis, tugs at the hair and loses the hair. Less common causes, as we all know, from thyroid disorders, systemic lupus erythematosus, diabetes mellitus, malnutrition, and some of the hair shaft disorders or abnormalities that result in breakage and dry brittle hair. If a teenager enters your clinic, a young female or a young male complaining of hair fall, you don't have to know everything about hair. Just think of three conditions, three possible conditions, because these are the three most common ones. In fact, these are the most common in adults also. So I would not categorize into teenagers or adults. Let's do it together. So there are three conditions. One is telogen effluvium, androgenetic alopecia, alopecia areata. So when they come, how do they present? They come with asymptomatic patchy hair loss. Suppose you're a gynecologist, they will definitely mention to you that she's losing hair. Okay, just pay a little attention. So it could be a patchy loss, or she may talk about scaling of the scalp, or maybe a diffuse hair loss, like shedding and all. Then there is a change in hair texture and color, or she may present with pruritus or pain in the scalp. Some of these may be non-specific, but then if you give a few minutes, maybe you'll find something. So in order to establish the cause, there is no special route. The same old medical school methodology, which is history taking. So right from hair grooming, what hairstyles, youngsters go for a lot of hair treatments nowadays, keratin, hair straightening, a lot of treatments where they use a lot of heat and chemicals on the hair. So you have to get a full detailed history of the hair grooming practices, any tics or habits. So while the child is studying, maybe tugging at its hair at a continuous pace. So you have rounded patches of hair loss. Scalp appears normal, but there are broken hair. Again, are there any associated nail changes? Mostly we see, along with hair, we may see a little bit of pitting. Any associated skin diseases? Any systemic disease, underlying systemic disease? Does anybody in the family have similar conditions or any changes? Any drug history? Again, if you take a quick look at the scalp, you may see some erythema or scales, which could hint that there was or there is a fungal infection. If there is no erythema, no scales, it could be alopecia areata. If there is follicular plugging, then it could be a lupus erythematosus. If there is there are no follicular ostia, I said that is a cicatricial alopecia. Also look at the color, the texture, the fragility of the hair and the hair bulb. So hair on other parts of the body, like eyebrows and eyelashes, sometimes give you a quick clue. Okay, this is, I had a patient of trichotillomania. So she was picking her hair on the right side, while on the left side, because she's a right-handed girl. So on the left side, it appears totally normal. So we'll talk about the three main conditions. That is telogen effluvium, which can present as an acute or a chronic shedding of telogen hair. So there is an insult 4 to 6 months ago. If you remember, post-COVID, all of us have encountered patients complaining of hair fall. Not all of us attributed it to COVID, but it is true that post-COVID or post-vaccination or post-exposure in the family, they all had telogen effluvium. So the insult occurs 4 to 6 months and the shedding appears 4 to 6 months later. So this follows metabolic stress or hormonal changes or certain medications. So the stress could be in the form of febrile stress, severe infection, a major surgery. See, young boys get into an accident and they're lying on the bed with all nails and whatever plates in the bones. So they are subjected to stress in their post-surgical period. So then there is severe trauma, postpartum hormonal changes, especially the estrogen drop, hypothyroidism, discontinuation of OC pills or any estrogen containing medication can also cause telogen effluvium. Crash dieting, I'm sure all of us see this on a day-to-day basis. Low protein intake and iron deficiencies. These are the common insults that can result in telogen effluvium. So what are the medications? Beta blockers. Yes, some of them do take beta blockers. Retinoids, oral retinoids, anticoagulants, propyl thiouracil, immunizations. Like I said, post-COVID immunization or post-COVID vaccination, many people showed up with extensive hair shedding, and that is telogen effluvium. So what happens on the scalp? There's 85% of good active hair in anagen phase, and there is only 15% of telogen phase, and there's a small amount in the catagen phase. So if the insult is there in a certain amount of periodic time, 70% of the anagen hair responds by shifting into the telogen phase. So there's pushing of the telogen hair, the anagen hair, and when 25% of hair is in the telogen phase, that's clinching the diagnosis. So when you examine the hair follicle under the microscope, so the normal anagen hair root looks like this on the left side, which is covered by a long sheath, but the one on the right side is club shaped. These are like very simple. If you have time, you're interested, you can do that. Now, the next is alopecia areata. This is an autoimmune condition where the immune system is attacking your own hair follicle. There is patchy loss, commonly affecting the head and face. Now, the course of the condition varies from person to person. Some may present with just single patch, responds very well to interlesional triamcinolone, or some may have a continuous episode of newer patches coming, but still responding. So the presentation varies from person to person. The only thing you can do is reassure. The recovery is also unpredictable. Some people respond to multiple sessions of interlesional injections. Some people respond very quickly with just one round of interlesional injections. So it can progress. Again, some of them are prone to progression to alopecia totalis, where they lose all the hair on the scalp. If they lose all the hair elsewhere on the body, it's called alopecia universalis. And it is diagnosed by using the dermoscope, where exclamation mark hairs are seen. If you see the first picture, it has a round patch. I'm sorry, the picture is not clear. That is the alopecia areata patch. Again, this picture is not clear, but there are exclamation marks and there is tapering of the hair follicle under the microscope. Now, alopecia and PCOS. So most of us see young girls coming to the clinic or the hospital with a prior diagnosis of PCOS, some of them. So when they come with a prior diagnosis of PCOS for a hair loss consultation, they can have any form of hair loss. The alopecia could be alopecia areata, it could be lichen planopilaris. But the most common or the most specific clinical sign of hyperandrogenism, which is associated with PCOS, is the female pattern hair loss. So this is the one we mostly look at or we find. Sometimes patients come directly for hair loss evaluation and we coincidentally find, along with the alopecia, clinical signs of hyperandrogenism, which is hirsutism, acanthosis nigricans, acne, and biochemical signs of hyperandrogenism, or they may be just irregular menstrual periods, or maybe associated with previous equivocal diagnosis of PCOS. Any of these, along with the alopecia, if they are present, we then refer them to an endocrinologist for further evaluation. Definitely, PCOS poses a great challenge because all these features mimic normal puberty. And PCOS is an extensive topic we cannot discuss here. So one common or the most common cause of alopecia, both in teenagers as well as adults, is the androgenetic alopecia. It is a genetically determined disorder due to an excessive response to androgens. Here the hair loss is progressive and it is the terminal hair that you lose. So what happens is terminal hair is converted to vellus hair with the help of a 5-alpha reductase. So it is common in teenagers. It is also seen in more than 50% of men and women over 50 years of age. Typically, women lose hair in the mid-frontal area, including the vertex, but the hairline is spared. Again, in men, typically there's a frontotemporal recession, and then there may be vertex loss. There are a lot of atypical presentations and a lot of other existing alopecias coexisting with androgenetic alopecia that pose a great challenge, especially for people like us who do hair transplant surgery. When we do hair transplant surgery, we don't want to do for alopecia areata because it's a contraindication. The graft will not be taken up, or it will not result in it will not end up in giving a good result. So we do not want alopecia areata. And if you do not rule it out, and if you do a hair transplant surgery, there is no result, and then you are in trouble. So it's always good to know coexistence of other alopecias along with androgenetic alopecia. So diagnosed by extensive miniaturization on dermoscopy. So look at this picture. The extreme left has good amount of hair. There's a spot marked to be reviewed later. After a certain amount of period, you can see a lot of hair thinning out. There is hair, but they're very thin. Again, the extreme right shows extensive miniaturization. This says this is androgenetic alopecia. So I kind of placed my patients in this Ludwig classification of androgenetic alopecia, which is class 1, where the loss is minimal. And if it is slightly more, it is class 2. And very obvious, it is class 3. So again, androgenetic alopecia in men is classified on Norwood scale. The 1 and 2 is almost negligible. So you can see class 3, class 4, class 5, where there is still hair in the mid zone, but the vertex and the frontotemporal angle recessions are there. Then there is 6 and extreme loss, that is 7. So every dermatologist has the basic diagnostic tools to assess the alopecias or the scalp conditions. So that is Woods lamp and the KOH smear of the scalp scrapings to exclude fungus. Then we also do a bacteriological and mycological profile. So there is microscopy of the shed hair that helps us diagnose identify telogen hair and other shaft abnormalities. Dermoscopy is a topic by itself. If ever IMA is interested, one of the dermatologists, we can talk about dermoscopy. It's a huge subject. You would all be interested. And the routine labs, that is complete blood picture, the serum iron and zinc levels, the thyroid function tests, and the anti-nuclear antibodies. I mean, it's the same. Commonest is androgenetic alopecia. There is something that people don't talk about much is frontal fibrosing alopecia, which is like recession of the hairline. That is almost like a cicatrix. Hair does not grow back. And even if you do a hair transplant surgery, it can be done, but it should be done very carefully. And then there is drug-induced. So prevention, I think scalp examination must become a routine in schools, as well as at the time the children are getting out of the school and in their teenage time period, because that's when we are missing. We don't know when we are missing. The child is fine today. In 6 months' time, the child is coming with extensive diffuse hair loss. I think periodic examination of the scalp must be a part of physical examination and early detection and confirmation. Let's not just brush it aside and say it's just hair or scalp. It's always good to take colleagues' opinions for confirming the diagnosis and then addressing it. Most of the hair disorders do not have a cure. So we need to collaborate and communicate with interprofessional team. That means we need to talk to the endocrinologist, we need the gynecologist's opinion, we need some counseling for the patient. So everybody is affected by hair loss. So we need a lot of people to have to sit together to plan the treatment protocol for the patient. And of course, somebody has to sit with the lifestyle changes. I won't go into detail because we all know that, we all know what's happening with the kids, and we know what all need to be done. Their sleep, their diet, definitely all play an important role. If we cannot find any reason, then we all blame it on stress. But yes, stress does play a role. There are scientific papers which prove that stress is playing a role in hair loss. That's it. Thank you. Thank you very much.
Thank you, Radha. And that's a wonderful lecture. Dr. Harita, madam.
Thank you, Radha, madam. Being an AMC alumna myself, I know you for a long time, madam. But
thank you.
Your CV is just a huge, madam, I can say. I've been going through the whole pages. Thank you so much.
I should thank Durga and I should thank Ramni, madam, because without them, I would not have a chance to talk today.
Thank you, Rani madam. I'm really thankful for you for accepting this. It was eye opener for us also. Thank you, ma'am.
Thank you, madam.
Definitely have sessions with you again. Thank you.
Thank you, madam.
Any questions? I think they were posted in chat box. We let you know later.
None, there are no questions.
Wonderful section. Thank
Madam,
you.
can I ask a question, madam?
Yeah, yes, of course. You can.
Madam, what kind of hair transplant you prefer, madam? Latest? FUT or FUE?
So actually, there are two techniques. One is FUT, where we remove a strip of skin and then we isolate the grafts under the microscopes. That is time tested. And you're getting the best grafts in from the donor area. Now, FUE is another tool. Definitely, it's one of the methods which will help a lot of situations where we cannot do the strip method. So both are they're two instruments in our toolbox. Use it whatever is appropriate for the patient. But if you have to ask, or if I have to answer theoretically, FUT is better because you're getting hair which lasts longer, which will give better results. The graft is stronger, graft uptake is better, the graft transaction is less. So theoretically, FUT is best, but if you cannot do FUT, then FUE is the best. I mean, I'm talking about people doing, yeah.
Okay. Madam, and what about platelet-rich plasma therapy, madam? Do you do it very often, madam?
So actually, platelet-rich plasma is not mandatory for all cases of hair transplant. So PRP was used for various reasons as a holding medium. I mean, we hold grafts in a medium, right? So as a holding medium, or we could inject PRP just to improve the graft uptake, the conditions for the graft uptake. But it's not that PRP is mandatory. It is not that PRP will do miracles. And it is not that hair transplant is nothing without PRP. Actually, PRP is not a part and parcel of hair transplant at all. But yes, because patients ask us, if I feel it is necessary, like if the donor hair has miniaturization, then we discuss with the patient, we do. Otherwise, it's not mandatory. Now, if you want to do it as an isolated procedure for androgenetic alopecia, it doesn't do anything for androgenetic alopecia. Has nothing to do with androgenetic alopecia. So you can do it, but nothing's going to happen. Most of the times it works as a placebo.
Ma'am, I have a question, ma'am. If a patient has a small patch of hair loss on her head, stress usually has generalized hair loss. So does stress be contributed, or should workup be done for that patchy area of hair loss in an area?
Yes, some amount of work. If you take her to any dermatologist, they will have a dermoscope. So it's like 10x magnification or 20x magnification or much more magnification. So if you see under that, you can exclude a lot of conditions.
So stress usually will have generalized hair loss, not a localized.
Generalized.
Thank you.
Thank you, madam.
Thank you, madam.
Next, we move on to the session by Dr. Manjeera.
Good evening, ma'am. Am I audible?
Yeah, madam, 1 minute. Dr. Mrudula, are you there, madam?
Yeah, good evening, madam.
Doctor.
And I request Saujanya to introduce Dr. Mrudula.
Dr. Mrudula did her MBBS from NRI Medical College, Guntur. She did her MS Orthopedics from Katuri Medical College, Guntur, and she is currently working as Assistant Professor of Orthopedics, Siddhartha Medical College, Vijayawada. We are privileged to have you here, Dr. Mrudula.
Thank you, ma'am.
Dr. Manjeera.
Am I audible, ma'am?
Yeah. Dr. Manjeera worked as Assistant Professor of Orthopedics from AIMS Visakhapatnam. She did MS from Maharaja Institute and she did her fellowship from Mumbai Pediatrics Orthopedics. Madam, over to you, Manjeera, madam. Please continue.
Is my screen visible, ma'am?
No, ma'am.
Screen is visible.
And there is a share screen option.
I have done share screen.
So select your PowerPoint, madam.
Please give me 1 minute.
Yeah. Oh, yeah. But you are visible, but your screen not shared.
Ma'am, there's a green button, share screen. You can click on that, ma'am.
I have already clicked on that, sir.
So after clicking that, you have to select the screen, ma'am. The first screen that is visible. Click and then there is another button on the bottom right corner where you will find the option called share. Once you click on that, we will be able to see your screen, ma'am.
Now is it visible?
Yes, it is starting. Yeah. Yeah, you can open your presentation. We are able to see your WhatsApp. Yeah, open your presentation, please.
Opportunity.
Yes. Awesome. Please go
Are
ahead,
the
ma'am.
slides visible, sir?
Yeah. Yes. You can on your video, then we can start. Yes. Okay, just go ahead with the presentation, please. Yeah. I think you're facing some challenge. You're going to directly go ahead with your presentation. Yeah. Just go ahead.
Now
Madam.
it's okay, sir.
Yeah, it's okay. Please go ahead. Thank you.
A very good evening. I'm Dr. Manjeera. I'm working as assistant professor in KGH Visakhapatnam. Firstly, I'm very thankful for giving an inexperienced person like me to present before such an august gathering. Today, the topic I'm going to speak about is obesity and bone health. So overweight and obesity are defined as abnormal or excessive fat accumulation that may impair health. They occur primarily because of imbalance in the calorie intake and expenditure. A normal body mass index is between 18.5 to 25 kilograms per meter square. So a body mass index greater than 25 or 25 is termed overweight, and anything greater than 30 or higher is considered as obesity. Coming to children under 5 years of age, overweight is described as weight for height greater than 2 standard deviation above the World Health Organization Child Growth Standard median. And obesity is described when it is above 3 standard deviation. From 5 to 19 years, anything over 1 standard deviation from the growth reference median is termed overweight, and 2 standard deviation is termed obesity. So according to WHO, about 13% of the world's population were obese, out of which 11% were men and 15% were women. In 2019, 38.2 million children under the age of 5 years were either overweight or obese. And between the ages of 5 to 19, 340 million children were overweight or obese in 2016. Once considered as a high-income country problem, overweight and obesity are now on the rise in low and middle-income countries also, especially in the urban settings of these countries. NCDs, non-communicable diseases, were already recognized as a major challenge for sustainable development by WHO, and obesity and overweight are linked to more deaths worldwide than underweight. Almost half of the children who are under 5 years of age were overweight and obese. They are from Asia, and globally there are more people who are obese than underweight, and except for in some regions of sub-Saharan Africa and Asia, this is the same in all the other parts of the world. So globally, the cause of obesity has been deemed because of an increased intake of energy-dense foods that are high in fat and sugars, and an increased physical inactivity due to increasingly sedentary nature of works, the improvement in transportation services, and the urbanization. As per the National Family Health Survey data, in India, 23% of women and 22.1% of men are overweight. As per the BMI. The preliminary findings on status of abdominal obesity reveals that 40% of women and 12% of men are abdominally obese in our country. So a raised BMI is a major risk factor for many non-communicable diseases like cardiovascular diseases, diabetes, musculoskeletal disorders, and some cancers. And childhood obesity is associated with a higher chance of premature death and disability. And obese children also experience breathing difficulties. There is an increased risk of fractures, hypertension, cardiovascular diseases, insulin resistance, and other psychological effects in children. So this is a diagram showing what all conditions obesity leads to, like endocrine changes and adipose tissue dysfunction, cardiovascular abnormalities, mental dysfunctions, and metabolic syndromes. So a normal adipose tissue has intricate role in maintaining bodily health and functioning, and not surprisingly, obesity, which is very often accompanied by many endocrine and metabolic disturbances, also disturbs the metabolism of bones. So coming to adipose tissue and bone health. So adipose tissue has multiple roles like regulation of food intake, energy balance, immunomodulation, growth and functioning of reproductive organs, etc. And in the recent years, we are coming to understand adipose tissue as the largest endocrine organ within the mammalian body, which when functioning normally controls a lot of a lot of systems in the body. Instead of just considering as some lipid storage or cushioning or thermal insulating mass, it is now being recognized as a specialized organ with many studies which are concentrating on the functions and of the adipose tissue, the regenerative value of the adipose tissue, and what it has to do with the bones. So this is a diagram showing the deposits of adipose tissue in our body. So there are two types of adipose tissue: white adipose tissue, which forms the majority of the adipose in our body. It starts accumulating during the second trimester of gestation, and its accumulation continues throughout life. So it is also present in the bone marrow, periarticular regions, as well as intramuscularly. Then the second one is the brown adipose tissue. So brown adipose tissue is originally thought to be only in the newborn for thermal regulation and present especially in the interscapular region. But recent positron emission tomography CT studies have shown that some brown adipose tissue is also present in adults also. And this brown adipose tissue is inversely related to obesity and directly related to bone health. It means that if there is increased brown adipose tissue deposits, the person is more healthy, less prone to obesity, and there is an increased bone mass density. This brown adipose tissue has also been found to be more in women compared to men. So the brown adipose tissue is again of two types. One is the embryonic one, and the other one is the beach adipose tissue, which is white adipose tissue, which is converted to brown. So in mammals, the bone marrow adipose tissue, which consists of about 8% of total fat mass of the body, develops steadily after birth, and it accumulates rapidly during puberty. And by the time a person reaches adulthood, it comprises of up to 70% of bone marrow volume. As you can see in this figure, there is a distribution of marrow adipose tissue. And as we age, the marrow adipose tissue becomes larger, increases compared to the other cells in the bone marrow. And the potential functions of MAT again include endocrine and metabolic functions, skeletal remodeling by releasing local adiponectins and leptin, hematopoietic regulation, and bone tumor progression. This marrow adipose tissue again is affected by aging, conditions like anorexia, calorie restriction, obesity, diabetes, hyperlipidemia, and other endocrine conditions. So the question comes now is whether this marrow adipose tissue accumulation is bad for bone health. Unfortunately, it is too early to tell, but there are many studies which are focused on how this affects bone health. And it has been proved that increased MAT is not always associated with bone loss. So this is a diagram which shows the common progenitor mesenchymal stem cells. It is common for both the adipocytes as well as the osteoblasts. So if they are under the influence of adipocyte progenitor like peroxisome proliferator activated receptor gamma, then the mesenchymal stem cells are converted into adipocytes. Then osteoblast progenitor genes, they convert mesenchymal cells into osteoblasts. So it has been proposed that there is a competition between adipocytes and osteoblasts in the marrow. And so when there is obesity, there is increased adipocyte production from the mesenchymal stem cells, leading to a decreased osteoblasts. So animal studies have demonstrated that an increased bone marrow fat content in the long bones in high fat fed mice is associated with decreased osteoblast growth and reduced bone formation. So, and in vitro studies have demonstrated that some fatty acids which are produced by adipocytes, they are toxic to the osteoblasts. So this is in general what obesity has, the effect the obesity has on bones. So the positive effects are there is increased skeletal loading, and as we all know that mechanical loading increases bone mass density. The second one is the fat cushions falls. So especially in hip fractures, excess fat or obesity acts as a cushioning effect for hip fractures. And then there is increased leptin from the adipose tissue. Leptin is leptin is a bone anabolic hormone, and in regulated levels, leptin increases bone mass density. Then the negative effects are, because of obesity, there is a tendency for less physical activity in people who are obese, and there is a poor diet which consists of high fat and low nutrients. There are increased comorbidities like diabetes or in pre-diabetic conditions. And because of the body weight, there is greater force during falls, leading to more fractures and poor balance in obese people, and a relatively low bone mass compared to the weight. And when there is morbid obesity, like the leptin levels, they increase a lot, and leptin and adipokines are pro-inflammatory cytokines. They lead to bone loss. And this pro-inflammatory state, like inflammation, also activates the osteoclast, decreasing bone mass density. And because of the mechanical and also biochemical stresses, there are degenerative joint diseases. So this is another flow chart which shows how high fat diet, which leads to dyslipidemia, it causes expansion of adipose tissue. And because of expansion of adipose tissue in the marrow, the osteoblasts decrease. These adipocytes, they secrete cytokines which are pro-inflammatory, and in turn they activate osteoclasts. Osteoclasts cause bone resorption and decreased bone mass density. So it must be noted that obesity to date is a proven risk factor for ankle, leg, and humeral fractures. But it has been shown that it is a protective factor for wrist, hip, and pelvic fractures. So hip, it has been proven in many studies. In wrist and pelvic fractures, there are still some, there is debate. So coming to obesity and fracture healing. Bone fracture healing was significantly slower in obese mice compared to that of normal mice. This has been attributed to low levels of cytokine growth-related peptide, fibroblast growth factor, and tissue growth factor beta, and because of higher levels of TNF-alpha, which is a pro-inflammatory cytokine. And then also decreased, there is also sarcopenia because of increased accumulation of white fat in the muscles. This causes decreased biomechanical stresses and delay fracture healing. Coming to the effect of obesity in the joints, obesity is positively associated with the progression of osteoarthritis in both weight-bearing and non-weight-bearing joints. Weight-bearing causes structural damage to the joints because of altered biomechanics, decreased muscle strength because of sarcopenia, and altering the forces about the joints. And biochemically, there is aberrant adipokine expression, which is a pro-inflammatory cytokine, which contributes to destruction of the cartilage and remodeling of joint tissue. And this leads to osteoarthritis in non-weight-bearing joints, such as the joints of the hands. So these are some of the factors which lead to osteoarthritis, and obesity is one of the systemic risk factors. Dealing with obese people, obesity in the orthopedic surgery. So animal studies have reported that a high-fat diet induced reduction in bone to implant contact in male mice and female guinea pigs. This suggested that, diet-induced systemic changes like dyslipidemia, they affect bone to implant interface, and this is independent of the diabetic condition. So although implant failure was not associated with obesity, other complications like inflammation around the implant, bone loss, fistula tract formations, etc. were more likely in obese individuals. And importantly, they were independent of all the other risk factors like smoking or diabetes, etc. So in obese patients with a BMI between 20 and 30 kilogram per meter square, the risk of thromboembolism and infection is doubled. And in patients with morbid obesity, that is BMI greater than 40, the general mortality is twice as high as normal individuals, and post-surgery mortality rate is nearly 4%. Then the anesthesia and surgery times are also significantly increased. The infection rates are higher after any elective surgery, and the functional score, long-term implant survival, is also lower in patients with obesity. And even the surgical technique has to be pre-planned, and the implants have to be made tailor-made for people with morbid obesity, because the regular nails and regular plates may not be sufficient. So compared to patients of normal weight, patients with obesity will also experience lower functional outcomes after rotator cuff injury repairs. This is because the muscles are already, there is sarcopenia already in the muscle bellies because of accumulation of fat. And then in spine, because of the mechanical access changes, there are higher rates of hardware failure, complications, and infection. There is a direct decrease in hand grip strength. And there are significantly higher rates of complication after total joint arthroplasty. However, in obese individuals, we can see that the pain is significantly reduced, and postoperative function there is a huge improvement in postoperative function. But still, we have to warn them that full range of movement will not occur, because in case of a total knee replacement, the calf to thigh contact occurs early. So in foot and ankle, the excessive weight disturbs the mechanical axis and leads to conditions like flat foot. And then there are other things like plantar fasciitis, Achilles tendonitis, leading to chronic foot and ankle pain. Apart from this, because of the chronic inflammatory conditions, because of the increased adiponectins and leptin, they have more chances of myalgia and other chronic pains. So these are the recommendations developed by the American Association of Orthopedic Surgeons for morbidly obese people who want to undergo an elective orthopedic surgery. So first is they have to discuss with their physicians and consider carefully the complications of surgery and the results they will get after the surgery. And they should plan to lose weight before a surgery. And it is better to delay the surgery to potentially avoid serious and life-changing complications. And then the patient, they recommend that the patient should participate in a weight loss program before undergoing a total joint replacement. And a plan should be developed to manage comorbidities before undergoing surgery. And then the nutritional status should be assessed, and any deficiency should be assessed before. The rehabilitation protocols must be pre-planned by the physicians, and the commitment of the patients should also be determined. And then the commitment of the patients to lose weight and to regularly exercise postoperatively and to change their lifestyles for the better, should be taken into consideration before undergoing elective surgeries, major surgeries like joint replacements, so that they avoid long-term complications and increase the life of the implant. Coming to obesity in children. So obesity has a direct impact on child's quality of life, as it produces a slower and more tentative gait. Elevated leptin levels, they affect the bone density and lead to a greater bone fragility. So pediatric populations which are obese tend to have knee, foot, and back pain more commonly than control groups. And the growth plates also mature more quickly in obese children. There are deformities like genu valgum, genu recurvatum, which are more common. And then there are conditions like SIFI, slipped capital femoral epiphysis, which are more common in obese children. So, and it is also found that the rate of fracture is 1.5 times higher in children with obesity compared to their healthy counterparts. So, obesity, as a brief summary, obesity affects how bone remodels, and people with obesity usually have type 2 diabetes, which also increases the fracture risk combined. Chemicals produced by the body fat makes the bones less strong. Fat cells and cells that form bones come from the same stem cells. So more fat cells means fewer bone forming cells. And surgical management is involved with, surgical management of fractures is involved with more complications. So how do we manage obesity? So first is lifestyle changes. Lifestyle change, the WHO Global Strategy on Diet, Physical Activity, and Health describes actions needed to support physical activity and healthy diets like walking, cycling, aqua aerobics, etc. NCDs, as I already mentioned, were recognized as a major challenge for sustainable development, and a global action plan on physical activity has already been declared to create more active people for a healthier world. And there has been a commission for ending childhood obesity, which was formed in 2016, which gave 6 directives for ending to prevent childhood obesities. So they focused on conditions, like they focused on factors like food consumption, food production, social psychology, individual psychology, the physiology of the person, and individual activity and physical activity environment. They deemed that all of these have effect on whether children develop obesity or not, and they have prescribed guidelines for making government regulations to promote physical activity and decrease childhood obesity. So then there is a tailored weight loss program, which is a safe and successful weight loss program for reducing weight and for maintaining the reduction in weight. So it typically includes 14 or more weight loss counseling sessions, which are conducted over a period of 6 months, an eating plan, and at least 150 minutes of per week of moderate intensity exercises, daily monitoring of food intake and physical activities, and weekly monitoring of weight, and regular feedback and support from specialists. So a healthy weight isn't about following any diet plan or exercise program or a short-term fast decrease in weight for cosmetic purposes. Instead, it involves a healthy lifestyle with good eating patterns, regular physical exercise, and stress management also, so that the weight lost in obese persons are maintained throughout their life. So people with a gradual steady weight loss are more likely to keep weight off than people who lose weight quickly. So a well thought out action plan is necessary for retaining these long-term benefits. So there are 5 steps which have been described, like maintaining commitment and knowing where you are, setting your goals, and identifying resources for information and support, and continually monitoring progress and taking initiatives. Yes. Thank you very much for giving me this opportunity to speak in presence of such an august gathering. Thank you all.
Thank you, madam.
Yeah, yeah, obesity and bone health is a very complex topic actually. But our speaker, Dr. Manjira, has presented really very well and crisp. So looking at the statistics, it's very alarming. Looking at the statistics, for the past 30 years, obesity has increased by 3-fold. And we women are more prone for obesity, be it because of the pregnancy or menopause. And definitely it involves a multidisciplinary approach dealing with obesity and bone health. The topic is open for discussion. Any questions?
Satvika? I think there are no questions. No questions, madam. Thank you, madam, for participation. And
Thank you very
much.
much.
Move on to next session. Dr. Ramya Varada. Madam, are you there? Yeah. Saujanya, please introduce Dr. Ramya Varada.
Dr. Ramya Varada is a consultant endocrinologist at Apollo Hospitals. She did her MBBS and MD from Guntur and DM from AMC Vizag. Member of Endocrine Society, and she is a member of Research Society for the Study of Diabetes in India. It's an honor to have you here, madam. Welcome, Dr. Ramya Varada.
Yeah, thank you. Thank you for the kind introduction. Yeah.
Dr. Aishwarya, are you there? It's my privilege to introduce Dr. Aishwarya Elamanchi. She did MBBS and MD, General Medicine and DM Endocrinology, Consultant Endocrinologist, Origin Endocrine Center and Elamanchi Hospital for Endocrine, Diabetes and Mental Disorders, Vijayawada. Former Senior Clinical Fellowship in Diabetes and Endocrinology, New Cross Hospital, England, and Reproductive Endocrinology from Oxford University, England, and Governing Council member of APRSSDI. She had several publications in international journals. Current research, selective or non-selective alpha blockers for pre-operative preparation of eochromocytoma. And areas of interest are diabetic foot, adrenal, and reproductive endocrinology. And with this brief introduction, over to you, Dr. Aishwarya. Hello. Hello.
Ma'am, we are able to hear you, ma'am. Durga Rani, ma'am, please.
No, Aishwarya is there.
We don't see her name on the participants list, ma'am. Probably iPhone 4 or something. But as of now, we are unable to see.
I have seen one iPhone.
Madam, I'll just call her, madam, once.
Yeah, make a call.
Madam, I don't have her number, madam. Madam, I don't have her number, madam, phone number.
Aishwarya.
Yes, my number is not there with me.
Hello. Hello. Yes. So she's not there.
So, ma'am, shall I carry on with a few important things regarding subclinical hypothyroidism until she joins?
Yeah, continue, madam.
So I just briefly want to like a few highlights about subclinical hypothyroidism, when to treat and when not to treat until Dr. Aishwarya joined. So it was generally we consider when the TSH is mildly elevated and with a T3, T4 within normal range, we diagnose it as subclinical hypothyroidism. The symptoms of subclinical hypothyroidism are never overt for the patient to come to us and join. And, during a regular health checkup, we could identify it. Until then, even sometimes overt hypothyroidism being TSH more than 100 is also diagnosed during routine health check. So what is the importance of treating it, especially in a pregnancy, immediately when or planning for pregnancy, infertility issues? The subclinical hypothyroidism has a great concern. When the TSH is between 5 to 10 and T3, T4 within normal range, we consider. And sometimes, very rarely, in young girls and women, even with the TSH of 6, they have irregular menstrual cycles, menorrhagia, and sometimes conceiving conception is a great issue for them. Unexplained infertility, maybe TSH is a problem. In them, anti-TPO antibodies are generally advised. So when a young woman planning to conceive with an anti-TPO antibody positive and TSH slightly elevated, it need to be treated. And the previous Thyroid Society guidelines say the upper limit of TSH in first and second trimester is first trimester is 2.5 and third and fourth trimester is 3. And the recent 2017 guidelines has revised. Depending upon the Indian setup, we need to have our own TSH range in pregnancy. So in Indian and Asian setup, the TSH can be relaxed up to 4 in first trimester of pregnancy and 4.5 to in second and third trimester. And when it's like anti-TPO is positive, we need to treat even with a TSH of 4. If not, we can just wait. Even if it is TSH is 4 or 5.5, if anti-TPO negative, no need to treat. It's not a concern. Maybe due to elevated HCG, the TSH is elevated, and that is not a major concern. And women with irregular cycles, young women with a TSH of 6 and 7 need to be treated. And coming to the older age of around 70 and 75, TSH of 6 or 7 need not be treated. And we generally see in our clinical practice, people come with a TSH of 7 or 6 and say that their unexplained weight gain is due to this. But we oppose. The slightly elevated TSH of 6 or 7 is due to obesity. Once we treat this obesity, this TSH may become normal. And when the TSH is 6 to 10, if the patient has symptoms like excess lethargy, irregular cycles, constipation, when it is in a higher end, like 9 or 10, that need to be treated. And if it is anti-TPO positive, that need to be treated. If it's anti-TPO negative and the TSH is 6 and 7, we'll have a serial monitoring of TSH once in 3 to 6 months. If there is an uptrend, we are treating it. And there are many studies showing the relationship between the subclinical hypothyroidism and dyslipidemia and coronary artery disease. But overt hypothyroidism really have a relation with this dyslipidemia, like elevated LDL and elevated triglycerides. They need not be treated if the TSH is more than 100 still. Once the TSH become normal, this dyslipidemia, it becomes normal. Once we treat the hypothyroidism properly, the LDL and triglycerides decreases. So there is no clear relation between treating the SCH and decreasing the coronary artery disease and dyslipidemia. And there need to be further studies to confirm whether there's significant relation between dyslipidemia and CAD. And it is very clear if the TSH is only 6 or 7, even if it's an anti-TPO positive, there is risk of progression to overt hypothyroidism. And there is no rush in treating them. Only serial monitoring is required. Only when a TSH is more than 10 with a T3, T4 normal range, it need to be treated. And with between 5 to 10, it's only a serial monitoring. The significance of treating is only in case of fertility issue and menorrhagia and pregnancy. So anyone want to have any question?
Madam, for pregnant women, when we are treating with thyroxine tablets, what is the goal that we need to achieve? Is it dependent upon the trimester?
Yes, madam. Before conception, if it is a fertility is a major issue, and generally in IVF centers, they want the TSH should be strictly below 2.5. Even if a normal woman with a TPO negative, no strong family history, with a TSH of 4 or 4.5, still we are just treating them to maintain the TSH below 2.5. And if a woman conceives spontaneously, previously, 5 years back, the guidelines show the first trimester TSH should be less than 2.5 and it need to be treated. But later, from 2017, TSH of around 4 in the first trimester with anti-TPO negative, it doesn't require treatment.
And should we be advising termination if the TSH at the booking visit is high?
No, madam, there is no single guidelines either in diabetes in pregnancy, even if a HbA1c is 10 at the time of conception, Even TSH is more than 100 at the time of conception, no guidelines say it need to be terminated. We have, we'll generally have a regular scan. Still, we have a termination at the time of T4, early T5 show major abnormalities. But we see many patients with TSH overt hypothyroidism or overt diabetes at diagnosis. And it is easy to manage diabetes within 1 week with basal bolus therapy. So if they're present in 7 or 8 weeks with HbA1c of 11, we never advise termination. And we have a many pregnant women with a healthy babies at the end. And recently we saw a young woman with overt thyrotoxicosis presenting at 12 weeks. And we managed with propyl thiouracil in our initial 3 months, and later on methimazole throughout the pregnancy. And she also have like a TRAP positive, which has like significant impact of transfer to the baby. Still, she has like a normal delivery, without any C-section, normal vaginal delivery. And the baby is pretty much healthy with a birth weight of 2.5 kg. So we generally don't advise termination with uncontrolled hyperthyroidism or uncontrolled hypothyroidism or overt diabetes. This we can manage.
Yes, one of our patient is currently 9 weeks pregnant. Her TSH is 129. She does not know she has hypothyroidism. T3,
Yes,
T4 is normal, and her hemoglobin is 4.5. And B12 levels are slightly on the lower side. One of the endocrinologists suggested her that the risk of prednisone may be there because she is in her early trimester.
Yes, definitely the risk will be there, but never ever we advise termination. We just can wait. Anything can happen because we have, early pregnancy T4 or whatever. If we could diagnose early, if it is really, significant morbidity is there in the fetus, then definitely we'll advise termination. But without knowing what is happening in 9 weeks or 10 weeks, never ever advise this termination. We'll just wait, because by giving a higher dose of levothyroxine, because she's anemic, we can't right away start with 100 micrograms or 125. Still, we'll start with 50 micrograms. Over a week, we'll double the dose. And within 4 weeks, at least we can normalize the thyroxine levels in the fetus.
Okay, thank you. Thank you very much, ma'am.
Ma'am, we have a question on the chat box, ma'am, please.
Yes, I'll just go through. So the question is being, the T3 is low with TSH normal, any significance? Definitely not. T3 is not that much sensitive assay that need to be treated. We generally treat the patients based only on T4 and TSH. Like when the T4 is elevated and the T4 up to 18 is normal in early gestation. So in pregnancy, the TSH being in a normal level and T4 is 12 or 13 or 14, still it is acceptable. And T3, we generally, don't give that much significance because the assay is not that much sensitive. Only in a case of T3 thyrotoxicosis, it is significant. T3 thyrotoxicosis means T4 is in a normal range, TSH is low, and T3 is elevated. It indicates T3 thyrotoxicosis. T3 low, it's not significant. And there is another question. Yeah. In pregnancy, do you use usual T3, T4 or free T3, free T4? In pregnancy, free T3 and free T4 are less sensitive. They are less sensitive, and even T3 and T4 are also, the changes depending upon the binding proteins. The binding proteins also increase in pregnancy, so the T3, T4 levels change. But we more rely on T3, T4 rather than T3, T4. Free T3 and free T4, we rely on T3 and T4. The assay itself is not super sensitive, so we rely on only total T3 and total T4. So I just want to add a few things about subclinical hypothyroidism. In elderly, yes, we thought 6 and 7 in elderly need not be treated. And another thing is underlying cardiovascular disease. We has another entity called subclinical thyrotoxicosis. Whether this need to be treated, because as a T4 is slightly elevated, there will be increase in the heart rate, and that may have an impact if there is an underlying cardiac disease. Any kind of subclinical thyrotoxicosis, we generally treat with beta blocker and we'll wait for a couple of weeks. If still we couldn't manage the heart rate and slightly elevated T4, then only we'll add a low dose of antithyroid drug to decrease the impact on the cardiac disease.
Where is she?
Can we move on to the next session, ma'am? If
This is
Aishwarya
the
ma'am-
last session.
Okay. Awesome.
Yeah, he said is there. Where is? Let me see. Sorry, from this why not do the sir?
There's a question in the chat box, ma'am. Ramya ma'am.
Yeah, let me go through. So the question is difference between TSH and ultra-sensitive TSH. Actually, it depends upon the. I'm muted. Yeah, it depends upon the assay we do. There are many methods by do enzyme chemiluminescent enzyme ELISA and CLIA, and there is no specific thing like ultra-sensitive TSH we generally follow. And if we think the TSH, T3, T4 doesn't correlate, we generally change the machine and change the method we do. Many a times, the T4 will be elevated and TSH still in the normal range. And if we expect that need to be, different, or sometimes despite adequate replacement of T3, T4, though in range, the TSH will be elevated. So in these cases, we need to reconfirm whether the enzyme or machine we are doing it is in a proper way, or there are any interfering substances. In the recent, in the recent few years, there is like a progressive use, or what we call, more use of vitamin supplements containing biotin that interferes with the thyroid assay, TFTs. So the TSH, if we still and T3, T4 doesn't correlate in a clinical scenario, we'll repeat in another lab, and we don't generally advise ultra-sensitive TSH for any patients.
Most of the times, my patients will be asking about any diet specifications that has to be taken in hypothyroidism.
Yes, madam. This is a very specific question, but thyroid is an autoimmune disorder. Whatever change in the diet, still, if the disease is progressive, they are supposed to take the levothyroxine. But there are few things generally we ask the patient to avoid because they are goitrogens. Only goitrogens we ask them to avoid. And due to adequate iodine intake in our diet, iodine deficiency, goiter or hypothyroidism became very rare. The most common cause of hypothyroidism is being autoimmune. So generally we ask the patient to avoid rock salt, which is absolutely without any iodine, and avoid goitrogens, especially cabbage and cauliflower raw. Once they are cooked, it doesn't make sense. Even if it is whatever we only raw cabbage, cauliflower, broccoli. And in the recent times, there is increase in the intake of millets, and not all the millets, especially the pearl millet. We call it as pearl millet. Bajra generally has a more of goitrogens. And soya. These are the few foods we ask the patient to avoid. They increase the risk of increase in the size of the thyroid gland. Rather than that, anything they can have. And sometimes seafood like kelp, which has lot of iodine, not only less iodine intake, more iodine intake also has an impact on the thyroid gland. These are the few things we ask them to avoid. But as we are discussing, obesity per se causes slight increase in the TSH. We see young women or men who are very much obese in 20s and 30s with a TSH of 6. In them, decreasing the weight itself, the TSH becomes normal. So with a healthy lifestyle or change in the diet, we cannot avoid autoimmune thyroid dysfunction. And sometimes autoimmune thyroid dysfunction and celiac disease, they go hand in hand. In them, hypothyroidism with unidentified anemia, gluten-free diet can help. Celiac disease is a disease, it is due to which require gluten-free diet. So if the two diseases go hand in hand, we ask them to avoid gluten, which is present in wheat, rye, oats, and barley. We ask them, but generally not every thyroid patient need to avoid gluten.
Ma'am, how to manage the women presenting with sometimes hypothyroidism and hyperthyroidism like that? And I encountered with 2-3 cases with recurrent pregnancy loss.
Yes, your question is few women who have initial hypothyroidism, later they present with hyperthyroidism. So this is called, fluctuation of thyroid antibodies. As we are discussing now, the most common cause of thyroid dysfunction is autoimmune. And there is a switch between the stimulating antibody and the blocking antibody. When the woman has like a lot of blocking antibodies, they're present with overt hypothyroidism and they are on levothyroxine. Later on, when there is increase in the TSH stimulating antibody, so initially they are on 100 micrograms of levothyroxine, and later on there will be a gradual decrease in the levothyroxine replacement. And despite completely stopping the levothyroxine also, the TSH will be low. So then we generally, what is happening, it's not due to thyroid excess, and we'll get this trap. TPO, generally we do at the time of diagnosis if the patient are not sure what is the type of thyroid disease they have. In those, we generally do TRAB, thyroid receptor antibody test. If this is positive, so definitely it's a case of autoimmune thyroid dysfunction. We cannot straight away say it's a hypo or hyper. Autoimmune thyroid dysfunction with fluctuating antibodies between TRAB and TSH, anti-TPO antibodies. So how will we manage them is like regular monitoring, getting the thyroid profile done once in 3 months. So we'll get the pattern. We cannot do something to decrease or increase the antibodies. The only thing we do is treating the thyroid dysfunction. If it is a hypo with a levothyroxine and hypo with the antithyroid drug. But if the patient is like, the only treatment for hypothyroidism, we all know it's a lifelong levothyroxine. But the treatment for hypothyroidism differs depending upon the type of hyperthyroidism. If it is Graves' disease, we generally treat with anti-thyroid drugs for 1.5 to 2 years. Later on, there will be sometimes not. Most of the times there will be remission. There will be gradual decrease in the anti-thyroid drug requirement. And at the end of 1.5 years, maybe they are out of anti-thyroid drugs. And a few people, despite on anti-thyroid drugs, there will not be decrease in the requirement of neomercazole or methimazole, whatever it is. In them, they require either radioiodine ablation or total thyroidectomy, depending upon the size of the goiter and many other factors. So sometimes if it is like a solitary thyroid nodule or multinodular goiter, that need to be definitely treated with a iodine ablation or thyroidectomy. Anti-thyroid drugs doesn't have a major role until only until the thyroid profile is normalized, they'll be on anti-thyroid drugs. If it is a solitary function nodule or multinodular goiter, that need to be treated right away, depending upon the size of the goiter, with radioiodine ablation or thyroidectomy. So I have another question. So the first question is the percentage of hypothyroid patients nowadays due to iodine deficiency. I exactly don't know the percentage right now, but definitely it is, very much less than 1%. Only we see very few individuals from those tribal areas coming with a big goiter, which is iodine deficiency, which we used to see in our MBBS days, maybe 20 years back. We need to see in our surgery wards with a large goiter, but now it became very rare due to universal iodinization of our salt. So the antibodies we need to test to screen for autoimmune thyroid disease is anti-TPO antibody and sometimes anti-TG antibody. So another question is the subclinical hypothyroidism managed during pregnancy. Is a treatment needed? Definitely needed. That is what we are discussing. When the TSH is 4 and if it is anti-TPO positive, that need to be treated. If the TSH is 4 in the first trimester or 4.5 in the second trimester, if it is an anti-TPO negative, that doesn't require any treatment. So another question is, indiscriminate iodine supplementation in staple foods might be precipitating autoimmune thyroiditis in coastal region. I don't think so. Iodine in staple food will not precipitate autoimmune thyroiditis, but if the patient is prone to, if the patient already has an autoimmune thyroid dysfunction, excess iodine intake may precipitate it. Not every individual who take a more of iodine in the salt or wheat, they develop this thyroiditis due to iodine intake. So another question is, why aren't the immunosuppressants used in autoimmune thyroiditis? The only condition they're used in thyroid storm, or I think maybe myxedema coma. So the answer being, using of immunosuppressants doesn't help because treating hypothyroidism is more easy than treating with steroids to decrease the anti-TPO antibody. I think you got it. Yes, madam. Yes, madam.
I think we shall round up now because it
sure,
is too
madam. Sure, definitely. Definitely. I'm waiting for your
people are waiting for valedictory function.
Sure, madam. I'll definitely. I'm just
Thank you. Thank you for your elaborate session. And
yeah, thank you, madam. Thank you for
patiently answered all the questions. Thank you very much.
Now
thank you,
we shall start the validation function, and Durga Rani, please call our leaders to join. Thank you.
Yeah. I think it's the end of such a mega session.
Dr. Fanidhar sir.
I would like to invite Dr. Ravikrishna sir, President, IMA-AP. Please come on to the virtual dais and to preside the valedictory function. And Secretary, Dr. Fanidhar sir.
Ma'am, I am here. Join.
Sir, any national leaders? IMA National President Dr. Saraj Agarwal, sir.
No, it's not available.
IMA President-elect Dr. Gunshekar, sir.
No. JC
IMA
Naidu.
President-elect AP JC Naidu. I think he's already left. IMA Finance Secretary Dr. Ravindranath, sir.
Yes.
And IMA Statement Dr. Ramni, madam.
I'm here.
Observer Dr. Anand Kumar. Madam.
I'm here.
And Women Doctors Wing Chairperson Dr. Hemalata and Secretary Dr. Vasudha.
Durga ma'am, I'm here.
Vasudha.
Good evening, ma'am. Good evening, all.
MPH Chairperson and Secretary. Good evening. Dr. Sauzanya.
Good evening, ma'am. Good evening, everybody.
Good evening. Sir, Ralkrishna sir, please preside the meeting, sir.
Thank you, madam. Today we have created a history-like thing. This is the first time a marathon session with 11 hours exclusively women doctor speakers on different subjects and coming from various faculties, from neurologists, endocrinologists, ophthalmologists, and dermatologists. All faculties we have covered, and we are very happy that more than 2,000 members, delegates registered, and there some members are joining and spending 3 to 4 hours, and they are leaving, and new members are joining. And at any time from the morning till now, almost 900 to 1100 people are on the online watching the marathon program. And we would like to congratulate the AMS chairperson, Dr. Ramani Madam, and Women Doctors Wing chairperson and secretary, Dr. G. Hemalata, and Dr. S. Vasudharani, and Mission Pink Health chairperson and secretary, Dr. P.V. Durgarani, and Dr. U. Lakshmi Saujanya for organizing this wonderful program. Definitely, it is going to give a lot of mileage to the IMA Andhra Pradesh state because of your all efforts. And once again, we would like to congratulate all the leaders for making this Evecon program successful. And to Dr. Anand Kumari Madam, APMC Observer, for coming and staying for the program. And also, I thank Dr. Panidhar sir for guiding this program right from the beginning. And my heartfelt thanks to the video technologies, Shyam, Gautam, and other team members of the video technologies.
Satvika and Sindhu.
Satvika and Sindhu, and your team members from your college.
Jasmine and Sandhya.
Yes. And especially speakers, Dr. Vengamma Madam, SWIMS past director. She is a very senior neurologist. We are very happy to have Dr. Vengamma Madam as our speaker today, and also Dr. Radhika Reddy Madam, Registrar of University of Health Sciences, coming and giving a good lecture on this occasion. And with this program, I am giving another target to the Mission Pink Health World Women Doctors Wing and AMS, the exclusive super specialty program in the month of October. Are you ready, madam? AMS, WDW, and MPH, and we will extend our cooperation. We will extend all our cooperation. We would like to have a super specialty women doctors CME program in the month of October. These words, once again, I thank everybody for making this wonderful program a big success. Thank you very much. And I request Dr. Panidhar sir to share his views on this occasion.
Yeah, it is very heartening and a very pleasure to watch such a session, a marathon session since morning. Beloved President Dr. Ravi Krishna Garu, the three women on colleagues on the IMAP State Executive, Dr. Ramani Madam, Dr. Durga Rani Madam, Dr. Hemalata Madam, and all the women speakers and moderators who have run this session in such a way that initially when this was contemplated, I was little skeptical to have, because we had a session on 5th and 6th of this month, a 2-day session, and close to its heels, another session means I'm a little skeptical. That is what the register also expressed, the BMC. But breaking our suspicions, it has been a great success. But we have to introspect what made this a success. But I thought, is it for credit points? I don't think everybody is having some online access to all the CMEs. Okay, but I think it is the enthusiasm among the women, and also the material we have been providing. The speakers and the subjects are very, very important, I think. And we usually a Sunday we expect, but our sense prevailed, our president, and sense that Saturday may be a more advantageous day to have a session. Even that has clicked at every point of time. 1,000 people are online, and in the morning's session, the ophthalmology rainbow session, it inspired me. If I have a second innings, I want to also go for plastic. I don't think I had an opportunity, but definitely if a second innings is there for me, I will go for the plastic. I should compliment all the speakers, especially the efforts put in by my beloved president and my finance secretary. All the session has run more than what is scheduled. Usually APMC will be vigilant whether the session complete hours were completed or not. But this is one session where we exceeded the time, and that should be a satisfactory thing for the APMC also. These few words, I think once again I congratulate all the speakers, moderators, and especially women leader of our IMAP state for such a wonderful program. Thank you.
Thank you, sir. At 8 o'clock, I have joined the program, and right from that time, I'm still in my office. Continuously, I'm on the online, because if something technical hiccups come, I have to be there. And so I have been on the online since 8 a.m. and it's a wonderful experience to listen to so many speakers speaking and elaborately and eloquently on various subjects. Thank you, sir. I invite.
It is the occasion. I think we should thank the technologies also.
Yes, yes.
With each CME, they noted our requirements and they are upgrading all the techniques. It's very, now it has become so easy. I think by CGP CME will be much more easier to utilize the technology. Thanks for the video technology.
From tomorrow onwards, we will be focusing on the CGP program on September 3rd, sir.
Tomorrow, sir?
No, September 3rd. From tomorrow onwards, we will be concentrating on making the success of CGP CME on September 3rd. We have that program on September 3rd, General Practitioners CME program. Already 600 registrations are already done. And the next 1 week, I think it will also cross more than 1,000. I request Dr. Ramani Madam, AMS Chairperson, to speak on this occasion.
Madam Lenattunnaru.
Unnaru.
So, on behalf of IMA AMS IP State, we express our sincere thanks to our leader, Dr. G. Ravikrishna sir, and Dr. Panidar sir and Dr. Ravindranath sir for encouraging us constantly and then supporting us at every step, advising us for conducting this wonderful conference. This would have been not possible without your support, sir. We too have learned several things with this marathon conferences. Thank you very much, sir. Definitely, IMAMS look forward to your support. Every month we are supposed to conduct one conference, and then modules. We have to take up module. Nowadays, it is not only the credit points, it is the trainings with credit points that has more value according to the APMC, sir. Now we have to sit and start planning the modules to train our doctors in similar way, like instead of the simple hearing and living, we have to train, test them, assess them. We will have a wonderful time again, sir. Thank you so much, sir. Thank you.
Thank you.
And I thank the WDW chairperson Hemlata madam and Mission Pink chairperson Durga madam also for the help and coordination. Thank you.
Thank you. Thank you. Now I request Dr. G. Hemalata, WDW chairperson, to say a few words on this occasion.
Thank you, sir, for giving this opportunity. Sir, chala wonderful program. More than 2,000 registrations. Viewers kuda more than 1,200 varaku unnaru. Very thanks to Dr. Ravikrishna sir, Pandar sir, Ravindranath sir. ఇంత ప్రోగ్రామ్ ఇంత సక్సెస్ అవ్వడానికి మేము ఎంత కష్టపడ్డామో మాకంటే మీరు ముగ్గురు కష్టం చాలా ఎక్కువ ఉంది. చాలా థ్యాంక్స్ సార్. అలాగే థ్యాంక్స్ టు డాక్టర్ రమణి మేడం, దుర్గారాణి మేడం, అలాగే ఐఎం ఉమెన్ డాక్టర్స్ వింగ్ సెక్రటరీ డాక్టర్ వసుధ అండ్ అనంతపురం బ్రాంచ్, మా బ్రాంచ్ లో ఉన్న మా ఐఎం ఉమెన్ డాక్టర్స్ వింగ్స్ మొత్తం ఈ రోజు మా దగ్గరే ఉంది ఈ ప్రోగ్రామ్ కి. అలాగే టీమ్, ఈ కండక్ట్ చేసిన టీమ్ మరియు అందరికీ ప్రతి ఒక్కరికి థ్యాంక్ యూ వెరీ మచ్. ఇలాంటి ప్రోగ్రామ్స్ ముందు ఎన్నో కోరుకుంటున్నాను సార్ మీ సపోర్ట్.
Thank you. Thank you. And we would like to thank our IMA National President-elect Dr. Arvi Ashokan sir and YSR University of Health Sciences Vice Chancellor Dr. K. Babji sir and AMS National Chairperson Dr. Pankaj Mutneja and Vice President D. Srihari Rao for joining the program, and also the Joint Secretary of IMA National Dr. Venkatachalpati. They have joined the program and gave nice messages along with Dr. Srinivasarao sir, immediate past president. We would like to thank them also. And I request now Dr. P. Durgarani Madam, Chairperson, Mission Pink Health, to say a few words on this occasion.
Good evening, all of you. On behalf of our Mission Pink Health, and I think it's really a big scientific mega program. Never before, ever after, I think. Specialty program next chestam gaani entamandini mari specialties, ladies, all ladies. But this is a wonderful program, I think. And support given by Ramni madam and Hemalata, Vasudha and Saujanya. Especially they are definitely they're calling and asking whether they are in online or not, how to proceed, how to do. And thank our Panidar sir and Ravina sir for organizing Zoom meetings and advising us regarding the programs. And I thank our observer madam. Madam, you are so important for this. Thank you very much for logging. In the morning only came 7:30, I think, madam. 7:30 ke vastaru kada meeru. Yeah. Thank you, madam. Thank you very much. Thank you, sir.
Thank you. Thank you. I request now Dr. S. Vasudharani to say a few words. WDW State Secretary.
Good evening, all of you. Thank you, sir, for giving me this opportunity. I'm really glad I'm part of this team and my extended IMA family. I actually congratulate all the women for doing it so well and for conceiving, planning, organizing, and executing this very, very good CME. Today, I thank you, sir, Ravikrishna sir, and all the supportive team of the state IMA, national, and WDW, LBH, and AMS teams. I can't thank them more. I don't know, మీరు తెలిసి చేశారో తెలియక చేశారో తెలియదు కానీ ఈ రోజు మహిళా సమానత్వ దినం, ఉమెన్స్ ఈక్వాలిటీ డే, ఇంటర్నేషనల్ డే. సో అది బై ఛాన్స్ వచ్చిందేమో నాకు తెలియదు, బట్ you've given wonderful opportunity to so many efficient and able women. So I'm really happy. All the women did so well. Thank you so much, sir. Thank you, all of you.
Thank you. And I request Dr. Saujanya, Mission Pink Health State Secretary, to say a few words.
Good evening, one and all. It's a thank you, Ravi Krishna sir, Fanidhar sir, Ravindranath sir, IMAMS Chairperson Ramani Madam, MPH Chairperson Durga Rani Madam, WDW Chairperson Dr. Hemlata, my colleague Dr. Vasudha, and one and everyone here. Thanks a lot. It was a wonderful program. All these days we were attending most of the times brand specific CMEs. Today I have seen so many specialty women speaking so well organized. Even the technical team supported so well. The timing and all, even though we are not prepared while presenting, by looking at the time, we had to rush to complete in time. And whenever we had glitches, they were supporting so well. And it was really a wonderful program. Thank you, sir. Thank you for giving this idea. And I'm really surprised looking at the energy of our senior doctors like Ramani Madam, Durga Rani Madam, Hemlata Madam, and learned a lot from this. Thank you, one and all.
I request Dr. Anand Kumari, Madam, observer from IPMC, to say a few words on this occasion.
Good evening, everyone. Sir, Dr. Ravi Krishna, Dr. Fanidhar sir, Dr. Ramani Madam, Dr. Durga Rani, Dr. Vasudha Madam, and Lakshmi Saujanya Madam. This marathon CME is very nice, and I congratulate all of you for this initiative, and I appreciate you, and I'm very happy that
are you our Anand Kumari from Visakhapatnam?
Yes, ma'am. The same one, sir. I'm Vizag, victim of mandatory transfers. But
I'm very happy.
is looking. We have no boundaries. We belong to AP state, and we are serving the AP government. We are.
Yes. I'm very happy to see you.
It's a very nice CME and unique. It is very unique, and all the speakers and moderators also, they are very excellent in presenting, and it is very informative and educative. So I wish all of you to do more CMEs and to make all the programs successful, and all your future endeavors. I congratulate all of you.
Thank you.
Thank you, Madam.
I conclude.
Before concluding, I request that Vengamma Madam is the program on the line. I request Madam to say a few words before closing this CM. Dr. Vengamma Madam, former Director SWIMS Neurologist, she presented a topic today. Unnaru line lo so okay, no problem. I request
Janagana Mana sir.
1 minute, sir. We can close off with that, sir, right?
Before that, Durga Rani Madam, concluding words. You close the, you do the concluding words, then the national anthem can be played.
Okay. So before end of this program, I conclude this program with saying thanks to all the state leaders, Ravi Krishna sir, Panin sir, and Ravindra sir, and all the speakers who have presented excellently in spite of a short time, and all the moderators who have supported in time. So the time is altered, like Radhika Reddy Madam registrar, they also waited till their turn comes and they presented the sessions very well. and that shows their commitment. And I thank all my colleagues and my senior Ramni Madam and Hamlata, Vasudha and Saujanya. Thank you, sir. Thank you very much. And with this, I think we can conclude this program. And before leaving, I think we should have Janaganamana song. This is like మనకి ఏదైనా అచ్చొచ్చినట్టుగా, ఎందుకంటే మన ఏఎంఎస్ చేసినప్పుడు రమణి మేడం అందరినీ నించోబెట్టి జనగణమని చెప్పించారు. ఇప్పుడు మనం చెప్పి నెక్స్ట్ ఇంకో ప్రోగ్రామ్ చేద్దాం మేడం.
హలో,
స్టార్ట్ చేయమ్మా.
ఓకే మ్యామ్.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता, पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा, विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा, तव शुभ नामे जागे, तव शुभ आशीष मांगे, गाहे तव जय गाथा, जन गण मंगलदायक जय हे भारत भाग्य विधाता, जय हे जय हे जय हे जय 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 हे
जय हिंद.
जय हिंद.
Thank you video technique.
Thank you, sir. That time I think my connectivity was gone when you called up.
Okay,
program was very nice. Thank you so much.
Thank you,
Thank
madam.
you.
Thank you, madam.
Bye everyone. Bye everyone.
Thank you.
Thank you.
Family.
Thank you.
We should tell all the 1100 people to leave, ma'am. They are still here.
The program, see,
Otherwise they will not leave. They want certificates. Okay.
They haven't seen the song.
All can leave.
All the delegates should be thanked for their wonderful patience.
Yeah. Their commitment.
Yes.
So, all the delegates, thank you very much. And the program is over. You can leave. And we'll meet
Gautam.
soon. The next program, probably.
Yes, ma'am.
CGP program on September 3rd.
Thank you.
Hello, ma'am. Thank you so much, ma'am. Thank you.
Thank you.
Thank you, Sham. Thank you, Sham, Gautam, and Satvika.
Thank you. And also,
Madan.
Madan.
yes, ma'am. Thank you so much, ma'am. Have a good day.
Okay. Bye.